Arvind, good morning, Arvind. Arvind, can you hear me?
Good morning, Dr. Morganath.
Good morning, good morning. You look different, Sheshadri.
Sir, என்ன சொல்லுங்க?
ஒரு மாதிரி டிஃபரெண்டா இருக்கீங்க.
Good morning, Doctor. Good morning, Dr. Morganathan. How are you, sir?
Good morning. How are you?
I'm doing good, sir. Thank you.
How is your daughter?
Daughter is fine. She should be joining us any second.
Okay.
And the tulips are looking great behind your photograph, and then it's a lovely virtual background that you have.
It's actually my house drawing hall. It is the, permanent poster, not for the video.
Okay, it's not for the videos. It's a regular big poster,
Yeah.
is it?
Yeah.
Looking very nice, sir.
Sir, you got the invitation from RxEvents, yeah?
Yeah.
Okay. So, otherwise, we need to take it forward, sir.
Yeah, that day they said they will connect me at 3 o'clock, but I was waiting. There's no.
They told me that you are not joining that day.
But I had a word with that coordinator.
Tanujava.
I told her, and I spoke to that vice president also.
Hari Hegde.
Yeah.
Now I will reconnect, sir. I think that is better.
Okay.
I will talk to them. I think they are planning to launch it somewhere around October 15th.
Okay.
உங்களுக்கு மெயில் வரலையா?
வரலையே, ஒன்றும் வரல. அன்னைக்கு ஃபர்ஸ்ட் டைம்
உங்க எந்த மெயில்ல வந்து நீங்க கரெக்டா பாப்பீங்கன்னு சொல்லுங்க சார். வேற எதுக்கே அனுப்பிச்சு வச்சிருப்பாங்க அவங்க.
Okay. I always see my personal mail a.muruganathan@gmail.com. I'll write it.
I will pass it on to Tanuja and tell her to get in touch with you.
I am all the time busy with webinars only, And this month I'm planning to do 100 webinars on hypertension.
Sir, super, sir.
Already I've planned 15 webinars, masterclass that is going every Wednesday, every Friday, Saturday. And I'm also planning to do with Rotary and Lions, non-medical also, to create this is World Hypertension Day month.
Very nice. Yesterday we had a very interesting discussion that you would like. Evening varla, we had a very nice discussion on creating a cardiometabolic physician. Where some elements of endocrinology and diabetes, some elements of cardiology go into people who are post internal medicine to sort of this thing. Dr. Robert Eckel is the president of the ADA. He spoke and very nice discussion. In fact, I was thinking of you last night, wondering where you were.
My passion, my dream, my ambition, my goal is to make hypertensionists, hypertension specialists, hypertensionologists. Because I envy all diabetologists, because nook and corner you get diabetologists. But I don't find even one person who is specializing and focusing hypertension. So I classify hypertension into hypertensionist, who is undergraduate with some qualification, some degree. Hypertensionologist is somebody after MD. So
Okay.
Divided, and also I'm promoting a hypertension clinic. Hypertension clinic is my aim. Nobody has even the blood pressure apparatus, a proper BP apparatus, and they don't have even 3 cup size. If a motor wala comes, an obese person comes, they cannot check the pressure because they don't have a cuff. If a lean person comes also, no cuff. Simply at least 3 BP cups, one validator monitor is the need of aware, but nobody has that.
No, but also the supply side also is a problem, sir. My cough.
Yeah.
I get it from the US every time I go, because once in 3 years it changes. I'll tell you something. My patients have a BMI of 35-40. To be able to get a cough that suits them is very difficult in India.
Krishna, unless there is a demand, there won't be any supply. You see, in a small village, if you go and ask for a fish cutlet, nobody will give because there's no demand. They don't make it.
I know. I found out there's no pongal in this hotel in the morning.
Yeah, so that, you see, when there's no demand, there's no supply. So it's like that. See, if suppose I give an order for 1,000 BP cups, immediately you will get it. See, when the BP mobile phones came, it was very costly.
Sir, we can start, sir.
I'm ready.
The other speakers are so sir, just to let you know that Shashank will this thing will be recorded.
Shashank sir joining in 5 minutes.
Hello, who's this? Neelam, I think it's 10 o'clock, so we'll go ahead and start. He has sent a recorded one anyway, so he will join for the discussion.
Okay.
Dr. Muruganathan can start. If Shashank joins, that's fine. Otherwise, we'll play the recorded.
Yeah, no problem.
There is some electrical issue in his house, so.
I see.
So I'm pleased to, good morning everyone, and welcome to the final day of the ADA Primer program. We are very, very happy to be with all of you. We've had 2 amazing days of exceptional scientific deliberations. We've also had some record-breaking attendances, and we are that's something unheard of, and we're happy to be that this program has received so much patronage, not only from India but also from places in sub-Saharan Africa that we're taking this meeting to. Let me start off with the very vibrant Dr. A. Muruganathan, a senior colleague, tremendous physician, spearheads hypertension as his passion in life. And during this time of COVID, been a support for so many people. And his tremendous work is with the American College of Physicians India chapter. Dr. Muruganathan, all yours.
Okay. Thank you, Dr. Krishna Seshadri, Dr. Aravind, and my dear brothers and sisters. Good morning.
Good morning, Dr. Mishra.
And I'm going to be the opening batsman. I may not be like Rohit Sharma, but at least I'll try to be. Today we
Dr.
have
Mishra, good morning.
two
Dr. Mishra, you main hall.
Can you mute all, Krishna? It's getting disturbed. Thank you for muting all. So today we have 2 interesting sessions in the morning. The first speaker is Dr. Shashank Joshi. All of you know, he's the chair of IDF Southeast Asia. He's the president of the Indian Academy of Diabetes, former president of the Association of Physicians of India, Research Society for Study of Diabetes, involved with the activities of the American Association, and is serving as the chairperson of the India chapter, has honored with Government of India Padma Shri, and he has published a lot of articles. He's going to talk about the COVID, diabetes, and mental health. In fact, my mnemonics for this particular topic, I always give a mnemonics. It's called SAD diabetic. The COVID situation or disaster or any pandemic, a diabetic becomes sad diabetic. My mnemonics goes like this: SAD, S for stress, A for anxiety, D for depression, and another D for denial, I for irritable, A for anger, B for behavioral changes, E for emotional instability, and then T for therapeutic inertia, insomnia, and confusion. So this is what I say. Person will have sad diabetic will have these all the programs. These are the problems. Why these problems? Because mainly inconsistent, incomprehensive, inadequate, idiotic, inappropriate information to this ignorant person leads to illusion, delusion, imagination, and insecurity. All these things now, thanks to WhatsApp, thanks to social media. See, all these things, television, every day if you see, they say diabetic patients died. People with comorbidity has more problems. All these things, when they learn from WhatsApp or in the Facebook, they get into problems. That is why I always tell my patients, avoid seeing that. I have 2 anecdotes, interesting anecdotes. One of the Western person, after seeing the television every day on COVID, he went to the garden and broke his television. And another anecdote is one Singapore person that during the lockdown, because of the depression, he was about to jump from the 4th floor to commit suicide. So much of stress and tension for diabetics, especially the depression, we call it as diabetic distress, DD. So diabetics always have depression. Compared to normal people, the depression is more. So talk to us about this COVID, diabetes, and this mental health, which is very need of the aware. It's a very important topic, interesting topic, but improperly addressed so far. Now, thanks to the organizers to include this topic. Now I request Dr. Shashank Joshi to present his case. Over to Shashank.
Yeah, start.
So at the onset, I would like to thank the ADI primary team of Dr. Prasanna Kumar, Dr. Arvind, Dr. Sanjay Reddy, and Dr. Krishna Sheshadri for having diabetes and COVID, particularly with psychological stress. And what I'm going to do is give you a complete overview of COVID with diabetes. And of course, Dr. Mishra is going to talk on COVID hyperglycemia. So this is fundamentally how I'm going to talk. And I'm going to end my talk with a declaration of Diabetes India, which Dr. Mishra will allude to a little later. We know that SARS-CoV-2 is a unique RNA virus, which is a corona-like appearance on the electron microscope. And it is a third of its kind, which has just come up in this last 2 decades. First being the SARS-CoV-1, followed by the MERS. And we all know that SARS-CoV-2 in its timetable has diabetes as a major underlying comorbidity. So people with diabetes are more vulnerable, more serious when they get SARS-CoV-2. So when you look at the most common disease association with COVID, I think in the pecking order, number 1 is hypertension and number 2 is clearly diabetes mellitus. And across the world, even when you look at Mumbai data, when you look at Maharashtra data, we are in the process of compiling our own data. And I can very clearly tell you that diabetes is the number 2 most common comorbidity which has been observed. Clearly, we also know that prevalence of diabetes in hospitalized and ICU patients with COVID is clearly higher, and obviously the survival is worse. So what is the risk which is propelled by COVID in diabetes? What is the pathophysiology? We really don't know the true pathophysiology, but we know for sure that there is increased susceptibility to the SARS-CoV-2 infection in diabetics. Predominantly, the virus entry in a diabetic is more efficient. The viral clearance is less or decreased. There is higher affinity to cellular binding. The T cell function in diabetics is diminished. There is always coexisting of cardiovascular disease in diabetes, and there is increased susceptibility for hyperinflammation and cytokine storm syndrome. So clearly we know some shared pathophysiological risk, which we know very well. SARS-CoV-2 effectively utilizes the ACE2 to infect human cells, and there is increased affinity and cellular binding for efficient virus entry. Secondly, increasing age, male gender, and ACE2 associated factors affect the viral clearance, which is blunted. Clearly, we know that in diabetes, there are impairments of the adaptive immunity, and a late hyperinflammatory response is often seen with blunting of the T cell function. And we also know that with hyperglycemia, the susceptibility for hyperinflammation and cytokine syndrome is high, and therefore the mortality may be due to the viral-driven hyperinflammation and cytokine release syndrome. What is very clear-cut is any glucose elevation, any short-term hyperglycemia temporarily stunts the innate immune system. And we clearly now know that the ACE2 expression is reduced in diabetes, possibly due to glycosylation. And that probably makes a predisposition for severe lung injury and ARDS with COVID. So severity of infection, risk factors, and comorbidities are very, very common. So we know that inadequate glucose monitoring, susceptibility to hyperglycemia for steroid therapy, lack of contact with healthcare professionals, and inappropriate discontinuation of ARB and ACE, all of them are risk factors which actually confer diabetics a poorer outcome and morbidity with COVID. So what is the impact of COVID and diabetes? Number 1 is that it significantly has worse symptoms and outcomes. It interferes with insulin secretion and glycemic control. It clearly hampers glucose levels. There are higher chances of getting severe symptoms and complications, and may necessitate reassessment of drugs and their dosages. So clearly, worse outcomes, increased severity of infection, increased hospitalization, increased morbidity and mortality is very, very well documented. We know that there is a bad prognostic indicator of the presence of diabetes, because when there is hyperglycemia with insulin resistance, a lot of pro-inflammatory cytokines, glycosylation end products are secreted, a lot of oxidative stress and production of adhesion molecules to mediate tissue inflammation. And that leads to poorer outcomes in diabetes with COVID. So what happens with diabetes, we all know, is a low-grade chronic inflammation induced by excessive visceral adipose tissue, which affects the homeostasis of glucose and peripheral sensitivity, chronic hyperglycemia and inflammation, and abnormal and ineffective immune response, which reduces inflammatory mediators, inhibits the TNF-alpha, lowers the secretion of cytokines in response to liposaccharides. Obesity clearly increases the ACE2 expression and is important in metabolic dysfunction of diabetes. And clearly we have data to show that obese diabetic population with SARS-CoV-2 have required invasive mechanical ventilation. And as we increase the number of comorbidities, the clinical outcomes get poorer. And we clearly know that diabetes is an adverse risk factor for rapid prognosis and bad prognosis of SARS-CoV-2. How can healthcare professionals or doctors help diabetic patients during COVID? Because there's a lot of stress. And the stress generated, psychological stress generated during COVID is huge. And there are 7 treasures of policy for diabetes management during COVID outbreaks. One is health education, balanced nutrition, physical activity to be maintained, standard medication, glucose monitoring, regular schedule, and care of mental health. And remember that all these 7 treasures must be maintained. Being optimistic, being positive, ensuring that we de-stress ourselves, ensuring that, because there is a very elegant data, and I'm sure Dr. Mishra will tell you, that if in this lockdown period, it is like a post-traumatic stress disorder, the likelihood of dysglycemia or very bad glucose control is very high, because we don't focus on education, we don't eat a balanced nutrition, our physical activity is very low, we may not take medications on time, we may not monitor, and we probably get stressed out. So there are some special considerations during COVID outbreaks. The 5 no's, the 5 keeps, and the 5 refuses. The 5 no's for every diabetic is no going out, no gatherings, no sedentariness, no stoppage of medications, no anxiety. The 5 keeps is keep wearing a mask when you go out, keep your hands clean, do your routine medical checkup and be connected with your diabetes doctor, keep a regular lifestyle, and have a very scientific and not anecdotal approach towards COVID-19. The 5 refuses are: refuse to visit friends, refuse group dining, refuse to taste wild animals, refuse rumors, and refuse to shake hands and hug, and have a no-touch technique. So clearly, in diabetic patients in COVID pandemic, we need to do telemedicine and home health to maintain better glucose control, frequent glucose monitoring. We need to use telemedicine to communicate with their patients through phone calls or video calls. And we need to ensure that we must avoid too many changes and have simple measures which can do that very well. Also remember that healthcare workers have a lot of issues, and during COVID pandemic, the risk of shortage of healthcare workers is high, and therefore we need to focus on safety. RxEvents came out with its own guidelines on how healthcare workers can give diabetic patients for suspected or confirmed COVID infection. Drink plenty of fluids, maintain personal hygiene, do frequent glucose monitoring on your own, check for urine ketones, do distancing, and warning symptoms and need for hospitalizations. So obviously, a diabetic patient infected with COVID, what is our advice? Practice sick day rules, have adequate stock of medicines and supplies and glucose monitors at home, and keep in touch with your healthcare provider. So obviously, the clinical considerations during COVID times are very clear. Some services may be postponed or cancelled. Non-urgent patient contacts could be postponed. Many contacts can be performed remotely. Specific visits for blood testing may be arranged only if there is going to change management. Group-based face-to-face contact should be avoided, and unproductive attendances at hospital also must be avoided. So managing diabetic patients with COVID, well, we have 5 categories: asymptomatic COVID, mild to moderate COVID at home, moderate to severe COVID in hospital, severe COVID in ICU, severe COVID ventilated, dialysis, sepsis, or ECMO. Clearly, medical nutrition therapy, exercise, stoppage of smoking alcohol, glycemic management, blood pressure, lipids, and ACE and ARB are very crucial. But staying positive, staying happy, being fearless, but ensuring that being careful is going to be very key. Obviously, all lifestyle medications are there. You have a separate lecture where somebody is going to talk on the anti-COVID impact of metformin and various other drugs can be used. Usually we don't change molecules in asymptomatic COVID. If somebody is well controlled, we probably continue the same medications. Again, with mild to moderate COVID at home, you can give all the standard of care drugs and follow sick day rules. Particularly if there's a type 1 diabetic or somebody on insulin, never stop insulin. Inform the diabetes team early. Check your blood glucose more frequently. Check ketones and ensure that you are well hydrated. But when it comes to hospitalization with moderate to severe COVID, obviously insulin becomes on the pecking order with a small dose of tablets. But if there is severe COVID in ICU or with ventilation, dialysis, sepsis or ECMO, a lot of steroids go on board. And often it is very difficult in COVID environments to do frequent blood glucose testing, which we encourage patients to do on their own and monitor them often on insulin drips. And insulin has been a standard of care. There are some special considerations of management of diabetic people with COVID. We know that gliptins can be protective. GLP-1 receptors have a mixed report, but probably the current thinking is that they'll cause fat loss and might be protective. Pioglitazone had again a dual impact. Some say it is protective, some say it is harmful. We'll look into that a little later. ACE inhibitors and ARB again have a dual impact. Some people feel it is useful, some people feel it is harmful. And then SGLT2 inhibitors, most people say avoid it, but we know that we have very good data to suggest that there is an ongoing trial of DAPA in the COVID space. So in each of these 4 conditions, probably DPP4 inhibitors and metformin is safe and insulin is to be given. ACE and ARBs need not be stopped. SGLT2 inhibitors and pioglitazone can be best avoided. So gliptins have a role. And we clearly know beyond reasonable doubt that the gliptins or DPP4 expression in visceral adipose tissue directly correlates with the adipocyte inflammation and insulin resistance. And we know that there is a very vital role of immune regulation of activating T cells and upregulating the CD86 expression and NF-kappa beta pathway. And clearly that blockage of gliptin or DPP4 reduces the chances of progression to an ARDS because DPP4 increases inflammation in type 2 diabetes, both through the catalytic and non-catalytic mechanism. So that's something very well known. And there's very good data to suggest that gliptins can be anti-COVID. What about the pioglitazone, liraglutide and SGLT2? Initially, a lot of concerns were expressed that all these 3 can be a problem because we know SGLT2 inhibitor, GLP-1 and pioglitazone and even insulin might overexpress the ACE2 receptor. And therefore, initially it was felt that they could have deleterious consequences in people infected with COVID. We know glitazones can unmask fluid retention and heart failure. We know SGLT2 inhibitors can cause euglycemic diabetic ketoacidosis. And therefore, in ICU or hospitalized situations, it is best to avoid both these drugs. And we know pioglitazone has a correlation. It reduces the expression of CARD9, which is capsase recruitment domain containing protein 9, which decreases the secretion of TNF alpha, IL-1 and IL-6, and inhibits the NF-kappa and MAPK pathways. So obviously, we have a mixed bag from the anti-diabetic drug space. Insulin is still the drug of choice. And of course, metformin and gliptin might have some use. There is a DAPA-based trial which is ongoing, but that's about it. As far as the ACE and ARB is concerned, American Cardiology Association, American Heart Failure Society of US has said, do not add or remove RAS-related treatments. Keep it as is, where is. So there is no experimental or clinical data demonstrating beneficial or adverse events on use of ACE inhibitors or ARBs. So till the want of better data, and COVID is always in research mode, try to ensure that we keep adherence to the main guidelines. I would urge all of you all to read this document, which was very nicely compiled by Professor Anup Mishra, who is the next speaker, for strict glycemic control in the times of COVID epidemic in India, a call of action for all physicians. My last point, which I want to talk about a little bit, is stress and how to handle stress in COVID times with diabetes. Because COVID has been recognized and diabetes has been recognized with COVID as one of the major risk factors in COVID and in a vulnerable comorbidity group, people have got extraordinarily anxious. And this generation of negativity leads to a lot of anxiety and insomnia. Lack of sleep is extremely important because that will make you more vulnerable for respiratory viruses. So if you have to de-stress yourself, you have to stay positive, remove all the excess sensory overload by actually negating and doing a 2-hour digital detox every day. WhatsApp University, Googleization of medicine should be avoided by diabetic patients. They might do reverse isolation as long as they stay happy. They need a good 8 hours of sleep. They need 2 hours of digital detox. They should do some form of physical activity at home. As Dr. Mishra will say, do a 1 hour of physical activity at home and make one-third of appropriate exercises, including NEAT, including a good aerobic exercise and doing some Surya Namaskar and Uthak Baitak. So it's very, very important that physical activity is maintained. Eat on time, eat the right food, have adequate protein and sleep for 8 hours and de-stress ourselves. So clearly we now know that diabetes or high glucose and insulin resistance worsens outcome in diabetic patients with COVID-19. I'm not touching COVID hypoglycemia because that's what Professor Mishra is going to allude. We clearly know that among the risk factors for diabetic patients with COVID-19, poor glucose monitoring, susceptibility for steroid therapy, which happens due to hyperglycemia, lack of contact with the doctors, inappropriate discontinuation of drugs can actually be deleterious. A very patient-oriented approach should be the guide. We know that antivirals which have been used anecdotally like hydroxychloroquine and chloroquine can actually cause hypoglycemia, and we need to be a little careful of that. And gliptins might actually be a protective target, so-called metformin. But remember that do not discontinue agents if they are doing well, particularly in the corona-positive patients. So we are all here to stay safe, and diabetes is a risk factor, but that doesn't mean that diabetic patients become negative, and they should always learn to debrief, de-stress, stay safe with a no-touch technique, and ensure that they are happy and smiling. Thank you for a patient hearing.
Thank you.
So you can proceed, Dr. Muruganathan.
Yeah. Thank you, Dr. Shashank Joshi, for that nice presentation. Now we have the next speaker, Dr. Anup Mishra. Can I have his introductory slide, please? I think Anup doesn't need an introduction, but still, something gone.
So it's on the screen.
Okay. I mean, my screen is not opening. Okay, doesn't matter. I think all of you can see his biodata. Is a very reputed endocrinologist. Has done a lot of work on research on diabetes and the lifestyles. He's going to talk to us on the new onset of diabetes. In my opinion, I had an opportunity to interview at least 7 endocrinologists last week about diabetes and COVID. All the 7 endocrinologists, showed me a case where there was no diabetes before the COVID, and after the COVID, they had diabetes. The 3 major reasons what I found out was, one is stress-induced diabetes, second is the drug-induced diabetes, third, probably the COVID virus itself affects the beta cells and produces diabetes. Not only it produces diabetes, it produces so many endocrine disorders, including subacute thyroiditis and all that. So to listen to Anup, you will get more experience and more wisdom from him and his experience about how COVID caused new diabetes. And now I request Dr. Anup to take over and present his presentation.
Thank you, sir. I thank Arvind, Dr. Sheshadri, everybody in the organizing committee for giving me this opportunity. Actually, Shashank has brilliantly covered almost all the 3 lectures, subsequent lectures. So, our job has become very simple because he has covered a whole lot of things which we are going to speak. But still, I will focus on some of the things in particular while taking diabetes and COVID in general. So this is the current state of affairs in India and perhaps the whole world. You're at serious risk for dying from diabetes, heart disease, stroke, and cancer. Thank goodness. I thought you were going to say COVID. So COVID is in everybody's mind, and actually rest of the things are killing people. Now, these are some of our publications. Globally, we have written consensus document globally, and global call and Indian call, and we have till now in last 5 months more than 40 publications on COVID, some original, some reviews. Now, we all know, as Shashank has clearly indicated, that coronavirus is a bad omen for patients with diabetes. And all of you know, just to recap, that those people who have severe COVID infection, a large proportion of those people have diabetes. As indicated by the tall bar, these are patients seriously sick with COVID-19. As compared to the smaller bar, these are mildly sick patients where diabetes is not a major problem. So diabetes is causing severe problem when they are infected with COVID-19. So this is a very early publication. Dr. Avdesh, who will be speaking subsequently, and my team in April, when it was just beginning. At that time, these were the data from various Chinese publications and US publications. Now, we also know that diabetes is one of the major diseases which kill patients with COVID. And if you look at the mortality in patients with COVID-19, cardiovascular disease still ranks number 1, diabetes is number 2, and rest are number 3, 4, 5. We also know that more than 60 years of age is something which is a watershed, and where the mortality becomes 3 times and then subsequently another 3 times. So below that, mortality is perhaps less, but then it depends on the country, the people, the geographical status, the immune status, and so many other factors. Now, we have done a couple of studies which we did early and projected some of the data in the future. And if you look at that, this is what Shashank was referring to. First paper on lockdown and its effect on patients with diabetes, what are the changes in the lifestyle and what it portends for the future. Now, there was a small online survey which we published sometimes in May. We found that there are some habits which improved and some habits which worsened. So there is increase in the carbohydrate intake, snacking increase. There's nothing to do, they keep on snacking. But also because of a lot of information on the media, and also they talk to their physicians, the fruit intake increased, and there was a major decrease in ordering food from outside because none of the outlets were open. But major decrease in the physical exercise, and 20% gained weight. And what Shashank was saying, widespread stress was very clearly evident in this particular study, where we found 87% of the people, and this is the primary problem in the people, 87% were either stressed because of quarantine, because of lockdown, because of fear of COVID, or economic stress, which is continuing at this point of time. This was at 71 days of lockdown in India. Now, based on some of these data, we projected in patients with diabetes, how many will worsen subsequently because of all these things which are happening, lifestyle changes, and there may be some problems in procuring medications and so on. And we found when we put a mathematical model here, this is Samit Ghoshal and his group and our group, we found that predicted increment in A1C was quite high at 30 and 45 days, and so were annual increase in the complications, NPDR, PDR, microalbuminuria, peripheral neuropathy, and even amputation. So this non-diabetic, which have undergone lockdown and subsequently are likely to worsen, and their complications are likely to increase. So we are going to get more people with complications and uncontrolled diabetes. Now, it is also very well known that if a person is well controlled, a diabetic is well controlled, the mortality is markedly reduced. Look at this study, where well-controlled people versus poorly controlled over 28 days who are infected with COVID, the well-controlled people had 86% decrease in mortality. 0.14 is adjusted which is remarkable. And similarly, if you look at all the complications, septic shock, ARDS, acute kidney injury, etc., they from 40 to 70% decrease in those who are well controlled. So well-controlled diabetic, they fare as good as a patient who's non-diabetic. So we all, and that's why the call for action which Shashank projected, that we should all tell our patients that this is the time we should control diabetes more than ever. Then we looked at the people who are non-diabetic. And this is another study which we published with Samit Goshal's group. And we found that taking in account the weight gain, which occurred in 40% of the non-diabetic cohort, 7% of these people will become diabetic. So there is increase in the risk of diabetes in non-diabetic people. And we have seen that diabetic people will be worse off in terms of their glucose control and also complications. It is also very interesting to note that those people who are non-diabetic and have slightly high sugar at the hospital admission with COVID-19 are worse off. So they are non-diabetic people. But look at the higher strata of glucose up to more than 7 nanomole. And the moment the admission glucose value is high, the hazard ratio for 28 days mortality is 2.5 times, and in hospital complications 4 times. So any hyperglycemia is bad. If a patient with diabetes well controlled will have less mortality, patient diabetes poorly controlled, high mortality, patient non-diabetic and yet have a hyperglycemia and high mortality and complications. Now, Shashank has very nicely told you why diabetes increases mortality risk, but this is just to recap. Actually, diabetes does not seem to increase risk for COVID. So risk of contracting COVID is not high in patients with diabetes. But once a diabetic person contracts COVID, then mortality is high because of impaired T cell function, in general impaired immunity, procoagulant state, pulmonary thrombotic microangiopathy. You will see on the right side how pulmonary thrombotic microangiopathy in a diabetic patient looks like. And high interleukin-6, TNF-alpha, increased levels of cytokine storm, compromised cardiac and renal function. And you could see this picture at the bottom where lots of interleukins are surrounding this COVID-19 virus. And also pre-existing endothelial function and microangiopathy. Then let's look at the COVID-19 and pancreas. Now this is a 10-year-old study, and where binding of SARS coronavirus to receptors have been shown in pancreas. Now look at this. This is the hemotoxin eosin strain showing exocrine pancreatic tissue and islets. Islets are in the middle, and exocrine tissue is surrounding it. And the moment you put the stain for ACE2, expression of ACE2 in pancreas as by immunohistochemistry, shows that endocrine pancreas is strongly positive for compared to exocrine pancreas. So this is a highly positive for ACE2. ACE2 receptors are high in islets. And if you look at the type 1 and type 2 alveolar epithelial cells in lungs, the ACE2 staining is almost similar to the endocrine pancreas. Let's go further and let's look at the current data. This was a 10-year-old study with other coronavirus. Now here, ACE2 expression in various tissues has been measured. And look at this. So there are a number of tissues here. And if you look on the left side here, where my cursor is the lung, and this is the ACE2 expression. These dots are ACE2 expression is high. But look at on the right side, this is pancreas. It's even higher than lung tissue. And in this study, 17% of the patients with COVID-19 had pancreatic injury. So it is doing something to the pancreas. It's going through this receptor and directly damaging the pancreas. Now, we have recently reported a case of 63-year-old male, known diabetic. This is not a patient not known to have diabetes, known diabetic, with fever, no abdominal pain, RT-PCR positive, random blood sugar high, hemoglobin A1C high, high CRP, and NCCT showed that bulky pancreatic tail with areas of necrosis in body and tail of pancreas less than 30%. So here is a necrotic pancreas less than 30% induced by COVID-19 in a known patient of diabetes. So this is the first case report, second case report from India, first from Gangaram. Now, new-onset diabetes in COVID-19, if you look at the two case reports from India, case one, 30-year-old male presented with fever and weakness, no prior history of diabetes, no family history, random blood sugar 555, A1C high, metabolic acidosis, urine ketones, and CT chest showed bilateral pneumonia, and this is the blood gas parameters and interleukin levels, which are very high, and metabolic acidosis. So 30 or young patient with new onset diabetes is presenting with ketoacidosis. This is my colleague Shafiq Kuche from Medanta Hospital. Second case, 60-year-old male presented with fever, cough, weakness left upper and lower limbs, no prior history of diabetes, random blood sugar 582, A1C, this is 9.2, CT chest showed no pneumonia, MRI head showed acute CBA right mid. So here is another case, new onset diabetes in 60-year-old man. So these are the two cases reported from here, and there are a couple of cases reported worldwide. And so hyperglycemia, now we know, may occur due to multiple factors here. Number one, increased insulin resistance with sepsis, viral sepsis. Beta cell dysfunction or destruction due to new onset diabetes, ketoacidosis, hyperosmolar states will be seen more frequently, and you can see previously ketoacidosis and hyperosmolar both were seen. Prolonged ketonemia is seen, high cytokine levels, beta cell apoptosis may occur, and direct pancreatic destruction to ACE2 receptors. Use of corticosteroid, of course, will increase hyperglycemia, as Shashank has already said. Poor oral intake and use of hydroxychloroquine will decrease blood sugar. And we are continuing with our new onset diabetes study. We have 56 cases till now, out of which COVID RT-PCR positive are 3 cases. Asymptomatic patient with new onset diabetes, COVID antibody positive are 12, and COVID antibody negative are 41. Almost 87% had a high BMI. So I think that directly diabetes arising from COVID-19 is rare, and diabetes due to obesity and various other factors during lockdown is more common. Now, we have already known about this. Shashank has already briefed you, but just to recap, the ACE2 expression by various drugs and insulin used in treatment of diabetes: insulin, metformin, PPR gamma, TPP4, GLP-1, SGLT2, and sulfonylurea. There is a preclinical evidence in animal studies that ACE2 expression is increased due to multiple agents, except now DPP4 inhibitors and sulfonylurea. And there is a preclinical evidence of anti-inflammatory effects in the models of lung injury, except SGLT2, rest of others. But then we know now that metformin and the gliptins are, in retrospective study, have shown to decrease mortality. I'm sure this will be touched subsequently by Dr. Bhandari and Dr. A.K. Singh. So what should we do? This is last couple of slides here. There are 5 hyperglycemia scenarios. Pre-existing poor glycemic control without COVID-19 or with mild COVID-19, mortality is high if patient gets COVID-19. Hyperglycemia at admission in patient not known to be having diabetes, mortality is high. Hyperglycemia and pregnancy with COVID-19, we don't know about mortality, difficult to manage again. Hyperglycemia during hospital stay with COVID-19, high mortality. And new onset diabetes, high mortality. There are different methods of management here. I'm not going to details of this. This is given in our paper, which Shashank referred to, place of care, management solutions, and healthcare provider, or if somebody wants, they can go through this. These are 2 papers that we published. On the left side, strict glycemic control is needed in the times of COVID-19 epidemic in India. A call for action of all physicians, all those who are present in this particular panel, in the morning from Shashank to Avdesh, all have contributed to this particular very good paper. And it says that at this point of time, we have to go back to our patient and reiterate that glycemic control, blood pressure control, and weight control is of paramount importance, and it will actually protect you from COVID-19. And on the right side is another paper which has been prepared with the help of almost 70 nutritionists throughout the country. Balanced diet is needed in times of COVID-19 epidemic. A call for action for all nutritionists and physicians, and it is state-of-art, small paper with tables summarizing what are the current evidence as far as nutrition, immunity, and COVID-19 is concerned. So thank you very much for giving me this opportunity.
Thank you, Dr. Anup Mishra, for that very clear, vivid presentation. Now I have a couple of questions for you. You did not mention anything about stress-induced diabetes. Don't you think stress also can cause diabetes?
I think that has been mentioned already by Shashank. Stress was his area, and he has dealt it brilliantly. Yes, to answer your question, stress is certainly contributing to diabetes, and I have already shown you that 87% of the patients during lockdown had stress, and those new-onset diabetes, which we are discovering now, stress is a significant factor.
Dr. Muruganathan, Dr. Shashank's also joined, so questions can be addressed to him also.
Okay. Shashank. I think Shashank has some problem in connection. Dr. Anup, you said about insulin resistance in COVID. Did you say that?
Hello?
I can't hear you.
Can you hear me, Dr. Muruganathan?
Yes, I can hear you now. Yes.
Yeah, did you ask me a question? Because can you repeat it? I have very poor audio quality. That is why. I think I'll switch off my video.
Okay. Yeah. Your internet is weak, I think.
Yeah.
No, I was asking Anup Mishra about the stress and diabetes.
Yeah, please go ahead. Please go ahead. Sorry. Yeah.
Yeah, I've already answered. If you want to contribute something.
No, I think I'm sorry. I have very poor connectivity because they have actually shut off electricity in my building. So I'm answering through my phone and it's very intermittent. But I would agree with Dr. Mishra that, COVID is still under investigation and we need to do a lot more work. And the COVID diabetes has many facets to it. In fact, Dr. Anup Mishra's call for action article has shown that there are 5 different subtypes of COVID-related diabetes, whether it is pre-existing, whether it is ongoing, whether it is insulin resistance, whether it is pancreatopathy. And I think another 6 months, we will have more answers to that.
Okay. Dr. Anup Mishra, in all your cases, you did not mention about the blood pressure in those cases. Is it blood pressure also increased or only you get new onset of diabetes?
Because of brevity and clarity, I did not mention many other things in each case. But if you recall the second case where it was associated with a cerebrovascular accident, the blood pressure was also very high, and it was under control. Rest of the 2 patients, blood pressure was slightly high, but nothing out of order.
In your cases, any case developed fungal infection? Because last week I interviewed one of the endocrinologists where the diabetes also fungus, and they have to undergo surgery. So,
Dr. Muruganathan, you're not audible.
Yeah, okay. Dr. Muruganathan.
Yeah. Hello, can you hear me now?
I can hear, but it's
audible now.
Okay. I was asking you, after the diabetes, was there any complications like fungal infection? Because last week I had a case of diabetes, COVID diabetes, and then he had mucormycosis.
Yes, sir. It is true that uncontrolled diabetes, we are likely to get many more complications than I had chance to enumerate. And that was actually not my aim also. But as you rightly said, that fungal infection is one of the common ones. And recently we saw patients who had COVID-19 and diabetes had a lung lesion, which we thought was COVID pneumonia, but we went ahead and biopsied it anyway and found that it was actinomycosis. So we are, surprises are there, we are learning more, and we have to keep our eyes open for all these unusual infections also.
Did you get any case of subacute thyroiditis also after COVID?
No, sir, I have not seen, but other people have seen. I'm sure you have seen, sir.
Yeah. So because now COVID gives a lot of newer problems and unpredictable thing. So in this, I had a humorous anecdote. I am becoming fed up with being fed up. So that sort of depression and especially the WhatsApp and all that gives. So all diabetic patients are worried. For example, my sister is a diabetic patient. My elder brother is a diabetic patient. When all those things from the news and the WhatsApp, they are worried if they get whether they'll get better. And your point is very, very, very valid. If you are a controlled diabetic, you are as equal as normal. So no need to worry. Even if you contract disease, you will feel well. I think this message.
Dr. Muruganathan.
Yes.
We have seen quite a few cases of atypical infections. As Dr. Anup Mishra described, we have seen aspergillosis, cryptococcosis, particularly people who have got this pulse methylprednisolone and also this tocilizumab. We are seeing a lot of fungal infections which are delayed. We have seen 4 cases of strongyloidosis also. That is number 1. Number 2, we have seen, independent of diabetes, a spate of thyroiditis coming up, which has been very well controlled. In fact, one of my colleagues also got thyroiditis, and he has written a very nice blog in the Hindu, which I'll send it to all of you. But we are clearly seeing COVID-related thyroiditis, and these all findings are just being seen in an observational way. We will need to do much more systematic data collection. Dr. Mishra is our motivator to write up work, and then we will be able to put it out in a perspective. But we are clearly seeing a small peak of thyroiditis in the COVID pandemic.
Shashank and Dr. Anup, can I ask you a question? And more importantly, your comment, simply because there are so many physicians who experience not just COVID, but more importantly, stress not related to COVID, and economic downturn. Many people not able to even pay, for example, their LIC premiums, and this was being highlighted. Given your vast experience and all of that, what are the coping mechanisms that clinicians should practice during this particular time? I think we'll take that as a last.
Yeah, Shashank is the better person to answer this. His subject was exactly that. So maybe Shashank can speak first and then subsequently.
Yeah, I think my comments on that, Krishna, are very simple. That this is a time of medical uncertainty. And in times of uncertainty, we need to be positive. We need to declutter. We need to be minimalistic. You have seen that all our spending in the virtual world has become minimalistic. I completely agree. I have doctor colleagues of mine who are in their 30s, who have taken large EMIs. In city like Mumbai, it is not easy to survive. And they are under acute stress. So they have economic stress, they are personal hardships. Many of them are also under counseling. And but I think we need to still stay positive. This too shall pass. And I think what we need to do is avoid a lot of unnecessary clutter. It is time to declutter, focus, particularly on the economic front. If needed, talk to friends and colleagues. In fact, even the Indian Medical Association and various other medical societies are trying to help out our professional colleagues, and ensure that, we are able to negotiate this hardship. If we stay positive with a positive mind, I think we can, overcome all this.
I'll just add something.
Anup would have some comments.
Yeah, I'll just add to what you have said. Dr. Sheshadri, things are opening up, and I see in Delhi now, those illnesses which are bottled up for 4 months are just coming out, and people are coming out with various ailments and uncontrolled diabetes and uncontrolled blood pressure and also heart disease. So physicians will never go out of job, and in fact, in next couple of months they'll be probably slowly pick up and may be busier. So they just have to hold forth for some time.
Only problem with the physicians now is, they have fear. Though they have, because seeing so many cases, they are little reluctant to touch the patient. Still, they want to, maintain that physical distancing, and nobody dares to take the stethoscope and auscultate. And, slowly, I think it will go. One more important thing, Krishna, sleep is very important. Actually, there was steady Ebola virus. They said sleep between 10 p.m. to 11 p.m. is most important. That is the time the IL-12 is secreted, and that is growth hormone. That is very important for immunity. So there was a paper which says sleep is the very important thing for immunity, and that too early sleep, 10 p.m. to 11 p.m. is must, because all of us, we don't sleep by 11, 12. So this is the message for all of us, that we must sleep early to get the IL-12 and then growth hormone secreted. I think both the speakers spoke very well, and the message is, I want everyone to have the positive message that even with diabetes, even with comorbidities, if everything is under control, if you follow lifestyle modification, COVID is not a big thing. That message you should send it to everyone, because everybody who sees the WhatsApp or my request is, don't see WhatsApp, don't see any Facebook. Everybody gets frightened because we get inadequate, incomprehensive, threatening messages and communications makes the people, really bad. So even the doctors, every day one prediction comes. One day they say, you take testosterone, you will increase the immunity. Or somebody says, take colchicine, that improves immunity. So there are a lot of confusion. So I think a body like yours should give us clear message, what to take, what not to take. Also must, reassure, give a positive message that even with diabetes, even with obesity, even with hypertension, if everything is under control, you are as normal as anybody else. Even if you get it, you get it better. This is the message. I think positively, you must send the positive radiation from our association. And you should have a helpline number, so that if somebody has any doubt, this helpline must help. So I think these are my suggestions. Thank you for the opportunity, Krishna and Arvind. And it was a very good talk by Anup Mishra. Though I could not see my brother Shashank, he gave a lot of information on both the topics, covering the anxiety part as well as the treatment part.
So Dr. Shashank is waving to you. So thank you so much, Dr. Muruganathan. Thank you, Dr. Anup, and thank you, Shashank, for this amazing start to the day. This is my 5th month in a row where I have not watched the news or Netflix, and that detox has probably helped me more than anything else. With that, I'm going to bring in Dr. Basavanna Gaudappa. Arvind, you want to introduce Dr. Basavanna Gaudappa? Can we have his introduction, please? Neelam? Dr. Basavanna Gaudappa, just to let you know, we'll have Dr. Pramila Kalra start.
Okay.
No, she was here, isn't it?
But she's left, but AK Singh has joined.
No, sir.
So we will start with Dr. AK Singh today, because Dr. Bhandari will come in a little later. We will start with Dr. AK Singh.
Okay.
Can I have Dr. Basavanna Gaudappa's introductory slide, please? Neelam?
No, sir, we have not.
Can you put Dr.
Arvind,
Basavanna
can just say
Gaudappa's
one word
introductory
about
slide,
me and you can start.
One second. Give me Dr. Basavanna Gaudappa's introductory slide, please. Thank you.
One.
Sir, Dr. Basavanna Gaudappa is a senior colleague of ours from Karnataka. I've known him for many years. He's from Mysore. He's a tremendous clinician. He's been a patron of the diabetologists here in Karnataka, and I've also have a friend of his standing just behind me to tell a few more words about it.
Sorry, I think I was away, and then that was a bio break that I had to take, and so very.
His bio break is in the mouth.
Okay. It's very fascinating to have Dr. Basavanna Gaudappa, because he's one of the principal investigator who is also working on the COVID vaccine. And I think this is something that you can tell us all about. And as you moderate, you have been the principal head of the Department of Medicine at Mysore, and you're also the principal investigator for the COVID vaccine trials that are going on. So I think I will not come between you and the rest of the panelists.
Thank you, Arvind. Thank you, Shishadri, and thank you, Prasanna Kumar, and all the team of ADA Primer. I'm very, very fortunate to be here to moderate this session. I'm told Sudhir Bhandari is going to speak later. The first talk will be by Dr. AK Singh. We'll be talking on repurposing of metformin in COVID-19. Just word about COVID vaccine. We are fortunate that ICMR selected our center as one of the center among the 4 in the first phase where we tested the safety issue. It was all very good. All were very safe, unlike the one report that came from UK. And then we have also extended to immunogenicity, where I was also a participant in taking vaccine. Okay, now we have been given 3 vaccine trials to the center. One is Covishield from Serum Institute of India. Second is Novavax that comes from Australia. Then the other vaccine from Russia also is coming to our center. We're also doing a study on BCG vaccination for elderly people. We will talk about that later, and we are fortunate that we have been awarded this opportunity. I take this opportunity to introduce Dr. A.K. Singh. He's a senior consultant endocrinologist, and he is principal investigator in phase 3, phase 4 trials in many multicentric trials. And he will be talking to us on repurposing of metformin in COVID-19. I thank ADA Primer for giving me this opportunity to chair this session. Over to Dr. A.K. Singh to start his presentation.
Thank you, chairpersons, for the kind word. Thank you, organizer, team ADA Primer, entire team, Dr. Krishna, Dr. Arvind, Dr. Prasanna Kumar, and Bhavna. So what I'm going to do today in next 15-20 minutes is to take you through this particular anti-diabetic drug, which seems to be exciting for certain reason, which I will explain you why this is exciting. As you all know, metformin is the first-line anti-diabetic drug. Somehow from some corner from the world, now it is proposed that even it can be used in patients with COVID-19 without diabetes for certain reasons, which I will explain you. But let's first stick to metformin in diabetic subset and how metformin seems to have been interesting repurposed agents, during COVID-19. Let me remind everyone that metformin, as a drug was discovered as an anti-influenza drug. It was never an anti-diabetic drug, right? So this drug was, first used way back, somewhere in 1949 during Taiwan influenza outbreak. And as an anti-influenza drug, people later on found that this drug has got an anti-malarial drug, and metformin was used in treatment of malaria. Still, the elder brother of metformin, which is a proguanil, which is another big bigunide. In fact, that's the first bigunide and followed by fenformin and then metformin. So proguanil is still the drug of choice as a prophylaxis for someone who is traveling to the malaria endemic parts of the world. Now remember, metformin is the younger brother of the same proguanil. So as I said, it was not at all anti-diabetic drug to start with. It was discovered as anti-influenza, followed by anti-malarial. And during the use of malaria, it was found to have glucose-lowering ability. So serendipitously, this drug was, found to have anti-diabetic properties. And since then, the story of metformin, and right now that's the first-line anti-diabetic drug. When COVID started somewhere in the end of December and January 2020, people started thinking about what drugs should be used and which drugs are unharmful in patients with COVID-19 and diabetes. Several theories have been proposed so far. This is a paper in DRCP you can see from India. Sanjay Badada and Ramesh Pal wrote this paper in Diabetes Research and Clinical Practice, and they proposed certain considerations. Remember, these considerations were put forward in absence of any clinical studies at that point of time. And they proposed that there are certain drugs which has a potential to increase angiotensin converting enzyme 2, and therefore try to avoid those drugs during the COVID-19. Insulin doesn't have any direct relation to ACE2, so it was proposed that insulin is fine, and it is always fine. Metformin also doesn't work through ACE2, so they recommended that it's fine to continue with metformin. So was the sulfonylurea. There was some concern raised for the pioglitazone first, because pioglitazone is a drug, as you know, which is associated with increase in ACE2, and this is how this drug works to reduce insulin resistance. And people proposed that stop pioglitazone. In fact, the first paper, you know, if you remember in Lancet, respiratory disease, which was proposing not to use ACE or ARB, in the same paper, it was proposed that don't use pioglitazone. And the entire consideration was because it increases ACE2, it upregulates ACE2 in insulin, firstly in the animals and supposedly in the human, so stop this. Then GLP-1, as you know, this works also through the GLP-1, so they proposed stop this drug because this drug increases ACE2, and that's one mechanism by which GLP-1 receptor agonist reduces cardiovascular event in the different cardiovascular outcome trial. Similar story with SGLT2. So this three drug in particular, pioglitazone, GLP-1 receptor agonist, and SGLT2 was advised to be stopped in patients with diabetes because of likelihood of contracting COVID-19 because of increase in ACE2 expression. No studies. Remember, the caveat is these all are proposals, theoretical propositions. DPP-4 inhibitor was thought to be the drug which can lower, chance of COVID-19 infections. There are a lot of stories. I'm not going to DPP-4 today. And of course, at that point of time, the Trump and hydroxychloroquine was at the front line. And as you know, the entire hullabaloo behind the SCQ, people proposed, because in India, you have got a DCGI permission to use hydroxychloroquine in patients with diabetes. Now, let's just stick to the metformin. So, metformin, although by this theoretical ACE2 consideration was not supposed to be stopped, however, different guidelines in the world perhaps thought in a different direction. Surprisingly, you would be amazed to see that we were first from India to propose treatment of diabetes during COVID-19. Way back somewhere in March, we published this paper, and right now it has got a 200 citation by now, as you can understand, because this was the first paper across the world where we proposed, just in anticipation that, stop metformin or SGLT2 inhibitor in someone who has got a severe COVID-19 or someone who are critical, in anticipation that metformin increases lactic acidosis and SGLT2 inhibitor has got a chance of having increased euglycemic diabetic ketoacidosis. But then remember, we cautioned only in the severe COVID-19. We didn't say that to stop in every diabetic patients with mild to moderate COVID-19. The next paper came, so we proposed to stop metformin and SGLT2. This is a paper in Lancet Diabetes and Endocrinology. They perhaps went, as you can see, all big shots in the world. They had expert opinion again on diabetes treatment during COVID-19, and they went further and suggested, not to use metformin, same ideology, anticipated lactic acidosis, stop SGLT2, anticipated euglycemic diabetic ketoacidosis, stop GLP-1, anticipated nausea and vomiting during COVID-19. So they proposed to stop this three class of anti-diabetic drug, but they were fine with DPP-4 and insulin. The third guideline in the world came from the UK. So this is a paper, as you can see, in diabetic medicine. This is a position statement from Diabetes UK. They were in similar direction to our proposal, and they suggested to stop metformin and SGLT2 in severe COVID-19. So these are the three guidelines in the, an expert opinion across the world, where the Lancet paper somehow suggested stop metformin in every place. So let's take you back to this story, how we, went further to look into. And as a caveat, I suggested these all were expert opinion in absence of any clinical trial done so far with anti-diabetic drug in patients with COVID-19. So we started looking into why people are worried about metformin. Now, if you look back into this metformin meta-analysis, as you can see, this is a paper published in patients with sepsis, and you would assume that these patients will do very badly on metformin, surprisingly to suggest that metformin has been found to be a wonderful drug during even sepsis. And you can see there is 41% reduction in all-cause death in someone who were metformin user who developed sepsis. So when we are talking about metformin, we are not suggesting that you continue metformin in someone who is a ventilator. We are suggesting that metformin user means prior to the hospital admission, patient must be receiving metformin. So there should not be any confusion. And in this paper, as you can see, metformin user prior to getting admitted in ICCYT setup had a 41% relative risk reduction in all-cause death during sepsis. So we looked back into different anti-diabetic drug, continued during the COVID-19. So this is our paper in DRCP when we reviewed the anti-diabetes drug per se and looked back whether really these drugs has got anything wrong in patients with COVID-19 if you continue. And you would be amazed to see, this is a BG slide, let's focus to metformin. And we changed the entire status. We looked into all the data conducted with metformin during past SARS-CoV-1, during MERS-CoV, during bacterial pneumonia, during fungal pneumonia, viral pneumonia, sepsis. And we came up to a conclusion that there is no harm in continuing metformin in patients with mild to moderate COVID-19. This was our proposal, which was in contrast to the previous guidelines which suggested to stop metformin in every Tom, Dick and Harry if you have got a COVID-19, irrespective of the status of COVID-19. Now, we went further to look into how the metformin is working. So this is a first paper. In fact, it's a first large retrospective study, but this is a dedicated diabetes study, very famously known as Coronado study. You can see 1,317 patients. Actually, this trial was, supposed to have a 28 days follow-up. And this paper was presented in Diabetologia when it was a 7 days follow-up data. 28 days follow-up data is soon coming into the Lancet. I know the result from that because I was the referee of that paper. So in this paper of Coronado study in patients with diabetes and COVID-19, when they look back into anti-diabetes drugs, so I'm not going into the diabetes part, and the outcomes with the anti-diabetes drug, there was somehow a hint that, some of the anti-diabetic drug might be useful in fact, but one thing came out pretty clear from Coronado that as you can see, left-hand side, none of the anti-diabetic drug is doing a great harm if you continue in patients with COVID-19, right? When I'm saying continuous until the admission, and which consists of mild to moderate patient, including the severe patient. Now, when you look back into the metformin data, you would find the secondary outcome in the Coronado study was, death at day 7. It seems to, have a pretty interesting data, and there was a significant reduction in the death when it was not adjusted for the other comorbidity. So in a non-propensity matched data, it appeared that metformin, rather than doing harm, might be doing, good in patients with COVID-19 as opposed to insulin. As you know, this is the drug of choice in patients with COVID-19. It was amazing to suggest that rather insulin might be doing harm and metformin might be doing good. But then in these kind of studies, you need to do a multivariate analysis. And after the multivariate analysis, it was found that neither drug is doing harm or any benefit in the Coronado trial. I can tell you, this is just 7 days data from the Coronado. A very recent paper, as I suggested, is coming in the Lancet, is the Coronado's 28 days that metformin has done a wonder, outcome, and there is almost 1/4 reduction in mortality. So I'm breaking the news before it is getting published in the 28 days follow-up data of Coronado with the metformin. So that was the first paper that looked into anti-diabetic drug. This is the next paper, came in the diabetes care, small number of patients, as you can see, 120. Suffice to suggest that metformin is not doing anything wrong in patients with COVID-19. And in fact, if you closely look here, the percentage of patients receiving metformin had lesser in hospital death, although the p-value didn't reach the statistical significance in metformin. But see, on the right-hand side is the patient receiving insulin. There is no harm in patients receiving insulin. If you look back into, even the biochemical parameter, look the lower panel, interleukin 6 level in the metformin users were significantly lesser compared to someone not receiving metformin. But this is a pretty small study giving you a hint that metformin is not doing anything wrong in patients with COVID-19. If anything is there with the metformin, it seems to be interesting and useful. This is a third paper. This paper came from China. This directly looked into the role of metformin. And as you can see, this was in fact the first paper to suggest that metformin might be reducing death by 4-fold in patients with COVID-19. And you know, this paper came everywhere in the news, in the Medscape, every corner of the world. This paper flashed out, suggesting metformin user had 4 times less death compared to someone not receiving metformin. The next paper, so we looked back into the metformin theory. This is my paper again in DRCP, and we looked back into the metformin paper. We extensively looked into the entire data of metformin, and we suggested that metformin should be used as a repurposed drug. Forget about diabetes, even in non-diabetic patient, based on these data which was coming at that point of time. I'm not going to read here. However, even further studies have come down with the metformin as the time goes by. Paper is again with the metformin in patients with COVID-19. It's almost one of the largest studies on the metformin. You can see more than 6,000 patients, half of them receiving metformin, half of them not receiving metformin. If you see the conclusion, there is a significant reduction. Now, this is the result from this paper. You can see there is a 4-fold reduction in all-cause death in a propensity matched model, but the benefit only extended to the women, not in the male, as you can see. You shouldn't be surprised that metformin is doing wonder in women. We had data in the past with metformin in female. Metformin has always been, you know, a wonder drug for women, and we do have data in the past which suggested metformin can be a wonderful drug in women. And in this paper, suggested there is 1/4 reduction in the all-cause death, especially in the women. So this is a propensity matched data of more than 6,000 patients receiving either metformin or not. Another paper, this paper also came into the newspaper and Medscape. This is 239 diabetic patients out of 604 COVID patients, and you can see the data on all-cause death odds ratio. Surprising to find that in all these studies, metformin seems to have something good to follow. You can see here 67% reduction, relative risk reduction in all-cause death. This is too good to believe. Remember, that's the problem in retrospective data. Nevertheless, this suggests that at least metformin is doing no harm. Perhaps there is a possibility that this drug might be doing wonder, especially in the context of COVID-19. And this is the latest paper, came in Cell Metabolism a week back, as you all appreciate. This paper looked into the metformin user. Perhaps this is one of the largest that looked into the different outcome. In this study, there was no decrease in mortality with the metformin. However, there was a significant reduction in heart failure in the metformin user. That's very interesting data. We never had such a fantastic data on heart failure reduction in the metformin user. You can see there is a 39% reduction in heart failure in the metformin user. However, there was some issues with the metformin as well. As you can see, there was increase in lactic acidosis in those who were metformin users. So that's very fascinating data, that despite increase in lactic acidosis, there was a decrease in heart failure. And when the others looked into who developed lactic acidosis, it was pretty clear that someone who had chronic disease only developed increase in lactic acidosis. So this paper suggested that you should be careful when you are continuing metformin. And here is the entire results from this particular paper. As you can appreciate, there was a suggestion of increase in lactic acidosis, but there was also a suggestion to have a reduction in heart failure with the metformin. However, this paper concluded that our findings suggest that you should continue metformin in patients with COVID-19 with type 2 diabetes. But whenever the kidney function goes down, especially in patients with severe COVID-19 with the eGFR less than 60, one should stop metformin. So to summarize, the entire paper with regards to the metformin in the COVID-19, this is the table in front of you. The Coronado was the first one. This is 7 days data, didn't find exceptional benefit, but as I suggested, 28 days data, which is coming up with the metformin, has shown a significant reduction in all-cause death in metformin user. Next was the diabetes care paper, hint of less mortality in the metformin user. Third one suggested 4-fold decrease in death. Next suggested 1.3-fold decrease in death. The fourth suggested 3-fold decrease in the death. And the final paper, as I shown you in cell metabolism, there was no reduction in the all-cause death, but there was a significant reduction in hospitalization due to heart failure by 41%. So somehow, if you look back into the metformin story, what I think is currently standing right now, that there is no doubt that metformin has shown a significant reduction on an average, a 4-fold decrease in 3 papers in patients with COVID-19 in diabetes, and this benefit seems to more in the women that I have shown you the data. Because this is a retrospective data, so to have a full evidence in terms of evidence-based medicine, we ideally need to conduct a randomized control trial. However, the death reduction, even in a real-world study, cannot be overlooked. So I don't know whether anyone would be interested to conduct a randomized control trial with the metformin at this point of time. Even with the retrospective data, which is consistent, and as the days progresses, we have got a consistent data which is suggesting some kind of benefit, whether it's all-cause death or heart failure reduction, is interesting. So, in my opinion, I would suggest that continue metformin in patients with COVID-19 until your patient is having a severe COVID-19 or shifted to a critical care unit, or if the eGFR comes to in a CKD range. As you all know, metformin is contraindicated in patients with eGFR less than 30, but in the context of COVID-19, stop once eGFR comes down to less than 60 because of increase in lactic acidosis, which has been confirmed in the last paper I had shown you. So that's the current status of metformin in COVID-19. Thank you very much for your patience listening.
Thank you, Dr. A.K. Singh, for an excellent exposition of evidences to build the confidence of clinician in using metformin in a patient with the COVID illness who has diabetes, who is already on metformin. Don't fear to discontinue. Continue it when there is mild to moderate case. That is your message. And of course, we all understand the clinician when there is a stress of infection, of any kind of infection, and especially with the profound inflammatory markers, the chances and fear of lactic acidosis is high. So when there is severity, please refrain from continuing metformin, stop it, and then change out insulin. That was the message, and a very, very clear, lucid presentation with evidences to support the utility of metformin, and it has built the confidence of clinicians who have been using metformin in several of their cases to continue the same when there is mild to moderate illness. I would ask you a question later, maybe after the session, a presentation by Sudeep Bhandari, if he's there. Then that would be Dr. Sudeep Bhandari.
Yeah, I'm there.
Sudeep Bhandari, it gives me a great pleasure to introduce Sudeep Bhandari. He's a professor of medicine at SMS Medical College and Hospital, Jaipur, a senior clinician and teacher who will be talking to us on the COVID outcomes in diabetes. Over to Dr. Sudeep Bhandari for the next 15 minutes. We'll listen to you, and then we'll take up the discussion on these two topics.
Thank you very much. First, thanks for inviting. It's been a wonderful hearing. Dr. A.K. Singh has been treated, and this is very interesting. In fact, when we started managing COVID patients, I think our understanding, our approach, our everything was little different in people with a comorbid condition than isolated COVID patients. And diabetes was one of the important thing which we really had to take into consideration. In fact, this is the most common disease associated with COVID-19 in the profile of patients we came across. Hypertension was the commonest, and diabetes happened to be the second most common disease along with ischemic heart disease, atrial fibrillation, and the immunocompromised conditions like rheumatic conditions or the cancer, etc. Now, the issue is that diabetes
Dr.
predisposes a
Bhandari, do you
patient.
want to make it full screen? If you
Yeah,
can.
I'll do it. I'll do it full screen. I'll make it full screen. Is it okay?
Yeah. Thank you. Thank you.
Yeah.
Now it's all
so
right.
Truly speaking, it is the second most common disease associated with COVID-19. It predisposes to more complication. It has a very early florid presentations comparing the non-diabetics. And truly speaking, I feel it is going to be number one even before hypertension, as we are learning over the period of time. The symptomatic patients are also falling more in group of diabetics and hypertensive and asymptomatic. As in day-to-day clinical practice, we have been coming across that 80% are either mildly or asymptomatic, and 15 to 18% are moderately symptomatic, and 2 to 3% are critical. The last 20% are mainly from the diabetic group, unlike the first 80%, which are absolutely controlled or very naive diabetic patient. One of the most commonly reported condition during ICU and hospitalization in COVID patient was diabetes. Prevalence of diabetes among hospitalized patients who were infected was reported to be 7.8%, and probably it is much higher, and which we have been coming across in day-to-day life. Uncontrolled diabetics, people having glycosylated hemoglobin more than 9%, has been linked to 60% increase of hospitalization and pneumonia-related severity during bacterial infection. We did one of the studies here, published in JAPI also, that people who had uncontrolled diabetes, had HbA1c more than 9%, had more CT severity with the same duration of illness. Out of CT severity score of COVID-19, where we take as a 9 to 10 as a cutoff value, most of the diabetic patient in short duration of time had a higher CT severity score with more complication. Diabetes was considered as an independent risk factor for complications, and it has been associated with severe acute respiratory syndrome before also. In hospitalized patient, it has been found that younger the patient, even if it's a diabetic, they will have complications. There'll be higher prevalence in the diabetic patient, and the complications, multi-organ involvement has been very high in diabetic patient. It has been found out that even the comorbid conditions associated with diabetes has been predisposing to the more complications of the COVID patient. As we know, the way the virus finds its way into the body, which acts to the ACE2 receptors and which leads to the multiple complications. All of us know these ACE2 receptors, which are loaded in the respiratory tree, also in the GI tract, adipose tissue, pancreas, etc. So it has been hitting hard. 30 to 40% COVID patients who have never been diabetic are experiencing first-time hyperglycemia, probably because of the preponderance of the ACE2 receptors affecting through the pancreas and the adipose tissue. The potential therapeutic link between COVID-19 and diabetes had been linked, and there has been also mechanism increasing the risk of COVID-19 in diabetes. This is because higher affinity of cellular binding, efficient virus entry, decreased virus clearance in diabetic patient, diminished T cell function in diabetic patient, presence of CVD, and increased susceptibility to hyperinflammation and cytokine storm, which is known to happen in diabetic patient. Potential mechanism increasing susceptibility for COVID-19 in diabetes is very well established. So definitely the incidence of cytokine storm is early in diabetic patient, and it is more significantly, which need to be very careful about. If we look at non-diabetic versus diabetic patient, the cytokine storm has been early and more intense in diabetic patient, more so if glycosylated hemoglobin is more than 9. There's an increased incidence and risk of COVID-19 in diabetic patient. There's an increased affinity of cellular binding and efficient virus entry, decreased virus clearance, have already spoken, increased susceptibility to hyperinflammation and T cell function, which I already talked about. Even short-term hyperglycemia temporarily stuns the innate immune system. So even the transient hyperglycemia brings down the immune status and leads to the increased complication rate. ACE2 expression is reduced in diabetes, possibly due to glycosylation. This might increase the predisposition to severe lung injury and ARDS with COVID-19, and this we need to take into consideration. Diabetes and hypertension, which is most of the time together, can significantly increase the risk of COVID-19 infection, and we need to be very careful about this. Most of the time, in Indian situation, the diabetes is associated with obesity, and evidence suggests that obesity associated with increased risk of severe COVID-19, more so if it coupled up with the diabetes. And this increase in BMI, along with diabetes more so, leads to the respiratory dysfunction, impaired respiratory mechanism, increased airway resistance, impaired gas exchange, low lung volume, and low muscle strength. The comorbid conditions I already talked to you, if associated with nephropathy, the hypertension, insulin resistance, and dyslipidemia all leads to the more COVID-19 associated complication in diabetic patient. High BMI might be an important risk factor for severe course of disease, particularly of pneumonia in such patients, and which is very well established. The increased synthesis of glycosylation and products and pro-inflammatory cytokines, oxidative stress, and production of adhesions molecules that mediate tissue inflammation, which all leads to the more complications and inflammatory cytokine complications more in these patients. The Indian COVID-19 risk score designed for high risk stratification from public health perspective to save the lives. Hence, we need to be very careful if the person is above age of 55 years, male gender, there's a hypertension, there's a diabetes, obesity, chronic heart disease, use of corticosteroids or immunosuppressants of transplant recipient, where we have been hyperglycemia finding very significantly, COPD, asthma, chronic lung disease, and chronic kidney diseases all makes the patient more vulnerable if coupled up with diabetes. Now, what do we do for diagnosis of COVID-19 in diabetic patient? We need to be very proactive. Here, I would like to share with you that RT-PCR, which we consider as a gold standard, has a sensitivity of only 65 to 70%, even if we taken the nasal and throat. Hence, any diabetic patient who has a COVID symptoms, we need not to bank upon a RT-PCR. In 30% cases, it could be negative. The CT sensitivity of COVID diagnosis is almost to the tune of 95 to 98%. So along with the RT-PCR, if any diabetic patient has symptoms matching with the suspected COVID, probably we should resort to an early HRCT test, which is a higher sensitivity, and it has been found out that you can pick up the COVID diagnosis much before, even if the RT-PCR is negative, which is very important, and one need to be very careful about it. Now, potential role of DPP-4 inhibitors is very significant when we talk about COVID-19 and diabetes. DPP-4 degrades incretin like GLP-1 and glucose-dependent insulinotropic polypeptide, thus leading to the reduced insulin secretion and abnormal visceral adipose tissue metabolism. DPP-4 increases inflammation both through catalytic and non-catalytic mechanism, and DPP-4 may be a potential target for preventing and decreasing risk and progression of acute complications that type 2 diabetes may add to COVID-19 infection. Risk of hypoglycemia is relatively lower with DPP-4 inhibitors, avoiding unfavorable hypoglycemia episode during active COVID-19 infection, which can happen sometime. The beneficial effects of DPP-4 inhibitors in COVID-19 infection has been documented. It exerts anti-fibrotic activity, it modulates inflammation, and suppresses T cell proliferation and production of pro-inflammatory cytokine. Hence, one can take the advantage of this situation. Pioglitazone potential role in COVID-19. Evidence suggests that treatment with pioglitazone does not have a rationale in COVID-19 treatment and could ameliorate prognosis of COVID-19 patient with diabetes, but could reduce inflammation and consequent risk of death associated with COVID-19, but not a, it can significantly reduce inflammatory markers like IL-6 and TNF-alpha, but waiting for more evidence to come. ACE and ARBs in COVID-19 infection. Recent evidence suggests that use of ACE and ARB may be beneficial in COVID-19 infection, prevention in diabetes. Several hypotheses proposed regarding the positive effect of ACE and ARB on COVID-19 infection. ACE2 receptor blockade, which overall decrease in inflammation and secondary to ACE and ARB, and hence the patient on these drugs may be allowed to continue with all this effect. There's a little concern about SGLT2 inhibitors in patients with COVID-19, and it is advisable to discontinue or SGLT2 inhibitors due to risk of dehydration or diabetic ketoacidosis. Just we have to take a holistic view if the patient is comfortable tolerating, but preferably not a drug of choice to be continued or to be added. Just take a holistic view, keeping in mind. So these are the drugs which are in trial. There has been the protocol of the COVID-19, which we have been following but whenever we take care of COVID-19 patient with diabetes, we need to make use of antiviral drug. It has been documented beyond doubt that COVID-19 is a prothrombotic disease, and there's a microthrombus documented in the lungs, which becomes more predominant in uncontrolled or a diabetic patient. Hence, it need to be coupled up with the clot dissolving agents. ARDS might require steroids, which may affect the sugar. We need to monitor which is there, which we need to do. Management of diabetic patient with COVID-19. Infection prevention and control measures for patient with suspect or confirmed COVID-19 is very important. Give suspect patient a triple layer surgical mask. Direct patient to separate area and isolation room if available. Keep at least 1 meter. That's standard protocols. We need to follow it up. And droplet infection need to be avoided. All of us know that the patient is coughing or sneezing up to 3 feet, which can go for. So we need to follow all the same protocols with the diabetic patient also. For COVID-19 patients with diabetes, optimal glycemic control and tailored therapeutic approach to be formulated based on clinical classification, coexisting comorbid conditions, age, and other things. Blood glucose must be controlled for all the patients during hospitalization to monitor disease progress and avoid aggregation. So little more careful control of the sugar. More so, there is an accelerated hyperglycemia in COVID-19 patient. During 4-week follow-up period after discharge, blood glucose homeostasis must be maintained continuously due to lower immune response and risk infection. I would like to share with you that this hyperglycemia or uncontrolled diabetes need to be monitored for at least 4 to 6 weeks. Many of diabetic patients, because of cytokine storm, receives the monoclonal antibodies, that is tocilizumab, etc., which has the effect of immune suppression even as late as 4 to 6 weeks. So uncontrolled diabetics who have received the monoclonal antibody like tocilizumab might be prone for a secondary infection. Hence, it is imperative to make very good control of diabetes for 4 to 6 weeks, which is very important. So if you look at this mild COVID-19 cases, we may continue. Previous medication regimes must be evaluated and followed as appropriate. In ordinary COVID-19 patient, subcutaneous insulin injections, including rapid-acting prandial and basal insulins or premixed insulin regimes can be thought of. And in ketoacidosis, we need to manage. So we need to manage if the patient is stable, earlier medications may be continued, but in a new onset hyperglycemia uncontrolled, basal bolus could be a good drug of choice. So when we talk about management of diabetes in a patient with COVID-19, we could have different situations. Diabetes with asymptomatic COVID, mild and moderate disease, moderate to severe disease, severe, and this thing also. So holistic management, it applies the same principle like any other diabetic patient. We need to follow all these protocols. ACE inhibitors and ARBs may be continued if the patient is already there. Lifestyle modification, metformin, very well spoken by Dr. A.K. Singh, we could continue in mild to mild cases. While we have a lot of galaxy of treatment available, here just we could use a premix or we can use a basal bolus to have the good glycemic control, which is there. Now, in case of patient with mild to moderate disease, we need to be very careful not to go ahead with the SGLT2 inhibitors. DPP4 inhibitors would be good drug of choice to make use of it. In type 1 diabetic patient, those who are on insulin, which is very important that patient never stops insulin, blood sugar should be monitored. Just like any other type 1 diabetic, we need to be very intense in having good glycemic control and to prevent the diabetic ketoacidosis. In moderate to severe, I think the insulin stays the drug and the method of choice to have a good glycemic control, and we need to be very careful about it. And insulin continues to be very important drug. The treatment outcome with hydroxychloroquine in COVID-19 hospitalized patient has also been very encouraging, as we know that it prevents the degradation of insulin, and in mild to moderate cases, it can be thought of using, which has also antiviral potentiality, which can be thought of. This is very important. The main objective of COVID-19 and diabetic guidance for home care, almost 80% patients these days are resorting for home isolation or home quarantine. So we need to give a strong message, a strong protocol for diabetic control of COVID-19 patient who opts for home quarantine. Minimize morbidity and mortality in care of home, which is very important. There has to be very strong communication with the doctor. The monitoring has to be multifold because many of these patients are requiring steroids, and hence the monitoring has to be very intense and treatment need to be tailored accordingly. Equip home care with sufficient blood glucose strips, keep hypoglycemic kit ready, and patient need to have all the clear instruction. I think the same protocol of a good diabetic care has to be monitored at 80% people who require home quarantine and in communication with doctor. He need to be constant in touch with the doctor with various methods of communication for monitoring the proper sugar, and we need to prevent the hypoglycemia also, which is very
I think
important.
I'm afraid we may not have time for case scenario.
No. I'll just like to share you, sir, that all I'm talking very practical thing that all diabetic patient, they have much advanced disease in a shorter duration. This is some pictures I wanted to show that all diabetic patient need to be screened very fast. If you take the matching age group, matching duration of illness, the CT severity score in diabetics is much higher. Hence, we need to be very proactive in picking up the lung injuries in diabetic. I wanted to show some x-rays, which I'll quickly run through, that diabetic patients have very high CT scoring. So the bottom line is that I'm not talking about the diabetic, but all diabetic patient and poorly controlled sugar patient should have very early CT scan of chest, even if they are in a happy hypoxia state, because of very high severity score in diabetic patient in short duration of time. This is one carrier message I want to give you. And secondly, those who are not possible to take them for ultrasound, CT, we should go for every diabetic patient need to be subjected to ultrasound in COVID-19. So this is one I'll conclude my saying that hypertension and diabetes is more common comorbid condition with COVID-19. Diabetic patient will have different degree of severity of infection and must be managed accordingly. So early pickup of pulmonary infiltration of diabetes is my strong message which I like to convey. And every diabetic patient should be subjected, suspected or diagnosed COVID for an early HRCT and early cytokine storm and a periodical repetition of HRCT and repetition of cytokine storm parameter to prevent the complications. Thank you.
Thank you so much, sir. I'm very sorry that you had excellent case scenario and x-rays to be shown, but we do not have time to do that. I'm very, very sorry for that. Excellent presentation and very nice disposition of what happens when these two coexist, COVID and the diabetes together. And you have clearly told how do you manage diabetes at a different severity of the disease and what will be the outcome. And you also cautioned us about what should be done in a patient who is seriously ill, both in terms of severity of diabetes as well as severity of the COVID illness itself. We have shown very clearly when the A1C is more than 9%, it is demonstrated by your own study that the CT severity was very high, indicating that the severity of ARDS and the age influencing factor, other comorbidities coming in, play a lot of role in outcome of COVID illness in a patient who is diabetic. Thank you so much for this presentation. We have also explained about mechanism of cytokine storm how it interplays, then role of importance of early diagnosis, early isolation, and quick attention, both to diabetes as well as COVID illness-related treatment. And you have spoken about all other OHAs and caution about SGLT2 inhibitors in COVID illness. And also, you have spoken about the management of diabetes and different strategies and different severity. Now, I let it open for any questions across the board. If there are any questions we have just propped up.
So we have just 1 minute.
Okay. One question to Dr. A.K. Singh. You told mild to moderate illness, there is no need to worry. We can continue the metformin, those who are already on. Would you recommend looking at inflammatory markers profile in a COVID illness patient with a diabetic in deciding whether to continue or not, instead of only severity of the illness? Let us say inflammatory markers are high, though patient is apparently mild as the disease score is concerned, would you still recommend to continue metformin?
Of course, I would recommend to continue because this is drug which is working through the anti-inflammatory effect. So the entire benefit of metformin goes to have working through induction through the AMPK, which is a potent anti-inflammatory agent. So as I've shown you the data from diabetes care by the Chen group suggesting a significant reduction in interleukin 6 in the metformin arm. So this suggests that the metformin should be, or rather I would say must be continued in patients who had a higher inflammatory marker. This is a drug where it will work. So when we do have evidence, you should continue.
Thank you, thank you so much. I'm told by Krishna that it is only 1 minute that was there. Thank you so much. Thank the ADA Primer for giving me this opportunity. Any question related to both presentation of Sudhir Bhandari as well as A.K. Singh can be posted. They will be replayed or mailed across those who have asked question. And I thank for giving me this opportunity to chair this session. Nice to see Dr. Rajiv Chawla and Sangram Biradar. Thank you, Arvind. Thank you, Krishna.
Thank you, sir. Thank you very much. So we move on to the next session, and this will be on, it's a potpourri session, and we have Dr. Sangram Biradar and Dr. Suman to take over and share the session. Please, gentlemen, the session is all yours.
Thank you, sir. This is Dr. Suman, actually. First of all, I would just like to thank ADA for giving us an opportunity. Well, I feel that, virtual conference is the way out. Probably, it becomes very easy for us, for the practitioners, whenever they are free, they can come back and, relook on the talks, what they have missed out. I think it's something good, actually, but somehow the pharma brothers are not interested in the virtual conference. I feel that definitely is one of the good conference. Well, today's potpourri called, first is a talk by Dr. Rajiv Chawla. Can I have the Dr. Rajiv Chawla's... Yeah, Dr. Rajiv Chawla is well known to all of us. I think Dr. Rajiv Chawla is immediate past president of RxDI, National Chapter. And today he's going to talk about the AGIs and its relevance in the clinical practice. Over to you, sir. We'll not delay. We'll just start off.
Thank you, Dr. Suman, for those kind words. Thanks a lot, Dr. Krishna and Dr. Arvind, the whole Primer ADA team for this opportunity to be part of very, very prestigious conference. Task you have assigned to me is to discuss about AGIs and its relevance in clinical practice, even in today's scenario. So over next 20 minutes, I'll try to do justice to AGI being still part of all algorithm, maybe our ADAs or even recently released RSSDI Endocrine Society Joint Consensus 2020 also. Well, flow of my presentation will be first to discuss what pathogenesis of type 2 diabetes and its whether AGIs are still relevant in terms of pathogenesis, AGIs, what unique mode of action they have, and whether they are still relevant in terms of efficacy as well as extra glycemic benefits other than their HETEROGENEITY reduction. We all know the physiology of type 2 diabetes. For 50 years, we knew that it is an interplay between insulin resistance and growing beta cell dysfunction. Initially, beta cell trying to compensate for insulin resistance by hyperinsulinemia, gradually a stage of IGT and over diabetes with persistent hyperglycemia. And we know that in setting of type 2 diabetes, not only you have increased insulin resistance into adipose tissue and muscles, but also into the liver, contributing through hepatic glucose production. And of course, as I said, a growing beta cell dysfunction, again contributing towards persistent hyperglycemia. So not only you're going to end up with acute complication, but also long-term micro as well as macro complication if you are not able to address to issue of persistent hyperglycemia. Let's quickly review our physiology. We know that brush border of small intestine harbors alpha glucosidase enzymes. It has number of enzymes like maltase, glucoinvertase, glucosidosucrase, important ones, then glucosidoinvertase, and also alpha-1,4-glucosidase. And we know that these alpha glucosidase, they break down starch from polysaccharide to disaccharide to oligo and monosaccharides. And it is the pancreatic amylase, which is the major enzyme of starch digestion, resulting in short oligosaccharides or monosaccharides. And we have both saliva as well as pancreatic alpha amylase working on that mechanism. This is a wonderful star study by Dr. Shashank, got published in BMJ Open 2014, where he has through a questionnaire, and it was actually a national survey where they found that carbohydrate intake, unfortunately, in Indian diet, whether you talk about North Indian diet or Southern diet or East or West, it is almost about 65%, which is a huge carbohydrate load. And unfortunately, because of that, postprandial glucose in almost 2/3 of patients still remains above the target, that is more than 180 milligram. And similar findings were seen across all zones in this study. Well, another India Heart 2 study, which has again tried to establish, it's got published in Diabetes Care 2008, talked about various population, whether you talk about Central Eastern Europe or you talk about Western Europe, Canada, South Africa, or West Asia, whether you have higher carbohydrate intake. And this is what was actually elaborated from the Indian population, that Indians, they tend to have much higher carbohydrate load, and for every meal they have much higher postprandial excursion, maybe it is at breakfast, lunch, or maybe at dinner. Not only that, we consume higher carbohydrate, close to 65%, which is contributing towards higher postprandial hyperglycemia. Unfortunately, by virtue of ethnicity, we also have higher glycemic response for 5 common foods which was seen in Asian Indians as compared to the Caucasian, whether it was sweet meal biscuit, sweet biscuit, or malted whole wheat cereal, or malted wheat cereal, or even cereal biscuit with milk. You could see that in Caucasian patient, although it was a small data on 34 patients from Caucasian and 13 patients from Asian, but trend was seen that Asian tend to have much higher glycemic response with the same amount of meal what as compared to the Caucasian population. And this got published in British Journal of Nutrition 2008, and most of these values were p-value wise significant. Even Mohan et al. 2009 in their core study, where they enrolled 1800 patients, they have tried to work out a association between dietary carbohydrates and glycemic load with risk of developing type 2 diabetes. Again, this got published in British Journal of Nutrition 2009. They concluded that refined grain was associated with high risk of developing type 2 diabetes. Overall carbohydrate amount as well as the glycemic are directly associated with increased risk of developing type 2 diabetes. But if you consume higher dietary fiber, then obviously the risk for developing type 2 diabetes was much lesser as compared to someone who have less amount of dietary fiber also. So we know that if you follow the natural course of the disease and the history, it is actually tends more in peripheral tissue. I talked about in adipose tissue, and consequently we have a suppression of hepatic glucose due to insulin deficiency, though that does not happen because of low levels of insulin. So that is also contributing towards higher postprandial sugar. It could be to the extent of almost 25 gram glucose as if getting released from the liver, even in a post-fed stage, contributing towards postprandial sugar. So again, very good data, which was by Monier et al. In 2003 said that if you are having a patient who has HbA1c close to 10, it is fasting sugar which contributes almost 70% towards the value of HbA1c, and it is a postprandial sugar, which becomes much more important once you are handling a patient who has HbA1c close to 7.5 between 8.5. But unfortunately, in Indian patients or in Asian patients, again, this study by Wang et al. In Diabetes Metabolic Research Review 2011 told you that if you are handling an Asian patient, not only it is the postprandial sugar which is important at an HbA1c of 7.5 or 8, but even at a higher HbA1c close to 10 or more than 10, there also 50% contribution still gets from the postprandial sugar. That means postprandial sugar in Asian or for that matter in Indian patient remain important, whether it is higher HbA1c or a lower HbA1c classically seen in Caucasian patient. So we know that Indian diabetics, as per STAR study, they tend to have much higher carbohydrate load, almost 65%. I've shown you in STAR study that 2/3 of patients, they don't meet postprandial target. Actually, it exceeds more than 180 mg/% because of higher carbohydrate load. So I think there is a need to address this high carbohydrate meal either through diet modification. But do you think that it actually works in clinical practice? Even if you tell southern patient not to take rice, they are going to take rice. And if you tell northern patient not to consume too high fat diet or pranthas or something, even then it is not practical. So possibly we need to have an agent which reduces the absorption of carbohydrate to routine management of Indian diabetic patient to control postprandial hyperglycemia in these patients. And we have option of 3 AGIs. Acarbose, we know, which has been a most tested molecule. It competes with polysaccharide and oligosaccharide, whereas migdalol and voglibos, they compete with disaccharide. So acarbose inhibits primarily through alpha glucosidase in the following order. It is glucoamylase, then sucrase, maltase, and isomaltase, while acarbose also inhibits simultaneously ciliary as well as pancreatic amylase also. That is why it tends to have much better postprandial correction as compared to maybe migdalol or voglibos also. And it is very rightly said that possibly prevention is the key, because even if you are consuming almost 65% of carbohydrate and you are simultaneously on one of the AGIs, maybe acarbose or voglibos, you have lesser amount of glucose getting absorbed from the small intestine, from the jejunum ileum towards the terminal ileum up to the colon. So you have less insulin release, lesser amount of hyperinsulinemia. So actually there is going to be a protection to the beta cell because of less challenge on the beta cell, and that will also result in improvement of insulin sensitivity, not only by improvement in GLUT4 levels, but also there is going to be better levels of insulin because of local GLP release as a result of polysaccharides lasting to terminal ileum or up to the colon. So do you think that AGIs today in practice, they meet that criteria of having good efficacy in terms of HbA1c reduction? Very true. Cochrane systematic review and meta-analysis of acarbose 28 trials, which were placebo-controlled randomized trial, have shown that HbA1c reduction with acarbose was as high as 0.8%. Fasting reduction was 20 milligram, and postprandial reduction was close to 42 milligram, which is very, very significant. Seeing that it was only at 50 milligram TDS dose, which is an optimum dose. Any drug for that matter will not lead on to a higher HbA1c reduction more than 0.9 for one until it is insulin or a GLP-1 analog. Another meta-analysis has shown, which is from 46 study, that if you are doing or using the same drug in Eastern population where they consume too much of high carbohydrate, then obviously HbA1c reduction will be even greater. It could be to the extent of 1.454 versus the Western diet where it could be only 0.52 because their carbohydrate intake is much lesser. That means you have an additional 1% HbA1c reduction in Asian or maybe for that matter in Indian patients also. And this is what GlucoVIP Indian data has also tried to establish. Close to 2,000 patients from India in this trial of 15,000 group have shown that over 12 weeks, there was a significant HbA1c reduction by 1% and almost 80% achieved the targets even at a dose less than 150 milligram per day with acarbose. There was a significant fasting reduction by 38 milligram and postprandial reduction by close to 75 milligram, which is very, very significant with any drug for that matter. And another trial from China on 788 patients, those who were drug naive, it was a 48-week trial, randomized trial, in newly diagnosed type 2 diabetic patient, where again, those patients who were having baseline HbA1c 7.5, they were either added on metformin or on acarbose, and you could see that a similar HbA1c reduction with metformin and acarbose 1.1%, with higher postprandial regulation or reduction with acarbose of 55 milligram versus metformin 42 milligram. So this study also concluded that newly diagnosed type 2 diabetic patients with exaggerated postprandial excursion could actually be the better candidate for starting maybe on AGIs, even as compared to the metformin arm. Another trial, which is very, very recent, got published in 2019 only. It is a comparison between voglibose and acarbose in patients with type 2 diabetes who were poorly controlled on metformin, got published in 2019. There were 156 patients in each arm, and again in this it was seen that patients in acarbose arm had little better HbA1c correction, better reduction of fasting, as well as 2 hours post-meal reduction, and actually weight reduction was also little better as compared to the voglibose arm because of the enzymes it handles, I told you right in the beginning. That is why possibly HbA1c reduction also seems to be little greater with acarbose as compared to voglibose, although voglibose in terms of tolerance is a better drug. Another phase 3 study from India where 230 patients type 2 diabetics who received acarbose plus metformin versus only metformin and placebo, BD or TDS over 12 weeks. Again, the arm which was on acarbose along with metformin, their HbA1c reduction was very, very significant. It was 1.76 as compared to alone metformin, where it was 1.06. So a significant difference of almost 0.7%. And there was a much higher postprandial as well as fasting correction in arm, which was simultaneously on acarbose with metformin. And again, although this is not a head-to-head comparison, but it is understood from all the phase 3 studies and meta-analysis that all oral anti-diabetics drugs, they have broadly similar efficacy. Whether you talk about DPP-4 almost up to 0.9%, it's a systematic drug which is designed to increase beta cell secretion and beta cell expression. Acarbose, which is a non-systemic therapy, but still gets you almost 0.5 to 1% HbA1c reduction, primarily through postprandial glucose regulation, and SGLT2, which is of course the flavor of the day. We know HbA1c reduction there also is almost close to 1%. Again, it is a systematic treatment which is designed to increase urinary glucose excretion or glycosuria, and all these mechanisms are beta cell independent mechanism. Another meta-analysis, it's a network meta-analysis of 62 randomized controlled trial in almost 32,000 participants, where again it was seen whether you are using a drug like acarbose or elogliptin, canagliflozin, dapagliflozin, glimepiride, linagliptin, sexa, or any DPP-4, by and large 2 or 3 trials in each group, they have seen that HbA1c reduction was absolutely comparable, whether it was DPP-4 or sulfonylurea or maybe even SGLT2 also. And another important thing is that with AGIs, you have durability of glycemic reduction because it is independent of beta cell mediated mechanism. So 5-year observational study with acarbose has shown that not only that HbA1c reduction, which came in the beginning, is going to last even fasting, as well as 2-hour postprandial regulation or reduction is also going to last for almost 5 years as compared to DPP-4 or sulfonylurea, more so for sulfonylurea, where we know that every 1 to 2 years you tend to lose that glycemic benefit because it is a beta cell mediated mechanism. Now, another aspect is whether we have any other benefits from AGIs. We have already proven these are wonderful drugs in terms of glycemic reduction, whether you use it versus metformin or in addition to metformin, or whether you try to get the HbA1c reduction in comparison with DPP-4, sulfonylurea, or maybe SGLT2 inhibitors. But then there are extra glycemic benefits in AGIs. It gets you insulin sparing effect. There is going to be a natural incretin enhancing effect. There is going to be a body weight reduction, and also trial has shown that there could be diabetes prevention, as was shown in STOP NLDM trial. And the glycemic variability is much lesser with AGIs, and you also have gut-friendly microbiota also developing. It's a symbiotic mechanism, and of course, because of that reduction in antioxidant, you have anti-inflammatory mechanism, and reduction in CV benefits also have been seen with AGIs also. This is again, you could see that if patient is on AGIs, not only there is going to be a post-glucose reduction, this is also going to reduce insulin levels, I have told you in the beginning. So lesser challenge on the beta cell. So it is something like an insulin sparing effect, which is very, very important in Asian patient, where we tend to lose beta cell mass quite early during the course of the disease. That is why, because of this mechanism, not only you have lesser hypoglycemia as compared to sulfonylurea, you actually end up with significant body weight, more so versus drugs like sulfonylurea or insulin. Of course, GLP-1 or SGLT2 in any case will also get good amount of weight reduction during their course. Carbs, as we know, this is again a very good data where they have established that there is going to be a GLP-1 increase in levels, maybe by 1 to 2% or maybe up to 3 times also many times. It starts as early as with the first dose or maybe even 2 weeks of acarbose treatment in normal subjects or those patients who are type 2 diabetic. And till 24 weeks, it has been seen that there is going to be an increase in GLP-1 values, both fasting as well as significantly in the postprandial phase. So that is also going to contribute not only towards reduction in HbA1c, it is also going to get all extra glycemic benefits, and some amount of weight reduction is also going to be there with increase in GLP-1 value also. And here is a comparison versus alogliptin, that if you add a drug like acarbose or any AGI with alogliptin, you could see that there is going to be not only a post-glucose reduction, but also there is going to be a significant increase in GLP values in the arm, which was simultaneously on AGIs other than the alogliptin. And this I have already discussed about, that actually there could be a reduction in new incidence of development of type 2 diabetes in 25% patient, what has been demonstrated in STOP NIDDM trial, a trial on almost 1400 patients, which lasted for 3.3 years. Actually, there was an increase in the reversion also to normal glucose tolerance in almost 1/3 of patients, which was p-value wise very, very significant. This is JCM real world data, again telling you a very robust study telling about real world evidence of acarbose as a second line oral anti-diabetic drug or as an OHA for reduction of atherosclerotic cardiovascular event in patients who are already on sulfonylurea metformin, a data of almost 14,000 patients, where ischemic stroke has gone down by 33%. Overall hospitalization because of atherosclerotic event is going down by 31%, and hospitalization because of hypoglycemia is significantly down versus sulfonylurea, because with acarbose you are not going to land up with hypoglycemia. This is a current international consensus published in 2019 talking about time in range, which is very, very important these days when we talk of glycemic variability, because with HbA1c possibly you may not be able to identify those excursions or hypos alone if you are doing only an HbA1c, because it also fails to identify the magnitude as well as frequency of not only intra but also intraday glucose variation also. And we know there are going to be issues with HbA1c interpretation in those patients who have anemia, hemoglobinopathies, iron deficiency, and maybe pregnancy also, because of lot many confounding factors. So glycemic variability is much lesser with AGIs. Again, this study with alogliptin over 3 days with the CGMS, they have tried to establish that if you just add acarbose in these patients, there is going to be a significant reduction in postprandial excursion in the group which was on acarbose, and it immediately comes on day 1. It was a 3-day monitoring by CGMS also. Another trial, which is a multi-center randomized double-blind placebo trial, those patients were already on vildagliptin and metformin. They were either added placebo or they were added acarbose in this arm, and there was a significant reduction in MAGE, which is a mean amplitude of glycemic excursion, and standard deviation also came down, and time above range, which is very, very important. I told you time in range today is very, very important. Ideally, your patient should have at least 70% time in range, and time above range should be less than 25%. So in this trial, it was seen that if you just add acarbose, time above range becomes only for 8% as compared to in the group which is only on vilda, metformin plus placebo, where it was seen in 31% of patients. So I think even if you add a drug like AGIs in those patients who are already on premix insulin versus metformin therapy, in this trial this was versus acarbose and versus metformin in all those patients who were already on premix insulin, and again it was seen that variation coefficient was much lesser. That means glycemic variability is much lesser in the arm which is on AGIs. MAGE also gets addressed to, and standard deviation also becomes much lesser in the group which is on acarbose in addition to premix insulin. So you have all the favorable benefits coming from any AGIs, and with acarbose or voglibos, with acarbose, we know that there is going to be a higher polysaccharide load towards the terminal ileum and the colon. So this is what is going to increase colonic bacterial mass. So it facilitates production of short chain fatty acids and H2 gas. So that improves overall health of the tissues, and it also mediates suppression of pro-inflammatory markers like cytokine, interleukin, TNF-alpha, or IL-6, which are very, very important into this scenario also. So if patient is like on metformin, is also on a drug like AGI, there are going to be lot many benefits in terms of reduction.
Just wanted to remind you on the time.
Last two slides, pro-inflammatory benefits, and you have CV benefits also. And this is what has been shown, that there's going to be a better abundance of 5 genera, those patients who are on acarbose versus those patients who are not. And actually those negative genera, which can induce insulin resistance, also going to be down. That is why typically all guidelines, especially when we talk about Japanese, Korean, Chinese, Taiwan guidelines, or our Indian guidelines, which got released this month as RSSDI endocrine and consensus, where we have said that post-meal hypoglycemia is harmful. It definitely needs to be addressed, because we tend to consume much higher carbohydrate load, and by virtue of our ethnicity, beta cell mass loss is also more, so we have much higher postprandial excursion also. So to conclude, Indian type 2 diabetic patient, they are consuming too much of carbohydrate, which adds towards postprandial sugar. AGIs tend to inhibit that carbohydrate absorption from the gut in a typical manner, what I have shown you. So they not only correct postprandial hyperglycemia, overall HbA1c, weight reduction, they also have extra glycemic benefits also, and CV risk reduction is also there. So even in this new era of newer therapies, AGIs are still being recommended by all guidelines, also by RSSDI endocrine giant consensus, which got recently published. Thank you very much for your patience listening. If you have any questions, I'm more than happy to answer them.
Sir, I think we'll take the questions late.
Yeah,
After the second speaker, I think I would like to thank sir actually for really elaborated talk on AGIs. Probably this is an era of gliptins and probably SGLT2s, whereas AGIs is really taking a backseat. In fact, you did a great justice of talking about AGIs and enlightening us all this. I just hand over the mic to my co-speaker, my co-chairperson, to introduce the next speaker. Sir.
Good afternoon, everybody. First, I thank the ADA Primer family, Dr. Krishna and others, for giving me an opportunity to chair the session. I welcome Dr. Vijay Panikar, a close friend of mine. He is known for his talks. He is an honorary consultant, Department of Endocrinology, Diabetes and Metabolism Hospital, Mumbai. He is the organizing chairman of RxSDI National Conference in Mumbai. He has several publications to his credit, pioneering work on triple drug therapy and Lowe's co-author for RxSDI recommendations and authored RxSDI guidelines. And he has developed so many newer frontiers for pioglitazone. He is the man for proponent for pioglitazone in the country. So over to you, Dr. Panikar, for your talk for re-examining the role of glitazones in clinical care.
Thank you, Dr. Sangram, for a very kind introduction. Let me I can't. How do I?
सर वापस घूम गया शेयर स्क्रीन वापस घूम गया आपका
स्क्रीन का ही लोचा होता है
at the bottom sir share screen green
बॉटम में हाँ अभी आया है
आप बॉटम देख रहे हो ना बराबर से
हाँ मेरा नहीं बाकी Yeah. Can you see me now? Yes.
Yes, sir.
Good morning, ladies and gentlemen. The topic given to me is re-examining the role of type 2 of TZD in clinical practice. I don't think there is re-examining. It was always there, but we had pushed it to the background. Let us look at the Indian scene. You know, Indians developed diabetes 10 years earlier than the Caucasians. And they have more cardiovascular problems than the Caucasians. Look at this. A person at 30 years who is a non-diabetic can live up to 75 years. This is the Indian data. But the moment he becomes diabetic, at the age of 30, he stands to lose 14.5 years of his life. So when we are treating a diabetic, we should be looking at how we can prevent him losing that 14.5 years of his life. If you look at diabetics, 80% of type 2 diabetics will ultimately develop a macrovascular disease, whether it is cardiovascular, stroke, or a peripheral vascular disease. Now the question is, everybody talks of HbA1c, glycemic control, and so on and so forth. Does intensive glucose control really prevent CVD? This is the UKPDA study. Initially, if you look at myocardial infarction, 16%, all-cause mortality reduced by 10%. And after a 10-year follow-up, we had a very similar thing. So this is the one study which after 20 years is giving you a 15% benefit. There were other major studies which came in real world. You had the ACCORD, the ADVANCE, and the VADT, where they tried to get the HbA1c down to 6.5, hoping that things would be much better and give a much better outcome. But what was the real outcome? It showed little benefit. Other than nephropathy in the ACCORD and ADVANCE study, the ACCORD was stopped because of increased mortality, weight gain, and hypoglycemia. Now, if you look at all these studies which looked at tight glycemic controls, the UKPDA, DCCT, EDIC was in type 1 diabetics, ACCORD, ADVANCE, initial phase, nowhere there is a decrease in cardiovascular mortality or CVD. But in ACCORD, there was an increase. But if you see in a follow-up, long-term follow-up, UKPDS showed a little decrease in mortality, but none of the others, no tight control has been helpful. So what is the message, big message for CVD in diabetes? That good glycemic control, you can have an HbA1c of 6.5 and still die of a heart attack. So it does not prevent a myocardial infarction. This is the Nurses' Health Study. Almost over 1 lakh of patients, 35 to 55 years, followed up for 20 years. And what were they looking for? Relative risk of myocardial infarction and stroke. This is before diabetes. There was no diabetes, before diabetes diagnosis, after diabetes diagnosis. I won't go into the details of this. But what did this study really tell us? That the elevated risk for cardiovascular disease began at least 15 years before the diagnosis of diabetes. So what are we talking about glycemic control? There are other factors which are more important than just plain glycemia to prevent macrovascular disease in diabetics. So what is that? What are the risk factors? Mainly insulin resistance, which in our country has been shown to start very early in life. In fact, teenagers, and in fact, they have shown infants with insulin resistance. Hypertension, yes, is a part and parcel of being a diabetic. 50% of diabetics have hypertension. Elevated LDL cholesterol, high triglyceride, low HDL, chronic vascular inflammation, pro-atherothrombotic state, all these are driven by insulin resistance. What is the role of insulin resistance in macrovascular disease? Almost 83% of diabetics have insulin resistance. And insulin resistance itself is a risk factor for cardiovascular disease. And insulin resistance promotes atherosclerosis even before it produces diabetes. That is the unfortunate reality. We have these two large prospective studies, the Helsinki study and the Verona diabetes complication study, which demonstrated that insulin resistance is a very strong independent predictor of cardiovascular disease, myocardial infarction, and stroke. So what is insulin resistance? There is increase in free fatty acid, resistance, leptin, TNF-alpha, and decrease in the good adiponectin. And what does this really lead to? It leads to a gamut of problems. IGT, and if there is insulin deficiency, becomes the diabetic. There's a classic dyslipidemia of diabetes driven by insulin resistance, non-alcoholic fatty liver disease, hypertension, endothelial dysfunction, inflammation, thrombosis. So this is a very atherogenic milieu that is created by insulin resistance. And all of them interact with each other to cause cardiovascular disease or macrovascular disease. Now, clinical manifestations, classically insulin resistance leads to glucose toxicity, increased lipotoxicity. There is a mobilization of free fatty acid, leads to fatty liver, decreased adiponectin. And
You have type 2 diabetes, glycemic disorders, dyslipidemia, which is classic of diabetes driven by insulin resistance, hypertension, endothelial dysfunction, and ultimately leads to diabetes, hypertension, atherosclerotic cardiovascular disease, heart failure, sleep apnea, peripheral vascular disease, stroke, PCOS, and NASH. Non-alcoholic fatty liver disease, the next epidemic on the horizon in India. Diabetes and insulin resistance in Indians, we are an insulin resistant population. And when fat is distributed preferentially in the abdominal area, that insulin mediated disposal is reduced, and Asian Indians are more prone to develop abdominal obesity compared to other ethnicity. So we are a population who are insulin resistant. This is a classic example of the thin fat Indian. That's Professor Yagnik and Yudzik. Both have a BMI of 22.3, but look at the fat content. Yudzik has 9.1 and Yagnik has 21.1. These are thin fat Indians. We are insulin resistant. And insulin resistance is highest in Asian Indians, and this is found in the UKPDS trial also. These are n number of studies which have been done, which show that insulin resistance have been demonstrated even in adolescents in the Indian population. So we ethnically are insulin resistant, and that is why we develop insulin much earlier. That is why we develop macrovascular disease much earlier and much worse than most others. Now, is there any evidence that treating insulin resistance can help or can prevent macrovascular disease? What are the treatment options for insulin resistance? The non-pharmacological is diet, exercise, weight reduction. Any of these will help in reducing reducing insulin resistance. The pharmacological treatment are only two drugs, metformin and pioglitazone, and that combination works beautifully in reducing insulin resistance. These are the diabetes prevention studies where there are all patients with IGT and where they looked at lifestyle modification, diet and exercise and showed very significant improvement. What was the basic thing? Reducing insulin resistance. And drugs were also pharmacological intervention. You have the tripod study, the pipod study, the DEEM. These were all using the TZD, which showed very significant. In fact, ACT now study showed almost 80% prevention in type 2 onset of type 2 diabetes. Let us look at this IRIS study. This study was done in non-diabetic patients who had a recent TIA or ischemic stroke. They checked them for insulin resistance, did their HOMA. If the HOMA was more than 3 and no history of heart failure, they were put on either a placebo or a pioglitazone 15 to 45 milligrams for 5 years. And what were they looking for? Fatal, non-fatal MI or stroke. And what did they find at the end of 5 years? That recurrent stroke reduction by 24%, myocardial infarction reduction by 24%, and new onset diabetes reduced by 24%. Mind you, this was treating non-diabetic patients with insulin resistance with the pioglitazone, telling us that there is a very significant improvement in macrovascular outcomes. So this is for the first time that a therapy directed at insulin resistance has been shown to prevent cardiovascular and cerebrovascular events in patients. Now, effect of pioglitazone on cardiovascular risk factors and biomarkers. There is a significant increase in HDL cholesterol, which is a strong marker for CV mortality in patients with type 2 diabetes. It decreases triglycerides, it increases HDL cholesterol. And what are the studies? There are 4 randomized controlled studies which have shown that pioglitazone has anti-atherogenic and cardioprotective effects. You have the PROACTIVE study, the Chicago, Periscope, IRIS, several meta-analyses and large observational studies are there. Let us just quickly go through the PROACTIVE study. What was the PROACTIVE study? It was effect of pioglitazone on recurrent myocardial infarction in almost 2,500 patients who had a previous myocardial infarction. So they already had a myocardial infarction and they were put on pioglitazone. And what did they find? That fatal, non-fatal MI reduced by 28% at the end of 36 months. Acute coronary syndrome reduced by 37% in the group given pioglitazone. Stroke reduction was 47%, whereas the IRIS study showed a 24%. In fact, because PROACTIVE study showed this 47% reduction, that is the reason why the IRIS study was done to see whether in non-diabetics they could prevent recurrence of stroke. Now, when you look at fatal and non-fatal MI, this is a Good reference here. But when you look at a statin which is given, see, statin takes 6 years to give you a 25% reduction. At 3 years, there is hardly any change. Look at that, 3 years. You give statin for 3 years and you don't have anything. But when you give a pioglitazone, at 3 years, you have a 19% reduction in fatal and non-fatal MI. So pioglitazone significantly reduced in the proactive study. Non-fatal MI by 28%, acute coronary syndrome by 37%, secondary stroke in patients with previous stroke by 47% as opposed to 24% in the IRIS study. Incidence of heart failure was definitely increased, but there was no increase in deaths in those patients who had heart failure. So talking of heart failure, proactive 5.7% of the patients compared to 4.1% on the placebo group had heart failure. Interestingly, fewer pioglitazone patients with serious heart failure had a combined endpoint of death and stroke. In fact, there was less death, 35% almost versus 47% in the placebo group, though they had a history of heart failure. So pioglitazone treated patient had a significantly lower rate of progression. This is the lesson from the Chicago and Periscope study, that pioglitazone treated patients had a relatively less progression of coronary atherosclerosis and reduction of carotid intima media thickness. Look at this, the Chicago study compared it with glimepiride. On glimepiride, there is an increase in the carotid intima media thickness, but with pioglitazone, it comes down. These are the other studies which shown the benefit of TZD on intima media thickness. Pioglitazone versus glimepiride in the Periscope study done by Steve Nissen. Steve Nissen was the person who was responsible for killing rosiglitazone. What he has shown is that patients on glimepiride had an increase in the atheroma volume, and these patients, they had done IVUS, intravascular ultrasound, to measure the thrombus and atheroma volume, and after 18 months, redid an IVUS to see that. So the group on pioglitazone obviously did not progress, but showed a decrease in the atheroma volume. So there are metabolically active molecules which link all these things together. And you have the adipocytokines which are atherogenic, the CRP, interleukin, and so on, TNF alpha. Unfortunately, all these are increased in type 2 diabetics. And you have an anti-atherogenic adipocytokine, which is adiponectin, which unfortunately is reduced in type 2 diabetes. The PPAR gamma or TZD, by direct and indirect activation, addresses all these, reduces cytokines, chemokines, etc., and that is how it blunts atherosclerosis. So this is the mechanism by which a pioglitazone would reduce atherosclerosis or prevent the progression of atherosclerosis. This is a very interesting study. Pioglitazone cause and specific mortality in patients with type 2 diabetes from the European multi-database cohort study. In fact, what they looked was patients who are exposed to pio, which was 31,000, and non-exposed to pio, 31,000. And patient years 2.6, 2.7. Now, if you look at the deaths, mortality, cardiovascular mortality was 691 in the pio exposed group. It was 2,000 plus in the non-pio exposed group. Non-cardiovascular death, 972 as opposed to 2,400 plus. All-cause mortality, 1,600 for the very distinctly the patient exposed to pio had a much better outcome. This is the same study. Further, ever exposed to pioglitazone, non-exposed to pioglitazone, mortality rate per 10,000 patient years. Myocardial infarction 467, it is 1,300. Stroke 9264, and so on. There is a definite, even heart failure is less, though pioglitazone is supposed to cause heart failure, but in a patient who does not have a coronary artery disease, pioglitazone will prevent him from getting heart failure. Arrhythmias, renovascular death, sudden death, all are significantly reduced in the pioglitazone group. So to conclude, this analysis suggests that pioglitazone is associated with a decrease in both cardiovascular and non-cardiovascular mortality. Now let us look at beta cell, which is at the heart of diabetic progression. This is from the UK PDS. What they have shown is at the onset of diabetes, more than 50% of beta cells are gone. Probably it is much more. But over a period of 6 years, there is a steady decline in the beta cell. There is an apoptosis of the beta cell. These are about 10 studies using sulfonylurea. Initially, there is a good reduction in HbA1c, but over a period of 5 years, you find that it steadily rises, telling us that the beta cells are dying. These are 8 studies using aglitazone. Initial reduction, and then there is a maintenance. What does this tell us? That probably this drug is preserving the beta cell, delaying or preventing the apoptosis of the beta cell, so you could get a good long-term glycemic control and durable glycemic control. And why does the beta cell die? Beta cell apoptosis, genetic background. Glucotoxicity is a very important factor which kills the beta cell. Lipotoxicity, especially elevated free fatty acids and triglycerides, are very important in accelerating beta cell apoptosis. And all these are driven by insulin resistance. Insulin resistance directly also has an effect. These are just on the sidelines. So how does a glitazone help in preservation of the beta cell function? There's a direct effect on beta cell, amelioration of insulin resistance, which is very important, reduction of plasma free fatty acid, that is reduces the lipotoxicity. But most important is this in yellow, mobilization of toxic lipid metabolites out of the beta cell. That is decreasing lipotoxicity, and that is one of the mechanisms by which it does. So there is a reversal of glucotoxicity, improve pro-insulin-insulin ratio, and decreases the prevalence and severity of amyloid in beta cell. So to sum it up, pioglitazone is the only agent available today that can effectively treat insulin resistance and preserve the beta cell. And these are the beneficial effects which have been shown with pioglitazone use. 47% reduction in secondary stroke, reduction in carotid intima media thickness, all suggesting anti-atherogenic property. 28% reinfarction proactive study, 37% reduction in coronary artery proactive study, stops or delays the progression of coronary atherosclerosis periscope study, MI and stroke and death in patients with CKD, again from the proactive study, decreases microalbuminuria quartet study, 51% mortality reduction in patients on hemodialysis. This is another study. But this is what is new and which is good. Reduction of inflammation and necrosis in NASH. And NASH is driven by insulin resistance across the board. So if you reduce insulin resistance right from day one, your chances of your patient getting NASH or a fatty liver would be minimized. And there is a 50% reduction in risk of hepatocellular CA. These are the benefits of using this drug, which unfortunately is not being used. It has been pushed to the background for some unknown reasons. So what are the favorable weight of evidence for pioglitazone? It reduces insulin resistance, preserves beta cells, very durable glucose lowering, improves lipids, has anti-inflammatory properties, may reduce CV events, and improve non-alcoholic fatty liver disease. Let's come to the unfavorable. Weight gain, congestive heart failure, bone fracture, bladder cancer. This is what keeps people away from it. Let us look at weight gain. The weight gain was significant, but lowering of visceral and hepatic fat is what is significant there. These are MRI pictures. If you look at the subcutaneous fat here, it is 144. And once you give pioglitazone for 16 weeks, the subcutaneous fat goes up to 204. That's a 42% increase in the subcutaneous fat. And the same thing, if you see the visceral fat was 140, it comes down to 105. That is a 25% decrease in visceral fat. So when you give a pioglitazone, there is an increase in body weight, but that is a redistribution of the fat. The visceral fat, which is the virulent fat in our body, is minimized, and the subcutaneous fat, which is docile, is what is increased. So the effect. Come again?
No, I just wanted to remind the time, sir. Another 2 minutes.
Now, pioglitazone and bladder cancer, all the studies have shown there is no significant correlation. I won't go into the details here. See, this pioglitazone is inexpensive, very effective at reducing HbA1c, no evidence of bladder cancer risk, plenty of evidence of cardiovascular benefit. So, To sum up, microvascular damage starts many years before the onset of diabetes. Insulin resistance and its complication and beta cell preservation have to be adequately addressed for positive long-term outcome. And this can be done only with a pioglitazone. If insulin resistance is treated right from day one, we will see lesser macrovascular complications. You will have healthy patients living much longer. Metformin and pio, most durable. Less weight gain with metformin in place. But here, if you add an SGLT2, that becomes an unbeatable combination. Because SGLT2 will take care of the side effects of pio in terms of weight gain, in terms of fluid retention, etc. And plus the renal and cardiovascular benefits of SGLT2 with the cardiovascular benefits of pio would be a deadly, unbeatable combination. Metformin pio gives you the best result when endogenous insulin is present. You should not use this very late in the course of the disease. Right from day one, the moment the patient is diagnosed, he should be on a metformin and pio unless there is a contraindication. So metformin plus pio plus SGLT2 with endogenous insulin, early use of this combination is what an intelligent use would be to give your patient a nice, healthy, good, complication-free, long life. Thank you.
Thank you, Dr. Panikkar, for your excellent deliberation covering all the points. Now the session is open for discussion. Since we are running short of time, I don't think we cannot permit any questions. There are no questions on the chat box also. Anything to be told by Suman?
Nothing, sir. I think we'll just end the session. I think probably it's already late, actually.
Yeah. So once again, I thank Dr. Panikkar for delivering an excellent deliberation.
Thank you.
And Dr. Chawla also. And I thank the ADA Primer family for giving us an opportunity to chair the session. Thank you, one and all.
Thank you.
Thank you very much.
Dr. Suman, and thank you, Dr. Biradar. I now request Dr. Manoj Chawla. He's already here ahead of time, so that's great. So I ask you to take over the session. As we all know, Dr. Manoj Chawla is a diabetologist from Mumbai, so over to you.
Thanks, Bhavna, and thank you, Primer team, for asking me to moderate this other session that I'm passionate about, which is monitoring in diabetes. And we have two wonderful speakers. We're going to be speaking on two aspects of monitoring in diabetes: SMBG in the connected app modes, and of course, then the importance of time in range. So with this, let me introduce the first speaker, Dr. Pramila Kalra. Pramila Kalra is MD DM Endocrinology, and she works as professor and consultant endocrinologist at the Ramaiah Medical College and Hospital, Bengaluru, India. Did her MBBS from King's College, Lucknow, MD Medicine from King's College, Lucknow, and then DM Endocrinology from Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. And Dr. Pramila will be speaking to us on the aspect of using SMBG data intelligently in app-based smartphone digital platforms. Over to you, Dr. Pramila.
Thanks, Dr. Chawla, for the kind introduction. And at the outset, I thank the organizers also for, am I audible? Am I audible?
Yes, ma'am.
Yes.
Yeah. So I thank good afternoon, everyone. And I thank the organizers for inviting me for this talk. And I thanks Dr. Chawla for the introduction. And mine is more of a clinical topic, because till now, for the past two talks, we were discussing a lot of things in diabetes, complicated. And now I'll be talking about a little bit of a clinical topic. So I'll be discussing about using SMBG data intelligently in app-based smartphone digital platform. Now, my talk in the next 20 minutes will be based on this 4 or 5 subheadings, that is a structured self-monitoring of blood glucose, digital app-based solutions, pattern analysis and management, and the integrated personalized diabetes management. Now, we know that self-management tasks in diabetes are not easy. It's quite challenging, because if you tell to the patient that you do monitoring, sometimes it is very difficult. But now what we have seen, especially during the times now with the COVID pandemic, we are seeing that patients are getting more and more ready to use these things in their daily lives, and they are using it, and they were using it before as well, not that they're using it just now, but it has become even more rampant and the acceptance has increased. So this topic becomes more relevant in the present scenario. And we know that mobile technology is one thing which can give us a lot of help in many of the diseases, not only in diabetes, but obviously today we are going to discuss about diabetes, self-management, the glucose management, the glycemic control, and also something about the lifestyle and the medication adherence motivation. Now, talking about the structured self-monitoring of blood glucose, we clearly know that if two patients like this have the same HbA1c, they may have different glycemic fluctuations. And we know that glycemic variability has been clearly shown to have deleterious effect, not only on the endothelial dysfunctions, as well as it leads to more complications, a bad metabolic memory and a bad legacy, and oxidative stress. So we know that this is also an important factor. So it's not only the HbA1c which we need to see, we also need to see how much is the variability. And these are the places where the monitoring of the blood glucose, either by the patient at home or the CGMS, all these things help us. So when we talk about this self-monitoring, we know that is done by the patient or the caregiver at different points. And obviously we get to know about the glycemic variability. We also know about the glycemic status in real time. This is very important because if we come to know something about 10 days later, it may not help, but at the real time, it is very important and the action can be taken then and there. And obviously with this, the changes can be made to the diet, therapy, exercise, and everything, and feedback can be given. Now you can see this chart. Now, if you see the patient's HbA1c has come down from 9.4 to 7.5, but the glycemic variability actually remains unchanged and the patient is getting more hypoglycemia. Now, if you see here, patient has got about 3 hypoglycemic episodes, which have been recorded by the self-monitoring at day 45, 48, and 55. So this is the thing which we are trying to catch from the self-monitoring. Now, what is this structured self-monitoring? This means that the monitoring is done, yes, for sure, but it is done at the right frequency, at the right time, and in the right situation as well. So what are the benefits for patient? We know that structured means that patient is aware what they are doing and why they are doing it. They know what is to do, what is to be done for this. Once they catch something, they know what behavioral modification or how it is to be reported. And obviously the patient is an active participant in that. And for the physician, definitely it gives a more reliable data and obviously more involvement of the patient. But there have been many studies on effectiveness. Some studies have shown positive results. Most of the studies, I should say, have shown positive results. Now, this was one which was recently published last year about the effectiveness of smartphone app-based interactive management on glycemic control. And they found that only with the self-management, it was not possible. But when we combine it with the interactive management, now that is where we talk about this phone apps and other things where it is an interactive management. This can help actually achieve rapid and sustained glycemic control. So this is very important. It's not only the checking or the patient is trying to see something or self-management is being done, but they also should know how to bring it into practice and what steps are to be taken to change that thing, or what steps are to be taken to modify whatever the things are coming, or if we want to intervene in that. This was another study where they had tried to see the smartphones and apps to control the HbA1c level in diabetes. This was a meta-analysis. And what they found that in the intervention group, there was a difference of 0.37. So definitely they said that this helps to improve their level of HbA1c. Maybe the clinical impact may not be too much, but it does help. But I would say in the recent times with the COVID pandemic this is very, very important. And we might get different results now because nowadays we are relying more and more on this. Now, these were few studies which I just wanted to show here that where they have tried to intervene in type 1 with mobile app, telephone calls, and SMSs, and they have found that there was a difference in some of the studies for the HbA1c reduction, but some of the studies, they did find an improvement in the hypoglycemic episode. So this is also very important because we know that hypoglycemia itself is one of the major factors for mortality also, and as well as the cardiovascular mortality, which we saw in the previous speaker's slides as well. And also similar data has been seen in type 2, where they have tried to titrate the dose in the first study for glargine with SMS and telephone calls. And what they found that only doing the monitoring doesn't help. It helps when it is done in an interactive manner, when the physician intervenes, or there is some nurse educator who intervenes, especially here also in the flash glucose testing in these two studies as well. And they found that definitely, even though there might not be a difference in the HbA1c, but there was a difference in the time in hypoglycemia. This is very, very important. So these are the different data. Now let us discuss the digital solutions. Now we know that manual logbooks are difficult, time consuming. Illegible data is a major problem. Many a times we see that patient writes something and they just forget to write at that time when they are entering your OPD. They just write something and bring it, and they omit the high blood glucose values because they don't want the doctor to see literacy problems, complexities are all there. So that is why we need to have these personalized diabetes management, which is based on advanced technologies, where we have the glucometers which can transmit the data to the phone, and we can have an effortless synchronization, and no more manual diaries, no data loss. You can directly see, and we all know that we use a lot of these things, especially not only for our patient managements as well as for our clinical trials, because it gives us more robust and clear data. So like if you see the integrated personalized diabetes management solutions, we know that we can have a detailed report, and you can see everything out here. You can see how many glucose values were below the range, how many were in the target, what could be their expected HbA1c. Obviously, that gives us an idea. And we also know how many hypos were there, how much percentage of the time patients spent in hyper. Though from these, we can extrapolate the data and get the results. And we can also enter the target values. We can have a set target value for a particular patient. For an older patient, you can set up to 200. For a younger patient, you can set up to 180, and we can, or 160. So we can set different targets for different patients. For hyperglycemia, again, we can set targets depending on the age of the patients, the other comorbidities like renal dysfunction, liver dysfunction. Obviously, for hypo, we can always have a setting. Even for very old patients, even 80 can be set, so that we know what is the problem and when we need to take action. And then we get a sort of a report like an average, a deviation of the blood glucose, how much has been the overall deviation, how many percentage hypos happen, how many hypers happen. So you can get from the time also, from this date to this date, so you can get to know. So there is no confusion in that. They all also from multiple values, and estimated HbA1c is also given, which you can get an idea. So these are the things which help us to know and plan the treatment, because the things are very clear in front of you. You can always take decisions on that. And obviously, we also do get some average of the blood glucose values, the deviations, like if we set a target, suppose 80 to 160, or maybe 90 to 200 for an older patients, and we can get the deviations, how much has been the plus minus standard deviation beyond that. We get to know the hypo and the hypers as well. And obviously, we know the particular week, which has from where the monitoring has been done, because many a times the patients do miss to write the dates and all in the logbook. So these are more easy for the doctor or the physician or the nurse educator to see and then take decisions. So this is how we get that report. Like we get an average, approximate deviations, we get the percentage, how many times patient had hypo, how many were the hypers. So all this can be taken into the consideration, and we can do the titration. And we also get the color coding. So we can set the targets, and then we get a color coding, which is the alarm value, where we need to get alarmed and take action, and above range can be set as red. So all these things can be done, and we can get the average of the SMBG values as well. So it makes the job of the physician or the nurse educator also very easy, because they can visibly see this on the screen and take actions. And we have also the CGMS technologies now available, where we have the alarms which can be set for the caregiver, for the health care practitioner, for the nurse educator, and they can get to know what's happening to the patient's glycemic values. So why the need of digital solution? We know we can see everything at a glance. This is the most important. When a patient comes to you, and if your resident doctor works up the patient and brings to you, you can have a great idea about the things, though you will definitely take the history and do the examination yourself, but you will definitely get at a glance what's happening. Similarly, this gives you a summary. You know the pattern detection, you know where the hypo and hypers are happening, what time of the day. Then you have, you can also further go into the depth, and we can also, now we have technologies to put photo of the meal for a more detailed report. We can calculate actually an approximate carb count from the photographs. All these technologies and apps are available. And we can also have the approximate HbA1c calculation. So what is the pattern analysis? Now you can see this is one blood glucose which patients normally bring to our clinic, where you have to see what is exactly there and which time they have written by mistake. They have written the wrong time or at the right time, and it's very difficult. So now you can see this pattern is more easy. So if you get a report like this or this, you will definitely like to see the right-hand report rather than the left-hand report. So step one, we have to see majorly hypos, hypers, postprandial hypoglycemia. Then you have to see the time, what time the patient had the abnormality, whether it is early morning, whether it is just before the lunch, or before the dinner, just after the dinner. You have to accordingly take your decisions about the insulin dose adjustment, or if in case you have a patient who is on a basal insulin with medications, you can do the adjustment accordingly. Then you have to see the potential causes, what time the patient is getting the hypo or the hyper. You have to see what physical activity, is it immediately after the activity a hypo is happening, or the food is different and they are eating outside at a particular time, or they are not taking the medication, or which medication you have to increase. And then you can obviously decide the best course of action. So that is why testing in structured way is very important. You can predict severe hypo. You can predict more than 50% of the hypoglycemic episodes based on the SMBG values. We know that doing a continuous glucose monitoring is one of the best ways, but this can give you a great idea. So you can get to know about 58 to 60% of the predicted episodes can be there. And you know that, yeah, this is the point where you need to intervene. And people have tried to see patients with diabetes performing the pattern analysis, and it was 96 to 90% accurate. And patients were willing to repeat the structured glucose testing because they seem to get benefit of their variability. They get a better control. Their hypo and hypers come down. So they are ready to do it in future also. And they say that 93% of the participants actually agreed that the tool was easy to complete, and 68% of the participants correlated meal size with postprandial blood glucose. So it gives a better understanding not only to the patient as well as to the doctor, and it helps for the counseling as well. So pattern analysis supports a better diabetes management. 86% of the physicians found the pattern analysis to be of greater or at least equal value to HbA1c alone, and 77% of the physicians decided to change the therapeutic decisions after seeing the pattern analysis. So how do we manage? We know what is pattern management. It is a systematic process of keeping the blood glucose levels at individualized targets by seeing the relationship between the blood glucose and the patient behaviors, be it exercise, be it the diet, and we can add this knowledge or act on this knowledge to improve the glycemic control. Patient will know his or her individualized target preprandial and postprandial, which we can set for the patient, and we can get an idea about the blood glucose levels after the physical activity, food intake, the medication dose, and what are the stressors or some stress in the family or personal stress or stress because of job or whatever. And we have to look for patterns and assess the possible relationships, like nowadays we are seeing two sets of patients. One set is who is doing good physical activity at home and their glucose values are better. And we are seeing another group of patients who have absolutely stopped physical activity and they have come with grossly uncontrolled blood sugar. So this all will give you an idea about that. And then we can determine the cause of the suboptimal blood glucose. And obviously we can make the necessary changes. So we need to have the patient and as well as the physician should educate, or we should educate the caregiver as well as the patient about SMBG. We should tell them that little bit interpretation of their blood glucose results in case they understand. The physician or the healthcare provider has to correct the medication administration. They have to identify the effect of diet and activity, because many a times it does happen. The patient tells you, when I eat this food, my sugars go high. Because we know it's not only the type of the food, there are many other factors, the way the food is cooked, what is added to the food, what time of the day, what is the amount of food they are taking. So they'll tell you that when I eat this particular diet, my glucose values will go high. And sometimes the doctor may not imagine that this food will cause so much of excursion, but the patient will definitely tell you. So these are the things which you get to know, and you involve the patient in the management. That is the best thing, because this is what we have to do. So we have to keep the records and of the blood glucose, diet, and exercise. So act of the structured monitoring is therapeutic and diagnostic, what we can use the word theranostic. So structured assessment, there's a treatment effectiveness assessment, personalized treatment. We do a systematic analysis, we do a structured documentation, and we give a structured therapy. And obviously the patient gets adapted to this and they start collecting the SMBG data. So when we talk about the integrated personalized management, it definitely improves glycemic control with in patients with insulin-treated type 2. This was one study which was published where they had 907 patients with insulin with treated type 2, and they were taken from 101 sites, and they tried to see the improvement in the HbA1c at 12 months. And they found that there was a reduction of difference, I should say, of 0.2% in the two. One is the control arm and one is the integrated personalized diabetes management arm. So in the control, it was 0.3%, integrated personalized diabetes management 0.5, difference of 0.2 was there. So that's what I was trying to show in the initial study also. Though you may not see a very great difference in the HbA1c, but what you will see is the hypo and the hyperglycemic episodes come down, the variability comes down, the patient starts feeling better, gets involved in the care. So it improves the glycemic control, variability, therapeutic adjustments can be done, better adherence. This is the most important thing for diabetes management. And obviously nothing else is better than the patient satisfaction with the treatment. And obviously healthcare practitioner also gets satisfied. To summarize, we know that the integrated personalized diabetes management, that is establishment of a structured and digitally supported process with the structured self-monitoring, I would say, leads to better outcomes, no doubt. Obviously leads to a reduction in the glycemic variability. It results in rapid changes and adjustments of diabetes therapy, because you can do then and there. Once it comes on the smartphone, the patient sends it to you, you know that this is the time you have to take action. You can tell the patient, okay, you can reduce the insulin dose. Okay, your glucose is very low, don't take insulin, take action. You can prevent a lot of severe hypoglycemic episodes, reduces the clinical inertia. Obviously, optimization of procedure with these digital tools will lead to improvement in therapy without additional effort or cost. I would not say total no effort, it will be, but cost definitely comes down because the cost of an admission for a hypoglycemic episode is huge. So if we can prevent one episode which is severe, we can do a lot of help for the patient as well and bring down the cost. And it can be used with any type of treatment without substantially changing the previous treatment. So this is what we call as process optimization. And obviously for the doctors, it is like improved inclusion of the patient and empowerment of the patient. That is more important, because now we talk that it should be personalized, it should be, patient should be involved in that, caregiver should be involved. Otherwise these therapies don't work. So we have to do now what the patients need next. So with this I end. I think we can have discussion in the end.
Thank you. Thank you, Dr. Pramila. I think that was a very passionate talk on SMBG and connectivity, and I'm sure there are going to be some good, interesting questions springing up, and we'll keep that for the end of the session, the entire monitoring session. We have Dr. Ranjit Unnikishan joining us. Dr. Ranjit is Vice Chairman, Dr. Mohan's Diabetes Specialty Center, Chennai, has more than 100 publications in international and national peer-reviewed journals and chapters and textbooks to his credit. He was awarded the Best Doctor Award by the Tamil Nadu Dr. MGR Medical University in 2012 and awarded the Dr. Coelho Memorial Lectureship in Experimental Medicine at Apicon 2015. And Dr. Ranjit Unnikishan will be speaking to us about the importance of time in range and glycemic control. Over to you, Ranjit.
Thank you, sir. Thank you for the kind introduction. At the outset, let me thank the organizers of ADA Primer, Dr. Arvind sir, Krishna Sheshadri sir, and Bhavna for inviting me for this, delivering this very interesting topic. I will now try to share my slides. So are my slides visible?
Yeah, they're visible, just expanded. Yeah, they're visible.
Just expanded, yes, yes. Thank you, sir. So now what I've been asked to speak about today is a very interesting topic and one which actually tails in quite nicely with what Pramila ma'am was talking about. And I really liked what she said, that what we should do now with what our patient needs next. I think this is something which our patients need next, if not really right now. So I'll be going to talk on, I'm going to be talking on time in range and what is its importance in glycemic control. I have no conflicts of interest relevant to this particular talk. So I'll first start by introducing the concept of time in range and what it is. And then I will go briefly into some of the guidelines which have been recently published regarding time in range, time above range, and time below range. And finally, I will close by talking about how best we can assess time in range with the technological advancements that are available today. So what's time in range? Time in range is exactly what it sounds like. It is the time, the proportion of time every day or over a period of days which an individual spends in a pre-specified range of blood glucose. And you can set your range depending on the characteristics of the patient. If you have somebody who needs tight glycemic control, you can keep your range quite narrow, for example, 70 to 140 milligrams per deciliter. But in general, we tend to recommend a range of 70 to 180 milligrams per deciliter. So for all practical purposes, what we mean by time in range is the amount of time, the percentage of time in a given period, which the individual spends with a blood glucose between 70 to 180 milligrams per deciliter. Following on from that, what is meant by time below range? Time below range is time the individual spends in hypoglycemia. And time above range is the time the individual spends in hyperglycemia. So these are very straightforward concepts, very easy for us to understand and equally easy for the patient to understand as well. Now, what's the importance of time in range? Now, increasingly, time in range is being used as an important metric in assessing glycemic control and the quality of care that a patient with diabetes is receiving. It is also being used as an endpoint in clinical research. Earlier, we used to assess efficacy of diabetes treatments by way of HbA1c. Then we started looking at glycemic variability. Now, increasingly, studies are looking at time in range as an endpoint to see whether a treatment for diabetes is doing what it really should be doing. And there is no exciting evidence, direct as well as indirect or calculated evidence, to show that time in range is related to diabetes complications. We have all this data about HbA1c being kept below 7, being appropriate for preventing micro and macrovascular disease. But we now have studies which show that over and above the HbA1c, keeping the sugars within range for increasing amounts of time is equally important to the prevention of complications. So how do you compare HbA1c and time in range? And now I think the title of this slide is a bit of a misnomer. You cannot look at HbA1c and time in range as two opposing parameters. I think they should have peaceful coexistence rather than being rivals to each other. They each look at different aspects of the glycemic paradigm. Now, HbA1c is a single value. As we all know, it is a retrospective average sugar which looks at the glucose control over the period of preceding 3 months. Now, the problem with the A1C is that, like any other average, it is unduly influenced by extreme events. One event of extreme hypoglycemia or extreme hyperglycemia will skew the HbA1c inappropriately. It also does not faithfully reproduce or represent the glycemic troughs or peak which occur even for normal individuals, but also more significantly for people with type 1 and type 2 diabetes occurring during the course of the day. When you make any changes in therapy, when you either start therapy for diabetes or make some changes in therapy, you will not be able to assess the effects of this therapy in the short term using HbA1c. You have to wait for 2 to 3 months. HbA1c is subject to various interferences. Still, the measurement of HbA1c in our country is a major challenge, a practical challenge. Not every lab is equipped in our country to accurately measure the HbA1c. There are various clinical conditions such as hemoglobinopathies, anemia, other comorbidities which can interfere with the HbA1c range. Now, the good thing about HbA1c is that most of the diabetes complications have been described with respect to the HbA1c. Most of the diabetes therapies have been assessed based on their ability to bring down the HbA1c levels. How does time in range compare? Time in range actually looks at the continuous glucose levels, minute to minute changes in glucose levels. It compares time periods, any time periods. You can look at it at 2 weeks, you can look at it at 1 week, you can look at it at 3 weeks. The only limiting factor here is the availability of technology, which is improving by the day, I might add. It captures all the glucose levels within the given time frame and tells you what proportion of time the individual is spending within a safe range, which you can define for each and every patient individually. If you make any changes in the therapy, you can immediately detect the acute effects of that change by looking at the time in range. Because it looks at glucose levels, glucose being a very easy analyte to measure either in the blood or in the interstitial fluid, it has got very low susceptibility to interference. Falsely high, falsely low values are very unusual. The disadvantage of using time in range is that at least until now, we do not have too many studies correlating time in range to the endpoints of interest to us. And the main endpoints of interest to us is that will maintaining the sugars within a particular range help our patient prevent or delay complications. We really don't have too much of data regarding that. But for those of us who have grown up looking at HbA1c and being HbA1c centric, there is some good news. In that, studies have shown that there is probably a fairly good correlation between the time in range, various values of time in range, and the HbA1c. And you can see here in both type 1 diabetes as well as in type 1 and type 2 diabetes, there have been studies which have looked at what is the HbA1c which correlates the best with varying time in ranges. And you can see that in A1c of 7, most people with an A1c of 7 would have their sugars within the range between 70 to 180 milligram per deciliter around 70% of the time. The same is the case for type 2 diabetes as well. And we find that every 10% increase in time in range, 10% of 24 hours is 2 hours and few minutes, 2 hours and 20 minutes rather. So every 10% increase in time in range is associated with a 0.5% reduction in HbA1c. So there is a somewhat linear relationship between your HbA1c levels and your time in range values. So this is one way by which we can correlate these two parameters and use them to improve the control of our patients. So now looking at whether there is any data as to whether improving the time in range can reduce the risk of complications. There are very few studies which have directly looked at this. And this is one study from Shanghai in China, in which they looked at around 3,000 individuals with diabetes. And they looked at actual CGM data, which was of course calibrated and rechecked using the glucometer readings. And they looked at the risk of severe retinopathy. And they found that, and then they actually divided patients on quartiles of TIR. And they found that individuals in the highest quartile of time in range had the lowest risk of severe retinopathy. And by severe retinopathy, we mean moderate MTDR as well as vision-threatening diabetic retinopathy, proliferative retinopathy as well as diabetic macular edema. That means the more time you spend in range, the less chance you have of developing vision-threatening diabetic retinopathy. So this is the one direct study which I was able to find out correlating time in range with the risk of chronic diabetes complications. Now, there have been some indirect assessments also. This is from the DCCT cohort. You know that during the time of DCCT, continuous glucose monitoring was in its infancy, and most participants in the DCCT did not undergo continuous glucose monitoring, but they did have 7-point glucose profiles. Now, based on those profiles, they tried to assess the time in range spent by these participants and try to correlate it to the risk of developing retinopathy and albuminuria. And they found that every 10% less time they spent in range, the retinopathy progression increased by 64%. This is not an insignificant increase. And microalbuminuria risk increased by 40%, showing that the more time you spend in range, the less likely you are to develop progression of these microvascular complications. Taking it even further, this is data from 4 or 5 large diabetes centers in US, in which they looked at whether improving the time in range would lead to reduced incidence of each of these complications over a period of 10 years. And they again did not look at it directly. They used this particular modeling known as the IQVIA core diabetes model. And you may ask me why they looked at 58% time in range, because this was the actual baseline time in range which patients who were being treated at these centers had. And you can see that there is a small but definite decrease in the incidence of complications when you increase the time in range from 58% to 70% to 80%. It doesn't matter whether you're having type 1 diabetes or type 2 diabetes. It doesn't matter whether you're looking at MI, ESRD, vision loss or amputation. There was a small but significant improvement in the risk of developing these complications if you increase your time in range from 58 to 80%. Might say it's not a big decrease, but remember that very few of our patients have 58% time in range. Most of our patients, from our experience with the continuous glucose monitoring system, most of them have 35, 40, 45% at the most, even so-called well-controlled ones. So our patients, if you can get them to around 70 or 80% time in range, the absolute reduction in the incidence of these complications that you may get is likely to be of much higher orders of magnitude. So now we'll go to the guidelines. What are the current guidelines which are available for the CGM metrics? And this was first discussed in the ATTD conference in Berlin in 2019. Earlier also, we had a lot of guidelines on CGM, but they were very complicated. They had divided people into type 1, type 2. There are too many metrics. And only people who were totally into it were able to make head or tail of it. So actually in 2019, they totally simplified it. And this got published in Diabetes Care last year. So what they did was that they collapsed the targets for both type 1 and type 2. They gave uniform targets for both type 1 and type 2. And they divided patients into only 3 categories: diabetes, frail patients with diabetes. These are people who don't need tight control. And then diabetes in pregnancy, which includes both GDM as well as pre-existing diabetes. And they also said that you don't, even though we're mentioning so many metrics of CGM, you don't need all of those for primary care or for somebody who's treating diabetes. All you need is time in range. There are 10 CGM metrics which they recommended for clinical use. I'll talk about that later. And they gave guidance on targets for TIR, TAR, and TBR for type 1 and type 2 diabetes, as well as diabetes in pregnancy. And they made recommendations for the standardized reporting of the ambulatory glucose profile. How to report it, what all things should be given in the report to say that it is complete. So these were the metrics which were initially recommended by the International Consensus Group way back in 2017. You can see there are 14 metrics here. They have now simplified that into 10 metrics. So the 10 metrics are how many days the CGM is worn. It's recommended to be worn for 14 days. You can wear it shorter period of time also. How much time the CGM is active. Suppose it doesn't work for half the time, it is not of any use. It should work for at least 70% of the time. What is the mean glucose and what is the GMI? This GMI is what is measured as mentioned as the estimated A1C on the top of your AGP report. Anyone who has used the Freestyle Libre Pro will know what I mean. That HbA1c, which is calculated using your mean glucose value, is now called the glucose management indicator. The latest software for the AGP also mentions the glycemic variability and it divides time above range into 2 categories, time below range into 2 categories, and you have the time in range. Time in range is 70 to 180 milligram per deciliter. Time in above range, category 1 is 181 to 250, category 2 is above 250. Below range, category 1 is 54 to 69, category 2 is below 54. All these should be mentioned in the CGM report. So these are the targets for type 1 and type 2 diabetes. The target glucose level, as I mentioned earlier, is 70 to 180 milligram per deciliter. And we should try to get our patients to this target more than 70% of the time, which equates to around 16 hours and 48 minutes, around 17 hours. In older individuals, target remains the same, but you may not be able to get them to target 70% of the time because you run the risk of hypoglycemia. So it might be sufficient if you keep them to that target at least half the day, that is 12 hours. In pregnancy, in type 1 diabetes, the target here is 63 to 140 milligram per deciliter. You see the target is tighter and you need to get them to target at least for 70% of the time, same as in type 1 and type 2 diabetes. The only difference being the target is more stringent. In type 2 diabetes complicating pregnancy and GDM, you see that the target remains the same as in type 1 diabetes in pregnancy, but they did not give any recommendation as to how much time you should be in range. Ideally, you should be in range 100% of the time. And it is possible also in GDM because it is a mild form of diabetes. But since we do not have enough evidence on the appropriate time in range for how much time you should remain in range in pregnancy in type 2 diabetes, they have not given any percentage. Now these are the targets for the time above range. You can see that time above range category 1 less than 25% of the time, category 2 less than 5% of the time. You're slightly more liberal in older individuals because you run the risk of hypoglycemia if you try to tighten it any further. Similarly, less than 25% of the time only, or less than 6 hours, you should be above 140 milligram per deciliter in type 1 diabetes complicating pregnancy. And here is the acceptable cutoff for time below range. You should only spend less than 15 minutes with glucose levels below 54 milligram per deciliter if you have type 1 or type 2 diabetes, even whatever be your age. If you are slightly younger, less frail, you can have slightly more time below range, because that is a penalty you pay when you try to get your time in range above 70%. We are not willing to accept that risk in older or higher risk individuals, so we have fewer time below range, below 70. You don't want them to get below 54 at any time. And similar cutoffs have been given for pregnancy as well. So every increase of 5% in time in range is associated with benefits. It's like you talk about HbA1c, you say 7%. But it doesn't mean that improvement from 9 to 8% is also not good. It is good. Each decrease in HbA1c, every 1% decrease in A1c is associated with benefits to the patient. Just like that, even if you're not able to get 70%, from 40%, if you get to 50%, the patient will benefit. So what are the technologies available for assessing the time in range? For time in range, you need what is known as continuous glucose monitoring. It is very difficult to assess the time in range using self-monitoring parameters. And we have different types of CGM available. We have the real-time CGM, by which the patient or the provider can see the glucose levels prevailing in the body at that particular time in real time. And we have the intermittently viewed or intermittently scanned CGM, like your Freestyle Libre Pro, which collects the data continuously, but which can be viewed intermittently by scanning the sensor. So you can use CGM data for looking at the time and target, looking at the glycemic excursion, what is the daily profile, what is the glucose variability, and what are the patterns, like Dr. Pramila was saying. The pattern recognition is extremely important. And it is very easy to assess these patterns using the CGM data, even more so than the SMBG data. Limitations are there. It has to be actively used. Accuracy limitations are there because it has got a lag period. It tends to lag behind the plasma glucose excursions. And it is not yet widely available, and it is slightly expensive. So this is the Freestyle Libre Pro, which we are commonly using. You can see the sensor. It is a very small sensor, the size of a coin, which is generally placed on the upper arm. It works for a period of 15 days. And at any time in the 15 days, you can just run the scanner over it. The data will be transferred using flash technology. Then you connect it to a computer in which the software has been loaded. It gives you all the metrics that you need, as I mentioned earlier. So these are the metrics which they mentioned. The current the Libre Pro, which we have in our market, does not give you all this range because the software is slightly old. But I am assured by the vendor that the next time, the next iteration of the software comes, you'll be able to see all these in greater detail. You'll also get the model day curve. This is all the 14 days readings collapsed into a single day. And very interestingly, you'll also be able to see the daily profile, what time of the day it is going. This will help the patient to correlate his activities, his food intake, to the glucose excursions. And
Ranjit, sorry to interrupt, but we're running out of time, so we need you to wind up.
Last 2 slides. So this is how you look at the time in range. Even if you are not having all these metrics being mentioned, you just look at the time in target, which is mentioned here. You can see here, this is a patient with diabetes. You can see that he is in range only 21% of the time. Here you see a person without diabetes. You find that he is in range 94% of the time. So just by looking at the graph, seeing what percentage of the time the individual is in this gray zone, which is the target zone, you will be able to measure the time in range. So first you need to reduce the time below range, because hypoglycemia prevention is most important, and then only you need to look at the time in range and time above the range targets. Elderly people, the focus is mainly on preventing time below the range and preventing excessive time above the range. Pregnancy in type 1 diabetes, you will be able to safely increase TIR because they are young people, otherwise healthy, reduce variability. More data is needed in gestational diabetes. So I'll conclude by saying that HbA1c remains the gold standard for diabetes management, but it does not give you any holistic and individualized glucose profile. Time in range gives you a better snapshot of the person's glycemic status, and therefore it aids in better glycemic control. And now we have some evidence, increasing evidence, that improving the time in range can probably reduce the micro and macrovascular complications in people with diabetes. And now we have guidelines, not just the ATTD guidelines, we also have guidelines from the ADA now on the appropriate use of CGM. And I think this is a very promising field, a developing field. Technology is advancing very fast. We are not able to keep up with it, but this is a field that really has a lot of promise. I thank you for your attention.
Thank you, Dr. Ranjit. And we now have some time for discussion. I'm looking for questions in the question box, but till we get questions there, the faculty that is joined in here is free to ask in questions, and let me get the ball rolling on the question. So, Dr. Pramila, the first question to you, and I think that was a very passionate talk on SMBG, its importance and connectivity. The question often arises about yet the relevance of SMBG in patients with type 2 diabetes not on insulin. I think that's one, if you can clarify. Also, every time we show the data of SMBG and connected SMBG improving HbA1c, is there data on the minimal amount of SMBG that is required for it to be relevant to change the HbA1c? So your thoughts on these two aspects?
Yeah, because this is a very important question, because if you see most of the patients on OADs, we may not tell them to do a regular SMBG monitoring. And that's what most of the guidelines also say. But we know that some of the patients, especially like I showed in the beginning, like a patient having a HbA1c, which is good, but still the patient is having some hyperglycemia we may not get to know, but hypoglycemic symptoms are there and we don't know what exactly is happening. Those patients definitely are the best candidates for CGM, but short of that, SMBG can give us a good idea in that. And maybe monitoring some pre-meals, some fasting will be a good idea in such patients who are plainly on OAD, especially on the OADs which can cause hypos like sulfonylureas. Metformin and DPP-4 and SGLT2, on these OADs, we normally don't need to do much of the SMBG monitoring. But once or twice a week, if the patient can do, at least it helps the patient to know what exactly is happening. And we mostly tell them to monitor fasting, pre-meals, and some post-dinners. That's what we normally do in our practice. But coming to insulin, when a patient suppose is on basal insulin, we would definitely like to see the fasting at least once in 3 days to get to know and adjust the basal insulin on that basis. And if you see patient on basal bolus, we need to tell them at least to do one different reading a day. That is one way of doing, like 1 day fasting, 1 day pre-lunch, 1 day pre-dinner, if they can't do all the readings. But in pregnant and all, we know that they have to monitor for SMBG values at least a day to know what is happening, and SOS as and when they feel that they have some hypoglycemic symptoms. This is normally what we tell. And coming to your next question of your HbA1c control, what was your next question? The HbA1c and sorry.
The minimal frequency of SMBG for it to be relevant.
Yeah, minimum frequency, that's what I mean to say, that if you have an OAD patient twice a week or thrice a week at different times may help you, but normally in all OADs, we don't tell them until and unless, as I said, we are having a doubt about some hypos happening or some which is not matching with the HbA1c, because many a times we get to see some HbA1c values which are beyond the range, but the patient tells the lab values look very good, the fasting and postprandials look very good. These are the candidates where we need to do, because not only we need to catch the hypos, we need to catch where the hypers are happening, and accordingly maybe change the diet, add whatever drugs are needed, like alpha glucosidase inhibitors or whatever, or you need to add further drugs, because these are the things which, because glycemic variability may be there in such patients, which needs to be caught.
Thank you. And before I pose the next question to you, Dr. Pramila, I'll move to Dr. Ranjit. Ranjit, again, completely elaborate and very, very specific information on TIR, which is becoming such an important concept. And yes, I think you mentioned about the link between TIR and the complication. In fact, there was this wonderful paper presented at ESD about a week and a half back by the Belgium group, which again showed the connection between TIR and some of the microvascular complications. In fact, they looked at TIR, duration of diabetes, SD, CV, with the different complications. And I think they clearly showed the correlation there. And my question to you is we are aware now that time in range is going to be looked upon much more closely as CGM is increasing. I'm sure you're also aware that the real-time CGM, the Libre freestyle, is going to be available in about 2 weeks from now across India gradually for patients to use it themselves. So with the real-time Libre coming in, where do you see the usage of TIR expanding to? And realistically, does SMBG continue to be relevant once you have more real-time CGM being available at a cost which may be more affordable?
I'll take the second part first, because this has always been asked if CGM comes in, will SMBG become extinct? I don't think that will happen. Just because HbA1c came, blood glucose monitoring did not go extinct. The thing about the wearing the CGM is that I don't think too many people will be happy wearing it on a continuous basis, year in, year out, day in, day out, continuously. So what we find is that at least in people with type 2 diabetes, you use the CGM to begin with to find out the trouble spots, whether they have difficulty in controlling the glucose levels. And then you make the therapy changes, and then you can use SMBG to actually focus on those trouble spots. CGM will tell you when you need to be doing the SMBG. Instead of doing it blindly, you can do it in a more focused manner. I think that is how things are going to play out. My only worry about this real-time CGM is that it's like having your real-time CGM with the pump. People get paranoid. Every 15 seconds, they will want to know what is the glucose levels, and they'll start calling us in the middle of the night saying, now my sugar is 200, what should I do? So that way we'll have to educate over that. That sort of patient is also there, as you all know. So I think that's one worry I have about this real-time CGM.
Time for us to keep our cell phones off once the real-time CGM starts getting more active. Right. Okay. So I think the message is clear from your side, Ranjit, and that's what people have been saying, that for people who cannot afford to do more continuous CGM, I think the professional CGM that we've been using in India is far more relevant to look at the pattern, because you're going to be doing it just once or twice a year and then rely on SMBG. But for those, especially the type 1s who can afford to do it continuously, only for them is the real-time CGM important, because real-time CGM's value is only for those 14 days when you're using it, right? So
I have one question, please.
Yes, please go ahead, doctor.
Ranjit, what is the utility of real-time CGM in intensive care management?
In intensity of management.
Intensive care.
ICU setups.
Yeah, ICU care also, you can most definitely use it. You can most definitely use it. You can use the intermittently scanned one also, because you can get the readings. See, if you want to know the glucose level prevailing at that particular point of time, a glucose meter reading is more than enough. But even if you put an intermittently scanned one, you can still get the scan for 1 day, 2 days. We do that. We actually put the Freestyle Libre Pro for most of the patients who are admitted in our inpatient wing, be it in the ICU or be it in the non-intensive care wing. Every day when I come for rounds, they show me the graph. And based on that, you really don't need the patient's EGM, but you can use the Pro itself.
The only aspect there, Dr. Basavgowda, is that these are not really approved for use in intensive yet. It's an off-label use. There is some lag expected. In fact, Abbott has come out with a hospital-based sensor only meant for intensive care, which they're doing pilot studies in China. The only place they're doing it in the world is China. We'll know whether that's going to be relevant. I think we are running short of time. One last question to Dr. Pramila. You showed the applications in terms of what the IPDM is offering. There are other applications today which are also offering the connectivity with your clinic software. Yes, so given the scenario today, what would you prefer? The one where only the patients are connected, or where even the clinic is connected with that offering?
See, obviously more connectivity is better, but it also gives more work. That's I would say. So we have to choose the right patient where you want a clinic connectivity, because see, in a garden variety of patient where you want to do the patient, the monitoring, and you want the patient to come back to you after 2 weeks, you need not connect it to your clinic. But if you have the setup, like if you have a proper setup where you have a nurse educator, a person who is involved in this, it is very good, because then you can do a better personalized management. So there's nothing better than that. I always think that more use of technology helps a patient, and especially in a field like diabetes, where we have seen lots of problems. Even if you teach the patient sometimes, and you see that though they may get a hypo, they will not understand that time what the doctor told, and they may do something else. So even in spite of repeated teaching, so it's always better to have a clinic.
More connectivity.
Thank you. And now we also see that even for cardiologists and all, they have ECG softwares where it directly comes on the cardio phone, so they can see and take action. Actually.
Thank you so much. Thank you, Dr. Pramila. I think we're out of time. Thank you both the speakers, Dr. Pramila Kalra and Dr. Ranjit Unnikrishnan, for the wonderful presentation on this important aspect of monitoring. Handing it back to Dr. Krishna and Dr. Bhavna. Thank you.
Okay. Thank you, Dr. Chawla, and thank you, Dr. Pramila and Dr. Unnikrishnan, for joining us. Let's take a short break for lunch, and I'll see you all soon. Stay tuned and stay with us, guys, because we have exciting sessions planned right after lunch. We're going to talk about different OADs, and we also have another Japanese doctor coming in talking to us about once-weekly basal insulin, and that's probably going to be the next big thing in some years. This is still in clinical trials, so stay with us, and we learn more and more about.
Anna, where exactly is the lunch served?
Lunch is in our
just walk out.
Kitchen, in my kitchen. So.
Just walk out, and I'm sure Purvi is already left the lunch table because you're going in late.
Online lunch. Thank you, Bob.
Okay. All right, so we'll break for lunch and see you all shortly. Bye-bye.
Thank you. Thanks, everyone.
Also, for those who are just not left, we're plugging in this evening's highlight, which is the primary honor lecture by Dr. Eugene Braunwald. A rare opportunity to actually hear the great man. Please come in. Thank you.
Sure.
Bye.
Bye-bye.
Bye.
Am I audible now?
Yes, sir. Yes.
Yeah. So we have 5 minutes to start?
Yes, sir.
Yeah, fine. Perfect.
Good afternoon, sir.
Good afternoon, Anuj. Good afternoon. I wrote a mail to you. You just get it in the evening.
Okay. When did you read? Right?
Just now it's going. My secretary typing now. It's going to invite you for a chapter somewhere book.
Oh, great, sir.
That usual book.
Yes, thank you,
Hi,
sir.
Dr.
Thank you.
Icodec.
Yes, Bhavna. How are you? Fine.
Yes,
Fine,
good.
fine.
I hope both of you have had lunch and you're joining us.
Yeah. Bunching all the time in lockdown. Lunch, brunch, munch. New rule.
Good. Okay, so since you both are here, we'll start off. So welcome everyone back to ADA Primer 2020 post-lunch session. Today is the third and final day of the event for this year. I now request Dr. Anuj Maheshwari to take over the session. So he's a very well-renowned physician known to all of us. So Dr. Anuj, over to you.
Thank you, Bhavna. And thank you, Dr. Arvind and Bhavna and all team of the ADA Primer for giving me this opportunity to come on this platform. Today's session shall be on the oral anti-diabetics agent, especially for the combinations. And Dr. Ashok Das is the renowned speaker. He doesn't need any introduction, at least in India. So, but for the customary, I can say that he is having current designation as Professor of the Medicine and Endocrinology at Pondicherry Institute of the Medical Sciences. He is former Senior Professor and Head of the Endocrinology at Jawaharlal Institute of the Postgraduate Medical Institute, JIPMER. And a lot of things in his credit, lot of papers, lot of books. Every year he writes and edits so many books. So it is really very difficult to give his introduction in a small time. I think one whole CME shall be requiring for his.
Oh, no.
So I think Dr. A.K. Das shall be taking us towards getting a fixed dose combinations of the oral anti-diabetic drug and what is that scenario in India. So over to Professor A.K. Das.
Thank you, Professor Anuj Maheshwari, for the kind introduction. Thank you to KMP, Krishna, Arvind and Bhavna and Sanjay for this wonderful ADA primer. Really, I liked it. And the perfect background to my talk was yesterday, Bhavna, when Jane spoke about the most important combination therapy, that is the lifestyle modification plus exercise. So I'll take up from what Jane said yesterday. Can I have my first slide, please? I'll project it. 1 minute. I'm just projecting. 1 minute. Is it visible? I'm going to speak about the fixed drug combination, the Indian experiences, and I'll talk about the most important Indian experiences, 2 drugs, and my younger brother Uni will take over from there for his masterly talk after this. Are my slides visible?
Yes, sir.
It's visible. Good. Dear friends, to make a long story short, the management of diabetes in India is very difficult. In spite of lower BMI, like other South Asians, we have more abdominal fat, more IR, more hyperinsulinemia, increased levels of C-reactive protein, lower level of adiponectin, and characteristic dyslipidemia. And also we have increased susceptibility to coronary disease, and of course, type 2 diabetes mellitus. I've taken it from from Uni's article, which was published along with Mahesh in JAPI in this year. Dear friends, now, why should you have intensive intervention? Instead of starting with diet and monotherapy, followed by stepwise treatment escalation, it leads to failure. In early phase of type 2 diabetes, intensive intervention reduces glucotoxicity and an effective strategy to induce long-term reduction of the sustainable long-term glycemic control and the control of the complication. It preserves beta cell function. And there are multiple hypoglycemic medications with complementary action, and they have to be combined, should be used. There are countries in the world today, 2 important examples is the Sri Lanka and UK. They do not need the fixed drug combination yet, but now a good news that they are trying to introduce FDCs. In a recent real world, fewer than 50% of the type 2 diabetics and with treatment failure, less than 50% with treatment failure received intensification within last 12 months. The median time to treatment intensification, I'll show another slide, was at least 1.6 years and HbA1c of 8. Now, if you take stepwise therapy, we know the potential advantage that we can have good patient adherence, cost, easier to access. But if you take combination therapy, the use of drug combination can aim at multiple pathogenetic mechanisms simultaneously and preferably in the complementary manner. Number two, there is earlier and better glycemic control achievement and potential delay in the disease progression and preservation of beta cell function. There are some disadvantages, that is sometimes we cannot modify the dose of each component. Assessment of efficacy or side effect of a single component may be difficult, and also patient adherence is sometimes complex, but more or less much better. Therefore, the FDC, according to DCGI, has been defined as a formulation of 2 or more. We have allowed up to 3. The latest paper we produced in landmark study, we said that people in India have used up to 4, and they have got some benefit. But beyond 4, adding 5th and 6th oral, you don't laugh at me, people do it, and that is of no use. You have to go to insulin. Up to 2 is most ideal. Up to 3 is acceptable. Up to 4, sometime we go, but 5th and 6th totally useless. FDC drug products may improve medication adherence and compliance of the patient, and also develop. This is today drug combination is everywhere, starting from malaria to meningitis to hypertension, dyslipidemia, ACS, rheumatoid arthritis, cancer, HIV and AIDS, and also for the COVID-19. Dear friends, there's a small cartoon which shows that healthy glucose controls the balance between the size of the beta cells, consistent with the speed of insulin release, consistent with the insulin sensitivity, and with the glycemic status. And that and glycemic load decides healthy control. When the glycemic load is high, because of the things I described, and also we need to give drugs which can reduce glucose uptake, which can increase renal glucose absorption and other mechanisms. Dear friends, why we do not achieve HbA1c goals? The answer is very simple. Beta cell function decline, whatever you may do, any drug, anything, any conference, anything, any update, beta cell dysfunction is a rule, and in type 2 diabetes occurs in regardless of intervention. Therefore, there's a need of early disease modification by giving combination. Therefore, dear friends, treating the pathophysiology of type 2 diabetes with early combination, which is an advantage in our country, it will support for redifferentiating the beta cells, enhance the incretin effect, improve insulin sensitivity, and more action on the liver, muscle, and fat. New combinations today can even decrease renal glucose reabsorption and rein in the glucose neogenesis, and also augment the glucose uptake by other tissues, reduce blood glucose. Therefore, the latest guideline says that to avoid clinical inertia, reassess and modify your drugs and the treatment every 3 monthly. Now, let us see what the median type 2 treatment intensification globally. If you see globally, the single drug, people stay up to 2.7 years. In India, at least 1.8 to 2.7 years or 2 years. And the double drug combination starts only after 1.5 years median. And the insulin starts much later. This is the current state of affairs. And we are ready to escalate around the world to the double drug combination. East Asia probably escalates at 7.7, Europe at 7.9, Latin America 8.5, Middle East 8.5, and India we escalate from a study about 8.6 years. I'm quoting Bade et al. This is the one I spoke about, the traditional stepwise approach. This is a stepwise approach, not to success, stepwise approach to failure, complication. But the early combination, intensive therapy with combination therapy reaches glycemic goal and reduces the risk of complication. OAD combinations early, up titration, maybe with insulin combination, maybe OAD with multiple daily insulin is the key to prevent complications. Dear friends, what are the consequences of inertia? Most important is the cardiovascular complication. And the dysglycemic legacy, this is a term I have borrowed from B. Mohan. This glycemic legacy drives risk for complication. So Mohan described two types of hyperglycemia, avoidable, unavoidable. This is avoidable hyperglycemia, which has to be treated effectively. And for effective treatment, possibly we need a combination. Dear friends, these are the various combinations available till yesterday. New combinations have come. I'll be touching upon it. We have the most important combination, sulfonylurea metformin, from the eternity, from the start of the probably diabetes therapy, and the reduction is almost up to minus 1.8 to 2. We have the famous metformin vildagliptin trial, the very great trial, which produces up to 1.5 to 1.6. It's a very effective therapy and change the scenario of the future combination. But because it has been discussed, I will not touch upon it. There is metformin, trazodone combination, pio combination, -1 with the TZD. It is again some studies 0.95 with sulfonylureas, with acarbose almost 0.1, with metformin with meglitide 0.9, and metformin acarbose 0.9, and sulfonylurea and meglitide up to 0.8. Dear friends, therefore, why FDs are preferred in our country? Adherence rates high, improves glycemic control, medical expenditure because of hospitalization can be reduced because of good control, decreases frequency of drug administration, and prevents polypharmacy. This is the ominous octet. I suffices to mention we must address multiple pathophysiology. Now, if you compare between the switching, the same therapy, H1 reduction maximum 0.5, switching the medication 0.5, adding a new drug to the current therapy that the FDC is reduction HbA1c 1.1. There are various oral anti-diabetic drugs for metformin, modern issues, DPP4, SGLT2I, AGI, GLP-1RA, and all these combined together can reduce hyperglycemia very effectively. Dear friends, FDC simplifies dosing regimen, improves adherence, improves compliance, and provides long-term diabetes control. And it has been shown the adherence published in IJAM with the fixed dose combination is 77% compared to 50% by the free drugs. Dear friends, the treatment guidelines in 2008 said initial combination therapy must be started when the HbA1c presenting is at least 1.5% above the target. But today, after the ADOPT, not so much after the ADOPT, after the very important verified trial, early combination treatment showing making the risk of time to initial treatment failure almost half. Median time to failure was 3 years initial monotherapy. Here it was more than 5 years. When all patients receiving the combination therapy, the risk of time to second treatment was reduced by 26%. And both approaches were safe and well cleared. Therefore, the early combination therapy, after verify, got a new life. And today, the EASD 2020 and ADA 2020 says healthcare providers should engage in shared decision making around initial combination therapy. Please mark the word initial combination therapy in new onset cases type 2 diabetes. And it was used in the study of David Matthew in Verify at 6.5. Dear friends, poor adherence leads to HbA1c becoming higher and higher. Now, you will find that more than 50% type 2 diabetes mellitus patients required 3 and sometimes 4 OADs, a beautiful cartoon, to maintain the HbA1c at the control level. ADA also says you can start with monotherapy, then go to dual therapy and triple therapy when necessary. This from the ADA guideline 2019. Now, this next 4 slides shows the various combinations available, not only in diabetes, but in hypertension. We'll come to diabetes. We have all sorts of combination, glime-rogi, glipi-metformin, glimepiride-rogi, pioglitazone, gliburide metformin, metformin sitagliptin, linagliptin metformin, sitagliptin metformin, alogliptin metformin. But I will confine today my discussion to the most commonly used drug, metformin and glimepiride. And the hypertension combinations are here. If you go to Europe, we have metformin and pio, glimi and pio, lina and metformin, vilda and metformin. metformin sitagliptin and metformin saxagliptin. In the Australia, they approved by the drug authority are glibenclamide metformin, linagliptin metformin, metformin sitagliptin, metformin saxagliptin, and vildagliptin. In Japan, we have various combinations almost similar to USA, to Europe, but we have a glibenclamide metformin prominent among them. Therefore, dear friends, before I go to two important combinations that I will take up today before I finish, the advantages are many: convenience, ease of administration, ease of remembrance, synergistic effect, so very effective, complementary mechanism of action, tolerability and safety because less side effect with low dose of each one, economy, there's a cost containment, and the reduced pill burden, a psychological advantage. Now, what should be the ideal characteristics? They should act through different mechanisms of action. There should be pharmacodynamic compatibility and physical compatibility. Now, should not hamper absorption, distribution, metabolism, and excretion, reduce the adverse effect, and should improve the convenience and compliance. Dear friends, one of the commonest combination therapy in our country is sulfonylurea and metformin, available in different countries, available in at least 30 countries that I could put my hand on. It's the best studied combination and a therapeutic approach that addresses both underlying defects, insulin deficiency and insulin resistance, and it's a very common tool in the hand of the rural doctors in our country and for the doctors who are in the secondary cities, the B towns or C towns or the villages, and this has been praised in the ADA. Now, coming to the rationale of the therapy, as I told you, it addresses the two core defects found in the disease, and also glimepiride improve beta cell function, increase insulin synthesis and release. Metformin has insulin sensitizing properties. Glimepiride reduces the hepatic glucose output through suppression of the glucagon from the alpha cells. Metformin also decreases HGO, that's the most important action, targeting liver to decrease gluconeogenesis and glycogenolysis. Dear friends, if you look to the various efficacy, I'm showing it again to mention that the sulfonylurea metformin combination has the maximum effectiveness almost minus 1.8 to 2, and there are various others which I've shown earlier. Now, the bioavailability of both the drugs in the various studies has been wonderful, and as individual, as FDC, the bioavailability is equal, and various combinations available: glimepiride 1, metformin 500, glimepiride 2, metformin 500, glimepiride 1, metformin 1000, and also glimepiride 2, metformin 500 and 2 and 1000. Now, you come to the last part of my presentation. Now, today, the market also flooded with another combination therapy called metformin, glimepiride, and with the voglibose. Now, why do we want to take care of the post-prandial hyperglycemia? If you look to the JAPI 2015 Sasank's article, there are traditional diets are carbohydrate rich. Yesterday, a STAR study after I attended a session on the basal insulin, and you know, carbohydrate rich sometimes as high as 80% of the macronutrient. So the higher glucose load is in the greater prandial glycemic exertion and increased glucosidase and incretin activity in the gut. Therefore, AGIs are one of the preferred choice to control PPG, and I cannot drive home the implications of PPG control and role of voglibose. It has been shown that closer association of PPG with HbA1c compared to FPG is more related to HbA1c than the FPG in our country. Hence, PPG is better in predicting overall glycemic control. In combination with voglibose and SU, is significantly better control of FPG and PPG. Voglibose can be used as a first-line therapy in patients with high PPG level. I have a study comparing it with sitagliptin, and it will show that that it is very good. FDC of the voglibose 0.2, glimepiride 1 or 2 milligram, metformin 500 HR in a small number of patients were given twice daily, showed a great benefit, but larger studies are now available. Now, the efficacy and the safety of the oral triple drug combination have been shown in the voglibose, glimepiride, and metformin. You see the various studies that have been published. And before I end, I should say you that if you compare the glycemic variability in patients who are given sitagliptin and voglibose, a continuous glucose monitoring based test, it was shown that all the slopes of blood glucose elevation after every meal were significantly lowered under the administration of voglibose. Dear friends, there's Sarita Bajaj's article in their guideline where they've said AGI can be added to the combination of metformin and sulfonylurea. This is the last slide of two slides of mine, where the latest SGLT2 inhibitor and DP4 inhibitor have been combined together to be available in our country. Little costly, but it has shown that without hypo and weight gain, one achieve optimal control. To summarize, current guidelines are recommending to start combination therapy. Achieving early combination therapy is essential to target the goal at 6.5 or 7. Metformin in all studies, even with the SGLT2I, Jigduo, the Empamet, the metformin is the part of all combination therapy. Glimepiride and metformin are both time tested. Many trials have established the benefit of early combination of glime, met, and voglibose. Unlike earlier studies, there is stronger evidence now that the combination therapy approach is much better. Dear friends, FDC improves therapeutic effectiveness, tolerability, medication compliance, adherence, cost of therapy. Should be bioequivalent to single drug given separately. Globally, more FDCs are being approved to improve patient adherence and compliance. Thank you very much for your patient hearing.
Thank you, Dr. A.K. Das, for the lucid presentation, and we enjoyed really this presentation. Before going for question answer, I think another talk should also be completed.
And then all the questions answered by Uni only. No, I'll be there. I'm just joking. Uni, start.
My very good friend, Dr. Unni Krishnan, who has spent his very good time in my state also in his DM days. So most of the time we enjoy him talking in Hindi also. So Dr. A.G. Unni Krishnan, who is presently endocrinologist and CEO of Chelaram Diabetes Institute, Pune. He is a leading diabetes institute. It's a leading diabetes institute in India and an IDF certified center for education and excellence in diabetes care. Apart from that, we know Dr. A.G. Unni Krishnan for his wonderful oratory skills and his knowledge and multiple publications, what he used to do every year. So with these words, I will not take much of the time. Over to Unni for his presentation on durability of oral anti-diabetes drugs.
Thank you, Dr. Anuj. I hope I am audible.
Yes. You are very much audible.
And I hope my screen is also visible.
Yes, sir. Your screen is also visible.
Okay. So it's a pleasure to be here, and I'm going to speak about durability of OHAs today. And this will be my agenda for today. What is the durability of common oral hypoglycemic drugs, and why is it important? Then I will talk about sulfonylureas and the legacy effect, and then end with the verify studies and their implications on legacy. So let's look at durability. Why is durability important? Durability is important because this is a UKPD study showing that despite diet, as shown in green color, and despite oral drugs, as shown in the red dots, the HbA1c rises and rises over a period of time. And that's because the beta cells fail. This means that most individuals with type 2 diabetes will eventually require insulin therapy. Now, this is again data which shows years from diagnosis in the x-axis, beta cell function in the y-axis to your left, and insulin sensitivity in the y-axis to your right. What you will find is that the pink colors are for 8 to 10 years of diabetes, and the orange color is 2 to 4 years of diabetes. What you will find is that the time to need glucose lowering drugs is actually very important, and insulin sensitivity remains the same, whereas beta cell fails. Now, what you will find is that if you look at the ADOPT study, which looked at glibenclamide, metformin, and rosiglitazone, and when you looked at the cumulative incidence of monotherapy failure, rosiglitazone had the least monotherapy failure. In other words, thiazolidinediones protected the beta cells. So this is a study which looks at time to treatment failure between various OADs when used as second line. 20,000 people who were newly treated with an SU, DPP4 or glitazone following metformin failure were studied in this real world study for up to 5 years. What they found is that all groups did equally well, but sulfonylurea metformin, as given in the blue color, did not do badly at all. In fact, it was DPP4 inhibitors which was associated with a greater need for intensification. This is data with glimepiride and linagliptin resulted in similar HbA1c reduction over a long period of time. And this is data again, 2 years. Glimepiride and liraglutide, you can in the green color, glimepiride and liraglutide brought down the HbA1c, kept it there for up to 2 years. So very important data that glimepiride works well. And this is pioglitazone data. And as you can see, pioglitazone can lower the HbA1c and fasting and keep it there, and also decreases the whole lot of insulin resistance.
You may want to turn off your video. You may want to turn off your video.
I'll do that.
Because your bandwidth is...
There you go.
What's the problem? I think he is quite audible to me.
Is it okay now?
No, it's much better, much better.
Okay.
Go ahead.
So the second part of my presentation would be the understanding of the legacy effects with regard to sulfonylureas. Let's go back and look at what is a legacy. A legacy is anything that is handed down from the past as an ancestor or a predecessor is called a legacy. Something bequeathed to us from an earlier time is called legacy. If you look at what the Indian cricketer Sourav Ganguly said, and that was my biggest legacy which I left, a side which had the ability of winning at home and winning away from home. So a legacy is something that you bequeath for the future. So the British left us the legacy of the railways. This is the old Darjeeling Railway at the top and the Kolkata Metro Railway later. A very British study, the Wikipedia study, also left us a legacy, and that was the legacy of the legacy effect. If you look at the legacy of the legacy effect, in the Wikipedia study, which was completed in 1997, there were 3 groups: intensive group with sulfonylurea insulin, intensive group with metformin, and conventional diet. At the end of 1997, these patients were followed up for another 10 years, and 3 groups were studied: sulfonylurea insulin, conventional, and metformin. What the study showed is that the sulfonylurea insulin group and the conventional group did equally well. At the end of the study, sulfonylurea insulin group did better, but once the study was over and the patients were followed up, the people with better glucose control worsened their glucose control a little bit, and people with the worsened glucose control improved the glucose control a little bit, and they were same. So initially the sulfonylureas reduced the HbA1c, but after 10 years, after the study ended, it was the same. But remarkably, the risk of microvascular disease, which was significant at that time, became even more significant. In other words, a short period of glucose control by sulfonylureas insulin, even after they were stopped, continued to give benefits for up to 10 years. Then if you look at myocardial infarction, the macrovascular complication with insulin sulfonylureas at the end of the Wikipedia study was not significant. Well, people would say it is not significant, but the p-value was 0.052. Some would call it borderline significant. But at the end of the study, when the people were followed up for 10 years post-study, those people who aggressively controlled their blood glucose levels with sulfonylureas and insulin had a statistically significant reduction of myocardial infarction 10 years later on. If you look at the legacy effect, after 1997 was when the UKPDS study got over. 2007 was 10 years from the UKPDS study. Any diabetes endpoint came down significantly. Microvascular came down significantly. Myocardial infarction came down significantly. All-cause mortality came down significantly. So what the study authors concluded is that despite an early loss of glycemic differences, an initial aggressive glucose control therapy, even after that glucose control is stopped, continued to produce a reduction in microvascular complications as well as myocardial infarction and death from any cause, even 10 years after the study. Now, this is a quote from Shakespeare, which talks about the legacy effect. In fact, this is from Julius Caesar, where Mark Antony says, "The evil that men do lives after them. The good is oft interred with the bones." So this is something which talks about the reverse legacy effect of hyperglycemic memory. Just like initially good glucose control, even the glucose control is not there later on, gives long-term benefits. Initial poor control, even if you control the blood sugar later on, leaves a mark. So the evil or the hyperglycemia that happens in diabetes even lives after the hyperglycemia, whereas it is not really interred with the bones, as Shakespeare said, but the good continues to do well. Even the early glucose control continues to do well, even after that control has been stopped. So we've talked about oral hypoglycemic agents. I showed you how thiazolidinediones are durable and that contrary to expectation, sulfonylureas also could be durable. I also showed you the legacy effect of long-term glucose control. Let's look at sulfonylureas and the legacy effect. Now, the Carolina study was expected to be a landmark study, which compared DPP-4 or SU. It was the largest active comparator study, very close to the UKPDS, and had the longest follow-up. So it was the largest CV outcome study of a gliptin with a comparator with the longest follow-up, and the results were published last year. And it was shown that on one side, glimepiride was given, and on the other side, linagliptin was given. And as you can see, the forest plots show all the dots in the center, suggesting that linagliptin and glimepiride both were CV neutral. You can see the lines overlapping with each other. In other words, glimepiride and linagliptin had similar CV outcomes. So we are told that sulfonylureas, cause beta cell failure, they cause hypoglycemia, people eat, people put on weight, that worsens insulin resistance and therefore removes durability. If you look at the study, the weight gain, if somebody asked, how much was the weight gain? And you tell the weight gain, and somebody asks 1.54 kgs in 4 years. Sorry to show Pankaj Tripathi, I thought it would wake up the audience. But if someone were to ask 1.54 kilograms in 4 saal, Sirji, in 256 weeks. So it's not 1.54 kilograms in 4 years. Sulfonylureas resulted in 1.54 kilograms in 256 weeks, close to 5 years. And therefore you can see this sort of scientific imagery that is built around sulfonylureas causing massive weight gain, massive hypoglycemia, beta cell failure, apoptosis. All these really didn't play out in the Carolina study, so to say. Let's look at beta cell failure. One of the important beta cell failure indicators are a progressive rise in HbA1c. And there was no progressive rise in HbA1c with glimepiride compared to linagliptin. And therefore, people initially used to whisper. Now people talk aloud. Where's the beta cell failure with sulfonylureas? Is it a figment of the pharmaceutical industry's imagination? You can see that weighted average of HbA1c remaining similar for glimepiride and metformin for 52 years. Yes, the point is taken. This is not a HOMA beta study of insulin secretion, nor is it a clamp study. But as an indirect indicator of beta cell failure, the HbA1c did not shoot up with glimepiride compared to linagliptin. But yes, glimepiride was associated with more hypoglycemia. That was there, and it is to be accepted. This is a study of comparison of all the studies which look at initial versus late intervention, and you can see that the UKPDS showed that both microvascular and macrovascular benefits are there. So I've looked at the durability of common oral hypoglycemic agents, why it is important. I've looked at legacy effect, how good glucose control initially, even if the glucose control goes away, gives benefits in the long run. I've looked at sulfonylureas and some of the reasons why they continue to be cost-effective drugs in a developing country like India, where affordability and accessibility to medicines are important. And at least the Carolina study questions the reportedly massive weight gain occurring with sulfonylureas like glimepiride. It certainly questions the CV risk of glimepiride. There's no CV risk. It was as CV neutral as linagliptin, and the persistence of HbA1c at a comparable level with linagliptin at least suggests that sulfonylureas do not cause more beta cell failure, causing HbA1c increase when compared to linagliptin. Now let's look at the VERIFY results. The VERIFY study, everybody is aware of the VERIFY study, which was an early combination study of vildagliptin and metformin. And this looked at durability, looked at CV outcomes. Of course, CV outcomes were exploratory. And putting VERIFY in the context of other studies, VERIFY was a very, very early study. And the HbA1c targets were very tight, and vildagliptin and metformin was started very, very early, and the HbA1c target was kept tight. Let's look at just the secondary endpoint, because the VERIFY study has been shown and shown and shown. And if you look at the time to secondary treatment failure, which is a secondary endpoint, what you will find is that the red line shows metformin and placebo, and the time to second treatment failure, that is 2 consecutive HbA1cs more than 7% with metformin and vildagliptin, you will see that the percentage with an event was lower in vildagliptin. In other words, starting DPP-4 and metformin very early actually reduced the need for additional therapy because the HbA1c did not, to that extent, reach more than 7% twice. So these were the reasons suggesting the durability. So some of the findings of the VERIFY study, where vildagliptin metformin combination was used early, is that early combination of DPP-4 and metformin reduced treatment failure, durability improved long-term control. An exploratory endpoint, of course, this cannot be taken because it was an exploratory endpoint, but there was some hint of a CV event reduction numerically, but the safety and tolerability of a vildagliptin metformin combination were confirmed, and there was real world evidence out there, and the VERIFY actually mimicked the real world evidence to a great extent. Well, this is my last slide, and this shows you on the x-axis time and on the y-axis A1C. You will see that to keep the A1C at or below 7% is a huge challenge, because the HbA1c will rise and rise and rise. And that's because beta cell will fail and fail and fail. Which means that from the first agent to multiple agents, we will have to keep on increasing therapy. Each time you add a second agent, the A1c rises. You add a third agent, the beta cell fails, the A1c rises. And this keeps on happening. Maybe initial combination of a drug like metformin and DPP-4 could have a role in keeping that A1c down and preventing the need for an additional agent. I'd like to summarize by saying that many oral drugs today are durable. Metformin is durable, pioglitazone is durable, vildagliptin is durable, linagliptin is durable, glimepiride is durable. So let's not talk about some drugs being holier than thou or more durable than others. I showed you even data with liraglutide and glimepiride, comparing them or combining them together. I want to add that the legacy effect is a very old effect where good initial glucose control benefits in the long run, and hyperglycemic memory where poor glucose control early on does not give the benefits later on. I also looked at sulfonylureas, very economical drugs in a developing country like India, where not everybody can afford expensive medicines. And I showed you data that sulfonylureas are relatively durable in the long run. Well, sulfonylureas do cause hypoglycemia, and therefore comes the role of DPP-4 And I showed you the verified data where a DPP-4 like metformin was combined with, sorry, a DPP-4 like vildagliptin was combined with metformin, and the early initial combination therapy showed durable effects. Really, it has been a pleasure to be here at this meeting and discuss these topics with all of you. I'd like to thank you all for listening to me, and will be happy to take any questions.
Thank you, Dr. Unnikrishnan. Another fantastic talk, what we could listen here. Till we get some questions from the question and answer box or chat box, I'm asking one or two questions from my side. And very nicely explained by Dr. Unnikrishnan that whenever we are using the dual drug combination, it is not simply 1 + 1, 2, it is giving us something more than 2. But my concern remains with the triple drug combination, and in fact, it's multiple people, those who are practicing, they have their concern that whenever we use 1 + 1 + 1 means, as Dr. Ashok Das has said, that sulfonylurea, voglibose plus metformin. When we are using this triple drug combination, is it really 1 + 1 + 1, 3, or something more than 3 or less than 3? So my question from both the speakers, one by one, both of you can answer.
I'll just answer first, then pass on to Uni.
Yeah.
Now, the triple drug combinations are not only with voglibose, Anuj. The triple drug combinations are also available with pioglitazone and many other oral antidiabetics.
Yes.
And the initial objection was raised regarding the voglibose because of its starch blocking agent, but that by studies have been negated. And you know, if you want to cut down the pill burden, it definitely helps. Now, there is 2 studies which have examined the triple drug combination with the voglibose, one by Anil Parikh from our country, and one more. Both have shown that the effect is much more than the individual drug addition. So I think that's the only thing that's available today. And you know that we have a program today in the country for this triple drug combination to see in various places how it can be taken forward. Results may be available shortly. Uni?
I completely agree with Dr. Das that the FDCs are actually a very Indian innovation. They improve compliance and they bring down the cost. So I agree with, as Dr. Anuj also mentioned, many times in India, we use 2 drugs, 3 drugs, and 4 drugs. Now, up to 3 drugs, I think it is a safe bet because HbA1c doesn't rise and rise and rise. When it comes to the 4th drug, studies have shown that instead of giving a 4th oral drug, it is probably good to add insulin. That's what the recent studies are showing. So up to 3 drugs, because that's not because of the quality of the 4 drugs. It's probably because we have taken that much time for the 4th drug to be added. And that duration of diabetes has resulted in more beta cell failure, meaning that the HbA1c has already unacceptably risen and the 4th drug may or may not work. So that's what the study is showing. It's up to 3 drugs, it's okay. But when it's the 4th drug, maybe the duration of diabetes and the degree of beta cell failure suggests that insulin could be an option or another injectable.
Anush, can I add one point to what Uni has beautifully presented the data on the legacy effect of sulfonylureas. Now, we have now working on a paper where we are showing that the combination of of the sulfonylurea plus metformin. I mean, metformin is the basic drug, and we know this legacy effect has shown the legacy effect in whatever advance on. Uni beautifully adhered to the UK PDS and many other studies. So we have said the newer drugs are good. They are fashionable. They are quite good. They have multiple benefits. Nobody can deny it. In our guideline, when we wrote, we have given the place of pride to all the new drugs, Anuj, we have given. But we have said that we could not poo-poo the older drugs. That's what I think Uni's message was. That's why we did this study. Keshu is here. Keshu may or may not agree. I call Seshadri Keshu. Keshu, we did that study of the SSS. In your language, Satyam, Shivam, Sundaram, in our language, SMART and smart sulfonylureas. And we said that it has to be used in the country of 90/10 and 10/90. And your conference is 10/90. You have realized that the 10% of the diabetes budget is spent for 90% people, and 90% of the of the diabetic budget is spent for the 10% people. That's why we have given simple topics. I really like it, Keshu. I have no motive. My lunch is assured. Now, I must tell you that this drug, we call it, I think Uni disappeared. Uni, we call,
yes, I'm here.
We call this drug, I mean, in our colloquial language, that they are like Ramayana and Mahabharata, that epics, sulfonylurea and metformin and their combination. And the newer drugs are good, but they have today, they don't have the legacy effect. They will wait another 20 years for the UKPDS study, another 12, 19 years for the advanced study, which showed 8 years of life extra. You all know it, I'm not carrying. And we call it, in a jocular way, excuse me, the Chetan Bhagat's half-girlfriend. So Ramayana and Mahabharata are established. The new drugs will definitely do all. I mean, I also adhered to the combination of the DPP-4 SGLT2, wonderful combination, but cost 78 rupees. You know, I'm just telling you that it is the way the world moves. So I think very happy to that this drug, this combination were discussed here. Any other question? We have time, I think, a couple of minutes.
Maybe I do want to come in, Dr. Das, because
yes,
you dragged me in.
Yes.
So it's very interesting that even, you know, that I've been shouting through the rooftops about, you know, how this durability issue has unnecessarily tarnished these sulfonylureas. Even if you look at the ADOPT trial,
exactly.
That if you go back and look at the ADOPT trial, the durability of the sulfonylureas in the ADOPT trial was around 3 years.
Exactly.
Right.
Exactly. I showed that slide only before I showed the verify one slide, because when he was talking about it, I showed the ADOPT slide.
So the ADOPT, even in the ADOPT trial, which is like about 10 years old now, the durability, if you go back carefully and look at the durability, it was not high. What seems to be determining both durability and anything for a drug is not just the characteristic of the drug, but how early in practice the drug is started.
Exactly.
I think the message that we are getting, and if you look at the VADT legacy effect, you will find that the VADT's legacy effect, you know, is not like how the UKPD has talked about it. So they are saying that the legacy effect hardly lasts for 2 to 3 years. So I think, you know, the key that for all of us is, you know, I understand at this end of the spectrum we're talking about complication, but at the beginning of the spectrum, when somebody is becoming a diabetic, our objective needs to be give whatever you want, but make sure that those glucoses are down in the first 2 to 3 years. I think this dichotomy in our approach is something that is required. Maybe last comments we can have from Anuj, Uni, and Dr. Das.
And I'll just a single sentence that Sanjay is speaking. Sanjay, please.
Yeah, no, I just wanted to ask a question to Uni. See, commonly we have all our algorithms which say, okay, single drug, dual drug, and depending on the A1C, very often you tend to start dual combinations early. Have you ever hazarded to start a triple combination at the start of, you know, diabetes itself? I mean, where would you think that?
I have.
We haven't had any such, you know, data coming up, and you say, okay, at the time of detection of diabetes, would you hazard starting a triple combination state?
I do.
Yeah, I mean, so where the situation where you would think of starting triple combination straight away?
So usually I wouldn't be so brave as to start 3 drugs along with lifestyle modifications.
Same with me.
But maybe occasionally, if somebody is very obese, has very high HbA1cs, does not require insulin, because I feel if somebody is polyuric, polydipsic, we should give insulin. Maybe at those patients, I might like to give a metformin, a DPP-4, maybe an SGLT2, maybe an SU. But my choice has generally been 2 drugs and lifestyle modifications. Maybe Dr. Krishna, you said you give.
Krishna,
I have, in a sense that someone's A1C is really crazily high.
Very
but,
high.
You know, I have. They need some time, especially they need some time for insulin. You know, a lot of people, even if we talk to them about short-time insulin, say, "Sir, can you give us some time?" Then what I do is, you know, I use a small dose of sulfonylureas, a DPP-4 inhibitor, and a metformin.
Exactly.
Simply because the SU will bring down the glucotoxicity, and the DPP-4 and the metformin will give them that stability that they need. And in someone who's got an A1C of 10, no symptoms, needs some time to get onto insulin. And interestingly, and really interestingly, you know, the combination of these drugs as well as this thing, you will find that many of them settle. It's not everyone. And Dr. Das, you want to?
Yes. Yeah, I just want to take a issue is exactly the same sentiment when we started this study now. Taken triple drug combination, all India study, a real world study, but it is also in investigator initiated study. I just like to add one thing, issue which I learned yesterday, Sanjay. Now we had a single sentence that the number 1, number 2, number 3 drug for the GDM is insulin. Am I correct? Metformin other than number 1, number 2. Today we have modified the slogan. The number 1, number 2, number 3 drug is not ordinary insulin, but the analog insulin, because of the benefits of analog insulin in GDM. I think the taking cue from what has been discussed and what Keshu has so prominently expressed, I think the slogan should be bring down the blood glucose control as early as possible by hook or by crook or by hook and crook. If you use 2 combinations, or Sanjay, if required, intelligently use 3 combinations by hook or crook or by hook and crook. Early aggressive control is the key that Keshu rightly said.
Thank you, everyone. Dr. Anuj, thank you so much for being here. It's very difficult for many of us as we get older to stay awake
Keshu, don't
before and after lunch.
Keshu, don't say that. You are not yet born.
I am. I'm not yet born.
Not yet.
I'm not born, but I'm bald.
Compared to no. You are not even tired. What you say about? No. You are so young.
So anyway, the beauty of this conference is I get to sit for about 8 to 10 hours every day listening to people doing such wonderful work. Thank you, everyone. We need to move on. Please stay on because we have some two exciting talks. One on weekly insulin with Dr. Erika Nishimura and Dr. Enrique Morales on the weekly oral semaglutide. This is a program that is brought to you by Novo Nordisk, but these are such exciting molecules that everyone should really be listening to them. I have Dr. Anil Kumar and Dr. Sanjay Agrawal. Welcome, Sanjay. Welcome, Anil.
Thank you.
Please take over this session and introduce the speaker. Dr. Erika, you're ready, I hope.
Okay. Anil, do you want to go ahead and introduce the first speaker?
Yeah, the first speaker is Dr. Is it
Dr. Nishimura's? Dr. Nishimura's introduction, please.
Okay. No, you can go ahead, sir. Dr. Sanjay, you can go ahead.
All right. Welcome, everybody. It's a great pleasure and honor to introduce our first speaker of the afternoon, Dr. Erika Nishimura. She is currently the Scientific Vice President, Diabetic Research and R&D at Novo Nordisk in Copenhagen, Denmark, where she's overseeing the late stage of insulin research and development projects. Erika obtained a PhD in physiology from the University of British Columbia in the field of gastrointestinal hormone receptors and was a postdoctoral fellow at the Peptide Biology Laboratory at the Salk Institute in California, where she studied neuroendocrine hormone receptors. In 1991, Erika joined Novo Nordisk as a principal investigator at the Hedon Research Institute, where her research interest was in the role of glucagon in the pathophysiology of type 2 diabetes and the possible therapeutic benefits of glucagon receptor antagonism. Since 2000, she has specialized in the development of next-generation insulin therapies, including the Degludec portfolio, consisting of Tresiba, Icodec, Zoltofy. Her current research focuses on the biological characterization of novel insulin analogs. Today, she will be speaking to us on taking the next leap in basal insulins. So over to you, Dr. Erika, and we'd love to hear you. Is Dr. Erika there?
Dr. Erika? I think she stepped out of her desk. Can we, Dr. Morales, would you like to go first? Since Dr.
Yes, of course.
Okay, so why don't we quickly switch gears and get Dr. Morales to speak, and Dr. Nishimura can come in after him. In the meantime, we will try to contact him.
Okay, I'll introduce him. I think we will. Hello.
Hello, how are you?
Hello, yeah. Dr. Enrique Morales is founder director, Cardiometabolic Research Center at Mexico. And hello.
So we can hear you. You can proceed, Dr. Anil Kumar. You can proceed.
We have the CV slide. CV slide went off.
Neelam, do not remove the CV slide till I tell you to stop. Thank you. I will come in. Yes.
And he's also the founder and director of cardiac catheterization at Hidalgo Hospital, Mexico. And he's founder and professor of cardiology fellowship at the same hospital. And is cardiology and intervention cardiology fellowship from the National Institute of Cardiology, Ignacio, and he was the principal investigator in 100 multicenter studies, phase 2, 3, and 4. And he was the author of several chapters in textbooks of cardiodiabetology, and his main research interest was primary cardiovascular prevention with focus on obesity, type 2 diabetes, endothelial dysfunction, and atherogenesis. And I think he's speaking on a very interesting subject on oral semaglutide, a protein in pill. I think we have seen a lot of injectable GLP-1 agonists, both once daily and once weekly. This will be a very interesting talk from you. Over to Dr. Enrica Morales.
Krishna, Dr. Erica has joined in. Do you want to keep the sequence, or would you like Dr. Morales to go on?
If you want Erica first.
We will leave it to both of them because
she's joined.
Dr. Nishimura, are you ready to start? Dr. Morales has agreed to start if you're not.
Hello, can you hear me?
Very well, very well. Are you ready?
Oh, okay, yeah. Yeah, I can if I've been having some problems joining, but I can see if it works now. Oh, okay. There I am.
Can you share your screen?
And I would share screen.
There's an icon at the bottom of the Zoom platform.
Yeah, I push share. Oh, I have to say entire screen. Yeah.
Dr. Nishimura, what I would suggest is that you come over to the green room and we will help you with doing this and then get you back here. Well, Dr.
Yeah, so that was my problem. I couldn't use any of those links to the green room.
Just refresh
so
it.
they gave me a direct link. Yeah. So I will talk to one of the supporters.
Right.
Okay. There's been some problems. Yeah. Okay. So
and
maybe
the other thing you could do is you could mail us your presentation, and we can present it from here while you speak. So what we'll do is we'll get you back to the green room. Dr. Morales will continue the talk. Dr. Morales?
Yeah. Okay.
Yeah.
Thank you.
Can you see my screen?
Yes, sir.
Yeah.
Okay, perfect. Good morning here in Mexico, and please join me in this short but incredible history. In 20 minutes, we will review the amazing background, research, and development that is paving the way for oral semaglutide, a protein in a pill. Be the change that you want to see in the world, Mahatma Gandhi. Thank you really for this kind invitation to participate in this ADA Primer 2020 from Mexico to India. The internet technology allows me to be connected with me here in Mexico, with you in the beautiful India, with 10 hours and a half of difference. Really awesome. These are my collaboration with the Big Pharma. With Novo Nordisk, I am a speaker, advisor, and researcher. Currently, I am principal investigator for SOUL trial and national leader for SELECT trial. Let me share with you my social media and my academic portal, where right now you can download this presentation. My topic today is the background, research, and development of a protein in a pill, paving the way with oral semaglutide. First of all, I would like to make an important disclaimer. subcutaneous semaglutide is neither available nor marketed in India. So let's start with the background. In this 2020, we are living in the so-called bright side of the type 2 diabetes mellitus. We are living in the cardiovascular era. Nowadays, we as doctors can offer to our patients a significant reduction of the morbid mortality for myocardial infarction, cerebral infarction, cardiovascular mortality, heart failure hospitalization, and chronic kidney disease progression with the use of 2 new classes of drugs and 6 new molecules, one of them semaglutide. Now, let's talk about GLP-1 receptor agonists, a class without class effect. With this class, we have published 7 CVOTs cardiovascular outcome trials with 57,000 patients included. In this slide, we can observe at a glance the results with this class. Exenatide and lixisenatide, both exendin-4 derivatives, are secure in the cardiovascular arena, but are not protected. Unlike liraglutide, dulaglutide, and semaglutide are secure and effective for cardiovascular risk reduction. What about research? Subcutaneous semaglutide is an improved GLP-1. This is the anatomy of GLP-1, a polypeptide derived from proglucagon with 31 amino acids, a molecular weight of 4.1 kilodaltons, produced by the intestinal L cells, and a half-life of just 2 minutes. This polypeptide binds to the GLP-1 receptor in the CX ring and is proteolized by the DPP-4 enzyme in the positions 8 and 27. Based on the knowledge of the GLP-1, Jesper Lowe and collaborators designed the semaglutide's anatomy. They substitute an alanine per an aminobutyric acid in the position 8, which gives protection versus DPP-4, and in position 26 linked through a linker, and 18 carbon diacyl fatty acids, which gives an unstable union to albumin. In this way, semaglutide preserves 31 amino acids, 94% of homology with the GLP-1, and prolongs its half-life from 2 minutes to 160 hours. Really an incredible achievement. The pharmacokinetic of semaglutide is perfect for a weekly use, and a half-life of 7 days and a Tmax of 1 to 3 days. Thanks to its anatomy, the union of semaglutide to the extramembranal domain of the GLP-1 receptor is almost perfect, as we can see in this beautiful image. In short, the phase 3 clinical research program of subcutaneous semaglutide has shown superiority on glycemic control without hypoglycemia and with body weight reduction versus all its comparators. These are the publications of the SUSTAIN program. Against placebo, sitagliptin, exenatide, glargine, dulaglutide, canagliflozin, and liraglutide, subcutaneous semaglutide has demonstrated significant superiority. Add on to glargine or SGLT2 inhibitors, semaglutide has shown a secure and additive effect, and in SUSTAIN 6 trial, semaglutide showed security, and beyond that, showed cardiovascular protection. SUSTAIN 6 trial was a paradigm in clinical research. This trial was designed to show non-inferiority in a pre-approval phase with a low upper limit of the confidence interval of the hazard ratio between 1.3 and 1.8. However, SUSTAIN 6 showed in 2.1 years of follow-up a relative risk reduction for the triple MACE of 26%, with an upper limit of the confidence interval of 0.95 and a p-value of 0.02 for superiority, an amazing result. In other words, an absolute risk reduction for the triple MACE of 2.3, equivalent to a number needed to treat of 43 in only 2.1 years, equivalent to 18 in 5 years of treatment. With this result, Sustain overcome the FDA rule and showed superiority over the standard of care. In conclusion, subcutaneous semaglutide has a half-life of 160 hours, is superior to all the comparators, and has shown cerebral, cardiac, and renal protection. Now, let's talk about oral semaglutide development. A dream comes true. Oral semaglutide is a protein in a pill. The main rationale for oral semaglutide is the fear of injections, which still remains, at least in 25% of patients, and incredible in doctors. Development of this kind of molecules has many challenges. Among the most important challenges we have: the requirement to increase gastrointestinal permeability, to decrease gastrointestinal enzymatic proteolysis, and to avoid food absorption interference. To overcome these challenges, semaglutide is co-formulated with a molecule called SNAC. SNAC, or sodium aminocaprylate, is an enhancer that reduces gastric pH and increases gastric absorption. In this way, oral semaglutide is absorbed through the gastric mucosa, as we can see in this beautiful animation. Semaglutide concentration is correlated with gastric tablet erosion and gastric emptying, as we can see in this slide. Once absorbed, the pharmacodynamic of oral semaglutide is equivalent to subcutaneous semaglutide, as we can see in this graphic, which compares the effect of A1C and body weight reduction in the Pioneer versus the Sustain trial, with oral and subcutaneous semaglutide respectively. So, as a second conclusion, we can say that oral semaglutide administered in fasting state overcome the challenges of gastric enzymatic degradation and absorption, reaching clinical efficacy. But what about clinical research with oral semaglutide? Oral semaglutide also has shown superiority for glycemic control without hypoglycemia and with body weight reduction. These are the trials of the Pioneer program with oral semaglutide. Oral semaglutide, as subcutaneous semaglutide, has shown superiority versus placebo, empagliflozin, sitagliptin, and liraglutide. In patients with level 3 of chronic kidney disease, is superior to placebo and secure. Add on to glargine, has an additive and secure effect, and in Pioneer 6 trial showed cardiovascular security in high-risk patients. In the next slides, you will see in the superior panel the results on A1C reduction, and in the inferior panel the results on body weight reduction. In pink, orange, and red bars, you will see the oral semaglutide results, and in white bars, the comparator results. Having said that, let me show the results of the Pioneer trials. These are the Pioneer 1 trial results. Against placebo, semaglutide 3, 7, and 14 milligrams has shown significant superiority on A1C reduction and in body weight reduction. In Pioneer 2 trial, against empagliflozin 25 milligrams, oral semaglutide 14 milligrams has shown superiority in A1C reduction. In Pioneer 3 trial, against sitagliptin 100 milligrams, oral semaglutide 7 and 14 milligrams has demonstrated superiority on A1C and body weight reduction. In Pioneer 7 Flex trial, the Pioneer 3 trial results was corroborated with a flexible scheme for oral semaglutide according with gastrointestinal tolerability and A1C level. In conclusion, oral semaglutide 7 and 14 milligrams has demonstrated significant superiority versus placebo, empagliflozin, and sitagliptin on A1C reduction, and superiority versus placebo and sitagliptin in body weight reduction. In Pioneer 5 trial, in patients with chronic kidney disease phase 3, oral semaglutide 14 milligrams has confirmed security and superiority versus placebo. Finally, in Pioneer 8 trial, semaglutide 3, 7, and 14 milligrams add-on to basal insulin has shown versus placebo security and additive effects on A1C and body weight reduction. In this way, semaglutide has demonstrated as oral formulation security and efficacy in individuals living with type 2 diabetes and chronic kidney disease. Also, oral semaglutide has demonstrated an additive effect on A1C reduction add-on to basal insulin with security. Now, what about cardiovascular security? Mansoor Hussain in Pioneer 6 trial published in New England Journal of Medicine in 2019 communicate that in a design to demonstrate non-inferiority with an pre-approval criteria, that means an upper limit of the confidence interval of the hazard ratio between 1.3 and 1.8 in patients with type 2 diabetes with high cardiovascular risk or with cardiovascular and or chronic kidney disease. In 3,183 individuals randomized to semaglutide 14 milligrams or placebo, the incidence of cardiovascular death, myocardial infarction, or stroke in 1.3 years of follow-up has a relative risk reduction of 21%, with an upper limit of the confidence interval of the hazard ratio of 1.11 inferior to 1.3, and with a p-value significant for non-inferiority, with an absolute risk reduction of 1% in a population with a triple MACE annualized risk of 3.6, lower than the risk observed in SUSTAIN 6 trial. With the results, Pioneer 6 accomplished and overcome the primary objective in a pre-approval phase and demonstrate cardiovascular security, paving the way to the SOUL trial. This trial, nowadays ongoing, is designed to show superiority versus placebo on top of the standard of care in patients with type 2 diabetes and high cardiovascular, cardiac, and renal risk. Without any doubt, we are paving the way with oral semaglutide for a better future in patients with type 2 diabetes. The world is changing. The question is, are we changing in the same way? With this, I finish my talk and say, thank you, India. I hope to see you soon. Thank you very much.
Thank you, Dr. Enrique. I think it was a wonderful talk. You covered very elaborately all the research that has come forth on semaglutide. Krishna, do we take questions now or after Dr. Erica's lecture? I think we'll take the question. Will you be on the platform till Dr. Erica finishes, Dr. Enrique?
Yes, of course.
Okay.
All right.
I can take your questions.
Are we ready with Dr. Erika?
Dr. Erika?
Hello?
Yeah.
Can you hear me now?
Yes.
We
Can
can
you show your slides?
I gave them to the organizers and they said they would.
Yeah, so it's already done. So you can tell them to when to advance
Okay.
the slides.
There, so I just have to tell them when to change. I'm sorry about the technical issues, but thank you to the chairman for having me on this meeting, and the committee for giving me this opportunity to speak about taking the next leap in basal insulin. It is really a pleasure for me to be able to introduce to you all the new insulin molecule, insulin Icodec, which is a once weekly basal insulin analog. So in the next slide, I just have my disclosures. I'm a Novo Nordisk employee and shareholders, and as such, I will not offer any clinical recommendations, and my talk will be limited to scientific data and research results. So the next slide, please. Here, we're just looking at the rationale for why we designed a insulin analog for use as a once weekly administration. And this was mainly with the patients in mind, because the idea is that once weekly injections rather than once daily would offer greater convenience. And as such, it would become easier for patients to overcome their clinical inertia when starting insulin therapy. And once they are on insulin therapy, then we would get better treatment adherence, and then we would expect to have good glycemic control. But of course, when making it once weekly insulin, where you have to dose 7 days of insulin in one injection, it was very important to ensure that we did not increase the risk of hypoglycemia. So from the research perspective, we knew that we had to ensure a molecule that has a very long half-life, and that this half-life should, PK and PD should be very flat and stable. And to do this, we had to build in a mechanism to slow down the clearance rate. Of course, we had to ensure that we get comparable glucose lowering effects compared to the once daily insulin, basal insulin therapy. And very importantly, we had to build in a mechanism to ensure that even though we're dosing 7 days of insulin in one injection, we don't increase the risk of hypoglycemia. So after a number of years of research in the lab, we were able to achieve all of this. And if you go to the next slide, we can see the how we designed this molecule. So this is how we built insulin Icodec. It's based on the established acylation technology we have used previously for our once daily basal insulin, insulin detamir and degludec. And we have made some additional modifications. So if you click the next, yeah, that shows the changes we have made to the amino acid backbone of the insulin molecule. So this is the insulin molecule amino acid sequence that we see here with 3 amino acid substitutions. And these have been introduced in order to increase the molecular stability of insulin Icodec, prevents degradation and breakdown, and also very importantly, it reduces the receptor, insulin receptor binding affinity, which then slows down the receptor-mediated clearance. In the next click, we can see that we have removed the terminal amino acid, and we have attached a small spacer. And at the end of that, we have introduced a C20, so a 20 carbon long icosane fatty diacid. And this is, the icosane is actually where the name insulin Icodec comes from. So this 20 carbon long fatty diacid imparts very strong but reversible binding to albumin. And in addition to that, this fatty acid also reduces the receptor affinity and also slows down receptor-mediated clearance. Now, if we click on the next, then we will see the effects of all these modifications to the molecule. These are the key features. We have a very high stability and solubility of this molecule, which means we can concentrate the formulation 7 times higher, so that even though you're giving a 7 times higher dose for the entire week, the dose volume will be the same as what you would be using for a once daily basal insulin. So no increase in dose volume. This strong albumin binding makes a depot of circulating insulin Icodec, which is bound to albumin. And one thing that we should note is that there is a high excess of albumin concentration compared to the insulin Icodec, over 2,000 times higher albumin compared to Icodec, which means that there won't be a situation, even under different conditions where we would have reductions in albumin, that there will be not enough albumin to bind the insulin Icodec. The reduced rate of receptor-mediated clearance due to the low insulin receptor affinity does not mean that we have a low potent analog. In fact, we have full effect. The only difference is that the effect is very slow in onset, and it is covering over a very long period of time. And finally, these modifications made to the insulin molecule, we have ensured that has not changed the biological actions of human insulin. So we've ensured that it still binds selectively to the insulin receptor and not to the IGF-1 receptor. I'm still in the other slide, but anyways, and we have not made any changes to the insulin molecule. So what these changes have done is made the molecule very long acting, and we had seen this very early in our preclinical studies. Here we're looking now at the pharmacokinetic profiles in dogs following a single injection of these different insulin analogs. And you can see for insulin Icodec, the C20 in light blue at the top, it has a very long half-life compared to, for example, insulin degludec in the dark blue, which is a C16, has a C16 fatty acid. We have a much longer kinetic profile, and you can see that this is associated with the longer fatty acid chain, getting more and more albumin binding. But the albumin binding isn't the only mechanism, and if you click on the next slide, what we are seeing is a cartoon of how insulin Icodec works. So the top panel there is the subcutis, represents the subcutis where the insulin is injected. Underneath, we see the blood vessel, and then beneath that, we have the interstitial space and the insulin target tissue. And this could be any tissue, fat cells, liver cell, muscle cell, anything that expresses the insulin receptor. And the gray flakes represent albumin. So if you, for the first injection, what we see then is that we inject 7 days worth of insulin in one injection. And because it has the higher concentration, we don't have to increase the volume compared to a once daily injection. And then if you click again, we see that the insulin Icodec slowly dissociates and then binds to albumin. So almost all of the injected insulin Icodec is bound to albumin, and in the albumin-bound form, it's inactive. So we're building up a depot of inactive insulin Icodec bound to albumin. And if you click again, then slowly over time, we see some insulin Icodec activating the receptor to give some glucose lowering effect. And this continues on the subsequent days, even after the injection on day 2, 3, 4, for the entire week. And then if you click again, we see at the end of the week, there's still some insulin Icodec left bound to the albumin. But then with the second injection, if you click again, we see that now we're adding more insulin Icodec to the pool of albumin-bound depot. And also, if you look down below, you see this insulin receptor-mediated clearance. This is very slow, and this also contributes to the buildup of the albumin-bound depot. And with the next click, you can see that then slowly over time, we will start getting more activation and more activation of the insulin receptor, and then we will get more glucose lowering effect. And then finally, if you click again, we will reach steady state. And steady state means when you have the dose that's going in is equivalent to the clearance of the insulin. So if you click again, you'll see that when we're at steady state, which will take 3 to 4 injections, now we'll see the full effect of the insulin Icodec dose. And if you click again, what you then will see is that because now the pool of insulin Icodec is large enough, we will see a continuous effect of insulin Icodec being released and activating the receptor. And we expect that at steady state, because of this albumin binding and slow activation of the receptor, that we will see only minimal changes in the glucose lowering effect with varying doses. And this should then buffer against hypoglycemia. So this is how we see insulin Icodec working. Now if we look at some actual data from humans, in the next slide, we will see the pharmacokinetic profiles in individuals with type 2 diabetes that were given multiple doses of insulin Icodec. So 5 weekly injections. So for 5 weeks, they have received insulin Icodec once a week. And now we're looking at what occurs at the 5th injection. And you can see we have a very long half-life. It is 196 hours, which is over a week. And you can see that the profile is very long and flat and stable, similar to what I have described in the cartoons. What you see in day 1 at around 16 hours, which is the Tmax, you see a peak. And this is expected because now at day 0, which is after the 5th injection, we have now injected 7 days worth of insulin. So of course there will be an increase in the plasma concentration of insulin Icodec. But we need to keep in mind that this is measuring the total of insulin Icodec. So this is bound insulin Icodec as well as free. And if you go to the next slide, what we're looking at now is the glucose lowering effect in the same group of people. And we're looking over each day. And you can see now in day 1 where we actually saw a peak in the PK profile in the concentration in the blood. Now we don't see a peak in the glucose lowering effect because most of this peak is just bound to albumin and is not giving the effect, and that effect takes place over many, many days. So now we can see that, yes, 1 injection of insulin Icodec in a week gives a fairly even distribution of glucose lowering effect over the entire week. which means that it should be suitable for once weekly basal insulin coverage. So then we tested this insulin Icodec in phase 2 clinical trials, and the next slide gives an overview of the phase 2 trials. So we conducted 3 different trials, 4383. It's a head-to-head study comparing insulin Icodec versus insulin glargine U100. This was done as a double-blind, double-dummy study, so the patients and the doctors did not know whether they were getting the insulin Icodec or the once-daily insulin glargine, because they had to give once a weekly injection in one leg and a once-daily injection in the other leg every day. So it was a completely blinded study. In the second study, we were interested in looking at different ways of titrating such a very long-acting insulin. So we compared 3 different titration algorithms. And this was an open-label study and slightly shorter for 16 weeks. And finally, we looked at 2 different ways of switching patients that already are on once-daily basal insulin and switching them over to a once-weekly insulin Icodec. And if you click again, we can see that the patients in the first 2 trials have never been on insulin before, so they were insulin naive, whereas in the third trial, these patients were on once-daily insulin. And if you look at the click again, these are the endpoints that we measured. In the head-to-head trial, the primary endpoint was a change in A1C. For the other 2 trials, the primary endpoint was time in range based on CGM, continuous glucose monitoring. However, what I'll show you today is just the A1C lowering in order to be able to compare the 3 trials, and I will also show the hypoglycemia data. So if we go to the first trial, in the next slide, once again, one more click. This is the way we titrated the insulin Icodec and the insulin glargine. And the first thing you should note is the target, the glycemic target. It's a very tight target with a goal of pre-breakfast self-monitored blood glucose levels between 3.9 and 6 millimoles, so very tight control. And the adjustment is plus 2 units if the fasting blood glucose was between 6 and 7, and an increase of 4 units if it was over 7. And the weekly corresponding doses is plus 14 units per week or plus 28 units per week. And the same goes if the glucose was lower than 3, between 3 and 3.8, then they would adjust by reducing by 2 units or the 14 units per week. Or if they were under 3 millimolar, they would adjust with reducing by 4 units or 28 units per week. So that was how the study was conducted. And if we look in the next slide, we can see the data where we compare the A1C lowering of insulin Icodec administered once a week compared to insulin glargine administered once daily. And we see a very similar reduction in A1C. There was a numerical lower A1C for insulin Icodec, but this was not significant. So very importantly, once weekly insulin Icodec has similar efficacy to once daily insulin glargine. Now, if we go to the next slide, we can see the rates of hypoglycemia. And this is shown in a bar graph where the dark part of the histogram represents level 1 hypoglycemia. So glucose levels between 3.9 and 3. And this is the hypoglycemia alert level. And you can see that in the Icodec arm, we do see higher levels of these level 1 hypoglycemia. We have the clear white bars represent the level 2 or severe combined, and we don't see any increase with the insulin Icodec in the level 2s or severes, but we do see an increase in the level 1 hypoglycemia. And this is maybe not too surprising, because if you look at our target, the target is pushing down to a fasting blood glucose of 3.9 to 6, and the level 1 hypoglycemia is actually under 3.9. So this is something that we were thinking about, and therefore, if you click onto the next slide, we tested different ways of titrating insulin Icodec, and this is the titration study. And if we go to the next slide, you can see how the 3 different ways that we have titrated insulin Icodec. So off to the right in dark blue, what we call Icodec titration C is the titration algorithm that we had used in the 4383 head-to-head study, where we had this tight target of 3.9 to 6 millimolar glucose, plus and minus the 4 units for adjustment. But then we tested a more less restricted target of 4.4 to 7.2, which is an ADA recommended target. So less stringent compared to the 3.9 to 6. And in one arm, we titrated with the plus and minus 4 units, so the plus 28 or minus 28, that is titration B. And we also used a slightly less, a lower adjustment with plus or minus 3 units. So that is plus 21 or minus 21, and that's titration A. So 3 different titration for insulin Icodec and insulin glargine was using the 4.4 ADA target plus and minus 4. So if you go to the next slide, we can see the results. We can see that for all 3 titration algorithms, we have very similar glucose lowering effects in terms of the A1C lowering. However, with the titration C, which was going down to the tighter titration target, we did see a significantly lower A1C lowering, but that is most likely because we have this lower target. And then if we go to the next slide, you can see the rates of hypoglycemia. So titration C in the middle there in light blue is the rates of hypoglycemia for the algorithm that was very similar to what we used in the first study. And as expected, the rates of hypoglycemia are very similar in these 2 arms with the tight glucose target. However, if you look at titration algorithm B in the middle and also titration algorithm A, where we even have a slower adjustment of the titration, now with this looser titration target of 4.4 to 7.2, which really reflects more real life, we have now been able to reduce the risk of the rate of hypoglycemia, both with titration algorithm B and also with titration algorithm A. So we have a way of ensuring good efficacy now without increasing the risk of hypoglycemia by adjusting the titration algorithm. And so finally, we have looked at the switch in the next slide from basal insulin to once weekly insulin, and we looked at using a loading dose of insulin Icodec with the first injection compared to no loading dose. And this is with the information in mind that insulin Icodec has this very, very long half-life, and it takes 3 to 4 weeks to reach steady state. And we wanted to see if we could give a loading dose to sort of get into steady state faster. So if we look at the titration or the switch in the next slide, this is how we switch the patients from their once daily to their once weekly. So if they were on the once daily basal insulin, they would switch 1 to 1. So if they were on 20 units of basal insulin, their starting daily dose, even for Icodec, will be also 20 units. For those patients that were on insulin glargine U300 or on twice daily basal insulin of any kind, we recommended that they drop their daily dose by 20%. And then for those who were on, so the weekly dose then was just a multiplication 7 times higher of their previous daily dose. And then those that were on the loading dose arm, they took their 7-day weekly dose and they doubled that. So basically, if they were on 20 units of basal insulin once daily, they would times that by 7 to give 140 units weekly dose, and then that was then doubled for those that were in the loading dose. So then 280 units per week. And then if you go to the next slide, we use the titration algorithm that was equivalent to titration B in the previous study, where we used the 4.4 to 7.2 ADA target and plus minus 4 units. And then if you look at the next slide, we see the results. So on the left, you see the A1C lowering. We get a good glucose lowering for both the arms with and without the loading dose, numerically lower for the ones with the loading dose, but not significantly different. So very similar glucose lowering overall in the 16 weeks. However, if you look on the right side, now we're looking at the fasting blood glucose levels. And you can see clearly that in the group that did not get the loading dose in dark blue, you see that there is some degree of glycemic slip occurring for the first 3 weeks. And this is a just an initial increase in their fasting blood glucose, because it does take this 3 to 4 weeks for insulin Icodec to reach its steady state and get the full effect. And then you can see quite clearly that if we give this loading dose, the double dose, and only on the very first injection they get a double dose, and then they return to their normal weekly dose, just one extra loading dose will then mitigate this increase in the fasting blood glucose over the first 3 weeks. So we've seen that this is a good way of mitigating this sort of initial transient increase in blood glucose. Then you will think, wow, okay, you've given such a high loading dose, what happens to hypoglycemia? So if we go into the next slide, if we look onto the right panel here, now we're looking at the rates of hypoglycemia with the insulin glargine arm compared to the loading dose or no loading dose. And we can see that the rates of hypoglycemia are very similar for all 3 groups. So even in the loading group, loading dose group, we did not get any increase in hypoglycemia, even though we have given a double dose at the first injection. And again, if you think about the mechanism, this is because now that double dose is pretty much just all bound to the albumin, and it takes a long time in order to get the full effect. So now I think we have a good deal of data from the phase 1 and phase 2 program showing that insulin Icodec is effective, and we have ways of titrating it this once weekly insulin Icodec in order to get a safe glucose lowering. and also safely switch patients from once daily to once weekly insulin. And so now we're gearing up for phase 3 clinical trials in the Onward program, which is due to start later this year. So finally, I'd just like to conclude with the summary of the data in the next slide. Just to say that we have designed an insulin molecule with some modifications to give this very long half-life by ensuring strong albumin binding and slow receptor-mediated clearance. And then we have shown from the phase 1 data that we do have a profile that is suitable for once weekly dosing, and our phase 2 trials have shown that insulin Icodec indeed has an efficacy and safety comparable to once daily insulin glargine. We have optimized ways of titrating in order to balance the efficacy and the safety, and that we know how to switch from once daily to once weekly insulin without without increasing the fasting blood glucose for the first few weeks. So I'm very excited to see how things go with the phase 3 trial, and I understand that there will be patients and doctors from India who will be participating in the Onward program, testing once weekly insulin Icodec. So I really look forward to how these studies turn out. So thank you very much for your attention.
Thank you, Dr. Erica. We'd like to take some questions for both of you. Let's start the questions. Do we have anything on the chat box? I'd just like to see the question answer. All right. Let me start with you, Dr. Erica. That, I mean, all basal insulins at very high doses tend to have a peaking effect. Have you seen that peaking effect happening with the Icodec? And also when you inject it, is there a differential absorption where you may find that a lot of it, the action occurs in the initial part of the week, and then there is a slowing down of effect in the later part of the week? So have you seen that kind of a response?
Yeah. So very good question. So we do see a PK peak, as I showed, that occurs at 16 hours. But that does not correspond to a PD peak. And we could see that particularly in the first day, there is no increase in the glucose lowering effect. But there is a slight increase in day 2 and day 3. And this is sort of the natural profile of the insulin Icodec, which has a slight peak at the middle of the week. So that is very similar to what you would see for a basal once daily, where you have a slight peak in the middle of the day, depending at the night if you take the dose in the evening, or in the middle of the day if you take the dose in the morning. So very similar profile with the once weekly, but it's stretched out over a week compared to once daily.
Yeah, I have 2 questions. Hello.
Yes.
Yeah.
Yes.
Questions on oral semaglutide. What is the bioavailability of oral semaglutide, and what are the main adverse events you see in regular practice?
The regular practice in Mexico is not yet done because already oral semaglutide in Mexico is not available. But talking about bioavailability, as I show in one slide, the bioavailability of 14 milligrams, 7 and 14 milligrams of oral semaglutide is equivalent to 1 milligram of subcutaneous semaglutide, 0.5 or 1 milligram. So you can get the same A1C reduction and the same body weight reduction with 7 and 14 milligrams. That of course is a higher dose than 1 milligram. And that is because the bioavailability in the oral presentation. But finally, the pharmacodynamic is the same. 7 and 14 is equivalent to 0.5 and 1 milligram of injectable semaglutide. So the clinical efficacy at the end of the day is the same.
You want to start at a lower dose and go to the higher dose?
Yes, you as any GLP-1 analog, in order to improve the adherence, you need to start with 3 milligrams. After that, you can increase to 7 milligrams, and optimally, you need to get the maximal therapeutic dose recommended, that is 14 milligrams. That is the schedule that is recommended for the therapeutic arena.
Whether you see any reduction of proteinuria on using oral semaglutide in CKD patients?
Really, I don't have this data, but we can check in the Pioneer 6 trial. But really, this kind of data, by sure, we will have this data in the SOUL trial. That is a trial with 500,000 patients. That is a very big trial, and this trial, the SOUL trial, is designed to show superiority against placebo on top of the standard of care. The results of this SOUL trial will be ready maybe for the 2024.
Is the GI intolerance a big issue with the oral semaglutide? Because as we see in the injectable one, we see in the initial stages. Does the same thing reflect when you take in the oral form?
Really, the behavior of the oral semaglutide in relation with gastrointestinal adverse events are very similar than the subcutaneous semaglutide. The clinical efficacy and the adverse events are very similar, really. Around 10% of patient has moderate or mild gastrointestinal adverse events. Effect that is the main issue with this kind of drugs, is a class effect. But if you titrate slowly, you can reduce the incidence of this kind of gastrointestinal adverse events. But the behavior is the same for oral and for subcutaneous semaglutide. Thank you for the question.
For Dr. Erika from Dr. Bhavna, that if a patient has hypoglycemia, do we expect recurrent hypos for a few days since the T half-life is long? What have the trials told us in this regard?
Yes, so a very good question. And no, we do not see that there was any prolonged hypoglycemia. If there was any hypoglycemia, it was mitigated by taking some food or sugar. And then it was exactly the same as any other hypoglycemic event observed for once daily basal insulin. So there was no increase in the or the prolonged hypoglycemia as we may expect. And I think this is because once we do get back up to normal glycemia, the action of insulin Icodec is so slow.
So going forwards, this is my last question because we're running out of time. That do you think going forwards we will have a combination of Icodec and semaglutide coming out? And has there been any movement of research in that area?
Yes. So yes, we do have a combination of insulin Icodec and sema in our pipeline. So yes, someday soon.
Thank you very much. Yeah, I'm sorry. Go ahead.
This is really an exciting arena of on research ongoing.
Yes, I think so.
It's very exciting to have that combination because I'm sure a lot of people would love to see that combination come out.
Yes.
Thank you very much. I think both of you have given excellent talks, very informative. We've run out of time, but we'd love to see you come into India and personally interact with all of them. Thank you very much for your time and lovely lecture.
Yeah, hopefully one day. Yeah.
Over to you.
Okay, thank you. Bye.
Thank you to you. Thank you from Mexico to India.
Thank you.
Bye-bye.
Thanks from
Dr.
Denmark.
Sanjay.
Yeah, bye-bye.
Thank you, Dr. Sanjay Agarwal, Dr. Anil Kumar, and I thank Dr. Nishimura, and a very special thank you to Dr. Morales, who's woken up at almost 4 in the morning to join us here in India today. So thank you both for your wonderful lectures, and we've learned something exciting about new drugs in the pipeline. But let's move on now, and I request Dr. Sydney D'Souza to come on. Dr. Sydney D'Souza is the head of Department of Medicine at Yanapoya Medical College in Mangalore. And sir, over to you. Please moderate the next session.
Thank you and good afternoon to all of you. Am I audible? Am I audible?
Yes, you're audible.
Sir. Very nice. Thank you. First of all, let me thank the organizers, right from Dr. Arvind to Dr. Reddy to Dr. Krishna Shishadri to Dr. Sadhkumar and Dr. Arvind's daughter as well, who is in front of me. Thank you for inviting me as the chairperson. Now, without any delay, we'll start with the insulin symposium. I think Indian population is completely different. We are a host of patients who are totally out of control, and the worst thing one should ever advise them is the insulin, which they never want to take it. Unfortunately, at one stage or other, they have to take insulin, and probably we may have to come to one, find out a injection which possibly is once a day or possibly a oral. Oral is not at all is available. So to deal with all these things, we have Dr. Unnikrishnan. I don't think you need any introduction for Dr. A.G. Unnikrishnan, but I have to tell you something about him. That is, he is an endocrinologist and CEO of the Chalaram Diabetes Institute, Pune, and leading diabetes institute in India, and IDF certified center for education and excellence in diabetes care. I just hand over the mic to Dr. Unnikrishnan to have the deliberation. Dr. Unnikrishnan, please.
Thank you, sir. It's nice to see you again after a long time.
Thank you.
Straight away. So I'm going to talk about total control with a focus on IDEGAS. And why do we want our patients to control blood sugar levels? That's because controlling blood sugar levels is important in preventing complications. And what do we want for our patients with diabetes? We want our patients euglycemia, which means a HbA1c less than 7%, because that will reduce microvascular complications, long-term CVD rates, and reduce mortality. In fact, HbA1c below 7% continuously for 1 year results in reduced diabetes treatment-related costs up to 25%. Now, oral drugs, we just discussed oral drugs in the last session. Oral drugs are an essential component of glucose control. So if you go from 2 oral drugs to 3 oral drugs to 4 oral drugs and to insulin, what studies suggest is that giving 2 oral drugs is very good. Giving 3 oral drugs is also good in reducing A1C. But once you add the 4th drug, the HbA1c really doesn't change much. And that's because of the duration of diabetes that has elapsed before the 4th drug is added. That duration of diabetes suggests a greater degree of beta cell failure. And this greater degree of beta cell failure might mean that our pills may not respond. And therefore, that's the time at which insulin should be considered, and people who need insulin should be prescribed insulin. But what we want from the insulin is to control the glucose, minimum risk of hypoglycemia, minimum burden and disruption to the patient's life, minimum complexity, and lots of simplicity. Let's look at a case. This is a 54-year-old lady with neuropathic symptoms in the feet. She's a housewife, type 2 diabetes for 8 years, hypertensive. Body weight is 65 kilos. Her fasting is 164. Post-breakfast is 198. Post-dinner is 296. HbA1c is 9.3%. So suggesting that her blood glucose is not controlled, and she's already on metformin, she is on vildagliptin, she is on gliclazide. So these are all the challenges of managing diabetes in India. You need a simple and convenient regimen. Many patients are uncontrolled on 3, 4, 5, 6 oral hypoglycemic drugs. The postprandial level is high because the Indian diet is carbohydrate rich. Now, if you look at different parts of the country, Eastern India, Western India, Northern India, Southern India, Central India, if I ask you to look at the tallest skyscraper, it's always the orange one. And what does the orange one stand for? It stands for carbohydrates. So 60 to 70% of energy intake in Indians is through the carbohydrates present in the diet. And this is a study done by Dr. Bhavdarini, which looks at the association of white rice with risk of diabetes. As you can see, the median white rice consumption is highest in South Asia, even more than Southeast Asia, South Asia. But if you look at South Asians, their risk of developing diabetes is also highest with considering they have excess rice intake. So the high carb diet in South Asians means that their risk of diabetes is higher, their postprandial glucose is higher, they require a prandial insulin, and this prandial insulin control may have clinical implications for macrovascular complications as well. So in this study, the first study, postprandial glucose reduced carotid intima-medial thickness, and high postprandial glucose increased carotid intima-medial thickness. In the Hoon study, post-glucose load, glucose level was a better indicator of all-cause mortality and cardiovascular death than HbA1c. In the Honolulu Heart Program, the Chicago Heart Study, and all the other studies, the postprandial glucose increased the risk of cardiovascular disease. Was assessed in the South Indian patients, and postprandial hyperglycemia was associated with greater risk of nephropathy, neuropathy, and retinopathy with significant p-value. Unlike in Western population, we know that Indian population is different. We know that unlike Western populations, when the HbA1c is low, there is an important contribution of fasting as well as postprandial, and the HbA1c is high, again, there is an important contribution by fasting and postprandial. But it's very important to note that though the contribution of fasting may change from time to time, from HbA1c to HbA1c, the postprandial remains an important contributor to HbA1c. And again, the study shows that in even in normal glycemic subjects, Asian Indians had lower insulin secretion. And even after a glucose load, Asian Indians showed a decrease in insulin secretion. So these studies show that insulin secretion is decreased in Asian Indians. So this is a study which looked at both patients and physicians. And if you look at both patients and physicians, both identify higher frequency of insulin injections as a burden. You can see that taking insulin injections at a prescribed time or with meals every day, the patient thinks it's a burden. Number of daily injections, the patient thinks it's a burden. And importantly, physicians also think it's a burden. So insulin should not be restrictive. This is the RSSPI ESI guidelines on management of diabetes. And what it says very clearly is that providers should avoid using insulin as a threat and should try to reduce patient anxiety about insulin. And insulin should be considered when people fail 3 oral drugs. One option for initiation in Indian patients is a co-formulation or a premix insulin. Why co-formulation or premix? Because a co-formulation having a long-acting and rapid-acting will control the fasting and postprandial, and you can start with a once daily simple regimen and intensify to a twice daily regimen. So Icodec, this is the physiological insulin profile. You can see the rise and the fall of insulin. And if you look at a co-formulation like Icodec, you have the rise similar to the physiological insulin of aspart, and you have the long-acting action of degludec. If you compare that to a premixed insulin, you can see the premixed insulin, the line between the rapid-acting and long-acting is blurred. In other words, there is a shoulder effect, or rather a lack of a shoulder effect. But as you can see in the orange color, the Icodec avoids the shoulder effect because the actions of the rapid-acting insulin and the long-acting insulin are discrete, distinct, and separate from each other. Well, another option is to give basal bolus insulin, but it's complicated. It requires multiple insulin injections. So Icodec is a very pragmatic solution for Indian realities because it tackles the major high carbohydrate diet with the major meals. It can be started with one insulin injection with one device at one site with one titration algorithm, therefore makes it convenient. It tackles the high postprandial glucose, therefore reducing both microvascular and macrovascular disease and providing overall glucose control. And for patients on multiple oral drugs, you can allay the fear of hypoglycemia and you have a simple device. This is a well-known Onishi study which looked at 296 type 2 diabetes people who have never taken insulin. Their HbA1c was 7 to 10%. Age was more than 20 years. They were randomized to Icodec with oral drugs or glargine with oral drugs. Icodec was dosed with the largest meal of the day, and glargine was administered according to the label or at patient discretion. What it showed is that Icodec controls the postprandial better. It controls the A1C better than glargine. It has a similar fasting control because the degludec works just like glargine, but unlike glargine, compared to glargine, Icodec was associated with numerically less hypoglycemia and less. This is important because we think that when a prandial aspart is added, the risk of hypoglycemia goes up, but it's numerically lower, or at least statistically remains the same with Icodec compared to glargine. So if you give Icodec instead of glargine, you can get a superior A1C reduction, a similar fasting control, better postprandial control, and numerically lower risk of nocturnal and combined confirmed hypoglycemia. In patients uncontrolled on oral drugs, insulin initiation must offer better efficacy without compromising on safety. And compared to glargine, as you can see in the gray skyscrapers, 25% is the number with glargine, a higher proportion, 43% at week 26 on degludec reach an A1C of less than 7%, importantly without hypoglycemia. With Icodec, 72% more patients achieve their targets without hypoglycemia compared to glargine. Coming back to the patient I showed, you can see that the dinner is a major meal of the day, but more than that, the post-dinner rice is the most. So if you are giving Icodec once a day to this lady, you might choose to give it before dinner. So Icodec was started before dinner, which was the largest meal of this patient. Dose was increased to 20 units. Gliclazide was stopped. Metformin was continued. Vildagliptin was continued in this case, Vignet. And at the end of 3 months, the fasting was 114, postprandial 148, post-dinner, post-breakfast 148, post-dinner 156, and A1C reduced from 9.3 to 7.2. Showing you that whenever you have a patient on multiple oral drugs, metformin, DPP4 inhibitors, sulfonylureas, it's always better to stop the sulfonylureas and add a co-formulation insulin. The patient had good glucose control. Insulin initiation was required for better glucose control. Diet was assessed. Total control with Icodec achieved good prandial and fasting glucose control. So what do we want from starting an insulin? We want to give a complete glucose control. We want to give a minimum risk of hypoglycemia. We want to give a minimum disruption to the patient's life, and we want flexibility, a minimum burden of injections, a simple device. And I think Icodec with a FlexTouch device checks many of those criteria. Thank you so much for listening to me. It has been a pleasure talking to you. And over to Dr. Sydney D'Souza for I think the questions are to be taken at the end. So over to Dr. Sydney D'Souza.
you, Dr. Unikrishnan. It was nice how you put in perspective how a single injection of Icodec can control the sugar so well, especially in the Indian situation where postprandial excretions are so high and we eat a lot of rice. So the younger generation may change now, but older generation definitely does eat a lot of rice. I think we'll keep the questions at the end. Now I invite Dr. Vijay Vishwanathan. Can I have his CV, please? Yes. I know Dr. Vijay Vishwanathan so well because he did his post-graduation with us. And he was yes, from there onwards, he has never looked back. Today, he is what he is because of his efforts. I know him well, but for the courtesy, I have to tell, he is a head of and chief diabetologist in MB Hospital for Diabetes and Professor Vishwanathan Diabetes Foundation. His field of interest is foot and diabetes, kidney and diabetes, patients with tuberculosis, and social economics of diabetes. It's a pleasure that I have heard his father way back in 80s when he came to Mangalore for API meetings. Today I see Dr. Vijay in the screen. So nice. Over to you, Dr. Vijay. He'll be speaking to us total control in special situations. Over to Dr. Vijay.
Thank you, Dr. Sydney. I think when I was in Manipal in 1988 doing my MD, you were teaching, and so you are my teacher. So what I'm going to do in the next 12 minutes, because we are about 5 minutes behind schedule. So I will just share the screen. Yeah. So what I'm going to do in the next 10 minutes or 12 minutes is to talk to you about management of people who are elderly, type 2 DMs who are elderly, type 2 DMs with kidney disease, and type 2 DMs with liver disease. You've already heard from Dr. Unikrishnan about Icodec, and my disclaimer is many of my slides are from Novo Nordisk. And with this introduction disclaimer, I will start the talk. Just find my pointer. Yep. So I'm going to start and talk about these 3 topics in the next 10 minutes. And I'm going to start with the elderly type 2 diabetes. Don't get confused by this slide. I'm going to make it very simple. So when you have elderly people, say above the age of 65, you can have some healthy elderly people who are shown here, who have a very intact cognitive function. You should aim for an HbA1c below 7.5 in these individuals. Now, because they have a long life expectancy. Then you have the second category, which is the intermediate category, where you have mild to moderate cognitive impairment and the daily living, activities of daily living are impaired to some extent. It's impaired. It's not completely gone. And for these people, you have to maintain the A1C around 8% because they have a very high chance of hypoglycemia. And this is the fasting, the preprandial glucose, which is shown here. And then you have the third category of elderly people who have severe, moderate to severe cognitive impairment, and they have dependencies for their activities of daily life. So this is the group which is a little uncommon, but it is quite commonly seen in practice, who have a very limited life expectancy, in whom you can keep your A1C below 8.5 and not 7.5, and the preprandial sugars around 100 to 180. Now, hypoglycemia is very, very important to understand. That is much more commoner in the older age group and in people with diabetes and so on. Therefore, elderly people, going back to the previous slide, I think we have a lot of options. In this talk, I'm going to talk about insulin, but we have options of the gliptins. We have excellent gliptins which are useful. We can use small doses of metformin up to maybe 500 or 1000 milligram. We can use SGLT2 inhibitors if you're able to have a control of the patients and see them frequently, and they don't have prostate issues and so on. But in this talk, I'm going to talk about insulin therapy, because many times we cannot escalate the dose of tablets in elderly people. because we can't go beyond 1 gram of metformin if a person is 75 years old or 80 years old with a lower EGFR and so on. And also, acute complications are often bothersome. The patient has got, say, balanoposthitis. It's quite bothersome to the elderly people who can't have access. They might be living in an old age home, so they can't go to the hospital very often. So insulin therapy is a good option in people who are elderly to improve their quality of life, treatment satisfaction. Now, basal bolus, there are many elderly people who do require basal bolus, but in general, it's a little too complicated for elderly people. Therefore, the Icodec, which Dr. Unnikrishnan described so beautifully, is a good option to give you total control of both fasting and postprandial in elderly people. It can provide simplified and convenient way to initiate insulin therapy and intensify insulin therapy. As you heard from Dr. Unnikrishnan, it's a co-formulation, but it exists as two separate molecules. And when you inject it also, you can see that they behave differently and they don't mix. You don't have to mix the insulin. So it's a co-formulation. It's a beautiful insulin and might be a substitute for basal bolus insulin therapy if the doses are lower. If the patient is taking some 60, 70 units or 90 units of basal bolus, it might be difficult to convert to Icodec. Now, whether you're talking about younger people or the elderly, above 65 people, the properties of insulin deglutec, about which I'm going to talk first, is not altered. As you can see that after injection, for nearly 24 hours, the curve is almost similar in younger people as well as in the elderly people. And you can see the area under the curve for younger people, which is shown in blue, and the elderly people, which is shown in the dotted lines. There's hardly any difference in the area under the curve between the two insulins. So what I'm trying to say is pretty much safe to use deglutec, Icodec, in people who are elderly. Do we have data? Yes, we have data which is comparing the biphasic insulin aspart, which is more commonly used in India, maybe because of the cost, and the Icodec. This was a wonderful study from the Boost Intensify All study in elderly people. And you can see that the A1C change was similar, whether you used the Icodec or the biphasic insulin aspart. But oftentimes, when you give biphasic aspart both morning and evening, you have to give another aspart in the afternoon, which will be probably avoided if you use an Icodec, which works for a longer time. And you can see that there was a significant reduction in the FPG, and the overall and nocturnal hypoglycemia were almost lower in the Icodec. The total insulin dose at the end of the trial was also lower. So Icodec might be a safer option compared to the biphasic insulin aspart. Now, secondly, I go on to renal impairment. So patients with CKD, you can see that both endogenous insulin and exogenous insulin is mostly cleared by the kidney. The exogenous insulin nearly 30-80%, and the endogenous insulin about 70%. Therefore, you need a healthy kidney to get rid of this insulin which you're injecting. Now, having said that, talking about the kidney, don't think that the person has got an EGFR of 40 or 50. He's going to die very soon. This was the STENO2 randomized trial, which showed that the mortality rate, the retinopathy progression, the kidney progression in a 21-year follow-up, one of the most beautiful studies in type 2 complications, showed that you not only reduce the progression of retinopathy and nephropathy and neuropathy, but you also gain a lot of years in life. So just because you have macroalbuminuria EGFR is 50, you can't label that person as going to die very soon, because you can get a lot of benefits by controlling the diabetes. Having said that, again, I'm going to look at first deglutec in patients with renal impairment. So if you have a CKD stage 4 or stage 1, you can see that the deglutec behaves in the same way whether you inject it into a person who's got a CKD stage 1 or stage 4. And you can see that there is hardly any change in the stimulated steady state in different degrees of renal impairment. Now, there is a question that deglutec is bound to albumin, and therefore, in patients with severe degrees of CKD, you can expect a lot of hypoglycemia. This has not been the case from 2 trials which have been done, where they compared deglutec and even glargine, because the ratio in which the deglutec binds to albumin is in the ratio of 1:10⁶. Therefore, even in low serum albumin levels, I showed in the Indian Journal of Nephrology about 15 years ago that patients with diabetic nephropathy have low serum albumin levels, which can predispose the patients to more kidney disease. Hypoalbuminemia leads to more kidney disease. I showed in a paper in Indian Journal of Nephrology about 15 years ago. Therefore, hypoalbuminemia is not a thing to worry about when you talk about deglutec. But in general, nephrologists and many physicians believe that if you use long-acting insulin, your patient will invariably go into hypoglycemia. It's not the case always. There are people who will go into hypoglycemia. You have to monitor the blood sugar, but not everybody will go into hypoglycemia. Now, this was the IASP, aspartate in different degrees of renal impairment. You can see that the people who are shown in the white box are those who have severe disease, and those who have the black dots are the normal kidney disease. You can see that aspart is also the area under the curve is not much altered by the degree of kidney impairment. Having said that, you have to adjust your total dose of insulin, TZD, according to the eGFR, which is easier. And if your eGFR, if you have a CKD stage 1, then you don't have to reduce. But in CKD stage 2 to stage 4, you have to reduce your insulin, total dose of insulin by 25%. And if you have CKD stage 5, which is less than 15 eGFR, you have to reduce your total dose by 50%. And for whichever insulin you are using, this is the general formula that if you're in CKD stage 1, you don't have to reduce the dose. If you're in CKD stage 2 to 4, you have to reduce by 25%. And if you're in CKD stage 5, you should reduce by 50%. And lastly, in the last 2 minutes, let me talk to you about type 2 diabetes with hepatic impairment. Now, liver disease and diabetes are going hand in hand today because of the obesity and insulin resistance and so on. Therefore, we can expect a lot of liver disease in the future in people with diabetes. The genetically and phenotypically, we are prone to get liver disease in diabetes. Now, in people with liver disease, insulin treatment, again, we have linagliptin. You can use low-dose sulfonylureas. You can use low-dose metformin. It's not that you use only insulin. But many people may not get controlled with just 5 milligram of linagliptin or 500,000 milligram of metformin. Therefore, you might have to use insulin. You will have to necessarily use insulin. Therefore, it's frequently required in people with diabetes and liver disease. And in people with decompensated liver disease, the requirement is often decreased. That's on one hand. But there can also be an insulin resistance, which makes I have many patients who are on insulin pump because they're not getting control with basal bolus insulin. They have so much of insulin resistance, and metformin doses are reduced. It's very difficult to control the diabetes in many people with liver disease, advanced liver disease. And having said that, when you use high doses of insulin, you have to be very careful and do a glucose monitoring and so on. Now, whether you're talking about, once again, as I said, in the kidney, whether you're talking about people who have milder forms of kidney disease or the child classification 3, where you have a lot of ascites and the prothrombin time is altered, hepatic encephalopathy, increase in serum bilirubin, whichever form of liver disease you are talking about, again, it has been shown that insulin deglutide is quite preserved, whichever degree of liver function you're talking about. You can see in 24 hours, there's hardly any change among people who have more advanced liver disease vis-a-vis people who have lesser liver disease. Same thing for aspart. You can see that white the white squares are the severe liver disease, and the blue circles are the normal kidney liver disease. There's not much difference in the area under the curve for both these states. Therefore, to conclude, my final slide, IDEGAS is a good option for people who are elderly, for people who have CKD, people who have liver impairment, hepatic impairment. It controls both fasting and postprandial, thereby gives you a much better HbA1c. Don't write off people who have kidney disease as they're going to die very soon, or elderly people, they're going to die very soon. For you need to control the A1C, and that's done by good insulins like IDEG ASP. So to summary, judicious use of insulin is quite important for people in special situations like the elderly population, kidney disease and liver disease. And IDEC ASP is an effective, safe and convenient insulin therapy in these three special populations. I'd like to thank the organizers once again for this invitation. I don't know how to stop sharing because, yeah, right.
Thank you, Dr. Vijay. Thank you for reassuring that IDEC can be used in renal disease, and patients with renal disease also do live for a long period of time, and better control is required. I don't find any questions in the chat box, so I would ask two questions. One to Dr. Unni. In your own experience, Dr. Unni, giving once a day IDEC, does it really control afternoon surge of blood sugars? Do you have any experience on that? Because we eat more food in the afternoon. The rice is more taken in the afternoon. Night people don't eat much, but afternoon that rice is a worrisome thing. But do you think one IDEC will control postprandial excretion?
So my experience with IDEC is that I usually, though the guidelines say dose up before dinner, I think usually I prefer to dose up before breakfast. And that is, to my mind, because we also tell our patients to eat a good breakfast and they should have a healthy breakfast. So once the breakfast is covered, I think the second meal effect goes away. You know, the post-breakfast spike isn't much, and that has a beneficial effect on the post-lunch sugars. So my personal experience has been to use, when I use IDEC, I use it once a day in the morning before breakfast. But I agree with the case I presented. In that case, the post-dinner spike was a higher spike. So in that particular case, I think before dinner would have been the ideal time to use it. But I agree with you that lunch is a time we need to worry. So my solution to that is not to give IDEC with lunch. My solution is to give it with breakfast, because once you control the post-breakfast sugar, the second meal effect, which is the impact of the first meal on the second meal, goes away, and you'll be able to cover the lunch spikes very well. And that we now see many times on CGM. And also we can add a second injection as the sugars increase.
Dr. Sidney, if I can add one word.
Yeah, please.
Type 1 diabetes, I use a lot of IDEC in children who are 6 years old, 8 years old. Making them take this basal bolus is quite difficult.
Yeah.
Unique said, I sometimes tell them to take 1 dose in the morning and 1 dose in the evening. And I have children who are doing extremely well. And I tell them not to eat much in the afternoon, but to take breakfast and dinner. So children might be one situation where it's useful.
IDEC twice a day is okay for you? You know, you have been using it?
Yeah, twice a day is usually needed. Yeah.
Yes.
One last question, because want of time, to Dr. Vijay. Do you use the same algorithm for the renal failure in IDEC for the reduction of the dosage?
Yeah, so this was a talk on IDEC, but I have a lot of patients with more advanced kidney disease for whom metformin is reduced. Just as I told about the liver, they have a very, very high insulin resistance. As the kidney disease progresses, the insulin resistance increases dramatically. and we can't use metformin, we can't use bioglitazone. Therefore, we are stuck. So Bhavana says we have 8 more minutes. So I think since we can't use metformin, I have many patients with CKD who are not controlled with basal bolus. I take gas twice a day. No, it's not controlling. Some, I'm not talking about all. Basal bolus doesn't work. I'm scared to give glimepiride with CKD. I give sitagliptin 50 milligram, it doesn't touch them. Therefore, it's quite difficult. There is a subset of CKD patients in whom diabetes control is extremely difficult. And I've started them on the pump because I can't give them metformin. And I wait for the EGFR to come to somewhat 30, 40 to start metformin. I keep waiting for them to get their EGFR to 30, 40 to start metformin. But when they're 35, I'm scared to start metformin or continue metformin. So I stop at usually 35 to 40 because follow-up is very bad in India. So when you see them, they might have an EGFR of 40. They'll come back to you after 3 years with an EGFR of 5 and still on metformin. Therefore, I generally stop metformin when it is around 40. So the ADA says you can go up to 30 and all that.
I agree with you because I have seen patients even with renal failure. Their requirement is quite high, and they are some of them require so low dose of insulin. Some of them require so high, probably because of the insulin resistance what they have in addition. Probably that's the reason. Now I think Dr. Bhavana is looking at us.
I have a question for.
Well, can I make a point?
Please.
So in our hospital, we have a dialysis unit, and we have a lot of people with end-stage kidney disease. And people with end-stage kidney disease, because of their poor muscle mass and poor intake, they seem to have paradoxically good control of blood sugar. So we are looking at, of course, many of them are on linagliptin, but we also give gas to some of them, and sometimes 1 injection or 2 injections is good enough because they already have burnt out diabetes with low A1C. So I think end-stage kidney disease, and of course, tight glucose control is not needed in them, and as mentioned, their HbA1cs are all under control. So a small dose of gas we have tried in them, and it works quite well.
I have a question for either of you. What is your experience with Icodec in pregnancy?
Maybe Dr. Vijay first.
I generally use biphasic aspart insulin because it's more approved. So I use that more than Icodec. Or what about you, Uni? You use that in pregnancy?
No, I don't use Icodec in pregnancy at all. I agree with you. My insulins of choice are aspart, sometimes Lispro, Detimir, and of course sometimes biphasic aspart. But Icodec I haven't used in pregnancy. I've been using a little bit of 5-asp in pregnancy and the faster acting aspart, and that I find to be quite effective in postprandial control.
Because I asked that question because there are studies which have shown, small studies of course, that degludec can be used in pregnancy. And there are studies going on even with type 1 in pregnancy, and aspart, as we know, is safe. So I was just wondering if we have sufficient data available on the co-formulation to be using it in this situation.
So Bhavana, the real problem is in gestational diabetes, the insulin requirement is very less. If you're talking about the pre-gestational type 1s who are becoming pregnant, they invariably need a basal bolus or a pump. They do extremely well. The GDMs will just need 1 dose of basic aspartate or whatever, or 2 doses. So they are easy to control in metformin. I'm sorry, in GDM. And you can even give metformin if you wanted to. Whereas in the type 1s who are becoming pregnant, it's extremely difficult to control with Icodec and all that.
Yeah, I think with this, we'll come to a close of this session. I thank Dr. Unni and Dr. Vijay.
Thank you. Nice to see you, Dr. Sidney Souza, and nice to meet you, Dr. Vijay, after a long time. And Dr. Bhavana, thank you all very much.
It's a pleasure being in this forum. And Bhavana, nice that you replaced your father and all the others. and you are taken over now.
She's
Evening section.
complimenting her dad, and she's not replacing. She's complimenting.
No. She's rather, made them go for a tea coffee break now.
Yeah,
And
yeah.
she has taken over. Very
Certainly.
nice. Thank you very much for giving me.
Thank you, everybody.
Welcome. Thank you.
Thank you, Dr. Krishnan. Thank you, Dr. Vishwanathan, and thank you, Dr. D'Souza, for this wonderful session on using insulins and telling us how to ensure that we get to the best target in specific to time and range and to get to total control. So we'll move on now. Let me just check. Dr. Prasanna, I think, is on the way. Dr. Prasanna Kumar. Our next session is going to be on DPP-4 inhibitors in clinical care. And since he's going to be joining us in a minute, I also see that we have Dr. Iyengar and Dr. Ganpati Bantwal already here with us. So why don't we go ahead and start off this session so that we have more time for discussion with the two of them instead of rushing up. So Neelam, I request you to display the introductory slide of Dr. Iyengar, please, for us. Yes. So thank you very much. Dr. Iyengar is familiar to all of us in Bangalore. He is the head of cardiology at St. John's Medical College. And he's been also awarded medals by the President of India during his lifetime. And he's a member of the Cardiology Society of India and fellow of Indian College of Cardiology. So Dr. Iyengar, over to you. I request you to tell us about what we can learn from the Carolina trial and how we can apply that in practice.
Good evening, Dr. Bhavna, and good evening to all ladies and gentlemen. Kindly permit me to share the screen. I'm going to talk what we have learned from Carolina trial. Carolina, we'll start with a few introduction, then go to the Carolina trial, then see what lessons we have learned. The Carolina word means song of happiness or joy. So let us see what happiness we are going to get going through this trial. This Carolina trial is basically a tale of two drugs, linagliptin and glimepiride. Now, linagliptin, unlike other DPP-4 inhibitors, is excreted chiefly via the enterohepatic circulation, and it can be used without dose adjustment in patients with renal or hepatic impairment. And we all know that there is a heterogeneity across the DPP-4 inhibitor class with regard to effects on the risk of heart failure and outcomes, with cloud over saxagliptin and elogliptin. DPP-4 inhibitors, they have neutral effect on weight, they have minimal risk of hypoglycemia, they have cardiovascular safety, but no additional benefit. Rarely, there may be problem of pancreatitis and musculoskeletal side effects. Whereas glimepiride, unlike the previous generation sulfonylureas, preserves ischemic preconditioning in the myocardium because it does not inhibit potassium-dependent ATF channels in cardiac myocytes. It has specific effect on the beta cells because in cardiomyocytes, it has low binding affinity and quick association and dissociation with sulfonylurea receptors. And the dictum with sulfonylureas usually start low and step up slow. There have been some pleiotropic effects described with different SUs apart from ischemic preconditioning in the form of insulin sensitization, insulin clearance, glucagon secretion, and antioxidant effects. Now, Carolina is a cardiovascular outcome trial, and cardiovascular outcome trial usually have very high-risk patients in their studies included. They will be usually non-inferiority design, but once non-inferiority is established, one could assess superiority. Now, this is the Carolina trial, cardiovascular outcome trial of linagliptin versus glimepiride in type 2 diabetes. It is a randomized, double-blind, active-controlled, non-inferiority trial conducted in 43 countries. It is the only DPP-4 inhibitor active comparator cardiovascular outcomes trial to assess the cardiovascular safety profile of linagliptin versus glimepiride in patients with early type 2 diabetes at increased cardiovascular risk or established cardiovascular complications. And this has given us enough information about the safety profiles of linagliptin and glimepiride. This is an active comparator cardiovascular outcome trial. Patients with type 2 diabetes were randomized to daily oral treatment with linagliptin 5 mg a day plus standard of care, or glimepiride 1 to 4 mg per day plus standard care. This is an event-driven trial, and study medications were given on top of stable background glucose-lowering therapy, and investigators were encouraged to treat all other cardiovascular risk factors as per the guidelines. It is also one of the longest cardiovascular outcome trials. The screening and enrollment started somewhere in November 2010, with last participant getting randomized in 2012, and last participant completed in August 2018. The median time in study was 6.3 years. As I mentioned, this trial included participants with relatively early type 2 diabetes at increased cardiovascular risk, and this elevated cardiovascular risk was defined as documented atherosclerotic cardiovascular disease, multiple cardiovascular risk factors, age at least 70 years, and evidence of microvascular complications. Participants reflect those typically we see in our clinical practice. 42% had established cardiovascular disease. 37% of them displayed 2 or more defined cardiovascular risk factors. 40% had type 2 diabetes less than 5 years. 83% of them were on metformin. None were on insulin, and 9% were treatment naive. Median duration was 6.3 years. Mean HbA1c was 7.2%, and they were receiving standard care for cardiovascular risk. The additional baseline characteristic features of note were hypertension in 90% of the subjects, microvascular disease in 28%, more than 50% with mild impaired kidney function, that is eGFR between 60 and 89, and 18% had moderately impaired kidney disease with eGFR between 30 and 59 ml per minute per 1.73 square meter body surface. Now, glimepiride was appropriately and adequately uptitrated. It was started with 1 mg initially and updated every 4-week intervals to a maximum of 4 mg per day. And the median dose of glimepiride was 2.9 plus minus 1.1 mg. Now let us look at some of these facets of the study. What was the glycemic control? What was the weight gain? How was hypoglycemia problem between linagliptin and glimepiride? Glycemic, there was no difference in HbA1c levels in both arms, the linagliptin and glimepiride. There was similar glycemic efficacy compared to glimepiride. Though in the initial stages, HbA1c showed favorable effect with glimepiride, but overall there's no difference between the two, as seen in this graph too. Looking at the body weight, which is another concern with sulfonylureas, linagliptin was associated with reduced weight compared to glimepiride. The end of study is about there's a difference of 1.5 kg between the two arms in favor of course, linagliptin. Coming to hypoglycemia, another concern with sulfonylureas, it was definitely lower with linagliptin as compared to glimepiride. Whereas about 1132 patients had hypoglycemic episodes, only 320 patients had hypoglycemia with linagliptin. And this hypoglycemia was across all categories of hypoglycemia. This is all hypoglycemic episodes, 10.6 versus 37.7% in favor of linagliptin. Moderate, severe, or those requiring hospitalization due to hypoglycemia, all were significantly less when one used linagliptin. Occurrence of major cardiovascular event, there is no difference between linagliptin and glimepiride. 356 here and 362 here, 11.8% and 12% with glimepiride. Now looking at the primary endpoint, that is time to 3-point MACE endpoint, that is cardiovascular death, first non-fatal MI, or first non-fatal stroke, there was no difference between glimepiride and linagliptin. Same thing with all-cause mortality, no difference between the two. Time to cardiovascular death, no difference between the two arms. Time to non-cardiovascular death, no difference between the two. So here are the hazard ratios for all-cause mortality, cardiovascular mortality, and non-cardiovascular mortality. Looking at some of the other points, hospitalization heart failure, of course, it was 3.7% with linagliptin and 3.1% with glimepiride. Numerically, slightly less. Participants with hospitalization, when you looked at hypoglycemic episodes, there are 25 more cases with glimepiride requiring hospitalization as far as hypoglycemia is concerned. When it came to heart failure, there are 20 more patients had to be hospitalized with heart failure with linagliptin as compared to glimepiride. So this was a very well designed and one of the longest cardiovascular outcome trials, carried over 6 years. Despite hypoglycemia, there was no evidence of increased cardiovascular risk with glimepiride. Clinicians should be reassured about the cardiovascular safety of modern sulfonylurea glimepiride. Looking at some other studies about glimepiride, one study where there was comparative cardiovascular and hypoglycemic safety of glimepiride in type 2 diabetes, a population-based cohort study, where they looked at 66,000 patients in the base cohort. 6,000 were receiving glimepiride and 20,000 were receiving the other second generation SUs. And if you look at the results, there's a marginal difference in cardiovascular death and all-cause mortality in favor of glimepiride during the follow-up of 1.3 years. So here is the thing, myocardial infarction, no difference, ischemic stroke, no difference, and cardiovascular death, no difference. But when it came to all-cause mortality, there was a difference in favor of glimepiride. So glimepiride exhibited low incidence of all-cause mortality as compared with other second-generation sulfonylureas. Reversible linagliptin, which in animal experiment, it's seen that linagliptin prevents atrial electrical remodeling, acting through the reactive oxygen species. It suppresses the electrical and structural remodeling in the myocardium, which is had an acute injury, and it has favorable effect on atherosclerotic lesions in the hyperlipidemic rabbit. And we also know about the Carmelina trial, where in patients with type 2 diabetes and concomitant atherosclerotic vascular disease and diabetic kidney disease, the anti-hyperglycemic medication linagliptin did not affect risk for heart failure, hospitalization, or other associated heart failure-related complications. So these data provide robust assurance that linagliptin does not increase heart failure risk. So the lessons we learned from this, that Carolina demonstrated that glimepiride and linagliptin are at par in terms of cardiovascular safety. Guidelines have maintained that modern SUs are cardio-safe. Cardiovascular should no longer be a decision-making criteria when you are choosing glimepiride. Modern SUs like glimepiride may be preferred in type 2 diabetes patients with cardiovascular disease. Of course, metformin remains the first line of agent for treatment of type 2 diabetes. Option for second line agent includes sulfonylurea or DPP-4 inhibitor. Lower cost would favor sulfonylurea, while less hypoglycemia and weight gain would favor the latter category. These results of course pertain only to linagliptin and glimepiride and may not be extrapolated to other compounds. So after having first-line therapy with metformin, comprehensive lifestyle modification, if there are indicators of high risk or established ASCVD, CKD, and heart failure, then the algorithm will be different. You go on to SGLT2 inhibitors, where if the answer is no, And there is a compelling need to take care of hypoglycemia or minimize hypoglycemia, you go for DPP-4 inhibitors because they have low hypoglycemic risk apart from intermediate efficacy, weight neutral, and oral administration. Cons may be cost and renal adjustment in some patients and rare side effects. Whereas if there is no specific comorbidities, no established CVD, low risk of hypoglycemia, low priority to avoid weight gain, or no weight-related comorbidities, and cost is a major issue, then sulfonylurea is the drug of choice. Because they have, apart from having high efficacy, orally administration, they have a low cost. There is, of course, we must keep in mind the risk of hypoglycemia and weight gain. So Carolina, if you look at the author, the primary author, Rosenstock said, we take a lot of pride in this study. We are addressing in this trial a lingering debate that has been going on for many years in terms of safety of sulfonylureas. We are now in a position to provide a clear answer to vindicate sulfonylureas, at least glimepiride, from the old cardiovascular stigma. It is no longer sufficient to achieve glucose reduction in the diabetic patient. It is all about pump, pipes, and filter, heart, vasculature, and kidneys. We must consider the greater good for our patients and act accordingly by initiating pharmacological therapies that are prone to reduce cardiovascular and renal risk in patients with or at risk of ASCVD or renal disease. A patient-centered approach should be used to guide the choice of pharmacological agents. Consultation has to be given to cardiovascular comorbidities, hypoglycemia risk, impact on weight, cost is a major factor in our country, risk for side effects, and patient preferences. So we must put our heart and kidneys into diabetic care. Thank you, Chairman, ladies and gentlemen.
Thank you, Dr. Iyengar, for an excellent talk. We appreciate that your involvement in cardiology as well as interest in diabetes as such. As we have started early and we'll have plenty of time, after having Dr. Ganapathi's Bantwal's talk, we will have question answers together. I'm sure there will be a lot of questions. It's my pleasure to introduce my colleague, Dr. Ganapathi Bantwal, MD, DM, MNA, MS. He is presently the professor and head of endocrinology at St. John's Medical College, and he is the president-elect of Endocrine Society of India. Shortly, he will be taking over as president of ESI. He was the treasurer of Karnataka Endocrine Society, past secretary of Endocrine Society of India, and past joint secretary Karnataka RSSD and vice president of Karnataka RSSD. He has received many awards, and he will be talking today about the Verify trial. As you know that the Carolina study was about glimepiride and linagliptin. Now, Verify trial is the one where one of the other gliptins, the vildagliptin, how is it that whether it is the efficacy or whether it's the cardiovascular safety or whether it's going to have any effect on the morbidity and others. So to tell us more about that, here is Dr. Ganapathi Bantwal. Over to you, Dr. Ganapathi.
Thank you, Dr. Prasanna Kumar, for a kind introduction. So this trial, we were a part of this trial from St. John's. We had recruited at least 13 patients and we completed the trial successfully. Now, why was this trial done basically? See, treatment guidelines as of now recommend metformin as the first line treatment with sequential intensification and second line therapy only when the glycemic, the HbA1c is more than 7%. But then there has been some studies, a meta-analysis was done by Fung and colleagues of 15 clinical trials. Here what they found was a combination of two drugs, reduced HbA1c and also reduced fasting plasma glucose compared with metformin alone. So this is one reason you are getting a better outcome, longer durability. The second thing, there was another study known as the diabetes in the aging study. Here, patients with newly diagnosed type 2 diabetics and 10 years of survival from the period of 1997 to 2013, average follow-up of around 13 years, involving around 35,000 patients from USA. They examined the association between HbA1c less than 6.5 for varying periods of early exposure, 6.5 to 7, 7 to 7.9, 8 to 8.9 for incident microvascular and macrovascular events. And they found that the patients who had in the first year an A1C less than 6.5 had the best outcome. Their microvascular complications were less. This is including those who had an A1C between 6.5 to 7 and 7 to 7.9 in the first year. So the one who had 6.5 to 7 had at least an 18% increase in the microvascular complications. And as the A1C increased in the first year, not only micro, the macro also started increasing. Hence, they thought, why not we start this therapy from 6.5 itself. So why is this? Because as you know, type 2 diabetes, when we say the diagnosis happens at the time when the insulin secretion starts falling down. But if you observe here, patient is already having insulin resistance for at least 10 to 15 years prior to the diagnosis also. And you can see, when you say insulin resistance is present prior, it indicates that this patient is also having macrovascular complications even before the onset of diabetes. And how does this happen? That's because you have insulin resistance and the insulin acting via the MAP kinase pathway and producing atherosclerosis. So there are challenges to obtain good glycemic control. One is a poor adherence to management regimens, clinical inertia, and diabetes is a progressive disease. That's what we have learned. Now, when we say clinical inertia, it's actually multifactorial with a range of contributing factors, which could be patient-related. Patients are unrelated. Many times people come and tell us, no, give me 3 more months time, let me wait, then we can start. But then, as I told from the diabetes and aging population study, you control aggressively from the beginning, you're getting to get good. So we have the legacy effect, which is persisting. So when the patients do not begin or intensify treatment, despite not achieving their A1C goal, we call it as a clinical inertia. And this leads to a significant proportion of patients, approximately 30 to 50%, experiencing years of suboptimal glycemic control before the treatment is actually escalated. So patient-related, clinician-related, healthcare system-related. So another study actually, which came in diabetes. So you can see here, once again, a group where patients with A1C more than 7%, not receiving intensive treatment within 1 year, versus somebody who had A1C less than 7%, who received intensive therapy before 1 year of diagnosis. So when they were followed up for around 5.5 years, there was a significantly increased risk of MI by around 67%, stroke by 54%, heart failure by 64%, and the composite CV endpoints by around 62% in the group who were not intensively treated in the first year. So this dysglycemic legacy drives the risk for complications. So we call it as the karma effect. You do good things in the past, you will be excused even if you deviate a little bit. Early intervention in type 2 diabetes is associated with lower long-term micro and macrovascular complications. So in the UKPDS, we found that newly diagnosed diabetic unequivocally reduced microvascular complications. Macrovascular complications came after some time in the follow-up study. So in the initial, they just missed by a whisker, but then in the follow-up study, they got the benefits. What about advanced ACORD and BADT? These were actually done because the UKPDS and the DCCT, you got good results in microvascular. Macro tendency was there, but not statistically significant. And hence the advanced BADT and the ACORD trials were conducted, where they thought, okay, if we bring down the HbA1c further down, maybe 6% or 6.5, can we get a benefit? But the difference here was these patients already had diabetes for at least 8 to 10 years or even more than that. And when they tried to aggressively reduce, you find that the ACORD had to be halted because there was a 22% increased risk of mortality. VADT, not much changes, and the same thing in the advanced, though microvascular complications came down. So Verify is in the context of the other studies. It's like the UKPDS, the ADOPT trial, where you have newly diagnosed diabetes, versus the VADT, leader, declare, ACORD, where they already had diabetes for some time. And here They tried to intensify when the A1C itself was more than 6.5. So it was such a narrow range, 6.5 to 7.5. That's what they wanted. Anybody having more than that. So they were included. So what does the guidelines say? Conventional management versus early intensification. So 2018 till such time. So they stated that initial combination therapy, there is little evidence that initial combination therapy is superior to sequential addition of medication for maintaining glycemic control. After the verified trial, providers should engage in shared decision making around initial combination therapy in new onset of type 2 diabetes. And in 2020, early combination therapy can be considered in some patients at treatment initiation to extend the time to treatment failure. So what is the rationale of this verified trial? So if we use drugs in combination, probably it's acting at multiple pathophysiological defects, so you have a better outcome. Treatment targeting the pathogenic abnormalities and not simply reducing A1C, and early treatment intensification probably should prevent the decline of beta cell function. We used to always hear that when the DPP-4 inhibitors came around 15 years back, that in animal models, it showed reduction of apoptosis of beta cells. But then now, if you see from the verify, probably, yes, if you use this drug from the beginning itself, probably we could slow the decline of beta cell function as evidenced by a greater durability. So this early combination is as a strategic therapy. So it tackles multiple pathophysiological mechanisms, potentially resulting in more durable treatment effect without increasing the risk of adverse event. This trial was conducted in 34 countries, 254 centers involving 2,001 patients from all over the continent. The objective was to assess the long-term clinical benefits of early treatment intensification with the vildagliptin metformin combination compared with standard of care metformin monotherapy in drug-naive patients with type 2 diabetes. It was a randomized, double-blind, two-arm parallel group study consisting of a screening visit, a 3-week run-in period, with a primary defined failure threshold conducted over a 5-year treatment period during which patients' treatment was consecutively intensified if clinically indicated. The key inclusion criteria is age between 18 to 70, BMI between 22 to 40, A1C between 6.5 to 7.5, and eGFR more than 60 ml per minute. And they were diagnosed diabetes less than 2 years, drug naive, or maximum 4 weeks of metformin. So these were the inclusion criteria. This is the study design. Early combination therapy was group 1, where they used metformin vildagliptin, and the group 2 was actually metformin with placebo. The period 2 was where they failed. So the time to this happened after 13 weeks when they looked at the A1C, and once again they looked after another 13 weeks, and if they continue to have an A1C more than 6.5, then the period 2 started. So the patients on metformin vilda, if they failed, if they had an A1C more than 6.5, they continue to stay on the combination, and the patients who did not fail continue to proceed as usual. In the group 2, the metformin and placebo, if they failed, they moved to combination therapy, and the patients on metformin plus placebo who had an A1C less than 6.5 continue to be followed up. And the group 3, or the period 3 rather, was the time to switch is 12 months to infinity. So this is when it was decided. If you see, they also did sub-studies like the meal test. This was done in Asia also. So what you can see here is the mean plasma glucose in the Europe cohort was around 9.3, Latin America 7.9, Asia it was high, and also in South Africa it was high. And the insulin levels, as usual in Asians, we have a high, telling that we have more insulin resistance. And similarly, the C-peptide levels were higher. So this standard meal test was done giving 500 kilocalories, 60% carbs, 30% fat, and 10% protein. So what it suggests is there could be inter-regional differences because of the early signs of increased insulin resistance and reduced beta cell function would be important to both document and interpret for optimized clinical decision making. Coming to the baseline characteristics. Now we'll first go to the Southeast Asia. Average age was around 48.5, A1C was 6.9, weight was around 71 with a BMI of around 27.2 with a fasting of around 7 millimoles, that is around 126. 5% were smokers. If you see the European cohort, age was, they were slightly older, 56.4, weight was 92, more obese, 32 kgs, fasting 7.9 and A1C of around 6.9. East Asia, 52 years, weight of 70 kgs. You can see the Asian group had slightly lesser weight. They had lesser BMI. But then what you find is age is lesser compared with the European cohort. The Australian cohort also 57 years, weight 85, BMI 32. So more obesity in the European and the Australian cohort. And early combination, okay, Caucasians were around 60%, Asians around 18%, blacks into 2.6%, Native American in 10.3% and others 7.8%. Now coming to the results and the implications. So the time to the initial treatment failure, monotherapy versus early combination, the hazard ratio reduced by around 49%. So the combination and Vilda did better compared with monotherapy alone. Now the median time to the initial treatment failure by strategy, that is period 2 to period 3. Period 3 onwards, still you got a failure of the where you required the addition. This was actually 61.9 months in the early combination therapy, telling that this combination therapy is more durable compared to initial monotherapy and add-on with metformin. So at the end of 36 months in the group 2, that is the metformin, who were added on vildagliptin. So by 36 months, they required the addition of the third drug, which was actually an insulin in this trial based on the protocol. And here, the group 1, which was the early combination, required the addition at the end of 61.9 months. In fact, after the trial of 60 months duration was over. So once again, 49% decrease. So the time to secondary failure was actually reduced by around 26%. Now, if you see success rates between the treatment approach, early combination and initial monotherapy. If you take A1C less than 7%, more than 90%, you can say up to around 2 years had A1C less than 7%. And then it did come down, of course, but then early combination did better. What about A1C less than 6.5? Here, actually, you can see the graph becomes more clearer. More patients in the early combination group had an A1C less than 6.5 compared to initial monotherapy, and A1C less than 6%. I would say double the patients in the early combination therapy had an A1C less than 6% compared to initial monotherapy. What are the clinical implications? So the strategy of an early combination treatment approach with Vilda plus metformin in patients with newly diagnosed type 2 diabetes significantly and consistently improved long-term glycemic durability compared with metformin monotherapy. Early combination therapy halved the risk of time to initial treatment failure versus monotherapy. That is from the time up from 12 weeks onwards till the end, that was reduced by around 49%. Median time to failure was 3 years in the initial monotherapy strategy versus 5 years in the early combination. So you had an additional benefit of 2 years. When all patients were receiving combination therapy, the risk for time to second treatment failure was reduced by 26%. But then both the approaches were safe and well tolerated. So what is the implications of this? We are getting a valuable long-term data on durability of glycemic control. Definitely. Beta cell functions, yes. When we say durability is more, it indirectly tells that the beta cell function is more. In fact, they did a sub-hoc analysis of the beta cell using a HOMA model, and they found that in the monotherapy group, actually the sensitivity came down. It was in the -2.2 versus around 17 in the early combination. What about insulin resistance? Yes, insulin resistance also does come down. And when you are doing that, you are actually reducing the progression of the diabetic complication. This is what we found from the diabetes of aging complication also because of the legacy effect. So probably early combination therapy is beneficial because you are increasing the durability, probably increasing the insulin resistance and the beta cell function, and also preventing progression of diabetic complication. Thank you for patient hearing.
Thank you, Dr. Ganapathy Bantwal, for telling us about the VERIFY trial, and you were also part of that trial, and what are the implications, whether it is a primary or a secondary failure retarded or beta cell failure has been postponed. Now I request all the participants, if you have any question answer, please put it in the Q&A box or in the chat box. Let us start with Dr. S.S. Iyengar, that we see in the last 10 years so many CVOT trials after FDA, which has made it mandatory. Do you think in future that CVOT trials are really necessary, which are so expensive that many of the good drugs, they don't even bother to do it because the cost of it ultimately to the consumer is high? Do you see in future that the FDA insisting that these CVOT trials are not necessary, like back what was in 2000s? Or do you think even still the data, whatever you get, is useful for the clinician, it is worth the cost of it? Dr. Iyengar, please.
Thank you, Dr. Vasanth. I think, we know that diabetes carries very high cardiovascular risk. So any drug that is trying to treat diabetes, we should be sure that it doesn't cause any harm to cardiovascular system or it protects it further. So I think it will continue to be a necessity to do cardiovascular outcome trials with any new drug to treat diabetes.
Okay, now in Carolina study, they chose glimepiride. Do you think it is right to compare that linagliptin or a gliptin with sulfonylurea? Or if you were the one, you would have chosen any other drug other than sulfonylurea. What are they trying to prove? They were trying to prove that gliptins are as good as sulfonylurea. Sulfonylureas are good. Ultimately, as you say, there is not much difference between that. You can't say that sulfonylurea had really higher cardiovascular mortality, morbidity. So trying to show that gliptins are better than sulfonylurea, did they end up meaning that sulfonylurea are as good as gliptins? Because people thought after so many studies in the past, maybe that sulfonylureas are dangerous. What did they achieve? Whether you would have chosen a different drug than sulfonylurea if you were asked to do same Carolina study?
I think what they started, the premises were different. They thought sulfonylurea will have cardiovascular problems. And they thought they will have a great difference between linagliptin and sulfonylurea. But unfortunately, it didn't happen.
But probably it proved that it is probably helpful to those sulfonylurea, this one, to say that, look here, gliptins are no way superior to that.
Yes, that's what I feel. I don't know what are the other.
Exactly. I also agree with you.
Yeah.
Maybe when they started this trial, I know the CVOT trial, 6 years, as you said, one of the longest and costed so much. What did you prove? You didn't prove that gliptins are superior to the sulfonylurea. So people who are using sulfonylurea, at least diabetologists got confirmed. Maybe first generation sulfonylureas were not that good. The second and even the third generation sulfonylurea, probably those things do not apply. They're as good as gliptins or anything, except that hypoglycemia, weight gain, it didn't prove. So probably it helped the sulfonylurea group believing that, like in India or all over Asia, 65% of the patients all over, including Singapore, which can boast one of the best standard of care, they still use sulfonylureas. It is not like Europe, 20-30%. So at least confirming the physicians that you are not wrong using sulfonylurea before insulin. Whatever you say, the cardiovascular effect is not so bad as people try to depict. That is gone theory about the first generation.
So it helped sulfonylurea and
exactly.
And our patients, yes.
And many of these studies end up like that. You start with an hypothesis and it may be exactly opposite. Again, you showed a slide where there are high cardiovascular risks. Metformin, lifestyle modification are the first. Then if you choose that if weight gain is a problem or weight loss is not an important problem, gliptin should be the second line. If we go to the other extreme, the European Society of Cardiology said the first line of drug therapy in cardiovascular high risk and renal risk is straight away SGLT2. Don't even bother about metformin. I think they are very bold because this is what you showed was ADA.
Whereas European Society of Cardiology, who should be the one talking about high risk, and they have said, I will even forego metformin, lifestyle modification, straight away SGLT2. What is your take on that? Does it evidence-based, or it is just a knee-jerk reaction after doing fantastic, or cardiologists feel that we should be prescribing more of SGLT2 than diabetologists?
Yeah, I think they have straight away recommended that those who are metformin naive patients can straight away start them on SGLT2 inhibitors if patient is at high cardiovascular risk or has already established cardiovascular disease. But I would still practice that metformin is the first drug of choice, and then you could add SGLT2 inhibitors. As Dr. Ganapathy has shown, it's better to start the combination therapy. Or even in hypertension, we talk of combination therapy, which will have a better outcome. So I think metformin will remain, at least in our practice, the first line of therapy for diabetics. And you could add, depending on the pulse of the patient, SGLT2 inhibitors.
Yeah, because if you see a lot of studies recently with metformin, whether you have congestive heart failure, because previously they said, okay, congestive heart failure, don't use metformin. Now we know, no, that the data has said, even after an MI, when you are using metformin, at the end of 1 or 2 years, cardiovascular mortality, morbidity is much less if you are metformin. Even in patient with congestive heart failure, if you continue metformin, long-term studies have shown they are beneficial. So to that extent, I think, yes, maybe whether the European Society of Cardiology had really evidence-based medicine, RCT to prove. I'm sure there is no such RCT to say using first line bypassing metformin. Suppose you take 5 years. Unless you have such RTCs, it may be a little difficult to accept that do away with. I can agree. Only place it becomes first line of therapy is when patients cannot tolerate metformin. It is not that metformin is contraindicated. Who will come with that? It is only that they cannot tolerate metformin. Yes. Then whether SGLT2 or the gliptins become the first line along with lifestyle. Other than that, I think as diabetologists would still like to go, if maybe cardiologists also, that metformin and lifestyle should be first and add on. Or as Ganapathy said in verified study, okay, you want to start, there is nothing wrong starting metformin plus SGLT2 as first line. That could have been probably a better algorithm rather than straight away telling SGLT2 should be the first one over and above the metformin, because there is no head-to-head comparison at all between metformin and SGLT2 regarding cardiovascular safety. Forget about other things. Maybe A1C reduction, weight loss, agree, but there is no head-to-head comparison to show cardiovascular outcomes. Maybe you'll have to wait for that and then see what it is.
I had one question for Dr. Ganapathy. Yeah. Ganapathy, you mentioned this, our Asian patients had a low BMI, younger age group. But what about their central adiposity? That was not looked into, isn't it? Was it?
They have not commented on that, but then that was also looked into. They will have more, sir. Though in the thing they have not done it. If I remember, we had measured the the waist-hip ratio also.
Okay. And other one is are there any trials comparing combination therapies? These two drugs versus these two drugs?
No.
No.
No combination. 2 drug versus no 2 drug. I'm actually very happy when you told, sir, 2-3 years back in Hyderabad, we had a meeting with canagliflozin with the international speakers, 3 endocrinologists, 4 cardiologists, 3 nephrologists. And they told, no, we must use this as the first line therapy. All the cardiologists. I'm very happy that as a cardiologist, you are telling, no, metformin is the first line. We were the only 3 endocrinologists told, no, we will use metformin. So you telling that is really good, sir. Because metformin has other benefits also. Longevity, theoretically, cancer, so many things. NASH, this, that.
Very cheap drug.
Yes, very cheap drug. That's another thing, yes. So unless you have a contraindication because of diarrhea or something like that, otherwise I think we must use it at the first line.
Yeah, more than contraindication, it is more of a intolerance. See, loose motion diarrhea is more of acidity.
Yeah.
See, because 20% of the patients you see in your practice cannot and do not tolerate metformin. 1. 2, even with metformin, there is a failure. 11% metformin failure. People thought there is nothing like metformin failure, take it long. Many times see metformin, withdraw metformin, you don't see any difference. These are like sulfonylurea failure, there's a metformin failure. A lot of studies have shown 11% per year. So it does happen, but unfortunately, that somehow people feel, oh, metformin always works, you continue to use them. So taking on from what SS Iyengar said, now verified trial was to see from the beginning, when you compare metformin alone, metformin and gliptin, what is something like a durability? It's a durability to study whether primary or secondary failure of it less because beta cells long. My question is, all right, you are using gliptin here. Let us say instead of gliptin, anything other than sulfonylurea, metformin and SGLT2, metformin pioglitazone, metformin GLP-1 unlock. Do you think if I had used it, result would have been same? It doesn't make any difference.
The question here was, we had the primary failure at the end of around 6 months. The period 2 to period 3, where the group which failed on metformin were also added vildagliptin. So that combination, when they were followed up, also you found a benefit. So that's the reason they did this. Now, if we are adding from the beginning 2 drugs, and this has to be better, no doubt. But then once that period 2 was over, where they added metformin with the vildagliptin in the group who are on metformin alone to begin with, that also showed a benefit in the sense that combination was actually better than add-on therapy. So that was actually the thing which indirectly tells that probably if you use it from the beginning, you're going to get benefits. Maybe you may get the same thing with an SGLT2 inhibitor with metformin combination also, I don't know. But then this was basically the rationale.
And again, if you take glitazones, because one of the drugs...
Glitazones without any doubt.
Yeah, because it has the longest durability among all the oral hypoglycemic. Let us say you start metformin glitazone day 1, and mostly, as you said, is because of glucotoxicity. Whatever you do, if we can reduce the blood sugar early, and then it does not exhaust the beta cell, does not stimulate, naturally durability will be more, and even the beta cell preservation will be there. And using from day 1, where again, if you see patient is not obese, there is no other contraindication, metformin pioglitazone from day 1, if we use it, definitely say, what is De Franzo's triple regime? It is nothing but metformin and DPP-4, glitazones and GLP-1 unlock, right? Daily. It was not weekly at that. So that is what triple therapy when HbA1c is 11, not even 10. He had about 700 and odd patients. They were on triple therapy, De Franzo's therapy, and he showed very clearly beta cell preserve and everything. Of course, that study was too short for cardiovascular, and even verify also cannot say in 6 months, 1 year about cardiovascular. So my takeoff is, whatever the second drug you use, except sulfonylurea and insulin, forget about this. All other oral plus GLP-1. Tomorrow we will have even GLP-1 unlock oral. Any second drug you use, probably will have much better. Same thing if you see the ACE guidelines. What does it say? Below 7.5, 1 drug, 7.5, 8.5, 2 drugs, 7.5 to 9.5, straight away start 3 drugs. Maybe you'll use metformin, gliptin, and SGLT2. And probably they will have a much better control compared to even 1 drug and 2 drugs. So basically, if you see the whole protocol, what was the purpose of it? We knew that definitely you are going to get a result. It's only to substantiate scientifically that combination should be done in the beginning rather than step care approach. As you said, metformin, and then add on, you would have wasted too much of time to bring them to below 7. Once you bring down below 7 at a shorter interval, the beta cell will definitely work longer and preservation. That was the very purpose of doing this study. And I think if that was the idea behind it, they have achieved it. Nothing more than that is necessary from this study, but combination is useful.
This combination therapy, when you talk, do you talk of reducing the doses of each?
Yeah, you can actually do that. But then here, what happened was to the maximally tolerated dose. So you can go up to 1.5 grams or even 2 grams also. So that's fine. You could reduce also. In fact, actually, after this trial, I'm using this combination as a single drug only. I won't use it even twice a day. So 50 plus 500 or 50 by 1000, it's doing extremely well. At least now in the last 6 months, many of them are doing, people don't want more tablets. No, they'll tell, no, can you reduce? Yes, this is what I do.
But again, the problem is you cannot start with a maximum dose of metformin. When you start metformin, you always start with 500.
Yes.
Because if you start 1 gram BD, 50% of them will have suddenly nausea, vomiting and all. So Ganapati knows very well as diabetologist, we don't start 1 gram BD, whatever the blood. So even in a combination, as you said, You start with a smaller one, and you can't do SGLT2 when blood sugar is 300. It cannot be part of it. GLP will be there. In such situation, better to use a smaller dose of metformin. Of course, gliptins are fixed dose. There is nothing like escalating the dose. So I have a fixed gliptin, maybe 500 plus 5 mg, then 500, 5 BD, whatever you go on like that. So ultimately, you try to achieve it. When it is triple also, then you start with a smaller dose of metformin, where SGLT2 gliptins, the dose is same. There is nothing like increasing, decreasing, unless you have got a renal failure significant and all. So sometimes this fixed drug combination are useful, like in verified study, but in some situation, you don't have so many permutation and combination of the drug. If you try to reduce later on, then you see you are doing suboptimal dose of gliptin. So when you have 5,500, 50,000, something like that, you have to step down to 5 by 1,000 to 5 by 500. We cannot make it half or once a day. These are the problems. But use selectively, at least we have a scientific data to show verified studies. Start from the beginning. If HbA1c more than 75, better start the combination rather than stepped care approach. We are using a lot of time. That should be the message to the audience. I don't see any other questions. I thank both Professor S.S. Iyengar and Dr. Ganapathy Bantwal. We started 5 minutes early. I think we have even closed 7 minutes earlier. You have a lot of time. And I think Dr. Des Schatz, hi, he's waiting there. So we are ready, sir. If you are ready to start your lecture, I am ready here with your biodata. Shall we start?
You just tell me what I need to do. I'll be happy to do whatever you want me to do.
Yeah, start
Good to see you, Kumar.
Yeah.
It's wonderful to get you. I was telling Bhavana and I was telling Aravind earlier on, you know, the fact that you guys could not actually get me out to go to a Royal Challengers game and to at least see, you know, Virat Kohli in form yesterday or the day before against Rajasthan. You know, this is definitely one as a rain check. So I'm just telling you that, you know, I'll be back and, you know, without you, this is the pseudo sweat, you know, stuff. But next time is the real stuff at a game.
You don't have a RCB cap. Last time you had a cap. This time you don't have a cap. Right?
You know, I'm actually in my office in the hospital, and I actually had my cap this morning.
Oh,
and I put it on, and I thought, God, somebody will think that in the United States this is Halloween, or there's something to that effect that it's like something. So look, it's tough enough me walking in, you know, to my office with a shirt. But I thought if I put on a cap, somebody may call the police or do something a little crazy there. So, you know, I thought I would just keep it a little bit lighter next time. But I haven't.
I am now watching you on one eye. On the other eye, I'm watching the match between Mumbai Indians as well as Hyderabad. So live. So I have got two eyes. And one part of the brain is for science. Another part is for the cricket.
Yeah, well, I hope during this part, I'll have at least a little part on the science and it won't be on the cricket because I couldn't tell you what I would. You know,
Anyway.
It wouldn't appeal to Aravind and Bhavana that, you know, I wasn't concentrating too much on this.
Mm-hmm.
So, you know, it's good. So, yeah, whatever you want me to do, I'm ready.
Yeah, we'll start straight away. You are ready with your slides. Okay.
Okay, so let me
Good afternoon, everybody. It's my pleasure to introduce my friend Desmond Schatz.
Yeah, we apologize for the photo. It's the wrong photo. We'll have that.
I know. I was wondering,
Sorry.
is it that Desmond Schatz was 30 years back like this or 20 years back? I also wanted to tell you it's a wrong photograph. I have never seen this. Anyway, take it out. I will read this one.
Yeah.
Dr. Schatz is professor and interim chair of pediatrics and medical director of Diabetes Institute and director of Clinical Research Center within the CTS at the University of Florida, Gainesville. He served as president of Science and Medicine of the American Diabetic Association 2016, and Schatz has been involved in type 1 diabetes research since the mid-1980s and has published over 360 manuscripts. Mind you, everything is on type 1 diabetes. Very few people are focused on type 1 diabetes, and Des Schatz is one like that. The majority related to prediction, natural history, genetics, immunopathogenesis, and prevention of disease, as well as management of children and adolescents with type 1 diabetes. A lot of us have 200, 300 publication in 150 subjects. He has got 360 publication in one field. That is what not only length and breadth, but the depth of knowledge and science will go into that. He is the principal investigator on several National Institute of Health awards. He was the principal investigator of University of Florida Clinical Center, participating in NIH-funded TrialNet, a founding member of DPT-1, Diabetes Prevention Trial 1, 1994. He is co-PI on a program project grant seeking to understand the immunopathogenesis of type 1 diabetes, and also serves as PI for the NIH-funded International Newborn Genetic Screening Program in North Central Florida. He is the PI on the NIH-funded Human Islet Research Network grant evaluating novel markers and mechanisms of beta cell destruction. He is the PI of the University of Florida site participating in type 1 diabetes. I can read here a biodata next 1 hour, but we have time for his. Over to Shorts for his presentation on type 1 diabetic, the heterogeneity.
Well, thank you very, very much. And I'll try and put the screen up, and really want to thank you, Kumar, who's really, since the very first time, really acted as family, as have Aravind and Bhavana and she was Krishna. I can tell you that as I was just talking to my son, our previous experiences have been so positive, and yet we're linked in this way. But again, I'm honored to be here with many of my colleagues. I participated, I listened to some talks already during this, and I'm actually going to continue the theme, which was really begun yesterday by Lou Phillipson, as well as John Buse, about personalized therapies, because I honestly believe that, to some extent we have not gotten as far as we need to be. We've made some great strides, but I think that right now we're at a intersection whereby we really need to move the field forward. And yes, we have evidence-based medicine, but I think we're learning so much about the disease that really we may find that the disease process in itself is not uniform. And that's the focus of today's talk, the heterogeneity of type 1 diabetes, the need for personalized therapies. When I spoke to Al Powers, who will be following me on this talk, he was going to talk about the heterogeneity of the pancreas itself. I could have done that. He wanted to do that. I will talk more about really the importance of different disease process, particularly as it relates to age. So I'm going to continue with this. Not sure why it's not moving to the next. We'll do it. But the objectives for my session are to define endotypes and the necessity to understand.
Could you go on slideshow and then it would move? You're not on slideshow mode yet.
Yes, I am. Let's say from current slide. Is that better?
Yes. Now it's fine.
Good.
Yes.
Okay, thank you. So the objectives of this talk today are to define some endotypes and the necessity to understand the heterogeneity of type 1 diabetes, the importance effects of age, and to describe the current and future efforts aimed at interdicting type 1 diabetes. So I want you to understand that what is an endotype? And I think that, we've heard of phenotypes, and a phenotype is just a characteristic, it's a trait, it's a morphology, it's a biochemical property, it's a behavior. But an endotype is really where we need to go, because an endotype defines mechanism. An endotype is defined by a distinct functional or pathobiological mechanism, which will then enable us to get to the very root of the question and then reverse or prevent the process that is going on. And so if we put endotypes together with genetic and environmental influences, that will enable us to explain the clinical presentation rather than just something happens, the epidemiology and the response to therapies. And again, that will enable us to talk about personalized therapies, precision medicine approaches to targeting different pathogenic processes. Now, this is not a novel concept. We actually preceded COVID-19. There was a lovely article in the New England Journal that talked about the adult respiratory disease and the response to different therapies. And it really was important. as to what the endotype was. Now, I show you a picture here of one face. And this is the face of type 1 diabetes, the face in which we think that this is all diabetes. But if you look very closely at the picture, yes, it's one face. But I ask you, and I challenge you, is type 1 diabetes just one disease? You look at these kids, you look at these adults, you look at the different races, the different ethnicities, and we sort of think, you know, different exposures, different mechanisms, yet there is one face. We really need to take a step back and ask, is there just one disease? Now, for many of you who are adult endocrinologists, I'll show you a slide from our colleague Satish Garg, in which he looks at an example of adult continuous glucose monitoring. And what you can see is if right in the middle of the pink, the purple is the median, what you can see is that you have variations in a person fairly well controlled between 140 and 160. And there really isn't much of a shift in the readings themselves, which is very different to a pediatric patient in our clinic who wears a continuous glucose monitor. And what you see distinctly, and I don't have a pointer, I'll use a pointer over here, but what you can see typically is that it goes up overnight. There's a tremendous fear of hypoglycemia. The blood sugars remain high overnight. They sort of come down to the morning, and then after breakfast, it's really difficult to manage. And then you see these big fluctuations in glucose. And so I ask you, yes, they're teenagers, yes, they're kids, but is the disease disease process the same in children as well as adults? And I think that Al Powers during his talk will talk about the fact that in some cases there may be a predominant T cell response in younger people, or rather than a B cell response, which may occur in other age groups. So again, looking at this slide that you guys have seen over and over again from the type 1 diabetes exchange and Kelly Miller, and you look at mean hemoglobin A1C here on the y-axis, and here on the x-axis is age. And what you can clearly see is that during the time between, let's say, 10 and 25, there's a tremendous increase in hemoglobin A1C, such that mean hemoglobin A1Cs, which were measured in 2010, 2012, were about 8.8. And ironically, despite the advent of continuous glucose monitoring, and despite the advent and the institution of more pumps, what we see is an increase in A1Cs. Now, with some of the more closed loop systems, we'll be very interested to see whether in fact that A1C goes down. But as a pediatric endocrinologist, I ask a simple question: is this all puberty? Is this just all, a youth who are just, who are finding themselves? Or in fact, could there be different diseases themselves in children versus adults? Now, the quest for a type 1 diabetes endotype and precision lags. I mean, let's think about cancer and think about, I talk to my colleagues in the cancer literature and even here, and they're already using specific therapies, Gleevec for patients who have the Philadelphia chromosome. So they're using personalized therapies to treat mutation, specific disease mutations. We used to use chemotherapy for patients with CLL, chronic lymphocytic leukemia, and now with certain phenotypes, we don't even do that anymore. We can just watch it and sort of see the course of the disease. But now we have good DNA sequencing, functional imaging, and integrative omic measurements, yet the field of diabetes is much broader and less well-defined. And yesterday, Lou Phillipson and John Buse talked a little bit about diabetes and the perception that there really was two types of diabetes type 1 and type 2, and even, our good friend Rohit Kulkarni has sort of gone on to this. And if you look at the reality, and I just show you, for an example, about 9 or 10 different forms of type 2 diabetes. Now, just as I ask you, and I ask you to think pretty deeply, how can the therapy for one of these conditions, when I came in on the end of a discussion that Brother Kumar was talking about metformin and combination therapy, but again, we simply talk about type 2 diabetes, but think of the spectrum of the various kinds of type 2 diabetes, and think of the fact that not only is there a spectrum, but there are different stages of the disease. So we clearly need to understand not only type 2 better, but also obviously to type 1 as well. So I want to just take one step back, because diabetes is rising. I would actually ask you, Kumar or Bhavana, to send me an update of type 1 in India, because that would be very, very helpful. But I want to just show you type 1 diabetes in the United States, that it's rising, that the prevalence is 1 in 300. There are over 1 million people with just type 1 for sure, that the annual incidence is over 20,000, and the most rapid increase is in very young children. And we expect this prevalence to reach 5 million by 2050, which tells us that, one, we don't know what the hell we're doing with this disease. We don't understand the cause. We need to focus more on why there's this increased autoimmunity in young kids that manifests as diabetes, because it does have an impact: shortened life expectancy, the acute complications of hypoglycemia, DKA, micro and macrovascular complications, and inability to achieve glycemic control. Well, what does this mean? In the United States, the annual healthcare costs, and this is an old slide, was about $20,000 per year per patient. And the hospital costs for admissions just for DKA are over $25,000. When you look at the annual medical costs and lost income, we're talking about $14.4 billion. And it's only going to get worse, particularly with the unfortunate situation that exists here in the United States. So let's look at some significant advances over the past 25 years, and it gives, again, relevance to this particular talk, that yes, the DCCT will reduce control complications, and yes, we practice intensive management and technological advances, and we're getting to an artificial pancreas, but again, insulin's not a cure. We understand beta cell biology. I just attended a 3-day meeting of the Human Islet Research Network. It sets the stage, but gosh, there is no cure. We can predict the disease, yes, it's immune mediated, it sets the stage for prevention, but gee, let's take a big step back, and there is no prevention. But really the question is, we know less than we think that we know. And that the road to curing type 1 diabetes is going to be knowing that we're going to have to stop an immune attack if it's already initiated. We're going to have to preserve or prevent the onset of autoimmunity, and then we're going to have to be able to replace beta cells. So we know what to do. It is very clear we know what to do, but why is it? Why is it, I ask you, have we not reversed type 1 diabetes? And that's another talk that I could give. I'm just going to list them on this particular slide, that we know little about the mechanism. We've learned very little from animal models. These immune interventions, yeah, maybe up until now, the wrong approach, the wrong time, the wrong combination. Don't have time to talk about the changing face itself of type 1 diabetes. And again, do not think that children are young adults. I'm a pediatrician, and I'll be the first to tell you that that's a mistake. Now, do I say we don't know? Well, we don't know. And I'm only going to put this up to confuse you, because it's a difficult slide to understand. And as a pure immunologist, and if we had an immunological session, I would go through this with you. But I really just want you to focus on the bottom. And the bottom is that we believe that the immune system has an intricate balance between regulation and killing. So in that phase, you and I don't have autoimmune disease. We are in a state of tolerance. But in a state of autoimmunity, that pendulum is shifted towards something of killing, be it diabetes, be it rheumatoid arthritis, be it celiac disease, be it whatever it's going to be. We're shifted towards the stage of killing. And so be it the joint, the beta cell, that's what happens. All this other stuff is discussion. All this other stuff is hypothesis. What happens when the MHC interacts with the immune system to result in killing? We can go on to this discussion honestly for days. But I want you to say it's a disorder of failed immunoregulation. And why should that process be the same at each and every stage? Well, that goes on to the stages of diabetes. And these are data that we published in Diabetes and Diabetes Care a couple of years ago. And the reason is important. It sets the stage for us to do something. So let me just run by you. If this is beta cell function here on the y-axis and this is time, we know that there is a genetic predisposition. There is an autoantibodies that signal the fire that's burning in the pancreas. With time, as beta cells are destroyed, there's dysglycemia and finally symptomatic disease. Well, that gives us at least an opportunity to say, well, if we can prevent antibodies, that's primary prevention. And that's the dream: a vaccination, an immunization, the removal of an agent. Wouldn't it be nice if it was just like celiac disease? We take something out of the diet. Then we get to secondary prevention, which is stage 1 or stage 2. Stage 1 is 2 antibodies with normal glucose, and stage 2 is 2 antibodies or more with dysglycemia, and finally you get to diabetes. So this at least sets a framework for intervening. Now, most of the studies from a perspective of equipoise have really focused on new onset patients because they already have the disease. And we're saying, okay, we're going to give an immunosuppressive agent because it's an autoimmune disease, and this is what we're going to do. So there have been several agents, don't have time to go through them, but if you look at the successful immunotherapies, what you can really see is that there is a response for the first 6 to 12 months. So you take a patient with new onset disease, you give them a successful immunotherapy, and I'm going to give you an example of one in another while. And what you do is you see that there's a great response for the first 6 to 12 months, and then the curves fall down and flatten out. And that really by 5 years, they're pretty much the same. So the question is, why are we doing this? Well, we do know as per DCCT that if you control diabetes, you can prevent complications, but also, in my opinion, it's important as a concept, certainly for prevention. So I'm going to give you an example of the successful immunotherapies, and probably the most successful, although this could be argued. And this is data from my colleague, Dr. Michael Heller, who's shown preservation of C-peptide in new onset patients. And this is going out at least 2 years. And what I want to show you really in the red, this is the time of diagnosis, this is therapy. And I want to show you really in the red, and I'm going to trace this, if you can follow my pointer, is the placebo group. And what I want to then show you is anti-thymocyte globulin. Don't be distracted by a combination that we thought, which was anti-thymocyte globulin plus GCSF, that's granulocyte colony stimulating factor. But what I really want to show you is the marked difference that we saw comparing anti-thymocyte globulin versus placebo, looking at the blue and the red. It's very apparent that ATG preserved C-peptide for at least 2 years. But in addition to that, it also had an effect not only on C-peptide, but also on biology, because what was the important thing was hemoglobin A1C. We weren't able at that stage to measure time in range. But if you look at the placebo, and after 2 years, the placebo, even in this group, was around about 8. But if you looked at ATG alone, it was just above 6. So clearly ATG is very effective in new onset patients and begs the question, should it be used in pre-type 1 diabetes? Well, ATG is not the only drug that's been used. And I just wanted to sort of show you that we really haven't been messing around over the past 10 years. I've updated the slide because I had given, I think, a talk a couple of years ago in Bangalore. And really over the past 10 years, we've done a combination of 106 antigen-specific and non-antigen-specific trials. And it's really impressive when I show you these studies. And again, I show you them only to tell you, because people have said, well, what have you been doing? These are the effects of antigens in the past 10 years. And these vary from insulin to GAD to diapep to combinations of those. And really up until this point anyway, in well-controlled studies, there's been no effect. There have been some subgroups that have shown effect, but really no effect that have been shown. And when we look at non-antigen specific therapies, you've got everything. I showed you the immune system. Just look at the people. People have been thinking. People have been really trying everything from really interrupting the immune system to disrupting the immune system to hitting the immune system with immunoablation, and really it had little effect, certainly in preventing type 1 diabetes, really perhaps until now. And when I say until now, we just say, yes, I have not failed. I've just found maybe 10,000 ways that don't work. And indeed, that is science. And when I say until now, there was a manuscript that we had published really with Kevin Herold as the first author, in which we used anti-CD3, which is tepalizumab, in relatives at risk for type 1 diabetes. So these were people who already had 2 or more antibodies, and the whole goal was to prevent their progression to diabetes. And what I want to show is the study. There were 76 people enrolled in the study. And what you can again see is the placebo group, which is shown here in red, and the treated group, which is shown here in blue. And what you can see was that there was, in the group, it was a 2-to-1 randomization, but clearly less patients who got tepalizumab developed diabetes, and the delay in the onset. So you would ask, what is the delay in the onset? This is, on study is on average about 2.5 years. So it clearly had a delay. Now you may argue, about equipoise and cost, and that in itself is another discussion. But at least we have a therapy that may delay. I would perhaps posit that anti-thymocyte globulin, which would be a lot cheaper, you would see exactly the same effects. So again, why do we see this difficulty? And I'm going to spend perhaps just the next 10 minutes that I have left just to tell you that children are not adults. There's tremendous variation between individuals, and you're going to see this with in Al Powers' talk, the differences in the pancreas and some of the surprises. And of course, you're going to see that if there's heterogeneity and various endotypes, there's a varying etiopathogenesis. It's going to affect diagnosis, it's going to affect systems biology, and therefore the response to therapy is going to need to be individualized. So what do we know about heterogeneity? Well, it's like every other autoimmune disease. Think of diabetes like lupus. Think of diabetes like multiple sclerosis, like rheumatoid arthritis. It's not like you get onto a slide and then what happens is you get off at the bottom. It relapses and it remits. And where you study them could be during a stage of relapse, of progression, or it could be a stage of remission. We know that if you look at beta cell function in children versus adults, we clearly know that the deterioration in beta cell function is a lot faster than that in children compared to adults and late childhood. And in fact, even people, and I would be happy to debate people now talk about LADA, latent autoimmune diabetes of adults. I would simply say to you, it is no different from type 1. It is just a much slower variation of type 1. But if I said to you, Kumar or Aravind or Bhavana, do a study and enroll those patients with LADA in the same study of type 1 with those that are in early childhood, you would say to me, you've got to be crazy. The disease processes we know are different. And how would you ever find any difference in the outcome of this particular trial? The same thing goes when you look at pre-diabetes and you look at what happens, and we look at the age screened, and we've known this for over 20 years. If you test positive for islet antibodies in the first 2 years of life, your chance of developing diabetes are over 90%. Contrast that with if I was to test positive, which is out there, my risk of developing diabetes would be much, much lower, less than 10%. So the risk of developing diabetes, if you have 2 antibodies, if you're young, is much, much higher than if you develop 2 or more antibodies at a much older age. And look at what actually happens. This is a slightly complicated slide, but it also shows that age modifies the rate of progression. Even if you have glucose intolerance, not a surprise, and you are younger, your chances of developing diabetes over a 5-year period are about 90%. So you already have glucose intolerance. But look at this. Even if you have 2 antibodies and you have glucose intolerance and you develop this over the age of 20, your risk is much lower. It's only about 30%. So again, we're comparing apples to oranges, and it must be that the disease process has got to be different at different ages. And I show you this, again, some provocative data from the other study that I'm participating in, which is the TEDdy study, and asks if there are different age-related disease processes even in the young. So here is a provocative slide that we had shown, and I want to just show you again. This is incidence shown on the y-axis, and here on the x-axis, I'm going to show you is age of seroconversion in months. And what you see is that there are clearly some patients who develop antibodies early. This is IAA, insulin autoantibodies. They develop insulin autoantibodies. There's a peak between 1 and 2 years of age, and then insulin autoantibodies fall off. When you look at GAD antibodies, GAD only start coming up at 1 to 2 years and then persist. Whereas insulin antibodies have gone away, GAD antibodies persist over time. Now look at this. If you look at the association between IAA and HLA, IAA are distinctly associated with the DR4 haplotype. Look at this. This is a DR34. If I move to this slide, it's DR44. And then there's a DR48. You can see that DR4 is associated with insulin autoantibodies, whereas it's not at all associated with DR3, which is where GAD is associated. So even in these very young patients, this immediately begs the question, is there evidence of a different disease process? If IAA becomes early and then declines, then GAD goes up, it's increasing because that's associated with DR4, but does HLA determine the disease process, or does this suggest a different environmental trigger or a difference in etiology? Again, that's what happens before. But look at what happens even after the disease. There's a distinct age. Again, if I treat somebody in your clinic, Aravind, over the age of 21, they're going to respond. It's going to look like it's better. Whereas if you treat them in my clinic, they have a lower C-peptide to begin with, and the decay in C-peptide is much slower. When we've actually looked at the successful trials, we saw that rituximab, for example, was successful. Rituximab was successful, but look at this compared to the controls. Do you know why? It was successful because the effect was driven by those in younger patients. If you look at it overall, rituximab didn't work overall as a group. You can certainly see if you look at those over the age of 18, when you look at control versus treated, but when you look at the treated and you compare that to the control group, rituximab exerted its effect because it was effective in younger patients. Now, we do know that the C-peptide varies with age, and we clearly know that even if you look after many, many years, that if you're diagnosed under the age of 18, compared to when you're diagnosed over the age of 18, and you even look at patients who've had diabetes for more than 40 years. If you were diagnosed under the age of 18 and you look at C-peptide either in the peripheral blood or the pancreas, you'll find that very few have insulin positive cells as evidenced by C-peptide. But there are people over the age of 18, and this is shown at every age, that there's persistence of beta cells as reflected by C-peptide, which actually gives us an opportunity perhaps to intervene at any age if we can rejuvenate or we can reinvigorate those beta cells. So as I wind down this talk, I want to say to you, heterogeneity plays a very important role in type 1 diabetes. Children are not adults. There are different disease processes. Al Powers hopefully is going to show you the differences within the pancreas, not only between individuals, but within the pancreas itself of an individual. It appears that certain areas are affected differently within the pancreas. And this obviously has a huge impact on pathogenesis, pathobiology, systems biology, which leads us to develop a systems-wise approach. We need to better understand the genome. We need to understand gene expression, the proteome, the metabolome, and how it affects the immune system, the microbiome and environment, so that indeed we can then develop therapies. So again, let me be provocative and say to you, yes, we've learned from evidence, and we've learned from the biostatisticians, and we need to do well-controlled studies. But here I'm going to challenge you outside of the box that maybe it's time to do intensive N=1 studies to think about what happens in that person and then to try and alter the course of the disease. We do it in cancer, and why don't we do it in diabetes? So again, I will end with some quotes from Nelson Mandela that we need to find solutions rather than spouting theory, because when we spout theory, we can go on and on forever and ever. We need to really shorten the discussion. I'm not an optimist, a great believer in hope. We've got to have hope, because if we don't have hope, it seems impossible until it is done. And I think we will be rewriting the textbooks on how type 1 diabetes develops. And perhaps another year, I'd like to perhaps give you an update on what we've learned from the NPOD and from the pancreas donors, at one of these meetings. So again, I want to thank most of all our patients. I want to thank really the funding agencies, my colleagues, Mike Heller, Mark Atkinson, and there are too many to describe. But most of all, I want to thank them, and I want to thank you for giving me the opportunity to speak and to encourage more and more of you to join with me, to join with us as we all work together to ultimately prevent and cure type 1 diabetes. So thank you very much.
Thank you, Dr. Descharts, for a brilliant talk. I have learned a lot. So many times I have heard your heterogeneity in type 1, but there's always something new that you come up, and it is something which is food for thought. And then some of these provocative slides to say how new data is adding. Though at the beginning it looks very, very depressive as you go on. Yes, there is a hope that finding answer is no easy. Even patient asks that question, doctor, we have so much of knowledge, we have so much of saying, can't you prevent diabetes? Can't you cure type 1? They think it is so simple. After 4 decades, you have realized. We have also seen immunotherapy from cyclophosphamide to this, and it is still the prevention of type 1 diabetes, probably a LSD goal. May not see in our generation, maybe next generation we see. Please stay back. At the end, I think Dr. L. Powers has already joined us. So after that, we have a lot of time for question answers, and I have my own questions and doubts. And it's my pleasure and privilege to introduce Dr. Alvin Powers. Dr. Powers is the Joe C. Davis Chair in Biological Science and Professor of Medicine, Molecular Physiology and Biophysics at Vanderbilt University, Director of Vanderbilt Diabetes Center, Chief of Vanderbilt Division of Diabetes Endocrinology and Metabolism. And Dr. Powers is the Director of the Vanderbilt Diabetes Research and Training Center, a NIH-funded center for facilities and diabetes-related research of more than 120 scientists in this group. He is a physician scientist whose research on type 1 and type 2 diabetes focuses on pancreatic islet biology, development, and function. He has been supported by NIH, the Veterinary Administrative Research Services, JDRF, Junior Diabetes Research Fund, and also Foundation, the American Diabetic Association, the Leona M. Harry B. Hemsley Charitable Trust. Dr. Powers was the director of Vanderbilt Medical Student Research Training Program in Diabetes Endocrinology and Metabolism during 1996 to 2019, and is the founding coordinator for the NIDDK Medical Student Research Programs. As you heard from Des Shorts about the heterogeneity of type 1, he said type 1 diabetes is as heterogeneous as type 2. Apart from that, now Al Powers will tell us how the heterogeneity in the pancreatic beta cells. We are waiting to hear, sir. More than 1,000 delegates are very eager to listen to you. Over to Dr. Al Powers for his talk on heterogeneity of pancreatic beta cells. Please share your screen.
So good morning and good afternoon. It's a pleasure to be here, an honor to be here. This has been a great conference. I've been joining remotely, and the only regret I have is that we're not interacting face to face. So I want to pick up and continue the theme that Dr. Schatz began about heterogeneity, but I'm also going to take it a little bit in another direction and talk about heterogeneity in diabetes in general and how we need to think more about the pathogenesis in different forms of diabetes. So I don't have any disclosures to make you aware of. And here's what I'd like to talk about briefly today. Is I'd like to give you some updates on progress and challenges related to pancreatic islet biology. And specifically, I want to review what we know about what's happening in the pancreas in type 1 diabetes, in certain forms of monogenic diabetes, in type 2 diabetes, in cystic fibrosis related diabetes, and diabetes related to immunosuppressive agents. The common feature of these forms of diabetes is they're all insulin deficient. But I want to emphasize about the different mechanisms by how a patient becomes insulin deficient. And to really emphasize that as we think about our current classification of diabetes, and Dr. Schatz just spoke about this and showed that in the very nice pie chart, it's really inadequate. So when we look in the textbook and we see these sorts of things for diabetes classification, it's really outdated. And it's not a rational pathophysiologic or genetic-based classification or nomenclature, and that's what we need. Now we're beginning to have some progress in that area, and I show here a work from Scandinavia where they identified 5 different clusters of diabetes. And what they did is they classified them as either severe autoimmune diabetes, severe insulin deficient diabetes, insulin resistant diabetes, mild obesity related diabetes, and age related. And they did that by measuring different things such as GAD antibodies, C-peptide levels, age of onset, and those sort of things. And they could identify 5 different clusters, and they're shown in these areas here. But really, this is a step forward, but it doesn't get us to the point where we understand the molecular pathogenesis for the different forms of diabetes. And that's what I want to speak about today. Now, much of what I'm going to talk about today is based on, we know the understanding of what goes on in glucose homeostasis. We also know that in GWAS studies that the genes that point to diabetes are often associated with the pancreatic beta cell. And really the premise that I think many people have is that beta cell mass, the number of beta cells we have and or their function are the critical determinants in whether or not diabetes develops. And the work I'm going to speak about today has been largely done as part of an NIH initiative called the Human Islet Research Network, or HERN. And that's a group of more than 40 scientific groups who are working together to understand the human pancreatic islet and how it becomes dysfunctional or destroyed in type 1 diabetes. Dr. Schatz is part of this group, and I'm going to specifically talk about work that's done in one of these groups called the Human Pancreas Analysis Program, or HPAT. Now, let me give you 2 examples to point out the heterogeneity that Dr. Schatz says. For example, here's Sarah, and so she was 7 years old, had weight loss polyuria because her older brother, Samuel, had diabetes, her parents had glucose checking equipment at home, and they diagnosed her with diabetes with 300. She never went to the hospitalized, but she's been doing very well on a pump with that sort of thing. But she had onset of diabetes at age 7. And I want you to contrast her to Mr. H, who was 27 years of age when he developed type 1 diabetes. Initially, he was treated with sulfonylureas and caloric restriction. Because of his age, he was told he had type 2 diabetes, but he clearly had type 1 diabetes. You can see his body habitus here. He was quite a fisherman, and so he was always telling me about his fishing stories. He was treated with insulin treatment, and he's done well, and he's had type 1 diabetes for more than 50 years. An incredible accomplishment. But think about, does he have the same disease that developed at 27 that Sarah developed at 7? And that's one of the things Dr. Schatz was speaking about. So I'm going to show this revised scheme that talks about the different stages that Dr. Schatz just spoke about, where one has genetic susceptibility and then develops diabetes here. But what I want to do is highlight these 5 asterisk marked areas that shows that our understanding of type 1 diabetes is really inadequate, and that we need, I said here, how we think type 1 diabetes developed, and it really is a series of hypotheses, and we need to know more. So we're going to talk about these different stages. So let's begin by talking about beta cell mass, where we think it's 100%. Now, if one looks at what's normal beta cell mass, it turns out it varies dramatically. So this is work from Peter Butler, which measured beta cell mass in non-diabetic individuals at autopsy over a wide range. And one can see that there's a huge range of beta cell mass, and it might vary 3 to 5-fold in individuals. Now, so that's really important if you think about the schematic of how that we're showing for type 1 diabetes. So we point this, and one slides down this curve and develops diabetes. But what if you'd been the individual who had a low beta cell mass, or you'd been the individual that had a much higher beta cell mass? Your risk and your time to getting diabetes is much different. So the baseline beta cell mass is an important determinant, and we need to know more about that. So the question that I want to just give you a little bit of data about is how and when is beta cell mass determined? And so if one thinks about beta cell mass being these 3 areas here, one can say, okay, beta cell mass at birth is the same in everyone. And then some people have less beta cell mass develop, others have more beta cell mass, and that it's determined in this first decade of life. It's clear that it's determined mostly in the first decade of life. The question is whether it's different at birth and is a product of the in utero environment. Are there things in the environment here that influence our beta cell mass? And I want to highlight one of the studies that Dr. Schatz is part of the TEDdy study, and he showed a different form of this slide where they looked at individuals who were high risk genetically for type 1 diabetes, and they measured autoantibodies 1, 2, or 3. And if you had 2 or 3 autoantibodies, your chance of developing type 1 diabetes in the first decade of life was quite high. But I think it's very interesting when one looks at when these autoantibodies develop. They often develop in these individuals in the first 5 years of life. For those 2 reasons, I think knowing what goes on with beta cell mass and the fact that autoimmunity begins in some individuals in the first 5 years of life, we've been involved in studies to look at the human pancreas early in life. And so this is work that we've done with Mark Atkinson at the University of Florida. And what we've done is we've been looking at the neonatal pancreas, and you can see that we studied a large number of pancreases. My colleagues, Marcella Bershova and Diane Saunders, have been leading this. So what we've done is when these tragic events happen and individuals die less than the age of 10, we're able to procure the pancreas as part of the organ donation process. It's then sectioned and then we're studied. And so I want to just show you some of those studies. We also isolate the islets from those and study their function. So this slide shows the human pancreas in tragic events where the individual died in the first 3 months of life, from 3 to 24 months, or they divided at 2 to 11 years. So here is insulin and the islets stained with insulin in green, glucagon in red. So one can see at this early age period, many islets. But look at the size of these islets. They're really still assembling, and these beta cells are beginning to coalesce. By 3 months to 24 months of age, they begin to look like this. And then by childhood, it looks like an adult pancreas where you have well-formed large islets that are quite dispersed. If one looks at the islets of these, it's quite surprising here in these young islets. The beta cells in green are in the middle, the delta cells and the glucagon cells are around the perimeter, but in the human adult islet, it looks quite different. So there's a change in the composition of the cells in this first few years of life. And so when one measures pancreas mass as a function of age shown here, it increases, again, established mostly by the first decade of life, but there's quite a bit of heterogeneity in this first few years of life, as shown here when one looks at the pancreas volume or the pancreas size during that time. So if we turn to our schematic here, we said that there's differences in pancreatic mass. And what about this sort of area of genetic susceptibility? One of the things that Dr. Schatz hinted at is type 1 diabetes. When is its most common age of onset? So this is work done by Richard Oram and Andrew Hattersley in the UK Biobank. And they classified individuals in this large bank as having type 1 diabetes by genetic factors. And they determined that maybe up to 42% of individuals who had type 1 diabetes developed it over the age of 30 years. So this concept of genetic risk score is being increasingly discussed. And so, for example, we go back to our Sarah and Mr. H, 7 age of onset, 27 age of onset. So I think they highlight that this heterogeneity, and Dr. Schatz just spoke about whether LADA is a different disease. This individual would not have LADA because he had clear type 1 diabetes. He just developed it in his 20s. So this emerging concept of type 1 genetic risk score and whether or not that will be useful in both predicting the onset of diabetes or clarifying whether an individual has type 1 diabetes or another form of diabetes. So I now want to talk about what we know about the pancreas at this age of onset. This is when we see most people who have diabetes. And most of our pancreatic studies are at this time because we don't have good ways of identifying individuals at this time of the disease. So in studies that are part of this Human Islet Research Network, or HPAP, we've been studying the pancreas of individuals who have type 1 or type 2 diabetes, who die for other reasons. The organs are procured as part of the transplant process. The pancreas, of course, if you have diabetes, is not being transplanted. So we're able to acquire that pancreas for studies. This involves investigators at the University of Pennsylvania. So once the pancreas is identified, it goes to an islet isolation program. The tissue and islets are procured, and then the tissues and islets are studied by investigators at Penn, Vanderbilt University, Stanford, and Alberta. And we integrate this with the redacted medical record of the individual, so we know something about their clinical history. And what we do in that is from the pancreas, we take sections of the pancreas shown here, and from the remaining yellow part of the pancreas, we isolate the pancreatic islet. And I want to show you some of those studies. But I want to highlight some of the things that Dr. Schatz talked about the heterogeneity of type 1 diabetes. I think it's heterogeneity within people, but it's also heterogeneous if we think about our models of this. So this is the most widely used mouse model of diabetes, NOD mouse. So here's a pancreatic islet shown here, the surrounding lymphocytes here. But what you see in humans is something that's very different. One of Dr. Schatz's colleagues at the University of Florida, Martha Campbell Thompson, has helped us categorize the insulitis, the inflammation in the pancreas, in individuals who have type 1 diabetes. And for example, here's an islet shown in the red line here. And these are the immune cells shown in dark here. So very few, very different than this. And here's another one where immune cells marked with this marker here. The other thing that Martha Campbell Thompson and the InPod shown here, this is an outstanding program that really is changing the way we understand type 1 diabetes. It's headquartered at the University of Florida. Dr. Schatz is part of that. Mark Atkinson heads it up. And so as part of that, they've shown that the islets are quite heterogeneous in different regions of the pancreas, and the insulitis is very different in individual to individual. So when one isolates those pancreatic islets from individuals with type 1 diabetes, this shows their ability to secrete insulin or glucagon. So here are the stimuli that we give that increase insulin secretion. Red is the individuals who have recent onset type 1 diabetes, less than 7 years of age, and these are controlled age-matched individuals. What's surprising when one looked at the insulin secretion, that the insulin secretion is fairly normal and very similar to controls. Now, of course, the content is very different. There are very few insulin positive cells. Both those insulin positive cells appear to have normal insulin secretion, with the exception of possibly a loss of first phase insulin secretion here. What was surprising is the glucagon secretion in these islets is deficient. So here are the individuals with type 1 diabetes compared to their controls. So even though they have the same amount of glucagon, they secrete less glucagon at all phases of the stimulatory process. Now, when one looks at the pancreas of these individuals, we see this kind of pattern. For example, here's a normal islet from a 10-year-old, and here's a young girl who had 12 years of age, type 1 diabetes for 3 years. Most of her islets look like this, where there are only glucagon positive cells, but there are clear islets that look like this, where it appears to be almost normal. And so that's very surprising. And so as one begins to analyze these cells in more detail, one finds that the beta cells that are remaining here appear to have relatively normal gene expression. And as we mentioned, they have normal gene insulin secretion. But the alpha cells are quite abnormal in that they don't secrete glucagon appropriately, and they have abnormal gene expression. So it appears to be, here's what happens in a summary of this. In type 1 diabetes, the beta cells have near normal insulin secretion and gene expression per cell. The alpha cells are impaired, and they secrete less glucagon and have altered gene expression. The alpha cells can get better if one takes them out of the type 1 environment and puts them into a normal glycemic environment. So the model would be something like this, that here's a alpha cell and here's a beta cell under normal individuals. The beta cells and alpha cells are communicating, and that makes one control and have normal alpha cell gene expression, normal glucagon secretion. But when one loses the beta cells in type 1 diabetes, it looks like this, where the alpha cells are not touched by beta cells, abnormal gene expression, impaired glucagon secretion. So is that a function of extreme beta cell loss? Is it systemic hyperglycemia or intermittent hypoglycemia that leads to this? As we were studying the pancreas of individuals who had type 1 diabetes, we were presented with one case that's quite a surprise to us. And this is a 33-year-old man who had 16 years of type 1 diabetes. His BMI was 25. He had a positive family history of diabetes. He was on a basal bolus insulin regimen, and his A1C was 9. He died tragically in a motor vehicle accident. And when we saw his pancreas, it was very surprising. So for example, here's a controlled 30-year-old individual, but when we looked at his pancreas, one saw lots and lots of beta cells, very different pattern than one saw in individuals with 16 years of type 1 diabetes. In collaboration with Lou Phillipson and others, we found that this individual had a mutation in HNF1 alpha and had a form of MODY3. And when one looked at his islets in the perifusion system, here's what normal islets do. I showed you in blue. Here's what his islets did. They had insulin shown here, but they didn't secrete it in response to glucose. But if one used something that increased cyclic AMP, like a GLP-1 receptor or analog, he could secrete insulin. We went on to show that this was a mutation in the monogenic form of diabetes, MODY3. And so what it showed you is that this dysfunction, that because of this mutation, that you have decreased expression of certain targets of this leads to beta cell dysfunction and leads to a form of insulin deficient diabetes. This individual was treated for 16 years for type 1 diabetes. So the message would be that clinical type 1 diabetes is not always type 1 diabetes. We think about it as an autoimmune process. One other surprise in the pancreas that I wanted to tell you about is one that is based on work, again, coming from InPod, Martha Campbell-Thompson, Irina Kusumavara, and Mark Atkinson. So example, this is a type 1 pancreas from a 13-year-old young man who died. He had type 1, he had duration for 5 years. His BMI was 21. Here's an age-matched control. you can see how much smaller the pancreas. So I wanted to tell you about studies that we've been doing in Vanderbilt and similar studies I've been going on at Florida, and I'll mention those at the end. So what we have done is recruited individuals with new-onset type 1 diabetes. And here's our pediatric endocrinology team. We've done MRI scans on those to measure their pancreas volume. Their pancreas volume their pancreas is outlined by a pediatric radiologist, and John Verasco is an imaging scientist who's been analyzing this. So here, for example, is an MRI of a control and a type 1. They're both 10-year-old males that are about the same size, and here's their pancreas here. Here's the T1D pancreas. One can see in most of these individuals with new-onset type 1 diabetes, studied within the first 100 days of diagnosis of diabetes, metabolically stable, that their pancreas volume is already reduced. And when one quantifies that, one sees that here's the pancreas volume in type 1 diabetes compared to those in controls. Now, when one follows those individuals over the next 2 years, one sees that the pancreas volume goes down in individual with type 1 diabetes, but not in age-matched control. So just to give you an idea of what that means, so here's a proverbial can, and so this is the pancreas volume in controls. This is the pancreas volume in individuals with new-onset type 1 diabetes. So it raises this concept of when we look at our model and we see that the pancreas is smaller, the entire pancreas is smaller. Remember, the islets are only 1 or 2% of the pancreas. So their loss, the loss of beta cells, can't explain this loss of pancreas volume. So the question is whether or not it's always smaller like this, or as part of the disease process, does the entire pancreas become smaller? Work that's been done at Florida that showed similar results, I think, is beginning to give us hints of this. So this is work led by Martha Campbell Thompson. Dr. Stats was part of this. Mike Holler is the pediatric endocrinologist. And so what they did is they performed MRI studies of individuals and their first-degree relatives. And they showed that the pancreas volume is already reduced in first-degree relatives of individuals with type 1 diabetes, suggesting that this reduced pancreas volume may precede the development of type 1 diabetes. I want to shift briefly and just talk about type 2 diabetes, which we've already talked about a lot at this meeting, and we know it's a very heterogeneous disease, but what we know is that there's an increase in functional beta cell mass in responsiveness and resistance, and then it declines. Why that is, we really don't know, and it's incredibly difficult thing to study, and we've not made as much progress as we needed to show. So I want to just highlight like here's a guy who's a principal in middle school, and so he had found out to have a blood glucose of 325, few symptoms, lots of people in his family had diabetes. He changed his diet, and his blood glucose is now 120. But 6 months later, his blood glucose is 275. But the thing I want to show this story is because he's already lost 50% of his beta cell mass, even though he had diabetes that was reversed. When one looks at the islets of such individuals, one can see this kind of pattern. Here's our normal insulin secretion here. Here, individuals have long-standing type 2 diabetes, individuals with relatively short duration type 2 diabetes. So there clearly is a defect in the islets, and it's progressive in individuals who have type 2 diabetes. So there are a number of questions that we need to address and to understand this. For example, adaptation to insulin resistance. There's a greater increase in function than there is in mass. There's a modest reduction in beta cell mass in individuals with type 2 diabetes, but it overlaps a lot with the non-diabetic population. There's limited regenerative or recovery capacity, but there have been recent studies that show with new onset type 2 diabetes that severe caloric restriction can greatly improve functional beta cell mass. There are islet amyloid deposits, but we don't know what their role is. We know that they produce chemokines and cytokines in an inflammatory environment. We don't know their role either. And what's the role of beta cell differentiation? So I just want to finish by talking about two rare forms of diabetes. And one of those is cystic fibrosis related diabetes. This is really one of the most common complications of cystic fibrosis. It's becoming quite frequent as individuals with cystic fibrosis live longer, and they have worse outcomes if they have diabetes. So work that Nathaniel Hart did looked at the pancreas of individuals with cystic fibrosis, and he really tested two hypotheses. Is it because there's collateral damage in the pancreas? Or is the mutation in the cystic fibrosis transmembrane receptor impaired? This is a chloride sensing channel. And so what he did is he looked at that, thinking that the CFTR mutation might lead to the beta cell function in cystic fibrosis. And so he quantified the function, he quantified the expression of the CFTR protein in human islets. And it's really expressed at very, very low levels. And it was expressed in the ducts. And when we looked at the functional consequences of this, there's no CFTR functional protein in the islets. So it's really expressed minimally there. And really what seems to be the problem is that this huge exocrine inflammatory process is going on. Here are islets in the individual with cystic fibrosis. They're encased in this inflammatory milieu. And so it really seems that that's the reason they develop diabetes. And just here would be the model of this, that there's inflammation in autolysis and immune cell recruitment. It induces inflammation. That inflammation and fibrosis impairs islet function, and it leads to diabetes. And then finally, I'll conclude by just telling you about work going on around post-transplant diabetes. This is very common. It's likely multifactorial, but it appears to be primarily insulin deficient. And depending on the type of transplant, it may happen in 25 to 30% of the individuals. And studies that Chunhwa Dai and others have done, they transplanted human islets into mice and they treated animals with immunosuppressive agents. And they could show that their insulin secretion goes down and down. When they took it away, it actually improved. Now, of course, in patients who are on immunosuppressant for transplant, one can't take the immunosuppressive agent away, but it seems to be a direct toxic effect of the immunosuppressive agents on the islets. One of the things that does happen is they develop amyloid, sort of a prototype of type 2 diabetes when they're treated with these agents, and it can also be reversed. So this is the model that they've put forward, where you have a normal beta cell, a dysfunctional beta cell post-transplant diabetes. When you treat with these agents, they have amyloid, decreased insulin secretion. You can reverse this if you remove the immunosuppressive agent. But what they also showed that you could co-treat with the GLP-1 receptor agonist and prevent these changes in that. So there are clinical trials testing GLP-1 now receptor agonists in individuals who are on immunosuppressive drugs. So I'm just going to conclude by saying that here's my sort of beta cell islet-centric view of diabetes. There's plasticity in the human pancreas in the first 5 years of life. What's the determinant of beta cell mass? We need to know that. There are multiple pathways to beta cell dysfunction. Reviewed today things like cystic fibrosis-related diabetes, type 1 diabetes, post-transplant diabetes. They have a similar phenotype, but a different pathogenesis. The alpha cells in type 1 diabetes are dysfunctional. Why is that? We know the alpha and beta cells in type 2 are dysfunctional. We know that there's limited beta cell regeneration or capacity. How can we enhance that? And finally, the studies from Florida and other places showing the pancreas volume as type 1 diabetes is smaller. What is that telling us about the pathogenic process of diabetes? And so I think what we need is diabetes classification based on molecular mechanisms. We need to develop targeted, individualized therapies, but how we interrupt beta cell dysfunction has to be based on the molecular determinants of that beta cell dysfunction. And as we've discussed today, there are different pathways that one can reach that. So I'll stop there and highlight our collaborators as part of the HPAT program. Their names are shown, are bolded here, and individuals in our labs, and my colleague, Marcela Brashova, who's a co-director of these studies. And I'll end there. Thank you very much.
Thank you all, Powers, for a fantastic talk. And after hearing the shots about the heterogeneity of type 1 diabetes, phenotype, genotype, to hear about the beta cell and interaction between alpha cell, beta cell, how there is so much of heterogeneity, it is very, very interesting. Dr. Krishna, you have any questions? You please unmute yourself.
Thank you, Dr. Powers. Really interesting. I'm just sort of reminded about what Dr. Unger talked many years ago about diabetes being a disease of the alpha cell rather than anything else. Somewhat prophetic, isn't it? The question is, though, that when you look at dynamic studies, it looks like the alpha cell and beta cells are mirror images of each other. Why do you think that changes in the alpha cell are not reflected in the beta cell? Is it just that the change in the alpha cell controls the function of the beta cell in type 1?
Yeah, it's a very good question. Let me just pay homage to Dr. Unger that you mentioned. So Dr. Unger was a leader in our understanding of glucagon and alpha cell physiology for more than 60 years. He recently died just a month or so ago, but really it was helping us to realize that diabetes is more complex than just insulin, more complex than just the beta cell. And I think this cross-reactivity, this communication between alpha cells and beta cells is important in normal physiology, and it becomes disordered in certain forms of diabetes. I feel like that in type 1 diabetes, because the alpha cells are not in contact, they're not touching beta cells, they become dysfunctional. So that says that if the hypoglycemia unawareness that happens in individuals who have type 1 diabetes, but that if we can improve alpha cell function by impacting the alpha cells directly, we might improve their ability to secrete glucagon. But a very important area, and lots of interest in how those two cells talk to each other.
Thank you, Alpavas. Now I will answer a few questions which Deschartes has asked me. First thing he asked me, do you think the prevalence or incidence of type 1 diabetes is increasing in India? Unfortunately, we don't have a national registry, and type 1 diabetes as such is not a notifiable disease. This is how we see we have so many things for infectious disease, COVID. Every day we know the number of patients who are infected, died and all. We don't have a such register. But back to 1995 to 2008, 13 years we did a study, 13 years follow-up, and to see the prevalence of type 1 diabetes, we used the typical what the diamond study had, the recapture method. We found that it was 3.7 per lakh population in children that we have type 1 diabetes. It was 3.8 in boys and 3.8 per 100,000 in 4 in girls. This is what we found. Now we did from 2005, 2011 to 2020. 9 years we have got CDIC, changing diabetes in children. We initially recruited 4 years, 4,000 children across India. We thought there's not a prevalence or incidence study as such, but we stopped recruiting. For now, I have got at least 34 centers in 27 districts of Karnataka. That means every district except 1 or 2 has got centers manned by endocrinologists and diabetologists, pediatric endocrinologists. Compared to January 2018 to 19 to 20, we see almost 60 cases more. See, Karnataka is with a population of 65 million population. So even if you take into that, what was I found out? I mean, what we found 2 decades back, almost 3.7 to 4 per 100,000. I'm sure it is going to 5 and 6, even by a very, very fair. Even imagining, or we have not captured 100%, not possible for this, but 34 centers across Karnataka, I can say, definitely increasing. The previous data showed that Asia as such, India, maybe we are increasing at 3%, it is 6% in the West. We are almost reaching there, or 5 or 6%. So definitely type 1 diabetes, last 3 decades I have seen, it is increasing. Still 90% of the population we get are in the lower socioeconomic group, only 10 to 15%. It is true in my clinic and also. Definitely it is increasing. So this is what I would like to say from our own data, what we have in this state of Karnataka. Coming back to, because Dr. Deschartes started with an idea, yesterday's talk was precision medicine in diabetes. Everybody is talking about precision diabetes only in type 2, depending upon whether insulin resistance, insulin sensitivity, combination of the both, or Dr. Mohan said, what about the adults which are happening 1 decade early? The question for both of you is, depending on C-peptide, whether it is beta cell mass or other things, slow versus rapid progression, and whether good responders to poor responders, obese versus lean type. And so, as you said, there is so much of heterogeneity in the phenotype and even the molecular basis and others. Can we still look in future? And also about the management before puberty, during puberty, and after puberty. Can we have a precision medicine at least in future? So what is your hope, Dr. Deschartes? What do you perceive in the future? Do you think based on all this heterogeneity, ultimately it's not just for classification. As a clinician, can I make all this? I have everything. Can I have precision medicine in future?
So I absolutely believe, and building on what Dr. Powers has said, we're going to have to understand the molecular basis for many things, not only beta cell mass, but also the immune response, and also interactions with the environment. So the answer to that question is, will we get it? The answer is yes. We're trying to tease out responders. So there's a really interesting study that I have actually just asked one of our fellows to do, and that's to look at the type 1 diabetes exchange and to ask a simple question is, we know that there are people who have very good control and there are people who have very bad control. Now we always assume that it's, you've got, there are socioeconomic factors, there are educational factors, there are, it's just puberty. But I wonder how much of that is determined by genes. I really want to look and now go back and look at things like genetic risk score and go back and really look and ask the question whether in fact, it's just, I would posit a hypothesis to Dr. Powers and to Hattersley and Oram and everything and say that those patients that we do see that are older have a different HLA compared to those that are the very young. There's no, I don't have the full data, but I would predict that that's the case. And I would just say to you is that yes, I believe we're going to tease out responders. I'm using one example of HLA, and one example of things that we can do easily. But I do believe we're going to be able to look at specific immune responses. As Al has talked about, even the Sarah Richardson and their group being different anti-CD3, anti-CD20 responses in different ages. And I do think that we're going to tease those out. And the way we treat a patient versus the way we treat a different patients are not going to be the same. So the answer is, a long answer to a question is that we're getting there, we're just not ready yet.
I agree with you because it is not patient. Yeah. Yes.
Yeah. There is another question which has been sent to me by phone from one of the practitioners. He says either Dr. Des or Al Powers can answer this. He says, what is the mechanism behind which honeymoon phase happens? And we see this in some patients, we don't see this in all patients. Is there a way in which we can predict which patient goes into honeymoon and which patient does not go into honeymoon phase? And there we have not even used any monoclonal antibodies, but with just insulin, some go into honeymoon, some do not go in. Is there a way to predict this?
I'll leave it to you.
Oh, no, I think you have to talk about the honeymoon phase. And so I think, we're talking about heterogeneity as the theme of this session. I think there's heterogeneity at multiple steps of the process. Heterogeneity in beta cell mass, but there's also likely heterogeneity in the immune process, heterogeneity in the response to the immune process, and heterogeneity in the ability to regenerate or to fend off the immune process. So I think what we need is ways to measure those processes. Going back to Dr. Schatz's analogy with cancer, we need molecular determinants, molecular things that we can measure at each of those steps to help choose the choice, to choose therapies and interventions and make it personalized. Now, in terms of honeymoon, it's difficult to predict whether that's a different process, but it's clear that that's usually relatively brief. And so I view it as part of that fluctuating of beta cell function that happens in people and not a different disease process. Dr. Schatz, do you want to comment?
Yeah, I will also say a lot of it depends on factors which may or may not be related. So the first one is age. The younger you are, the less is your honeymoon period. The next one relates to diagnosis. If you present later in the diagnosis, all right, you can be picked up very early on with a glucose tolerance test and have a blood glucose of 205 and you have diabetes confirmed, and then you start therapy, you're going to have a longer honeymoon period. I actually believe that the LADA that we see in the older patients is just a prolonged honeymoon period. That because you have more C-peptide to begin with, that you're going to then have a response. So a lot of it does depend on your residual C-peptide. A lot of it does depend on other factors like age, also body mass index. So I would say that yes, I can give you an overall prediction of who's going to respond. And obviously there's a lot of glucose toxicity, right? So we do know that with the glucose toxicity, as you get rid of the glucose toxicity, there is some recovery. Now the honeymoon period is a very interesting one. Some have posited that the honeymoon period is just as good a time to study the immune responses once you get rid of the glucose toxicity as the pre-diabetes period. Because the pre-type 1 diabetes, there are very few patients that actually, you can study intensively. They're just not the number, whereas there are a lot more type 1. So there have been some groups who've suggested, I haven't seen much data, but have suggested to really study the immune response at a time that you've now got normalization of glucose free of the metabolic variable of glucose and lipids, frankly, which we do know also affects beta cell function.
Thank you. Des. Last question before we conclude. Dr. Al Powers, you showed that at the beginning, the pancreatic volume comes down. This pancreatic volume decreasing cannot be due to alpha and beta cell because they form a very minor part of it. We know in type 1 and type 2 diabetes, especially in type 1, 30 to 40% of the patients between 5 to 15 years we have seen, maybe 100, 200 patients, there's an exocrine dysfunction. So if 30% of them have exocrine dysfunction, we know there's a paracrine effect between alpha cells, beta cell, how they interact, how they talk to each other. Why is it not possible alpha cells talk to beta cells and both of them talk to exocrine? And if 30% of them have an exocrine deficiency, if I treat the exocrine deficiency, are you going to improve the beta cell function or any change in the alpha cell? Do you have an answer for that?
Oh, those are great questions. I like those a lot. So this communication between the exocrine and the endocrine is one possibility. It's also possible that the disease process that targets the beta cells also targets the exocrine tissue. And so people have shown that there's increased polynuclear cells in the exocrine tissue. So I think those two possibilities need to be tested. Now, I think your final question about whether or not individuals with type 1 diabetes have exocrine dysfunction and could that lead to impaired glycemic control, right? And should we treat that? No one's done that. I think we're actually, maybe Schatz, we should do that study. I've been wanting to do that, to put people on continuous glucose monitors, treat them with exocrine replacement and see if it improves their glycemic ability. Des, do you want to comment on that? On this concept of exocrine endocrine?
Yeah, I don't know the answer. You bring up so many good discussion points. I mean, if 1 to 3% of the 1 to 3% of the whole pancreas is islets, yet the whole pancreas is smaller. I mean, how can that be, right? If that is true, if that's true, right? I'm not entirely convinced that it's exactly true. The studies have shown that, but if that is true, then there clearly has to be something related to the exocrine pancreas, which is clearly the vast majority of the rest, and including the ducts, etc. So there has to be some kind of crosstalk, as Al had said. Now to my knowledge, yes, and we've demonstrated some of the exocrine levels to be lower. But when I say lower, in the lower limits of normal. Not lower, right? So we haven't seen that. Let's say you've got a value of 20 to 50, and we find that a lot of those exocrine, the levels, whether it's amylase or lipase or trypsinogen, not all of them, but some of them are in the lower limits. But what does that mean? I don't know. It may be also secondary to something else that's going on. So I would love to have more discussion. I see Krishna's going to speak.
I just wanted to add, before we close, just extending what Prasanna asked and both of you replied. Is there any evidence to say that there is or transdifferentiation among these cells in type 1. We know at least there's some preliminary data about looking at it in type 2, but do we know if a beta cell can become a ductal cell or vice versa in the type 1 setting? And thank you for indulging.
Yeah, so I'll say this, so transdifferentiation meaning that one cell type can become another cell type. I think in type 1 diabetes, it would be interesting. It's interesting for several reasons. One, could the alpha cells become beta cells? So there's considerable effort over the last decade trying to drive cells in that direction. Because if one could do that, you have lots of alpha cells, you could create those into beta cells. It's been very difficult to show that happens in humans. And when one looks in individuals with longstanding type 1 diabetes, that doesn't seem to be happening. Now, one could argue that's because the autoimmune process kills those beta cells as soon as they transdifferentiate. Now, whether or not other cell types, such as exocrine or pancreatic ductal cells, can be transdifferentiated into islet cells is not clear that can happen. Remember that the exocrine and the endocrine have a common embryologic heritage, so it's a reasonable hypothesis, but it's been very difficult to drive those cells to differentiate into beta cells.
Thank you. Last comment I want to make. What I meant was asymptomatic exocrine dysfunction. I'm not talking of symptomatic because all of us treat symptomatic, and we have seen a lot of patients, though you treat exocrine dysfunction, it is not going to make difference. And there are living examples for it. We had a meeting 5 or 6 years back with gastroenterologists and endocrinologists. We thought we should take asymptomatic, which are 20-30% of type 1 and type 2, have their beta cell preserved, treat them for it, though they are asymptomatic, whether at the end of 1 or 2 years, their C-peptide improves their function. That is what the whole project, rather than treating symptomatic, anyway, you have to treat. And with clinical experience, we know that is not going to make much difference for it, but these asymptomatic, and that's why I asked the pancreatic volume, where you are telling it is there is something new to me, must be due to exocrine pancreatic cells which increase rather than the alpha beta cells, as Des said, contribute very small amount in volume for it. So with this, I would like to thank both the speaker, Des Shorts, as well as Al Powers for a fantastic one. I learned a lot. I benefited by moderating that. I think we are waiting for the next cardiologist talk, which most of the people, the father of cardiology.
It's an honor and a pleasure to be here. Thank you for having both Dr. Schatz and I. We really thrilled to be here.
Thank you.
Thank you. And we are all waiting for Eugene Braunwald, the father of modern cardiology, who will be talking to us. And over to Dr. Arvind to start this ADA Primer 2020 honor lecture by Eugene Braunwald. For the first time, we are listening to him live here in India.
Thank you, Dr. Prasanna Kumar, and I'll be requesting Dr. Bhavna Sosli to take over from this period, and she will be doing the introduction.
Hello, everyone, and I think we've been waiting 3 days to hear from Dr. Braunwald, and the time is now. As several of you have probably read Harrison's Principles of Internal Medicine or the textbook of cardiology, heart disease, and we all know he's the founding editor of heart disease. I have read both of these books when I was doing my internal medicine, and we're very excited to have Dr. Eugene Braunwald with us. So let's try to connect to him now, and I request the IT team to put him through, and he's going to be talking to us over the next 30 to 40 minutes on SGLT2 inhibitors and the paradigm shift in treatment of diabetes with SGLT2 inhibitors. So good to have you with us, Dr. Braunwald.
I am very pleased to be invited to give this important lecture. I have looked at the program of your diabetes meeting, and it's really first class. You have a very, very good program. And I am deeply honored to have been asked to give this lecture. Can I have the first slide, please? Please show me the first slide. So my subject today is sodium glucose cotransporter inhibitors, SGLT2I, for cardiac and renal failure. And I will describe 3 paradigm shifts. Can I have the next slide, please? The next slide. These are my disclosures. These are the grants that I have received through my institution. And the next slide. So to begin with, we have to remember that diabetes mellitus affects obviously every organ, but it affects in particular the heart and the kidney. And this is what I call the vicious circles of type 2 diabetes. On your left, you go an arrow from type 2 diabetes to diabetic kidney disease, which causes sodium retention. On your right, there are double arrows. Type 2 diabetes causes heart failure, diabetic cardiomyopathy, or accelerated atherosclerosis with infarction. But heart failure itself intensifies diabetes. Both kidney and heart disease result in sodium retention, and they affect each other. So you see a series of vicious circles. Next slide, please. A very brief history of the SGLT2 inhibitors. Peterson, a chemist, isolated fluorescein from the root bark of the apple tree and published that in 1835, almost 200 years ago. And it was used as an anti-malarial drug. In 1886, a German physician discovered that fluorescein results in glucosuria. And then in the 1930s, there was a lot of research to understand the intercellular transport of ions and other small molecules. Next slide, please. Now, interestingly, in 1994, a paper appeared in the Journal of Clinical Investigation that came from my department, from the renal division of the Brigham and Women's Hospital and Harvard Medical School. And this was an important paper. I was not involved in this, but it showed that there was a transporter, a sodium glucose exchange co-transporter, and that's where the term SGLT2 came from. And the conclusion of this work is the knowledge of the structural and functional properties of this major sodium glucose reabsorptive mechanism will advance our understanding of the pathophysiology of renal diseases. So this was a basic science study. And of course, the next thing that people did was to look for an inhibitor of this transporter. Next slide, please. And sure enough, in 1999, a group of Japanese investigators described the first inhibitor of the renal sodium glucose co-transporters. And this is what they said, published in the journal Diabetes. We introduce herein a novel agent that may be useful for the treatment of diabetic patients. And now listen to this. This drug is a derivative of fluorescein, which I told you was discovered by accident in 1835. And when this drug is, no, please go back. And when it lowers blood pressure by inhibiting the function of SGLT2s in the kidney and increasing urinary glucose excretion. So that is 1999. It's the first of these compounds, and several were found. Next slide, please. Now, here is a review published in the Annals of Internal Medicine in 2013. So what happened between 1999 and 2013 was a number of these co-transport inhibitors were made available and were approved by the regulatory authorities around the world. And they became useful for the treatment of diabetes. But they were not very powerful, because all they did was increase the urinary excretion of glucose. And you see in this review in 2013, the conclusion was sodium glucose co-transporter 2 inhibitors may improve short-term outcome in adults with type 2 diabetes, but effects on long-term outcomes and safety are unclear. So at that point, in the early teen years of the 21st century, this was considered, or these compounds were considered to be second-class drugs for diabetes. Next slide, please. So we go from 2013 to 2018. What happened in that interval, that the FDA determined that there were a number of anti-diabetics that had cardiac side effects, particularly rosiglitazone, which caused an increase in myocardial infarction. So they determined that before a anti-diabetic drug could be approved, it was necessary to show that they were safe. And in order to do that, they would have to conduct large trials. Next slide, please. And that is where the first real surprise came. Because remember, what they were looking for was adverse effects on the cardiovascular system, but they had thousands of patients with diabetes and looked for adverse cardiovascular effects. Next slide. So what was the surprise? In 2015, you can see the first paper that appeared, the first SGLT2 inhibitor given to thousands of patients for several years in order to determine the cardiovascular outcome. This came from a group at the University of Toronto, published in the New England Journal of Medicine. Next slide, please. And the findings were a surprise. They were startling. On the left side of the slide, on the left panel, you can see a Kaplan-Meier curve, Kaplan-Meier curves for placebo, patients with a heart failure event, death from cardiovascular causes in blue, and on empagliflozin, the SGLT2 inhibitor, in red. And you can see that there is a hazard ratio of 0.62. That means there was a 38% reduction in mortality. In the panel on the right, you can see that the hospitalizations for heart failure also showed a benefit, and they showed the 35% benefit. So I personally, and many people in the field in cardiovascular and in diabetes, felt that there was something wrong here. This was totally unexpected, a real surprise. And people wondered if they had gotten the placebo mixed up with the empagliflozin, or what was going on. Was this play of chance? Didn't seem to be a play of chance because the effect was so powerful. Next slide, please. So that was 2015. Well, at the same time, another drug in this class, canagliflozin, was examined. This is a forest plot. And you see that there is the confidence intervals are less than 1. And you see at the bottom the combination of cardiovascular death and hospitalization for heart failure. The hazard ratio, the HR, was 0.78, and you can see in red that that this excluded one. So a powerful effect was seen with this second large SGLT2 inhibitor. Now we have two drugs in this class that look very good, surprisingly good. Next slide, please. And the third one was the drug that we studied in our group in the TIMI trial. It's called Declare TIMI 58. And this is dapagliflozin. And again, you see a very positive response. The patients in this trial were far less ill than the others, and the response was not as great, but you could see that it's statistically superior. Placebo is in red, dapagliflozin is in blue, a 70% improvement. Next slide, please. So now we have three drugs. There have been 4 trials, and this is a meta-analysis that my colleague and I published earlier this year of 38,723 patients. And here are the endpoints. A huge number of patients, a huge number of events. If we looked at MACE, you can see the diamond there is a hazard ratio of 88. Cardiovascular death or heart failure hazard ratio of 0.76, a 24% reduction. Cardiovascular death, this large series of patients, 17% reduction. Hospitalization for heart failure, even better. And interestingly, a composite renal endpoint, renal failure, the need for dialysis, the need for transplantation, or kidney death, reduced by 39%. And at the very bottom, you see all-cause mortality. It's one thing to improve cardiovascular, renal mortality, but all-cause mortality reduced by 15%. So if we look at the whole field, it looks very encouraging. Next slide, please. Now here are the 4 trials, and this tells the story. And they're arranged according to the severity of the illness. The placebo, these are all placebo-controlled trials. The placebo bars are shown in violet. They're the PLB. And you see the placebo level goes from 15% per 1,000 patient years in the DECLARE trial, which I just described, all the way to 45, 3 times as serious in the Credence trial. In blue are shown the effects of the SGLT2 inhibitor. And you can see that in each of these 4 trials, there was a reduction in cardiovascular death or hospitalization for heart failure. The reduction was greatest in the sickest patients. You can see that in the Credence trial, which is the pair of bars on your right, you can see that there's a 34% reduction. And in the DECLARE trial, the 2 bars on the left, there is a 17% reduction. So in every instance, that was observed. Next slide, please. Now, renal failure. We also, and other investigators also looked at renal failure, and in these several trials, even though they were cardiac trials, you can see that renal failure was greatly improved. And it was consistent in all 4 of these trials. The overall reduction was large. Of renal failure was reduced to a hazard ratio of 0.58. That means a 42% reduction. Next slide, please. So we now have a paradigm shift at this point, and we're talking about a year ago. There's a paradigm shift. We now know, and it's been well confirmed, that SGLT2 inhibitors provide effective management of cardiac and renal dysfunction in type 2 diabetes. Next slide, please. Now, I want to take you to a presentation that occurred at the European Society of Cardiology a year ago. So exactly 13 months ago in the meeting in Paris. DAPA, which is dapagliflozin, which we had studied in the DECLARE trial, was looked at in patients with heart failure. Next slide, please. And here's the paper that was first authored by John McMurray and Scott Solomon, who is in our department at the Brigham and Women's Hospital and Harvard Medical School. So this is a study on patients who had heart failure with reduced ejection fraction. Remember, the earlier patients had disease, had diabetes disease, but they didn't have, it prevented heart failure. And here now we're looking, can we treat heart failure? Next slide, please. Now, these are patients that are very well treated. And I have circled in red to show you how adequately they were treated. 94% received an ACE inhibitor or an angiotensin receptor blocker. 96% received a beta blocker, and 71% a mineralocorticoid receptor antagonist like spironolactone. So these patients were managed extremely well for their heart failure. And the question was, would dapagliflozin add anything? Next slide, please. And it did. So these are patients who are well treated for heart failure. You add dapagliflozin, and there is a hazard ratio of 0.74. That means there is a relative reduction of 26% in worsening of the heart failure risk. And on the right, you can see the absolute risk reduction was 5%. Very impressive improvement. Next slide, please. And here comes the second surprise. What is the other surprise? Next slide, please. There were two types of patients in this trial. They all had heart failure with reduced ejection fraction. So all the patients you see at the top, there were 4,700 patients, and you see the hazard ratio was 0.74, 26% reduction. Now all the patients, about half of the patients had diabetes, and they showed the same as the total. But in red, you can see that there were about 2,500 patients, a little more than half, who didn't have diabetes. They had heart failure with reduced ejection fraction without having diabetes. And they showed the same great beneficial effect, a 27% reduction of adverse cardiac events, heart failure, cardiovascular death. Next slide, please. So we now have a second. We have shown you in the first slides the efficacy of prevention of heart failure in patients with diabetes. And in the DAPA heart failure trial, we just showed the efficacy of treatment of heart failure, which is very important in addition to prevention. And I've shown in red that this is seen in non-diabetics as well. So we have a drug that is effective in diabetics, and to people's surprise, it is also effective in non-diabetics. Next slide, please. So we have paradigm shift number 2, improved management of heart failure with reduced ejection fraction, even without diabetes. Next slide, please. I want to get back to the renal outcome. A paper that was just presented a month ago at the virtual ESC meeting was on the cardiovascular and renal outcomes of empagliflozin in heart failure. Published in New England Journal, has not yet been published in print, and it confirmed exactly what we saw in DAPA. So this is a beautiful confirmation with a separate SGLT2 inhibitor. And let me read you. Among patients receiving recommended therapy for heart failure, those in the EMPA group had a lower risk of CV death or hospitalization than those in the placebo group, regardless of the presence or absence of diabetes. So you can see why cardiologists are doubly excited about this. Next, please. And here comes another paper that was presented last month at the European Society. It has not yet been published. So these are slides that we made up from the slides that were shown at the meeting. The paper is in press, but it has not yet been published. And it's dapagliflozin in patients with chronic kidney disease. Next, please. And the primary outcome that we're looking at was a sustained reduction of the glomerular filtration rate by more than 50%, end-stage kidney disease, renal or cardiovascular death, a relative reduction of 39%, all-cause mortality in these patients with renal disease, 31%. Next slide, please. So the conclusion is that in patients with chronic kidney disease, and the story with kidney disease and these drugs is the same as the story I just told you in patients with heart disease. They didn't have to have diabetes, with and without type 2 diabetes. Dapagliflozin significantly reduced the risk of kidney failure, reduced the risk of cardiovascular death or heart failure, hospitalization, and prolonged survival. Next, please. So this is paradigm shift number 3. So that SGLT2 inhibitors, renal protective in patients with chronic kidney disease with and without diabetes. Now, I hasten to add that this has been just a single paper on the non-diabetic renal disease, and there are a number of trials that we're following and that are ongoing right now to confirm this. Just the same way as the discovery that SGLT2 inhibitors are helpful in heart failure in the absence of diabetes. We have one study that shows their effect in the absence of diabetic renal disease. Next slide, please. So what about the mechanism of action? How do these drugs work? Well, it's complicated, and we'll have to go through this fairly rapidly. Next slide, please. This diagram, cartoon shows on the right-hand side a vertical arrow. This is the glomerular filtrate. And you see the glucose molecules in red, and you see the sodium ions and as triangles in blue. And you see that in the center is a tubular cell, and under label 1 is the SGLT2 transporter. And so this is how the glomerular filtrate normally transports both sodium and glucose. And as you follow both of these molecules to the left, you see that they are returned to the bloodstream. Next slide, please. Now, if we have an SGLT2 inhibitor, which is shown on this cartoon in green, that blocks, so it's an SGLT2 inhibitor, it inhibits the reabsorption, and the sodium and the glucose appear in the urine. So that is one basic mechanism of action. Next slide, please. So how does that help renal disease? Well, this is an interesting paper published in Circulation 2014, before we even knew about this renal effect. And it showed in patients with diabetic kidney disease that the inhibitor decreased glomerular hyperfiltration. As we know, diabetic kidney disease is caused predominantly by glomerular damage because of hyperfiltration, particularly in relationship to the vasodilation of the afferent arteriole in the kidney. So, and that is what causes the fibrosis of the glomeruli and leads to renal failure. And this inhibits the glomerular hyperfiltration, and that probably is the most important mechanism by which it helps in diabetic kidney disease. We don't know yet whether this is also operative in patients with chronic kidney disease without diabetes. That's still open. Next slide, please. So what about the heart? Why does the heart improve? Well, here is a paper that is quite old, before 2007, before this whole storm arose. And there is an exchanger, sodium hydrogen exchanger that operates in the myocyte. And that can be inhibited. It can be inhibited by an SGLT2 inhibitor. Inhibition of the sodium hydrogen exchanger prevents the increase in intracellular sodium, induces the regression of cardiac hypertrophy, and exerts beneficial effects in experimental heart failure. So this is a very good clue as to what is happening to the heart. Next slide, please. So this shows the effect, and rather than taking you through each of these steps, I just call your attention to number 3, which shows that heart failure and or type 2 diabetes result in a reduction of the ATP concentration in the cell. Next slide, please. And when an SGLT2 inhibitor is given, you see in the same spot, there is an increase in ATP. So that is an important mechanism by which cardiac contraction is improved. Next slide, please. So we have talked only about systolic heart failure. And as you know, diastolic heart failure, or what we call heart failure with preserved ejection fraction, HFpEF, is responsible for about half of the patients with heart failure. And the other half are the ones we've been talking about. These are patients with so-called HFrEF, heart failure with reduced ejection fraction. Well, we do not have much evidence for improving diastolic function in human heart failure. I have here a very interesting paper published in the European Journal of Heart Failure that empagliflozin caused a direct pleiotropic effect on the myocardium by improving diastolic stiffness and hence diastolic function. These effects were also independent of diabetes. Next slide, please. So this comes from cardiomyocytes, cardiac cells from heart biopsies in patients with heart failure and preserved ejection fraction. And you see the relationship between the length of the sarcomere and the passive. And you see patients with heart failure and preserved ejection fraction are shown in black. And after the cell, this is treatment of the cell, not the patient, after empagliflozin is shown in red. So there is a decreased stiffness of the sarcomere. From a clinical perspective, it has been somewhat more difficult to show the effect of this. Dr. Scott Solomon in our Department of Cardiology at the Brigham has led a trial of dapagliflozin in patients with heart failure and preserved ejection fraction, and he saw a strong numerical trend which did not quite make statistical significance. He showed a reduction of about 15% with heart failure death and hospitalization for heart failure at a p-value of 0.06. So perhaps that trial has to be repeated before we can make a definitive statement about heart failure and preserved ejection fraction. Next slide, please. So, in conclusion, next. So we have to look at the balance between favorable and unfavorable effects. I will not say much about the balance in green, the favorable effects. We have discussed them in detail, major reduction of adverse cardiovascular and renal effects. But what about the adverse effects? The adverse effects are significant, but they are manageable. The first one is genital infections. That is seen because of the increased the increased glucose in the urine results in genital infections. So a hygienic, normal hygiene will prevent that. Diabetic ketoacidosis is sometimes seen in these patients, even though they may not have hyperglycemia. And that's fortunately a very rare. And also hypovolemia, because these drugs are diuretics. They result in the diuresis of glucose and the diuresis of sodium. So sometimes patients may become hypovolemic, particularly when you start them on the medication. And then with the passage of time and gradually increasing the dose, that goes away. Next slide, please. So what do the guidelines say? Well, here the European Society guidelines recommend class 1A SGLT2 inhibitors, and the three that have been studied are EMPA, CANA, and DAPA, are recommended to lower risk of heart failure hospitalization in patients with diabetes mellitus. Next slide, please. The ADA in patients with type 2 diabetes and established arteriosclerotic cardiovascular disease and multiple ASCVD risk factors or diabetic kidney disease and SGLT2 with demonstrated benefit is recommended to reduce the risk of major adverse cardiovascular events and heart failure hospitalization. Level of evidence A. I might say that the US Food and Drug Administration has now approved the use of the SGLT2 inhibitors in heart failure with a reduced ejection fraction in the absence of diabetes. Next slide, please. Are there remaining questions? The first one is yes. Are there important differences among the individual ones? So far, we haven't seen any major differences. This is a drug class like statins, and there are some differences between the statins, but the basic mechanism is the same. But that still has to be studied. I mentioned the problem about heart failure and preserved ejection fraction. We haven't solved that completely, although I think it's heading in the right direction. Chronic kidney disease without type 2 diabetes. I showed you one trial. I have a question mark there because we shouldn't jump to something until it's been confirmed. Can we combine this with a glucose receptor antagonist? Apparently we can, but that needs more work. And finally, we've looked at long-term benefits that have gone as long as 3 years, 3.5 years in one trial. Are they sustained? Because these could be lifetime administrations that would be necessary. Next slide, please. So I would conclude by saying that there are many, many areas where diabetologists and cardiologists intersect, and we have discussed them. They have diabetic patients who develop renal disease, who develop cardiovascular disease, cardiac patients who develop heart failure, patients who have renal disease alone. And I think we now need a new subspecialty, and I have chosen to call it diabetocardiology. Other people have also used this term and others, which I think is because there are so many diabetics and so many cardiac patients that we need specialists who are, instead of bouncing the patient from one specialist to another, there should be some specialists who are able to care for patients with both diabetes and cardiac disease. Well, I've taken you on a long journey, and we've covered a lot of territory. I hope that you have found this review useful. I think it is a major change in practice, really in internal medicine, not just diabetology, not just cardiology, but nephrology as well. And it's one of the major things that has changed in the 21st century. I thank you very much for your attention, and hope that the rest of this session will be useful as well. Thank you very much.
Thank you. Thank you, Dr. Braunwald. It was wonderful to have you with us. Can you unmute your phone, please? Dr. Braunwald's joined us by telephone. Can we
All
help?
right. While we wait for Dr. Braunwald to unmute, we would like to say that we're very thankful for you for accepting our invitation to join us and deliver the ADA Primer Honor Lecture. I'm very excited to read out the citation of Dr. Eugene Braunwald. He's the editor of Harrison's Principles of Internal Medicine for 12 editions, the founding editor of Heart Disease, now in its 11th edition, both very, very influential textbooks that we've all read in our fields. Science Watch has listed Dr. Braunwald as the most frequently cited author in cardiology. He's received numerous honors and awards from the American College of Cardiology, from the American Heart Association, and the European Society of Cardiology. He's also received an honorary Doctor of Science from the University of Oxford and several sorry, that screen just went off, and several other universities in various continents. The American College of Cardiology and the Heart Failure Association of the European Society of Cardiology have established annual lectures during their meetings in his name. Harvard University has also established the Eugene Braunwald Endowed Chair in Medicine. Dr. Braunwald is the first adult cardiologist elected to the National Academy of Sciences in the US. The Nobel Prize winners in medicine have voted Dr. Braunwald as the person who has contributed the most to cardiology in recent years. And Dr. Braunwald, I actually have a textbook personally autographed by you, which was given to me during my resident years, during one of the previous ADA primer meetings by some of the faculty. So that's something I cherish very much. So thank you for joining us today.
Thank you very much. Dr. Braunwald, can you hear us and can you unmute? We have to be, can someone call him, please?
He is online. I do see him online.
The 617 is his number.
Yes.
Dr. Braunwald, can you hear me?
Yes, can you hear me? Can you hear me?
Unmuted now.
Unmuted.
Yes, sir, we can hear you.
Just give him a minute.
You have to speak louder.
Yeah. Dr. Braunwald, can you hear us now?
Yes, I can hear you, but can you hear me?
Yes, very well now. Thank you. Dr. Braunwald, it's a pleasure having you with us. And this is Dr. Krishna Shishadri from Bangalore. Thank you for joining us this morning. As a first, you have a very long and checkered career in cardiology, and you know, just for there are so many people here who've logged in just because you're on. Can you recount the most important, if you would say, the landmark events that have changed the practice of medicine or cardiology through these years? And I know that this is a paradigm for you, but I'm sure you've seen more paradigms. And how does this compare to those?
Well, I think that probably the most exciting experience that I've had, I've been very lucky. I've called it adventures in cardiology, was the finding of hypertrophic cardiomyopathy, which I did together with a colleague when I was working at the National Heart, Lung, and Blood Institute in Bethesda. And my colleague was Dr. Glenn Morrow, who was a surgeon, cardiac surgeon. And we worked between us to really define this condition. So that was very exciting. And perhaps the thing that in which I learned a great deal was some years later when I was at the University of California. My colleagues and I worked on the concept of could we protect ischemic myocardium in patients who are undergoing myocardial infarction, and would it be possible to reduce infarct size, salvaging ischemic myocardium as it progresses to necrosis. And we did this in a large number of canine experiments. It looked as if it was going to work, and certainly in large animals. And then we were able to push very hard to study the effects on of reperfusion in patients. And we saw that it actually salvaged myocardium. That infarcts became smaller by early reperfusion combined with beta adrenergic blockade. And this then was moved into a large clinical trial area through the NIH, and we call that thrombolysis and myocardial infarction, TIMI. and we established a study group called the TIMI study group. The first trial was on looking at the use of TPA, its superiority to streptokinase in opening vessels, and then seeing that the open vessel results in a better outcome, and so that developed into the open infarct hypothesis. And TIMI has stayed on, and we are now embarking on the trial of TIMI 67. We've worked on many things other than thrombolysis, but thrombolysis and myocardial infarction is the name that has stuck with our group. And we have several trials obviously in patients with diabetes, and particularly with diabetes and coronary vascular disease.
Thank you, Dr. Brownwell. You've had a very unique ringside view of diabetes itself from the view of the heart, and are looking at the intersection of these two specialties. We actually had a symposium yesterday talking about actually creating a new fellowship in cardiometabolic diseases, and you made a brief mention of this. What would be your advice to a budding cardiologist or an endocrinologist to actually take forward, and also how we could upskill?
Yeah, well, so I think before the development of a formal fellowship, because that's a complicated business in terms of getting the licenses and getting formal recognition. I think something that we could do in our training programs today is cardiology fellows in the United States. They are largely 3-year fellowships now, and a period of perhaps 6 to 8 months where the cardiology fellow works in a diabetes clinic, so that they become familiar with the problems, that they spend several months doing diabetic consults in the hospital, but probably more important to see ambulatory patients with diabetes and become familiar with them, so that every time they see a diabetic patient, they don't automatically call a diabetologist. And reverse this thing the other way, that endocrine fellows or people who are training in general endocrinology and diabetology specifically, they should or also for a period of 6 months work in a cardiology clinic, and also for a period of 6 months do and follow around the cardiology consultants see patients in the hospital. So I think that would open the door and increase the quality of care that we could deliver without having to see, for the majority of patients, seeing 2 specialists. That costs money, it costs time, it's inefficient, and it probably isn't necessary.
Dr. Brownwell, before we let you go, one last question. After so many years of patient care and research, what are the patient care questions and clinical research questions that still keep you awake at night?
Oh, I think that I think in the cardiovascular area, I think we're at the threshold of using artificial intelligence and machine learning to characterize individual patients. So I think that we're in an era of big data. We have hospital records that are extremely detailed. We have much information, and I think it's too much for even the cleverest human mind to put this together. But there are now programs that are developing, and which can accomplish this. There are studies that have shown that that in patients who are in sinus rhythm but have had episodic paroxysmal atrial fibrillation, you can recognize that. And in an ECG that shows sinus rhythm, that can be done by what's called machine learning. So therefore, it becomes very easy to detect patients while they're in sinus rhythm that they have once had AF, and that puts them at a much higher risk of recurrent AF. You can also take an electrocardiogram and from an ECG alone define or show a higher risk of impaired ventricular function. By that I mean ejection fractions under 35%. So this is like magic, that you can take a routine screening electrocardiogram, which all of us do all over the world, 12-lead electrocardiogram, and come up with two enormously important findings. Namely, that this is a patient at high risk of, even though it's a screening electrocardiogram, high risk of recurrent atrial fibrillation, and either have impaired systolic function or are at high risk of developing LV dysfunction. So I think that is going to revolutionize the practice of cardiology. And I think it's going to be very exciting. I think it's going to be very difficult. It's going to require enormous amount of training, and it will have to be confirmed. There's these papers out there that claim this, but there has to be a confirmation to see that the formulation of this machine learning can be applied across different institutions and across different countries and different continents.
Any parting words for millions of your admirers? A few thousand of them have logged in here.
Well, I wish you well. I think that it's very important. I've looked at the program that you have. It's an outstanding program. I think you brought in very, very good people, and I think that I think education, graduate education, and the education of practicing physicians has to be kept at a high level, and you're certainly doing that. Your group is certainly providing that high level of education in India, and I'm very honored to have been invited to give this lecture.
Thank you, Dr. Braunwald. On behalf of ADA Primer, we have at least 4 past presidents of the ADA right in this hall at this time. Also, our group and thousands of Indian physicians who have looked up to you as their inspiration. Thank you, and we're so gratified that your childlike curiosity still drives the science that we all learn to practice. Thank you very much. We'll let you go on to do other things on your Sunday.
Thank you.
Thank you, sir. Now we move on to the next session. We have a really amazing session that's coming up. I have 2 people who are very passionate about prevention, and we have 2 chairs for this session, Dr. K.N. Manohar and Dr. Aravind Jagadisa, and they will take you through to the end of this program. Thank you.
Before we start off, Dr. Jagdish and Dr. Manohar, Dr. Arvind is requesting me to give him a moment because he wants to share something with everyone who's joined us this evening. Dr. Arvind, please share your slides, please.
You're muted, Arvind.
Dr. Arvind has to unmute himself.
Yes, I think someone in the control disabled the slides because it said Dr. Jack was
Arvind
next.
cannot,
So I request the
I
IT guys to
cannot.
let him share.
Anna, can you see the slide now? Yeah, you can explain the slide. Okay, it just gives me great pleasure before we close the session. Many people wanted to know how many have actually registered and what was the attendance in the auditoriums right through the 3 days. This is the source taken from the virtual MNC and RxEvents group. The total registrations were 14,323. On the 2nd of October, we had auditorium footfall of 5,111. 3rd October was 3,593. And at 6:50 p.m., just before Dr. Bronwald started his lecture, the number of live was 2,273. That is just the statistics that I want to share, and the same number of people are continuing to listen to Dr. Jack and Dr. Ramachandran at this point of time. Thank you so very much.
Yeah, over to you, Dr. Manohar. Please take over the next session. Thank you.
Thank you for the organizing committee and trying to put us in such a light crowd, and it's an honor to always be here. Well, it was an honor to listen to Dr. Eugene Braunwald, as Bhavna was telling. We have read his textbook so much. Moving on to the topic is reversal of prediabetes. It is said an ounce of prevention is better than tons of treatment. And we all know the GDP, what goes into medicine itself is very less, and for prevention, it is hardly any. I think for the first speaker, it is Dr. Samuel Jack, MD, FACP. Is a professor of medicine and chief of division of endocrinology, diabetes and metabolism at the University of Tennessee. He's also the senior associate vice chancellor and holds the AC Mullins endowed professional chair in translational research. His current research interests include the interface of genetic and environmental factors in prediction and prevention of diabetes, prediabetes, and its complication. He's a principal investigator in multiple NIH-funded studies. His innumerable publications, including 6 books, 31 book chapters, and more than 500 scientific papers in peer-reviewed journals. He's the past president of the ADA and the Distinction in Endocrinology Award from the American College of Endocrinology. He earned his MBBS, MD, and DSc degree from the University of Nigeria. He completed internal medicine residency at the Royal Victoria Infirmary, England, and fellowship training in endocrinology, diabetes, and metabolism at Washington University. We are proud to have you, sir. Welcome, and the stage is yours. Dr. Samuel. I think you need to unmute yourself.
Okay, and how do I share my slides?
There will be share screen option.
Yeah, it's not. it's not sharing. It's not. I'm not seeing that option on my screen from your end. So
Hello.
that is centrally controlled, I think.
No, sir. You can share
Usually
your
a
screen.
green button at the bottom.
Yeah. Okay.
Yeah, it's not. Let's see. It's not. I'm not seeing.
Dr. Sam, just take your cursor onto your face and bring it down, then you can see the share screen option.
Says live recording, custom live. It's something is probably disabled.
Come down. As you can see the mute and the start video. As you keep the cursor on, you can see chat and share screen at the lower end of your screen.
Yeah, let's see what's going on.
Sir, can you email your presentation? We can show it from here.
What's going on? Let's see, view.
Sir,
Almost everything is disabled at my end from, so I don't know whether you have anything to do with it from your end.
Sir, what exactly you are seeing on your screen? Is it on full screen? Is it minimized? Can you see a small window?
Yeah, I can't see the bottom of the screen for some reason, where the share screen would have been.
Exactly. You are seeing a miniature screen somewhere on your...
Yeah, and it's kind of frozen, so I can't.
Yeah.
So, all right, I see it now. Oh my goodness, share screen. Okay, I will share screen.
Yeah.
Perfect.
Okay.
Perfect.
Can you see my PowerPoint?
Yes, you can see the PowerPoint.
Oh, thank God.
Yes.
Okay, sorry, and you hear me loud and clear?
Yes, loud and clear.
Sorry about that little snafu. I'm delighted to join this audience. And it's amazing. This has been going on for many years now. And I do recall when the Bangalore group approached me as ADA president to try to bring about a recurring event of an ADA primer partnership. And it's nice to see a baby grow teeth and walk and now jog and maybe run a marathon, landing the likes of Dr. Eugene Braunwald to give a talk at this meeting. So I'm delighted. In the next 15 minutes or so, I will talk about reversal of prediabetes, one of my favorite topics. Here are my disclosures. And everybody knows that the transition from normal to type 2 diabetes takes time. And the vast majority of individuals actually stop at a halfway house of pre-diabetes. And they may stay there for probably 10 years or longer before sliding further down to type 2 diabetes. And because there are 90+ million Americans with pre-diabetes and over 400 million worldwide, there is opportunity for numerous cross-sectional studies in people with prevalent pre-diabetes to see how they differ from those with normal glucose tolerance. And those studies have led to the ability to prevent progression from pre-diabetes to type 2 diabetes. And a number of important studies, including the one from Chennai, IDPP 1 and 2, have demonstrated the ability to prevent progression from pre-diabetes to type 2 diabetes. In those studies, individuals randomized to the untreated placebo arm developed type 2 diabetes from pre-diabetes at a rate that ranged from 5.8% in Finland to nearly 20% in Chennai, India. In the US, it was about 10%. So we know we've learned a lot about this downstream limb of the trajectory, but relatively very little is known about the initial transition from normal glucose regulation to pre-diabetes. And that black box needs to be filled. A number of studies with limited demographics have suggested that among predominantly white population in the Baltimore longitudinal study on aging, the rate of incident pre-diabetes from normal glucose regulation was 6% per year. Among Pima Indians, it was about 8%. In our own Memphis diabetes offspring study, it was about 10, 11%. Now, because of our interest in filling in the black box in the first limb of the escape from normal glucose regulation, we have been studying initially normoglycemic African Americans and Caucasians, all of whom have biological parents with type 2 diabetes. We saw them every 3 months for 5 years, and we've continued to follow them less frequently. And in the initial screening test using oral glucose tolerance test, they had to have normal fasting glucose and normal glucose tolerance to join this study. After the first 5 years, we counted how many people still remained normal and those who had developed impaired fasting glucose, IGT, or dual pre-diabetes, both IFG and IGT, or in fact, direct transition to type 2 diabetes. We called all these people progressors and contrasted them with the non-progressors. And then along the line, we captured a lot of biological endpoints, a lot of metabolic phenotyping, including clamp studies, adipocytokines. We saved nuclear material, metabolomics, and all kinds of measurable elements. And what we observed was that about a third progressed from normal to pre-diabetes within 3 years, and the average, within an average follow-up of 2.62 years, and the average annual rate of about 11%, which did not differ between white and black subjects because they both were loaded, front-loaded with parental risk for diabetes. And we concluded that race ethnicity was not a significant determinant of progression from normal to pre-diabetes among those who were balanced with regard to parental risk. So we then have published nearly 50 papers from the cohort on various baseline predictors and interval predictors of incident pre-diabetes. Time will not permit me to go into many of them, but you can predict which factors will loom large, such as adiposity. Unexpectedly, we found that male sex was a predictor of incident pre-diabetes. Getting older was one. Blood pressure was a potent predictor. Glucose levels drifting in the upper end of normal predicted further deterioration into pre-diabetes. We had lipidomic profiles. Insulin sensitivity, of course, was low in those who progressed. Beta cell function through the disposition index calculation also was predictive. A variety of adipocytokines have been published. And this year at the ADA, we presented our microRNA data from the cohort. But in the context of preventing diabetes, the most impactful findings were that baseline adiposity, especially waist circumference, was a powerful determinant of who progressed. And the hazard ratio for 2-hour plasma glucose in the OGTT above 120 but below 139 was 2.54-fold higher compared to those below 120. And waist circumference or truncal fat mass in the 90th percentile as compared with 10th percentile also predicted 290% increased risk. The combined attribute of having a 2-hour plasma glucose of 120 or higher and a waist circumference at the 90th percentile predicted more than 700% increased risk of progressing from normal to prediabetes. Now, because of our interest in non-pharmacological intervention to prevent diabetes risk and prediabetes risk, we embraced the metabolomic data, which we've published now, one of the more recent observations from our cohort. And we analyzed 18 amino acids in our cohort, and we found a number of them to be discordant between progressors and non-progressors to prediabetes. We also found variable associations between plasma levels of a number of amino acids and insulin sensitivity and insulin secretion. Very few of them, however, were concurrently associated with both insulin sensitivity and insulin secretion. Now, those are boxed in red for easier reference. So we found the glutamic acid and glutamine was significantly associated with insulin sensitivity and insulin secretion. Glycine was positively associated. The higher the levels, the better the insulin sensitivity. It was also associated with secretion. And tyrosine levels, again, were significantly associated with both insulin sensitivity and insulin secretion. And this is a graphic display of the heterogeneity in the direction of associations among individual amino acids and glucoregulatory parameters. So insulin sensitivity on the y-axis, glycine, for instance, here on the x-axis in the top left, you see a direct association. Higher glycine levels predicted improved insulin sensitivity. By contrast, glutamic acid, glutamine levels, and tyrosine levels were inversely associated. So higher levels predicted insulin resistance. And then in the bottom panel, you see the associations with secretion again. Because glycine levels are positively associated with insulin sensitivity, the beta cells do not have to do as much work. So insulin secretion is actually in the inverse direction. Whereas the amino acids whose levels are associated with decreasing insulin sensitivity are pressing the system to secrete more insulin as a compensatory response. During stepwise multiple logistic regression modeling, we pulled out aspartic acid and asparagine as highly predictive of transition to prediabetes from normal glucose. Histidine levels also, and phenylalanine was borderline. However, histidine impact appeared to be protective. In other words, it decreased the risk of progression highly significantly, whereas aspartic acid and asparagine were positive, so they were deleterious. They inflicted harm. They increased the risk by 240%. And this signature of amino acids predictive of incident prediabetes differs somewhat from the famous branched chain amino acid and aromatic amino acids that came out from the Framingham study, where isoleucine, leucine, valine, tyrosine, and phenylalanine were highly predictive. Any 3 out of these 5 amino acids at baseline predicted 7-fold increased risk of type 2 diabetes in a predominantly Caucasian Framingham cohort. In our biracial cohort with equal representation of whites and blacks, many of these amino acids associated with type 2 diabetes showed up. In fact, phenylalanine here showed up, but in a very borderline manner. So we concluded that the amino acid signature predictive of the risk of prediabetes differs significantly from the signature that further predicted additional deterioration to type 2 diabetes, and that there may also be ethnic racial disparities. And we found lower levels of histidine to be a harm, so higher levels to be predictive of a reduced risk. And I looked into it, and it looks like histidine has long been recognized as a pro-metabolic amino acid. Numerous reports, just a sample here on the screen for you, associating higher insulin and arginine levels with anti-inflammatory and anti-oxidative impact, where histidine supplementation in experimental animals as well as obese humans improved insulin resistance, alleviated inflammation, suppressed food intake, and prevented the development of obesity and metabolic syndrome. So histidine is a good metabolite to have, and it panned out in our study to also be predictive in that manner. Now, we also looked at other group of metabolites, the fatty acid metabolites, acylcarnitines, because those have also been reported in the cross-sectional literature to be associated in studies conducted mostly in white people, to be associated with increased diabetes risk, but data are sorely lacking for the more proximal stage of prediabetes, and particularly in non-white populations. And since we have a biracial cohort, we looked at it. For those in the audience not too familiar, the acylcarnitines are very important, involved in fatty acid metabolism. Long-chain fatty acyl-CoA gets into the mitochondria through the gatekeeper CPT1 and as acylcarnitines, and further downstream beta oxidation releases fuel. However, the coenzyme A is released, and acylcarnitin can efflux back into plasma in situations of mitochondrial stress or abundance. So overstressed mitochondria, as might occur during insulin resistance, will lead to incomplete fatty acid oxidation with efflux of acylcarnitin, which can be measured in plasma as a biomarker. And when we did that, we analyzed 45 acylcarnitins in plasma in our POP ABC participants. And we found that a vast majority of the acylcarnitins were concordant. The levels were no different between progressors and non-progressors to prediabetes. However, 9 of them stood apart as being discordant. Of those, 8 were kind of lower in progressors, and the others one was higher in progressors. And the one that was higher in progressors is the acylcarnitin known as octanoyl carnitin, C81. It's a medium chain fatty acid metabolite, and its levels were higher in progressors, suggesting that it would be deleterious. And when we looked at the glucoregulatory associations, in fact, higher levels of octanoyl carnitin predicted worsening insulin sensitivity. So it's an insulin resistance inducer, and the insulin resistance triggers a compensatory insulin secretion, which you see in the bottom panel. And there is at least one condition, inborn error of metabolism, known as medium chain decarboxylase deficiency, where the marker is blood level of CH1, acyl-carnitine. And kids born with that defect, deficiency, do have problems with glucoregulation, with fluctuations between hypoglycemia and sometimes loss of consciousness, etc. So I've told you is in a snapshot what we understand to be the associated changes as people move from normal to pre-diabetes. But pre-diabetes itself progresses to type 2 diabetes, and it is associated with a variety of complications. In fact, the pre-diabetic complications are no different from those seen in long-standing diabetes, including increased risk of macrovascular disease, retinopathy. 40% of those patients with neuropathy in a random clinic will have pre-diabetes. You have glomerular disease with decreased EGFR even in pre-diabetic state. And this data from the US Renal Data Group makes the point that individuals with pre-diabetes, using not just microalbuminuria, but calculation of EGFR, 18%, 17.7% already had evidence of CKD of various stages, including stage 2, 3A, and 3B. So pre-diabetes is not benign, and as a result, society and medicine has focused on trying to prevent progression to type 2 diabetes. And on the screen, you see several landmark studies that have successfully demonstrated the effect of diet or exercise, or diet and exercise, in preventing progression from pre-diabetes to type 2 diabetes. And I applaud people who worked on these projects. These are not easy studies to conduct. But if you look at the outcome column in the far right, see that the impact in preventing occurrence of type 2 diabetes from pre-diabetes is never 100%. You see rates of low 20s to maybe 58, averaging 72, occasionally where they use pioglitazone. So we seldom achieve complete protection from progression from pre-diabetes to type 2 diabetes. Interestingly, the randomized control trials that I have shown you always pre-specify progression to type 2 diabetes. Never do they pre-specify reversal of the pre-diabetes, despite what I've shown you and despite the well-known associations of complications in the pre-diabetic state. So if you prevented progression to type 2 diabetes, but you did not reverse the pre-diabetes, that individual is still at prevalent risk of developing a variety of vascular complications. However, those reversal data were present in some of the publications, even though it was not pre-specified, so you have to dig deeper. And when we dug deeper, we found that the Malmo study, DPP, Stop NIDIM, and a variety of the other studies had metrics, numbers that they reported. And the reversal of pre-diabetes shown in the last column of the slide, the percentage reversal tended always to be lower than the percentage that prevented diabetes, type 2 diabetes, indicating that interventions that prevented diabetes do not necessarily erase or reverse pre-diabetes, and that outcome needs to be specifically targeted. Now, Malmo study is interesting because they used a variety of interventions with calisthenics, walking, jogging, soccer, badminton for 60 minutes, at least 2 times a week. And then they had physicians as well as dietitians pushing diet, decreasing sugar and carbs, increasing fiber, etc. But the body weight loss was not overly impressive, about 4% max. But the control group had, of course, a weight gain because nobody was working with them. In the DPP, we aimed for 5 to 7% body weight loss, and we achieved about 40% reversal in the first cut of the data. And later on, we looked at the impact of reaching normal glucose regulation during participation in the DPP, even if transiently, even just once, and its predictive impact on future risk of diabetes. And you can see that among the DPP participants who reached normal glucose regulation, fasting or 2 hours, even once, they had 50% reduction in the risk of 6-year incidence of diabetes. So it means something if a patient reaches normal glucose at any time from their initial pre-diabetic status. We also found a dose-response relationship. So those who reached normal glucose just once had 47% reduction in the risk of future diabetes, 2 times 61%, and 3 episodes of normal glucose regulation being reached during follow-up predicted nearly 70% protection from future diabetes. Additionally, we've published from the DPP that regression to normal glucose was associated with lower prevalence of aggregate macrovascular complications, including the retinopathy and neuropathy, which I've shown you that have been documented in people with pre-diabetes. And the odds ratio is a 22% reduction in the risk. In the Michigan study, after pre-diabetic individuals with symptomatic confirmed neuropathy, polyneuropathy, were enrolled in lifestyle interventions and lost more than 1 BMI point and achieved normal glucose status, biopsy studies showed reinnervation of the peripheral neuropathy lesion sites and the improvement in intraepidermal nerve fiber density from 8.2 fibers per millimeter to 15.1 fibers per millimeter. So given these compelling benefits of intervening in prediabetes to reverse it, our POP-ABC study was funded for an additional 5 years, not just to passively follow people and find out who develops prediabetes, but to enroll prevalent and incident prediabetic cases into an intensive lifestyle intervention with a goal of reversal of the prediabetes. We used a more intensive intervention than was used in the DPP, and look ahead, the activity goal was higher, 180 minutes per week. Weight loss goal was at least as high as the look ahead, greater than 10%, face-to-face visits and non-contact face-to-face remote visits as well, meal replacement targeted throughout the period, tremendous encouragement, special campaigns, self-monitoring, etc. We had more than 5,000 email messages sent to participants during the period, over 1,000 phone calls, nearly 7,000 snail mail, SMS text, etc. And with all of that, we achieved some benefits. Here are the baseline characteristics. The individuals who received the intensive lifestyle intervention are all participants in our POP-ABC study that has been going on for nearly 10 years now. They entered intensive lifestyle intervention at after different intervals of diagnosis of prediabetes. We trichotomized them into 3 groups of those who had developed prediabetes for less than 3 years, actually 3 months to less than 3 years before referral for initiation of lifestyle, 3 to 5 years before lifestyle, and more than 5 years. We wanted to test the hypothesis whether duration of prevalent prediabetes was a predictor of response to lifestyle intervention. And in interest of time, I show you the final readout from our study. After 5 years of lifestyle intervention, among individuals, all of whom were pre-diabetic at baseline, only 6.5% progressed to type 2 diabetes, achieving a greater than 90% prevention of diabetes in 5-year time frame, one of the highest ever reported. We believe we achieved that because the pre-diabetes was prospectively adjudicated from people who joined the study with normal glucose. So we knew the moment they had a pre-diabetes and they got intervention, that may have increased the yield. We also observed that those who reversed to normal glucose tolerance were not huge, about 44%. And the majority of people who did not develop type 2 diabetes were still stuck with stable pre-diabetes. There was no time dependency in the impact of lifestyle intervention to reverse pre-diabetes or prevent progression, which is reassuring, at least during the time frame of 3 months to about 8 years, which was the longest prevalent latency time. We found that the same numbers were reverting to normal glucose regulation, about 44%. The same numbers were remaining persistently pre-diabetic, about 50%, and very few were developing type 2 diabetes, about 3 to 8%. So we can conclude from our presentation that intensive lifestyle intervention started within 3 months to 8 years of pre-diabetes prevented development or progression to type 2 diabetes in virtually all overwhelming majority of high-risk people, all of whom had diabetic parents. However, reversal of the pre-diabetic status and restoration of normal glucose regulation occurred in less than half of them, and that the time to initiation of ILI, intensive lifestyle intervention, was not a significant predictor, and therefore a good and translationable finding that people, it's never too late to intervene. Again, despite prospective diagnosis and laborious methodology and hands-on by my staff, the pre-diabetes persisted in 50% of our participants. So lifestyle and medications can prevent type 2 diabetes, but pre-diabetes tends to persist in about half of the people at risk despite these reported interventions. Few studies have targeted reversal of pre-diabetes, even though the evidence suggests that we ought to do that, and the reversal of pre-diabetes ought to be the standard of care. So going forward, I think that our findings argue for novel interventions to achieve and maintain complete reversal of pre-diabetes. What may these interventions be? I believe there is a role for designer diets. The omnibus exclusion of reduction of calories and elimination of fats is not helping reverse pre-diabetes. Given our metabolomic data, there is a case for designer nutraceuticals that might be enriched with histidine and glycine and selectively depleted of aspartic acid and asparagine. There is also a role based on our additional acyl-carnitine data that perhaps the reduction in enrichment with medium chain and alteration in other short chain might be helpful. It's very early. There is also a role for adjunctive medications, because I don't think the diet alone can do this. And we may need to pull out of our hat of the available options to test a variety of strategies, including intermittent exposure to medications to achieve normal glucose tolerance, and then use the DPP findings that the prediction of future protection, if you hit normal even once, translate it in the general population. So thank you very much for your kind attention. I now wish to thank my sponsors of our study, NIH, ADA, and State of Tennessee, participants in our study who have generously given of their time for over a decade, repeatedly coming to be assessed, and of course my able team who do all the work. Again, thanks to the organizers of ADA Primer. Congratulations on such a global impact in diabetes education. Thank you.
Manor, unmute yourself.
You're muted. Hello, am I audible now?
Yeah.
Yeah, I think we'll take the questions in the end, and I would request Dr. Arvind to introduce the next speaker, who actually doesn't require any introduction in our country, especially Dr. A. Ramachandran. Over to Arvind.
So good evening, everybody, and good morning to US people. So at the outset, I thank Dr. Arvind, Dr. Sanjay Reddy, Dr. Prasanna Kumar, Dr. Krishna Sheshadri for such a wonderful and successful virtual diabetes conference. It is one of the best in the country, where all the international faculty we were able to hear today, especially Eugene Brownwald. So we were almost adore him during our MD days, and listening to him was a gift to all of us. So as an Indian, IPL season is going on. So, but last batsmen are always important. In the same way, the last topic is also very, very important. Because to end the talk, to end the conference with such a wonderful topic is most important, because we always discuss about the various aspects of treatment of diabetes, pathophysiology, and all those things. But reversal of the pre-diabetes and diabetes is always an interesting topic to discuss. To discuss about this, to talk about this, we have Dr. A. Ramachandran. He requires no introduction. He is one of the premier diabetologists in the country. He practices in Dr. Ramchandra Diabetes Hospital in Chennai. Over to Dr. Ramachandran for your presentation.
Thank you. You can hear me well?
Yeah, sure.
Okay, thank you for the introduction. And as you just now said, I must congratulate Aravind, Bhavna, Krishna, Prasanna Kumar, all my friends for this fantastic conference and very successful and an excellent program that you have drawn up. Okay, let me see whether I can share my slides now. Can you see my slides? Good.
Yeah.
Good. All right, come to conclusions. Let me go to the
PowerPoint.
Okay, yes, here you go. Now, yes. There you go. Okay. All right. So the previous speaker, Sam, has talked beautifully on the reversal. And in fact, I'm happy that he has actually mentioned about the Indian prevention programs which we have done in Chennai, and has also talked about the reversals about that. So it is little easy for me to introduce and talk about reversal or remission in pre-diabetes as well as in diabetes in the Indian perspective, from the Indian book. So I got to look at the studies in India. So what he just now talked about was normoglycemia going into pre-diabetes. And as he rightly said, majority of the patients will go through a stage of pre-diabetes and then go to diabetes. But then we have data to show that few proportion of patients may go from normoglycemia to diabetes, especially when they have stress and infections. And this is very, very specific for even now for COVID, because we have new-onset diabetes with COVID, where we have patients with normoglycemia going to new-onset diabetes. Of course, what we are now interested is regression from pre-diabetes to normal, and even regression to diabetes to normal. And in fact, diabetes can definitely go to normoglycemia. So there are different scenarios. Pre-diabetes gives you two opportunities. First, we get an opportunity to prevent diabetes, and that is a window of opportunity by pre-diabetes. And also treating pre-diabetes or doing lifestyle modification of pre-diabetes also reduce the risk of cardiovascular disease. So therefore, probably, I think identifying pre-diabetes at an early stage is an important clinical decision to make. The agenda for the next 20 minutes would be, I'm going to look at the primary prevention trials in the Indian population, which we have done. And then we are talking about the remission in the trials. And I'm going to talk about the papers that we have published on mechanism of remission then seen in these patients, which Sam has just shown just now, and there may be some similar to what he has shown. And then, of course, I could also talk about something on remission in type 2 diabetes, the direct study in the United Kingdom. I'm not talking about a look-ahead study. And I will show you a couple of studies from India, small studies where remission was shown possible in type 2 diabetes. This is the popular Indian diabetes prevention program, which we did and published in 2006. We had 531 individuals with pre-diabetes who were randomized into 4 arms of the study. The interventions were lifestyle modification, metformin, and the 4th arm was lifestyle modification with metformin. So what basically we were looking at was the incidence of diabetes at the end of 4 years. It took about 1 year for recruitment, and the trial continued for 3 years. And after 4 years, we got the results. And as the previous speaker was talking about, doing prevention trials and doing a follow-up is a little difficult job to do. So these are difficult studies to conduct, especially with limited resources in our settings. This shows you the cumulative incidence in the Indian diabetes prevention program. 1, showing the Cox proportional hazards model. As you can see, there's a 55% cumulative incidence of diabetes in the control population in 3 years, while it is 39.3 in lifestyle modification, 40.5 with metformin, and 39.5 with lifestyle modification plus metformin. So the relative risk reduction was 28.5 with LSM, 26.4 with metformin, and 28.2 with lifestyle modification and metformin. all of them are significant statistically. And more importantly, the addition of metformin to lifestyle modification did not have further beneficial effect to reduce the incidence of diabetes. Now, what we are interested is regression. In the 3-year outcome of the 437 individuals with pre-diabetes, 44.4% had the diabetes. The cumulative incidence 55, but an impaired glucose tolerance persisted in 34.2. That is almost 60% of the patients were having dysglycemia, while almost 21.3%, I mean, almost 80% had dysglycemia, but 21.3% was regression to normal, which is important. Now, this is a complete data. I have not divided here them into patients with intervention or without intervention, which I'll do in a pooled data. So the point is that, as the previous speaker was telling, the primary aim of all prevention trial is to look at the incidence of diabetes. But we also looked at regression to normal, which can occur in patients with pre-diabetes. I'm going to the second study, which is called the Indian SMS prevention trial, where people were randomized into 2 groups with pre-diabetes, depending upon the normal glucose tolerance. And one group was given just standard therapy, and the second group got SMS on a regular basis for the next 2 years to see whether using mobile phone technology, we can change the behavior of people to prevent diabetes. And this is published in Lancet in 2030. It's called Effectiveness of Mobile Phone Messaging in Prevention of Type 2 Diabetes by Lifestyle Modification in Men in India, a prospective parallel group randomized control trial. And this is very impressive. We had a 36% relative risk reduction in 2 years' time, which was a shorter period. So, and the absolute risk reduction was 9%. So we could actually, now I'm going to look at the pool data for regression. So the present talk is on regression to normal. So the pool data from the outcome from the IDDP1 and the SMS trial together is shown in the next slide. And what is shown here is that we had 622 people who were followed up for 2 to 3 years. And at the end of the study, we had 36% who regressed to normal, 43% continued to have impaired glucose tolerance, and 20% ended up having diabetes. Now, to look at whether intervention made any change, and as you can look at on the right-hand side, you can see in the control group, 30% only regressed to normal glucose tolerance, while in the intervention group, 40% regressed to normal. Of course, there was a significant difference in diabetes. 18% had diabetes in the intervention group, while 24% had diabetes in the control group. Of course, this is a prevention trial where the incidence of diabetes was significantly prevented. But our interest is here showing that 40% regressed to normoglycemia. In other words, we have made them normal from pre-diabetes. And only 30% became normal in the control group. So there was a difference, which is not statistically significant because the numbers are 73 and 150. But the most important point is here that when you recruit people with pre-diabetes, if you're recruiting them with 2 oral glucose tolerance tests, then there's a robust impaired glucose tolerance. If you're recruiting them with 1 impaired oral glucose tolerance test, then the incidence or conversion rate will be lower. So the regression to normal depends upon the risk of diabetes in the recruited group, which depends upon the recruiting mechanism, whether we do the single oral glucose tolerance test or double oral glucose tolerance test. Now, how did the regression occur? And as the previous speaker was showing, lifestyle modification. But in the prevention trial, in the SMS trial, we looked at different scores, and the scores were depending upon different scores achieved by lifestyle modification, whether they were dietary modifications, whether they were having success in the exercise program. If they had 5 score, they had the best lifestyle modification. If you had only 1 or 0, it was much less. Therefore, according to a score, we found the incidence rate was much less in those patients or those subjects who had the highest risk score. In other words, there was a graded decrease in the incidence of diabetes as an increased score of lifestyle modification was noted. So lifestyle modification really worked to prevent diabetes. Now, again talking about regression. We had to look at early regression to normoglycemia can predict final outcome. And this study was published again. Now we are again looking back at the Cox proportional hazard ratio in the SMS trial, which was followed for 2 years. Now, at the end of 6 months, we had a look at how many people regressed to normal and what happened. This is an exploratory analysis after the study was completely over. Now, what we found was that at the end of 6 months, we excluded all the people who had diabetes, who were 37. And we had 130 people who regressed to normal from impaired glucose tolerance, and 300 people continued to have impaired glucose tolerance. Now, this made a difference in the incidence of diabetes at the end of the study. In fact, 24% of those patients who had continued to have impaired glucose tolerance had diabetes at the end of the study, while only 6.3% had diabetes. In other words, if there was an early reversal to normoglycemia within 6 months, there was a 75% relative risk reduction in the incidence of diabetes at the end of 2 years. So therefore, reversing pre-diabetes has important implication in the incidence of diabetes later in life. Of course, we can always talk about how long will the effects of lifestyle modification last. We're talking about, so far we talked about within the trial, what happened to the incidence of diabetes. In the SMS trial, prevention trial, we wanted to see whether we could call these people after 2 years or 3 years and see whether we can see whether there's a persistence of the effect of lifestyle modification. So we had 394 people participant free of diabetes who were invited 3 years later. So, and we looked at what happened after 5 years, the beginning of the study, and we found that the incidence or the relative risk reduction continued to be having the effect even after the intervention was discontinued. In other words, there is a post-trial intervention effect up to 5 years in the SMS prevention trial. So I think looking in doing interventions in people at the risk of diabetes is worthwhile for long-term benefits of preventing diabetes. At this point of time, I want to examine what is the mechanism of remission. In fact, we had 2 papers published on this. This is back in 2009, when we looked at the changes to the insulin secretion and insulin sensitivity in relation to the glycemic outcome in people who were in the Indian Diabetes Prevention Program, who were originally recruited with impaired glucose tolerance. And I'm going to show you only one slide. And what we found was that we had done every year, first year, second year, and third year. And what you see on the left-hand side is the insulin secretion. There was no significant improvement in the insulin secretion at the end of third year. But what we improved was insulin resistance. In other words, lifestyle modification in 3 years improved insulin sensitivity, and therefore that is the mechanism by which we prevented diabetes, and that is the mechanism by which there is a regression to normal. In the idea, these are the patients, these are the subjects who reverted to normal by the end of the study from pre-diabetes to normal glucose tolerance test. Now, we want to look at the regression in the SMS trial, and this is another paper published in 2015. On the left hand, this is the people who had the first column is the people who may regress from impaired glucose tolerance to normal, and the second column is those who persisted to have impaired glucose tolerance, and the third one who were converted to diabetes. And as you can see, the insulin sensitivity improved considerably in those subjects who had regression to normal, while it improved only partially in those who persisted to have IGT. However, it actually became worse in those subjects who developed diabetes. And on the middle, you have the insulin secretion, which showed decrease in all the groups, In fact, if this is the natural progression of dysglycemia, what can occur. Even in those patients or the subjects who had regressed to normal, there was a decrease in the insulin secretion. But the point is what happened to the insulin action, and that is what we looked here. Here we looked at what is called disposition index, which is actually showing the insulin action. Although there was a decrease in the insulin secretion, because of the improvement in insulin sensitivity, there was a significant improvement in insulin action in those subjects who actually regressed to normal. Therefore, regression to normal in pre-diabetes is brought about by improvement in insulin action because of improvement in insulin sensitivity. And exactly similar data was shown by the previous speaker in the Western population. Well, now I have finished the studies on pre-diabetes which regress to normal, and I'm just going to finally end up talking about what about people who already developed diabetes. Of course, look at a study was already mentioned by the previous speaker, but I want to tell you about the direct study which was published in Lancet a few years ago, and this was a cluster randomized trial, open label, done in the clinics in England. This is in the primary care clinics, and this is by Rod Taylor's group. And what they found was that they randomized the groups into two groups, one on standard therapy, and the second group had intensive low-calorie diet program. And what you can see is that this is the decrease in weight during the time of the 12 months and the 24 months. It was a 2-year study. During this time, what happened to their diabetes? And that is shown in the next slide. What is shown here is that their percentage of achieving remission was 39% and 28%, 86% the first year, and 70%. By the end of 2 years, those individuals who lost more than 15 kilograms had an 86% reduction in first year and 70% remission in second year. And those who lost 10 to 15 kilograms had 57% remission to normal in the first year and 60% in the second year. In other words, there was a substantial remission or reversal of diabetes by reducing body weight in these individuals who were on an intensive diet program, which is called low-calorie diet. So therefore, they call it a cure for diabetes, or not only just reversal of diabetes. I wanted to look up and see whether there was any paper published from India on regression in diabetes, and I found 2 papers. One is this one. This is from Pune, effect of a low-calorie diet on restoration to normal glycemia in obese subjects with type 2 diabetes. It's a pretty small study. Of course, they had non-responders and responders. What is shown here is HbA1c from 9% mean HbA1c in the beginning came down to 6.2, which is significant. And then non-responders, it came down from 9.1 to 7.1. And how was this achieved? This is actually achieved by weight reduction from 83 to 76 in the responders and 84 to 78.5 in the non-responders. They call it non-responders depending upon the blood glucose response. At this time, I was looking at some of the papers we published. And interestingly, I found this paper. In 1987, this is an ancient paper. We, from our group, published this paper called Remission in Non-Insulin Dependent Diabetes. This was published in 1987 and in the Journal of Medical Association of Thailand. Interesting paper. We took there were 38 men and 7 women, age of 43 years, diagnosed with WHO criteria. Then the criteria, they needed oral hypoglycemic treatment at least for 3 months, and then maintain normoglycemia. They were continued on lifestyle modification. And then the drugs were withdrawn for at least more than 3 months or more, and we repeated the oral glucose tolerance test, which showed normal. And very interestingly, you can see that there was a complete remission of diabetes in these individuals, initial remission. So this is one of the first papers from India showing that reversal of type 2 diabetes is possible by intensive lifestyle modification. Now in this paper, we also published and see how was it achieved by looking at the weight reduction. And what you can see here again, exactly mirroring what we saw in the direct study from England. And what you can see is that those people who are even thin lost very minimal weight, but obese patients lost 75 to 65. So therefore, weight reduction in obese people can reverse diabetes, but even a very little weight reduction of even 1 kilogram or less than that, even in non-obese people, can improve insulin sensitivity and can reverse diabetes. This is the last talk of your program, and I don't want to take more time. So the period of remission varied from 1 to 10 years in these patients, and 15 patients, and the remission was more than 4 years. So to conclude, reversal and regression of diabetes is possible. It is possible to achieve reversal or remission to normal glycemia, both in pre-diabetes, as shown in the prevention trials, both in the American trials as well as in the Indian trials. And it's also possible in diabetes, as shown in Look Ahead study and the direct study from Western countries and the 2 Indian studies. The strategy will be to have intensive lifestyle modification to moderate lifestyle modification. The mechanism involved is improvement in insulin action by augmenting insulin sensitivity. Early detection of hyperglycemia, therefore, in the natural history of diabetes will help to institute appropriate measures to prevent progression of dysglycemia to diabetes, and that can have a long-term effect to prevent the cardiovascular complications in diabetes. I should thank my acknowledgement to my research team and the medical team, and also Des Johnston from Imperial College London, who was my collaborator in the SMS trial. Thank you.
Thank you, sir. Thank you for a wonderful deliberation on reversal of pre-diabetes and diabetes, which is, I think it is always the need of the hour. So what the incidence of diabetes, what we are seeing in the present situation is only the tip of the iceberg. So if you address this the issue of pre-diabetes reversal very early in the disease stage, we can always prevent the progression from pre-diabetes to diabetes, as well as pre-diabetes can become normal as well. So to begin with, one question for both of you, is there any differences, because we have an US perspective as well as Indian perspective here now. So is there any particular food pattern differences between US and India to assess the prevalence of pre-diabetes and diabetes, and any changes in this food pattern? For example, reducing the McDonald's foods in US and reducing the Saravana food stores in India, is that makes any differences in the reversal?
He can go first. US.
Well, obviously there are ethnic preferences and differences in habitual dietary consumption. Also economically mandated proportionality between carbohydrate and proteins. Proteinaceous meals tend to be more expensive. So those differences do exist. Ultimately, they read out as body mass index and body adiposity. And regardless of which environment you occupy, decrease in body fat always delivers metabolic tune-up benefits. And so rather than focusing on the variety of diets, I think the focusing on the body fat reduction is what we're using as the handle. Somebody?
Yes, I think what you said is right. I think, as I already shown you, weight reduction in type 2 diabetes have a lot of implications and has got drastically helped reducing glycemia. There's no doubt about that. And even if you are even slightly overweight, it can, even 1 kilo, even a 2 kilogram weight loss can actually have a fantastic, dramatic beneficial effect on insulin sensitivity. People have to understand that, because the reason people do not understand the importance of weight is that, let us say your ideal body weight is 60 and you are 62 kilograms. Now that 2 kilograms is your overweight. So if you lose 1 kilogram, you're losing 50% of your overweight. You must understand that. So every 1 kilogram loss of weight has got definite implication in improving insulin sensitivity. It is not just 1 kilogram and 60 kilograms. It is a percentage of overweight that you lose, which is very important. And as far as the diet is concerned, as he rightly said, those patients who are taking, especially in India, I would find you reduce sugar and fat. We don't have to go for intensive lifestyle modification like what was done in the DPP trial, where they had personal training programs, both in the finished program, etc. We need to have very simple messages to people, like stopping sugar, sweets as much as possible, do walk every day, reduce fat consumption, continue to take your own food pattern, don't change it completely, but you know what is to be avoided and what is not good for you. It can go a long way in reducing diet. Remember, even if you reduce 300 calories a day, in 1 year, you're reducing thousands of calories. So you'll definitely lose weight if you continue to do that. It is not necessary that you should start starving. Dieting does not mean starving. Dieting only means be smart, be clever.
I think some few days back, I heard Dr. Mohan's talk on his carbohydrate related study. I think worldwide he had presented that it is directly correlating the incidence prevalence of diabetes correlating with the amount of carbohydrates. I think it all boils down also to the government level. Most often than not, the junk foods are much cheaper than the healthy foods, and some people call for advocating taxes for junk food. And going ahead, one question to Dr. Sam. I think in your study you saw that reversing pre-diabetes was more difficult than reversing diabetes. Was it?
No, preventing diabetes was easier than reversing pre-diabetes. So all of my study participants had pre-diabetes. By design, I'm a preventologist at the proximal stage. So I never let study people who already have diabetes. I'm doing a number of things, but for this project, we want to prevent diabetes from showing up. So we enroll people with normal glucose whose parents have type 2 diabetes. We watch them very closely. As soon as they get to pre-diabetes, we intervene. And when we did that, we prevented the majority, over 90% of them, from developing diabetes. However, we had much less luck reversing the pre-diabetes. They didn't have diabetes, but they were still stuck with pre-diabetes half of the time. And it was impressive to see Dr. Ramachandran's data confirming that even in the Indian population, even with lifestyle intervention, you're getting about 40% reversal. And we got about 44% reversal. So it is really amazingly reproducible observation, which leads us to the next question: what are we going to do about it? And so because intensive lifestyle, there's a limit to how much you can push and badger your patients to keep cutting calories. We need to get smarter. So I'm thinking, and I've designed studies, some of which are being reviewed by grant makers, that yes, we can preach caloric reduction, etc., but the diet itself needs to be smartly constructed, front-loaded with pro-metabolic micro and macronutrients. And part of the data I showed you that took thousands of man-hours to profile the metabolomics of pre-diabetology by assaying 45 acyl carnitines and 18 amino acids and their trajectories, we pulled out 2 amino acids, glycine and histidine, which are very pro-metabolic. They predict insulin sensitivity improvement. The vast majority of other amino acids, of course, are gluconeogenic precursors. They are used by the liver to make glucose, and they were associated with insulin resistance. So people think that if you are reducing carbohydrate, you can eat proteins. But the type of proteins you eat and deliver and flood your system with anti-metabolic gluconeogenic precursor amino acids is not going to help you. Whereas if the protein component was manipulated, so I call it nutraceutical approach. It takes a little bit more work, and there are some patentable ideas in it, especially the formulation. We have to work out at animal level which ratios of glycine and histidine will give you 50% or more tune-up in insulin sensitivity, equivalent to 20-pound weight loss. So we have to use this smart approach where if human beings are tired of losing weight or their legs are hurting, they can't go exercise, can we sneak in a metabolic tune-up caloric dietary strategy that delivers the same benefits of diabetes prevention and pre-diabetic reversal. It's doable. It's something that is a testable hypothesis.
If you take in US as well as in India, like there are these studies, what we always see in the major studies, they are done in a very strict protocols. The patient has to come and the particular test has to be done and everything is being done. But practically in your clinical practice, both in US as well as we do in India, how long this intensive lifestyle will go on? I'm saying in my practice, they listen to us and they're aggressive, like for 6 months, 1 year, they do all the things. Moment they see they are feeling better, the things go haywire, and once again the normal stages will become pre-diabetic and diabetic. We always discuss about these studies and we are happy about this reversible, but how long they can sustain is always a big question. Dr. Sam, what is your opinion, as well as Dr. Ramchandra, please?
In the DPP study, we saw the diabetes prevention program study, we saw them every week for the first 16 weeks, then less frequently thereafter. In the first 6 months, they lost 7% of body weight. When we started seeing the participants less frequently, they gained back 50% of the weight they lost. Okay, so you're right, not very long, it's not sustainable, but even if they maintained a modest residual weight loss, as you saw from the SMS text study by Dr. Ramachandra, and as you see from many reports we've published from the DPP, there is sustained benefit of initial lifestyle intervention. The paradigm there is the Dacheng study, where 30 years of follow-up, they still had sustained benefits, even though the intervention was more than 20 years ago. So yes, there is an enduring quality to lifestyle intervention that is superior to medication washout. When you stop the drug, the body eliminates the residual drug and the drug effect is gone. Anytime we stop a diabetes drug in the DPP or rosiglitazone or metformin, within 90 days, the glucose rebounds. So these drugs are not helping us prevent diabetes per se, but lifestyle has a sustained benefit. Dr. Ramachandra, you can chime in here.
Okay. I think pre-diabetes and diabetes both are entirely different as far as the therapy is concerned and the effectiveness is concerned and the outcome is concerned. Let me tell you, in pre-diabetes, if you leave them alone without any intervention, there will be still a reversal in some people. About 20% of them will reverse to normal. However, when you do lifestyle modification, as Sam was just telling, you can improve the reversal to almost 80%. Number two, as you rightly said, the intervention can be only for 2 years or 3 years, but you can have a post-trial effect up to many years. And in the SMS Indian trial, we showed it up to 5 years. And in the Chinese study, they are shown up to 23 years, even cardiovascular benefit. So therefore, lifestyle modification, even for a short period in pre-diabetes, has substantial long-term benefits. On the other hand, in type 2 diabetes, reversal cannot be natural. It can be done only by intensive lifestyle modification and by weight reduction, especially in obese people. Now, this has to be done by continued motivation. As you rightly said, when they see results, they will be encouraged and they will continue to do that. So motivate them, impress them with the results, but definitely there will be a lot of people who will escape, and that will happen in type 2 diabetes.
Thank you, sir. Thank you, Dr. Sam, Dr. Ramchandra, for this wonderful deliberation and wonderful interaction. I thank the team ADA Primer for giving us the opportunity. And thanks, Dr. Bhavana, you are being the wonderful host today. So I'm sure you are tired since morning. We are sorry we have taken you a bit of a long time. Thanks for the opportunity. Over to Manohar.
Thank you everyone. I think Dr. S.R. Arvind wanted to make a point, I thought.
No, I just wanted to make a point that I will come in before you people close, because I just wanted to thank Dr. Ramchandran, my teacher. I wanted to thank Sam, who has been a mentor and who was instrumental in getting the relationship between the primer and the ADA going. I mean, two wonderful people are there together today, and then I'm extremely happy that it has ended extremely well. And I'm sure there are no more questions. And then I take this opportunity to thank ADA for having given us the permission during the COVID times to go ahead and do this virtual conference. Thanks to Dr. Sam. It also went live to Sub-Saharan Africa region and many countries across the world. And there were more than 15 speakers, eminent speakers from overseas who were part of this. And it has gone on for 3 days, almost 11 hours every day on 2nd, 3rd, and 4th. I thank RX Events Group from Ahmedabad who have been instrumental. And there's been a lot of coordination work that's been going on. I thank the Sheraton Hotel Group in Bangalore, where we all are parked now. 15 of us are parked inside the Sheraton, and then we have built up an IT team, a studio, and then it looks like a NASA Space Center kind of a thing at this point of time. So 15 of us are making sure that everything goes on time, and then there are no time delays. I thank everybody from the pharma industry, from the ADA, and from the Indian faculty and the delegates for all the patience that they have shown for the last 3 days. Thank you very much. I'm sure I will see all of you next year in a face-to-face meeting and not in a virtual meeting. Thank you so very much. Good night.
Good night. Thank you for the opportunity, sir. Only you can pull it off like this way. Thank you so much for all the team.
Thank you, and congratulations
thank you, Sanjay.
to all of you.
Thank you.
Nice to see you.
Thank you.
Nice to see you too. And one more thing to thank you for, Sam, is probably you're one of the few people who convinced me to get married. So my husband will be thankful for that. So thank you.
That's the biggest compliment you can get.
So see you all, and good morning to those in the US. Good night to those in India. Bye-bye.
See you.
Thank you. Stay safe.